this opportunity to invite our president, Dr. Rajkumar Deshpande, to deliver his inauguratory speech. Thank you, Dr. Deshpande.
Thanks, Arvind. Good morning to all my colleagues, young and my age. It's always a pleasure to see you all. I am hoping that we'll have offline meetings soon, and then we'll have the great camaraderie that we always have. It's an honor for me to be the president at this meeting, the MISSAB Summer Symposium of 2022. The program is looking fantastic. Arvind has put together a great team, and I hope you all enjoy the meeting today. It's going to be, as Arvind said, a watertight meeting. Looking forward to the intense debates and the healthy interactions. As you understand, MISSAB is a young society. It's committed to the encouragement of young surgeons, and I hope the young surgeons participate fully. And please ask questions during the debates. It's meant to have interactions, and I hope no personalities get ruffled. I'm looking forward to the free papers too. Hopefully, as I said, the pandemic is behind us and future meetings will be in person. Now, we have the encouragement and blessings from our past presidents, Dr. Arvind Jaiswal, Dr. Srinivas Rohidas. Of course, I didn't see Srinivas Rohidas today, and I'm told that he is participating elsewhere. And I hope his thoughts are with us today. Dr. Amit Jala, our Vice President, Dr. Arvind Kulkarni, our Secretary, Joint Secretary, Dr. Alok are all there. Please be there throughout the day. And the EC members are also there. And I'm very happy to see that all of you are participating in all large numbers. So wishing the meeting all the success. Over to you, Arvind.
So thank you, Mr. President. Can you hear me?
Yes, yes.
Right. So the last 2 years have been quite bittersweet. Our lives have been dictated by a virus which changes its forms and colors. Thanks to the virtual mode, we could interact monthly. And so the success of MISSAB relates to the success of its members. So apart from these enriching educative monthly meetings where we had fantastic interaction, learned a bunch of new things. From the point of academics, I'm happy to say that the EC has recognized and established fellowship centers across the length and breadth of the country. So this is available, the data is available in the newsletter that just got published last week. So keeping with the spirit of academics that MISSAB is well known for, there was a natural plan to hold a grand gala physical conference in April 2022 to continue with the ritual that was set by Dr. Umesh and Dr. Deshpande and the entire Bangalore team last April. However, then came this Omicron and destroyed the entire idea. So it took some time for us to realize that Omicron was toothless. And during that shadow period, there was some hesitancy to hold a blasting physical conference, which was put forth by the Pune team, as well as there were concerns from the EC also. So then again it was postponed indefinitely. So however, a situation has emerged for the better, and so we have a definitive program now in place. And Pune team will definitely rock us. So this team headed by Dr. Pramod Lokhande, a well-known endoscopic surgeon, they'll show us how a MIS conference is conducted. That will be between 18th and 20th in November. I request you to participate in full form, full physical form. So today's meeting is basically an endeavor to connect in between the two big conferences that we had, that is in April last year and that we are going to have in November this year, to connect all the members. And the EC thought that the best way would be a scientific way. So with this meeting, we hopefully, will pull the curtains down for all our virtual interactions, that is in big forms. Again, the theme selected for today's meeting is to discuss and debate solutions to tricky situations. So we didn't want to have monotonous speeches, lectures, talks. So we wanted to have debates on tricky situations that generally go very unanswered. They don't have one single answer, and something that we face in practice, which are marred by varying opinions. I hope you enjoy all the sessions. One more idea of this particular conference, and the idea to have free paper sessions, was to bring to surface new faces, new talent who will be the future torch bearers of the society. But EC is not happy with this, because we did not get that many abstracts. We are still lacking in this sphere. So I hope the next gen replaces the old generation, blooms and blossoms, and leads the society to unimaginable heights. With this, I conclude. But before concluding, I would like to thank our trade partners, without whom hosting such meetings is close to impossible. Medtronics, Jayon, Jesco, QR Surgicals, Revo Spine, Intas, two groups, Technoshine. I thank them all for being there and helping us conduct this particular event. Thank you. So I'll hand over the platform to the next chairpersons, the inaugural chairpersons, that is Dr. Bharat Dave from Stavya Hospital, Ahmedabad, and Dr. Rajamani from Madurai. Thank you.
Thank you, Dr. Arvind. Is Dr. Rajamani around?
Bharat sir, Rajamani sir, can we have 5-7 minutes of discussion more? We are still, 9 o'clock is the relay time, so maybe we can just have some discussions more happening.
Sure. I think we can have the pulse of wisdom from President Dr. Deshpande.
Dr. Dave, I am very happy to see all of you. That's the first thing. It has been a very lonely time, because COVID is a lonely disease. All of us have been impacted one way or another. Even though I had had a so-called minor form of disease some time ago, the repercussions of it was terrible for me. And I hope many of you who had suffered from this will understand what I'm saying. Apart from that, we would like to go back and sort of forget all the troubles we had 2 years, as Arvind said. I have young surgeons here, including my good friend Vishal Kundani. I have not seen his face for a while. Vishal, can I see your face?
Yes, sir. I'm here.
In the car. Oh my goodness.
Just 1 minute and I'll be
there. So you have something to say, Vishal? Go ahead.
Well, I think you're right, sir. And most of us have gone through this dark times of COVID, where not only pandemic came across, but also the infodemic came across, where everybody had some or the other thing to share. And I think Arvind and the whole MISSAB team has did something incredible to bring across the scientific way of bringing the knowledge forward, where the Association of Minimal Invasive Spine Surgeons of Bharat are bringing forward this summer symposium, which was long awaited. And I think minimal invasive spine surgery has been the crux, the newest thing that has happened in spine in last whole decade is the MIS surgery. Unfortunately, the MIS surgery has had many bends and twists, resulting into bends and twists of the scientific ethics of it also. And probably with this symposium and many more such from MISSAB, we'll be able to lay down some consensus and grounds for more scientific, more ethical, and more possible ways of reaching newer heights with in minimal invasive spine surgery.
Amit, you have been very, very quiet. The man from Ahmedabad, our esteemed vice president, I want to pick your brain, your thoughts, please.
Yeah, Dr. Rajkumar, we are all actually waiting to meet physically. We have been having, as Vishal said, that having a lot of infodemics in this pandemic, but we need to meet physically. We have kept our momentum of MISSAB going last year, even in the pandemic, by doing monthly meetings. And we should keep this ball rolling forwards. I'm very happy that Arvind has done a great job during the pandemic and in this symposium. And in last April, your team also did a great job to keep the MISSAB live during this pandemic. I hope we meet again in Pune, and Pramod definitely is working very hard to have a first physical conference after the pandemic. So best of luck to Pramod also. And we invite from MISSAB everyone to attend that physical meeting also.
Alok,
Yes, sir.
my friend, your great thoughts.
My great thoughts are good to see all your faces. I care two hoots about the academics nowadays because
My
good to see
God.
each other's face. Be good to see each other's face in a situation where we can see each other. Lots of things have happened. Everyone has some wound or other. Definitely good to have knowledge. But when you realize that life is more important than knowledge, it's good to be together. I want the next conference not because there's a lot of academic feast. I want the next conference because I want to meet all of you personally. My thought.
Dr. Rajamani, good to see you, sir. You are muted. So can you please tell your thoughts?
I'm happy to see all friends' face, as Alok said. They're all surviving their tough period, and then we're here to share our knowledge. And all very nice arrangement by Arvind. Excellent work done, and really it's very great topic.
Your audio is not clear, Dr. Rajamani. Your audio is not clear.
Good morning to all. Can you hear me now?
Yes.
Better, better.
Yeah, it is always nice to see all the friends, as Alok said. They passed a tough period, and then seeing the face itself gives a very happy mood today. And Arvind has done an excellent job of choosing the topics, and then interesting pieces there so that we can learn from each other. And let us have a good meeting today. Thank you so much, Rajkumar, and all the friends.
Dr. De, my friend from Bhubaneswar.
Yeah, last week I think I was in the neuroendocrine in Delhi.
Okay.
I think that was a very good get together. So I think we are also expecting something like that in the Pune. We all will join there, and we will enjoy their face to face, and there will be good interaction. In Zoom, I think there are some restrictions what we am feeling for last 2.5 years. Now I think this Pune will be Pramod. I think all of will join there, and it will be a good feast. And this also for the MISSAB summer course, I think the credit goes to the Arvind. There is a very good panels, the faculties, topics. I hope all the whole day will be the good feast for the academics.
Dr. Bharat, sir, your thoughts. Love to see you always.
Sir, I think the way we were discussing earlier before we started this inaugural speech, I think the pendulum has swung completely on the different direction now. And I think we are probably, facing more challenges because of the steroid. And probably every day I see about 4 or 5 AVN of the hip. I'm not sure whether the scenario is same with you guys or not, but this is something which is see every day 4 or 5 AVN. And the treatment of this AVN is all everywhere, haywire. I think we really need to have some kind of our own sort of protocol or some kind of sort of a white paper kind of thing, because that is where the MISSAB will have standing, or rather an organized will have standing, how to handle the osteoporotic fracture, how to handle certain conditions which has occurred because of the COVID. I think we really need to take a stand. I think that throws a challenge to Dr. Arvind and Dr. Amit and even ourselves as well, we should be really doing something good for the society, because this is going to be more and more challenging as the time passes, then coming next 6 months probably.
Dr. Ajay, you're hiding. Is Ajay there?
He should be there.
Dr. Anil Patil wanted to say something because he was raising his finger.
Oh,
Yes.
Anil.
Good
Go
morning,
ahead.
sir. Good morning. Good morning. Yeah, I am talking from the Tadoba Abhayaran. Dr. Rohidas, me and Dr. Mohanty are here for 2 days conference MCNS. You have presided it probably in 2016 in Mahabaleshwar. Are you getting my point, sir?
Yes, yes, yes.
Am I audible? So
Yes, you are
Dr.
audible.
Rohidas has gone to meet to Tiger, but I prefer to stay here. So it is good to see all the stalwarts. So I hope that here in Tadoba, I am sticking to restaurant because I don't have the range here. The only Wi-Fi working in the restaurant and the reception premises. So all the best for the conference. Thank you.
Ajay,
And I think we should ask Dr. Bala Murli and Dr. Anil Patil. Dr. Bala
Yes,
Murli.
sir.
Yeah. Ajay, you can give your input as well.
Yeah. It is good to see everybody around, and it is even good had we been physically present. That would have been better. Just waiting for the Pune conference. Good to see everybody. A lot of challenge.
Bala, good to see
Hi,
you.
good morning. Hi, good morning, everyone. Yes, I think the first point is good to see all the seniors back and the smiles on the face. You all look like excited little boys let out of school, to see one another. And obviously, the entire team has put in an excellent academic meeting. I think nowadays we're all getting fed up of online and, sitting in front of computer. But today I made it the point that, this is our core committee of, minimally invasive spine surgeons. And I thought I'll sit down all day and watch. So thank you and good to see you all.
What about Neeraj Vasavada?
And I think Rakesh.
Sir, here only. How are you
Uh,
all?
Neeraj,
So good to see you, everybody here.
Yeah,
Good morning, everyone. Good to see you, everyone.
Yes, I've been waiting for, as Ajay said, we all are waiting to get together personally rather than on Zoom. Zoom has probably made us, zoo animals probably.
Rakesh?
Yes, sir. Yeah, very happy to see all here in Salwards, enjoying.
So I would want to make a point. I forgot to thank and acknowledge the contributions of Ajay Krishnan. He has been the Karta Dharta of our website from the beginning, and it would be a big mistake if I don't credit him. So the whole website has been revamped, and you can see if you go on the website, there is a lot of academic information. There is members directory with the full details. You don't have to contact us. You will get all the details on the website. There is a way of becoming members through RuPay, that is credit online. Apart from that, there is a lot of data that is put up on the MISSAB website, and I would like you to explore the website. And again, as so Ajay was very prompt with every interaction, whenever you had to put up something new on the website, and I really want to heartfully thank him for the same. So I think Vishal is all set.
Shall we start? Dr. Vishal?
Yes, anytime, sir.
Okay. Thank you, Dr. Arvind. Thank you, Dr. Rajkumar. Thank you, Amit. And thank you all office bearers for giving me this opportunity to chair the session. And I welcome my co-chair, or rather my main chairperson, Dr. Rajamani. Good morning, sir, Dr. Rajamani. And let us have the boat, floating further. I welcome Dr. Vishal Kundani as a moderator. And the panelists are Dr. Malcolm Pastonji, Dr. Bala Murli, Dr. Gautam Javeri, and Dr. Day. So let us start with the first case, extraforaminal disc L5S1, challenges, dilemma, and approach.
Thank you, Dr. Bharat and Dr. Rajamani. I welcome all the delegates to the opening session of academics of MISSAB Summer Symposium. And I think no other disc.
I was just waiting for you.
Night, sir. No sleep. Zero. Sir, यहीं से 2:30 बजे गए और
So, degenerative disc disease and PIVD has always been the dilemma, being a clinical mystery, a radiological mystery. Why do same disc gives different symptoms, and why do different discs give same symptoms? This dilemma has always been a major dilemma in management of PIVD, but today we are going to take this dilemma one chapter high up to a extraforaminal disc. How does it poses challenges, dilemmas, and approaches? And with me, I welcome Dr. Gautam Zaveri, Dr. Day, Dr. Pastanji, and Dr. Bala Murli to help us sort this dilemma out and come to a consensus ground on how to approach, manage, and take care of extraforaminal disc L5S1. Mind you, we are not talking about discs like these, where a young middle-aged guy presents to you with left lower limb radiculopathy, which is not getting better by conservative treatment, and the MRIs are able to prove the clinical radiological correlation of symptoms to radiology. Like you, in this case, you can see left-sided PIVD with left-side radiculopathy in the dermatomal area. These are straightforward paracentral discs, which do not require too much of brainstorming. And these discs are fairly common to manage by one of the techniques here. We are going to be talking about challenges which are very similar to the clinical scenario we saw here. And I leave the case open where a young guy with left lower limb radiculopathy, excruciating pain in L5 dermatome, which is back of thigh and calf, greater than the lateral aspect of calf, and L5 myotomal weakness, and excruciating pain comes with almost normal looking MRI. The sagittal images are looking almost normal with a very tiny disc degeneration at L5S1. Dr. Gautam, are you there? Would you like to comment on the clinical picture here? I mean, if you see a young guy with excruciating pain, which sometimes seems to be disproportionate to the MR scans. So you are mute. Dr. Gautam, we can't hear you.
Can I have a look at the actual images?
Yes, those are the actual images, sir.
Yes, so there is a L5S1 far lateral disc prolapse, isn't it, that you want to show me?
Yes. So why is it, do you think that clinically also sometimes we can get scenarios like this where MRI seems to be normal, but patient has disproportionate pain and the MRIs can be termed as normal like it was in this condition?
So this is fairly common, Vishal. Can you hear me?
Yes, we can.
Yeah. So basically, this is not at all uncommon in a far lateral disc. In an extraforaminal disc, there is the disc impinges on the dorsal root ganglion, and therefore the pain is usually quite excruciating. But there is often burning pain, disc, a lot of dysesthesia, and it is very difficult for the patient to tolerate that kind of pain. So it is not that it is disproportionate, it is proportionate for the location of the pathology that is there.
Right. And also, is this atypical kind of presentation where L5S1 disc is resulting into ankle dorsiflexion weakness? I mean, anything in specific? Because L5S1 normally a disc.
L5S1 disc normally, if it is in the posterolateral place, will take the S1, which is the traversing nerve root. But when it's a far lateral disc, it will involve the L5 nerve root, which is the exiting nerve root. And therefore, the symptoms and signs will be those of an L5 nerve root pathology. And therefore, you are more likely to find EHL weakness, EDL weakness, and maybe minimal tibialis anterior weakness rather than weakness of the S1 muscles.
Very important. Thank you, Dr. Gautam, for bringing this forward. Disproportionate clinical symptoms with a normal looking MRI. Please don't shove such patients under the carpet saying that there is nothing, or this patient has psychogenic symptoms, or it has extra spinal symptoms, unless and until you have seen the foraminal and far lateral exiting nerve root area, which is very common to miss out both by the radiologist, and some of our orthopedic colleagues may actually not pay attention in this area, which is highlighted with the red dot here, that this is the area which you should actually start screening your patients for radiologically before you shove them off as normal radiological findings. Otherwise, you would have actually missed a diagnosis of a far lateral disc. And unless until you have a very high index of suspicion, particularly in patients with disproportionate symptoms, excruciating symptoms. And remember, it is the exiting nerve root, dermatome and myotome that is going to get affected rather than the traversing nerve root area. Dr. Bala, would you like to please tell us some telltale signs of far lateral disc herniation for all the delegates? Where should they look? What should they look for? And how should they screen a MRI for ruling out all different kind of disc, including the far lateral disc? Dr. Bala Mulli.
Yeah, hi. Thanks, Vishal. So I think when we look at a disc, you need to look at it both in the sagittal and axial planes for any disc. And you want to look at the fragment, whether it's herniated behind the body, above the various zones 1, 2, and 3. So that is in the sagittal plane. And as you correctly pointed out in the previous MRI scan, you probably would miss it if it is not a central disc. You're looking at the central. But then as you go lateral, depending on the side of the symptoms, for example, I think this patient had a left-sided symptom, then you probably would look at the foramen. And if you just go to the teardrop appearance, if you can point out, Dr. Vishal, you can see that there will be obliteration of that on the sagittal. On the sagittal, yes. So that you probably would not see on your, when it is a foraminal and extending into an extraforaminal. A pure extraforaminal, probably you might still see the foramen. But when it is usually these discs are a bulge in the foramen going into the extraforaminal, where you will miss that on the sagittal. And axial, sometimes even the radiologists miss it because the proper cuts are not taken. So you always compare both sides. So you look at the nerve roots on the opposite side and the nerve root on the affected side, and you will find that beyond the facet, or just by the lateral to the facet, you will find this, the circle part which Vishal has mentioned. So I think these are two important things, very easily missed, commonly missed pathologies extraforaminal, both on clinical examination and also on radiology. So I think these are the two on the sagittal and lateral you must see to confirm the diagnosis.
Thank you, Dr. Bala. Very important radiological and clinical finding points where you have to see for not only the central part, the paracentral part, but also under the facet and outside the facet area, because it is very common to see not only discs which are purely far lateral, but sometimes there may be a component which is far lateral as well as paracentral. And unless until you tackle both these fragments during your decompression, you are probably not doing a complete job, and a well-done discectomy may still leave the patient with a post-operative radicular symptom, or a failed disc can easily happen because you have tackled the best part of disc that is approachable, but something that has remained hidden, and you have not paid due attention on radiological diagnosis of such patients, and you will probably have a failed surgery. And this is extremely important, like Dr. Bala mentioned, not only the central part, but the paracentral part under the facet and the far lateral part. And the only thing that you may actually see as the subtle sign of far lateral thing is the obliteration of the foraminal fat on T2 or on T1, as you can see a teardrop failure in these sagittal and parasagittal images. So this is very important to have a clinical radiological diagnosis and a very high index of suspicion in every patient, be it L5S1 or 4-5. Before you plan your surgery, before you complete your surgery, please ensure that you have looked into the foraminal zone, whether there is a part of this fragment which is going there. Now, surgically, they are different. Dr. Gautam, would you please highlight how are they different to manage? Is there a natural history which is different for them? Is there a planning that is different for them? Is there conservative trial which is different for them? Can you help us to understand what is different about far lateral disc in management, natural history, conservative trial, root blocks? What is to be targeted? Dr. Gautam Zaveri.
So the natural history actually doesn't differ from a regular disc prolapse. it does resolve with time. Like most lumbar disc prolapses, you get 80% of pain relief in 6 weeks and 90% in about 3 months' time. Patients improve. The problem with a far lateral disc herniation is that the pain is often so exquisite and the burning, etc., is so much that the patient is not prepared to wait that long in order to obtain a pain relief. If they can wait, they will get pain relief like they do in a normal lumbar disc prolapse. So, if possible, one should always try a conservative line of treatment. This is one disc prolapse where a transforaminal epidural injection or a root block injection is extremely useful. And I tend to use that very frequently in far lateral disc prolapses with very good results. So the conservative treatment in my hands for this kind of a far lateral lumbar disc herniation would involve a root block injection along with the other conservative measures such as non-steroidal anti-inflammatory drugs, gentle exercises, a short period of rest of 2 to 3 days, etc. And with all this, I would expect that about 70 to 80% of these disc prolapses will settle with time. If the patient wishes to have conservative treatment, then I think they are very much, you can offer it to them and there will be a good result at the end.
Thank you, Dr. Gautam. I think bringing out one of the most important aspects, though they are clinically different, they are radiologically subtle, but they are having excruciating pain. Even then, despite being different clinically, despite being different radiologically, the conservative trial still remains the thumb rule because the natural history of a PIVD, whether central, far central or lateral, is same. And the natural history says that most of them will resolve, and it is the right of the patient to undergo conservative treatment as the first line of treatment always. And root blocks do wonders in such cases, probably because the dorsal root ganglion is the one that is affected. Now, coming to Dr. Day, Dr. PC Day, do you think that L5S1 is a location which makes it peculiar in terms of management, be it a root block or surgical intervention or any kind of treatment that you offer? Is that anatomical location little more peculiar than any other area like L3, 4, 4, 5 disc here?
Yes. It is in comparison to the L1, the pedicle length and the facet length is that the diameter of the pars is about 70% more. So most of the time the extraforaminal disc is associated with the foraminal disc, and sometimes we extend it to the foramen to the intercanacular area or spinal area. So that is the trick that if you are going to conservative management, it is fine. Even if you are going to the block also, it is fine. But once the surgery think about, then you have to think about the approach, because you have to go to the foramen to remove the complete disc. Otherwise, the recovery will be less, or maybe the residual pain will persist.
Right. Thank you, Dr. Day, bringing out the fact that to bring out that disc, you may not be able to access from the central part of the canal. You have to go into the foramen, and taking out that disc is not an easy job unless until you either violate the facet or you take a foraminal route. A central discectomy may not help you to take care of this far lateral disc unless and until you take a foraminal route or you sever the facet joint. Dr. Gautam, you have a point to make.
Yeah, Vishal, at the L5S1 level, whenever you're looking at, can you please go back to those lovely images you had? So if you look at the image on the right where you have written lateral isolated, you can see that there is a specific disc herniation, which is a extrusion over there. Often in a far lateral disc, you like the image at the bottom where you have two arrows going at the side, it is more a disc protrusion, and there is often an osteophyte there rather than a frank disc herniation. And therefore, you should be careful in differentiating this disc protrusion from disc herniation, because if you go in thinking that this is a herniation, the outcome may not be the same. So in such a patient, if at all you are thinking of surgery, the goal of the surgery should be primarily lateral recess decompression, then to think of a discectomy per se, and you must be sure that it's not just an osteophyte, you are dealing with a lumbar disc herniation.
Very important point. In fact, I have a case that is coming up next where we have a disc herniation with a osteophyte, this lateral osteophyte, which is protruding as lateral into the exiting nerve root foramen, and just removing a soft for fragment may not suffice, and you have to do a decompression there. And as Dr. Day mentioned, that far lateral discs are challenging because number one, a central discectomy may not suffice. You have to approach this disc fragment, and to approach this disc fragment, there are only two routes. Either you sever the facet and go foraminal by doing a transforaminal interbody work, removing the inferior facet, or you stay purely lateral into the foraminal zone. Now, when you talk about foraminal zone, it is so easy to talk about it. But when it comes to L5S1, the peculiarity of this is that the whole area of reaching the foramen is blocked by all the bony margins of sacral ala inferiorly. People who have given root blocks in this zone, they know how they have to navigate their needles between the transverse process, the lateral vertebral body, the sacral foramen, and of course, all this is obstructed on the surface by the iliac crest. So imagining giving a root block here is to navigate through this small triangle. Forget about reaching here either with a tube or with an endoscope, because the maneuverability with this bone island of iliac crest, sacral ala, lateral vertebral body is not going to be easy. Dr. Day, would you agree with this, Dr. Day?
Yeah, that's a very important point. The triangle, that keeping the anatomy is very, very important. Triangle is very tight here, not in the other patient. If you are approaching the dorsal aspect, it is fine. But if you are approaching from the transforaminal, it's a bit difficult.
Right. Now we have Dr. Malcolm Pastanji with us. Dr. Malcolm, what are the challenges do you face in managing such patients with L5S1 far lateral disc, at least during the planning? What is your thought process while you're planning any kind of surgery for such patients at L5S1 far lateral disc scenario? Dr. Malcolm, for example, you're planning a root block in this area. What are the pre-operative thought process that run into your mind? Dr. Malcolm. Can you unmute, please, Malcolm, sir? Unmute, please.
Yeah, I put the transverse and dilate. Take a narrow corridor directly into the foramen, upper part of the foramen, shift the needle towards the pedicle, and then give a selective nerve block there. So transforaminally also it's quite easy to reach there, but in my personal experience with transforaminal endoscopic discectomies, I've had a very high incidence of root dysesthesia, and therefore now I'm shifted to UB endoscopic spine surgery, where I land on the alar surface, then climb up into the pedicular zone of the S1, and then from there detecting the nerve root and going by the side of the nerve root, I'm quite comfortably able to dissect out the distal fragment. Now, endoscopically, initially we were doing a lot of work by transforaminal, but it doesn't work anymore.
Right. I think this is a very important point to make. Dr. Bharat, may I come to you? Dr. Bharat Dave, can you please highlight about the challenges, anatomical challenges that you may want to circumvent during your planning phase while you're planning either a root block or any kind of surgery? What are the things that you keep in mind while planning a root block oblique surgery in such patients?
I think the first would be the patient's anatomy and patient's overall physique. That is most important, because sometimes your needle may not reach there, so you may need a long needle as well. But that is very important. I think we need to have the AP X-ray as mentioned by Dr. Amit Jala in the chat box, which is very important, because then you have to really see the Bartolotti syndrome, rule out that as well. Sometimes, as Dr. Gautam said, that it could be bony as well. So all these things, they certainly throw the challenge in management of this kind of a case. So I think the discussion is going on really well. So let's move forward. But AP X-ray is must. And I think would like to add one more thing. Dr. Arvind Kulkarni has written contralateral approach. So please try to cover when you move forward in the discussion as well.
Yes, we have that. Dr. Bharat Dave, the contralateral approach is coming up. Dr. Rajamani, would you like to highlight about the approach in root block? Like in this patient, Dr. Gautam highlighted, it's an exiting nerve root, L5 nerve root that is affected with a far lateral disc herniation L5S1. How do we target that when we are planning a root block injection? We have spoken about the anatomical problems. We have spoken about the triangle. We have spoken about the difficulty in navigating a needle there, and the tight triangle there. The navigation is difficult for a needle. What is your approach in getting a good root block injection effect there? Dr. Rajamani. Unmute, please.
Dr. Rajamani, unmute, please. Unmute.
L5S1 approaching the extraforaminal disc is always difficult, not only for injection, but also the scopic surgery, also because of the said anatomy. So you have to carefully do CT if necessary to know all the bony walls, and then you have to negotiate and then go into know the bony anatomy very well. Do an actually where the question of CT sometimes helps you more than only an MRI. So know all the bony anatomies and then go in right.
Right. Thank you, Dr. Rajamani, for bringing forward how to do a root block injection. And exactly that's what was done in this patient. A L5 target nerve root block transforaminal through the L5S1 triangle was done, navigating through it, taking a true AP view, as you can see on the second image there, where you can see the L5 vertebral body paralyzed. In lateral view, the root block was given and patient had amazing relief. Within 7 days, patient was absolutely walking, but it is on the 8th day when the patient came back again with excruciating pain of same nature. Now, Dr. Gautam, at this point, would you target going in and doing a surgery, or you would repeat a root block, or what will your approach be after a root block has failed within 7 days, or it has not worked?
So again, it would depend upon the patient. If the patient has a neurologic deficit, or if the patient is not willing to try any more conservative treatment, I would certainly offer the option of surgery to this patient. If the patient wishes to try another root block, I'm happy to do it. Just to make a point about the root block, unlike in a typical root block where you go like you would do in a posterolateral endoscopic approach, where you go almost 5 to 7 finger breadths away from the midline in order to approach the foramen. In an L5S1, where there is a large transverse process, your needle has to go in almost vertically close to the distinct. So I use a 2-needle technique. I use a thicker needle to go inside, and then use a thinner needle which is longer, which goes through that thicker needle inside that, and then I can angulate that into the foramen, and that helps in this kind of a patient as far as foraminal injection. So most of the times, if it doesn't work, it is because you've not been able to give a good injection at L5S1. However, if the patient is not willing to now wait, then a surgery would be a good option. Now, compared to a far lateral disc at L1, 2, 2, 3, 3, 4, 4, 5, the L5S1 has unique challenges. The iliac bone overhangs the approach area. The sacrum is right there below, and especially if there has been a little bit of disc space reduction, then the approach from the posterolateral side is extremely difficult in the L5S1 area. Typically, we used to use a Wilsey approach, which is a far lateral approach to going into the far lateral zone. That is wonderful at all the levels above. But at L5S1, the Wilsey approach also does not offer you enough space to get into the L5S1 far lateral disc. What the endoscopy, I have no experience, but I have read articles about posterolateral endoscopy where they make an iliac window and enter the L5S1 disc space. I'm sure Professor Day or Dr. Rajamani would be able to highlight much better on that. But at L5S1, if I'm doing a surgery which is open, it will typically, and if there is a far lateral disc, then it will typically be a resection of the facet and transforaminal discectomy with interbody fusion.
Thank you, Dr. Gautam, for bringing out the word of fusion here, because that is one very, very valid option of treating this disc. As we discussed, that to take out this disc, it is not easy to do it in a central manner. You would either have to do a foraminal route, or you will have to sever the facet, and also you may have to sometimes do a contralateral approach coming from opposite side, going all the way there if you are technically skillful enough to reach out there. Dr. Arvind, would you like to highlight, would you like to do a discectomy alone in this case from transforaminal route, or a contralateral side, or a fusion like Dr. Gautam just mentioned? Because fusion makes it safe, simple, easy, and simple job there with a predictable outcome.
So in such situations, if there is a contained disc and there is some vertical instability on flexion extension X-rays, especially a vacuum sign, which I look for, then I would do a fusion straight away. because these patients are never happy with discectomy. But this looks like a good, chunk of disc, which is an extruded fragment. It's not a contained disc. It will be lying there. You just have to pull it out. If it is not anatomically feasible based on X-rays, in terms of doing a transforaminal discectomy, so using a 14 mm tube, I have done at other levels, not at L5S1, but I have done this from the contralateral side almost at least 3 or 4 times. So you basically one who's well-versed and who's doing it regularly for stenosis, it's not difficult. I think Amit has also done a few cases. And once you remove the, the superior facet, the medial, the lateral recess on the medial side, not that much, a much more tangential way of going. So then you can get access. Then you can get access to this particular disc fragment.
Yeah, I think it's very valid option, but I think this is something works best in professionals' hand. Dr. Gautam, yes, please come forward.
Arvind, I had a question. If you go through a contralateral side, how do you determine the end point of your surgery? And how are you sure that you remove
I'll come to that. That's a very valid point, and I think the end point of decompression has to be established, and we are going to be discussing this in all the different type of options here. It's a very, very important question, and probably the last question in my slide that is coming up. Let me take this forward here. We just discussed about the challenges. We discussed about the option of doing either pure discectomy or a fusion in such cases. And we have already the house divided into discectomy versus fusion there with the challenges mentioned. And the options are so many. You can do a Wilsey approach with its own challenges of iliac crest on one side, with you'll not be able to get that angulation to reach there. Or you can do an endoscopic transforaminal approach where the navigation triangle is so tight that your scope may actually break inside. Or you can do a trans-iliac burring, or you can do an interlaminar on the opposite side. You can actually do a microendoscopic tubular docking and do a far lateral approach and do a far lateral discectomy, or Dr. Gautam Simple's easy and predictable transforaminal interbody discectomy and fusion. Dr. Malcolm Ji has a hand to it. Dr. Malcolm Ji. Dr. Malcolm, please come forward. Unmute, sir, and please let your video come up. Dr. Malcolm.
Unmute yourself, sir.
Okay, while Dr. Malcolm comes up, let us hear from Dr. Approach. Can you please tell us about the technical details of how to do a Wilsey approach based on the figure here and the challenges that you may pose?
So whether you do it a traditional open, whether you use a microscope or whether you use a tubular retractor, the approach is a Wilsey approach. It is basically a paraspinal approach, which is basically an intermuscular approach across the intermuscular plane in the paraspinal region. You go about 2 finger breadths to 3 finger breadths away from the midline, and you take a vertical incision from the transverse process at suppose you are going for L4-5, you would extend your incision from the transverse process of L4 to the transverse process of L5 about 3 centimeters. Having going in there, take an incision in the lumbodorsal fascia, and then you split the muscle rather than cutting the muscle between and go there, and you approach. Where you will approach is the base of the transverse process, or from there you dissect the entire area from transverse process to transverse process and until the lateral border of the spine, which is the facet joint laterally, the lateral gutter, which is the pars interarticularis. And so you create a whole tunnel there and you go right up to the intertransverse membrane. What then I do is that I raise the intertransverse membrane by using a thin curette below the transverse process and separate the ligament, the intertransverse membrane from the transverse process and raise it. Immediately below that, you will see a small nerve go laterally. Don't mistake that as your main nerve. That is the dorsal branch of the nerve root, which is going there. That is not the main nerve root. If you get lost there, it'll be a problem. You then approach it further, and typically what will happen is that the nerve root goes obliquely or diagonally across the square which you have created, and you have to go just below the nerve root in order to access the disc. And gradually, if you are created enough space, I don't know, somebody mentioned that Malcolm, I said, mentioned that he has seen a lot of post-operative paresthesias. And I must say that the Wilsey approach that I have been doing, I have not found that to be a problem. Occasionally, if I don't get space, there are osteophytes in that region. I take a high-speed drill and bore a little bit of the lateral border of the pars interarticularis so that I can get a direct access into the intervertebral disc space. And once you approach that, you'll easily see the disc. You take out a chunk of the disc and the nerve root is free. The result is incredibly nice.
Thank you. Thank you, Dr. Gautam. Thank you so much.
The only problem there is the advantage of using a tubular retractor is that a tubular retractor is probably the one which gives you the best retraction in that zone. It is unlike there are no other very good retractors. I do use a McCulloch retractor for which I use for microdiscectomy in that zone, but even that is not as good as a tubular retractor to do the Wilsey approach in that zone.
Thank you, Dr. Gautam. You just mentioned about the endpoint of surgery. We have been discussing about the endpoint in chat box also. Let me bring forward Dr. PC Day. Dr. Day, how would you approach this in an endoscopic manner? We just saw how a Wilsey approach would do an open conventional discectomy for this. How would you do it endoscopically and challenges and endpoint of surgery? Dr. PC Day.
Should I share this, share my screen?
Yes, show us your video and how you would do it, sir.
You have 2 minutes, Dr. Vishal.
Yes, sir. Yes, sir. We'll quickly run through this. We have a small video on endoscopy. Dr. Day will quickly summarize on this. We'll just directly go to how would you manage it instead of the anatomical part.
So are you able to see my presentation?
Yes, sir. Yes, sir.
Okay, so this is the destined technique for the extraforaminal disc herniation. That we have already discussed the foraminal, extraforaminal, paracentral, and central. And the extraforaminal disc, as we have already discussed, is compressing the exciting nerve root. And the intractable leg pain is the symptom. And the micro and tubular usual muscle splitting, that is also discussed. But what we are doing, the subperiosteal dissection from the spinous process here up to the lateral aspect of the pars. So we are approaching from the pars, but if that is associated with the disc of the spinal disc or canal disc, then we can approach the combined also without disturbing the bone. And this is the 60 years lady, occasional pain, severe radiculopathy for 4 months. Spine, the X-ray is normal. The right side herniated L4, L5 disc. This is the L4, L5 extruded, and also this is the extraforaminal right side. And this is my positioning. This is the localization. This is the disc space. We are just putting 5 to 6 millimeter cranial, 5 to 6 millimeter cranial approach. Here is the cranial. This is not the interlaminar. This is the lateral aspect of the pars of the facet. So this is you are approaching. If there is associated the spinal intradiscal canal, then we have approached from the both side also, leaving the intact bone. And we are hitting the safe zone. We are not having this C-arm continuously. Without that also we have very few instruments. And this to 20 millimeter incision, 10 millimeter away from the midline, very stable instrument by. And this is the approach from the far lateral or lateral to the pars. As Gautam mentioned, is very clearly from the transverse process to transverse process, lateral aspect of the pars, and the lateral aspect of the inferior facet, and then the lateral aspect of the facet. This is the discectomy from the outside. This is your direct approach, direct posterior approach, or you can say lateral approach, and then annulotomy, and then the remove and tilt the instrument. That is a mobile operating tube. You can tilt the whole set of instrument, go little deep, go to the foramen, sacrifice 50% of the facet, no issue, and the cranial is the nerve root. So disc here and the nerve root here. So next, patient. The another patient is this, the L5S1 right side again, and this is the again the 5 to 6 millimeter cranial to the disc space. This is the marking. We have a special localizing device to mark, and this is the dual approach. If it is necessary, dual. You can approach from the far lateral outside and also the interlaminar at the same time.
Thank you. About to finish.
Thank you.
This is the beauty of the technique. Thank you.
Thank you. Thank you, Dr. Day. Please unshare. We'll quickly run through Dr. Balamurli, who does the same surgery in a tubular fashion. Dr. Balamurli, how is it different in your approach by doing a tubular surgery? What are the advantages and your endpoint? All these 3 points, please quickly.
Yeah, just for time, I just summarize in a few points. I think everything has been described very nicely about the bony landmarks that you have to remove, the way you have to dock, and make sure that you don't go into the far cranial part of the facet joint, the pars and articulars. So I think just a couple of points, difference between the two. The disadvantages of a tube is one is it's not a familiar anatomy for a lot of tubular surgeons. One, the pathology is very rare. You don't do as much as the other routine cases. So bleeding is a problem. So you will encounter a lot of bleeding when you go, whether you go through tube or through a Wilsey approach. Eventually you'll end up with a lot of bleeding. The anatomy, identifying the intertransverse fascia is very important, entering into it. Otherwise you will cause damage and more paresthesia to the ganglion and damage to the ganglion. And the end point is you have to make sure that the fragment is removed. And if necessary, you should, kind of probe into the foramen to make sure that there is nothing missed in the foramen, because that's one or two things I've noticed, that you remove a good chunk of disc, but then you leave a small foraminal fragment which still persists with pain. I think with that, I summarize that a tubular approach is good and it has a far more advantages than the open. But yes, endoscopy is also very good with these procedures.
Thank you, Dr. Bala. Quickly, we'll go on to Dr. Ketan Deshpande for a word on why transiliac is a better option and what are the challenges of transforaminal discectomy in such patients. Dr. Ketan, are you there with us? Dr. Ketan Deshpande.
Yes, sir, I'm here. So transiliac is a direct approach to the pathology wherein you can make a hole in the iliac crest, dilate it under local anesthesia with simple dilators. And since you're going to the majority of the cancellous part of the bone, so you can directly go into the disc and remove the disc fragment without manipulation of the nerve root. But as Dr. Malcolm sir had already mentioned, UB is now gaining much more popularity because it is more like a tubular or a distendo approach, wherein use of multiple instruments with traction of the nerve root and direct visualization of the pathology is possible.
Right, perfect. I think we have covered almost everything, including the fusion part of it, which involves going in directly, sacrificing the inferior facet and taking out the disc right in front of your vision, where the end point of decompression is a direct decompression. We have discussed this. I am sure this will be very subjective in different surgeons' eyes. To summarize, in the interest of time, far lateral disc herniations are a clinical challenge. They have always been radiologically innocuous unless you have a very high index of suspicion. Keeping your mind and eyes open before you plan anything and shove it off as a normal MRI, please look into the foraminal, extraforaminal zone. You may actually be looking at a combined disc with a paracentral to a far lateral extension or a pure far lateral disc herniation. Excruciating symptoms disproportionate to the radiology is very common because of dorsal root ganglion involvement. Approach to a far lateral disc is completely different. The nerve root involved is an exiting nerve root. You have to take those into consideration. The decompression also is targeted to the endpoint of decompression of the exiting nerve root. There are various approaches involving Wilsey's approach, which usually is through the multifidus muscle there. And to go through that, you can do either a conventional open approach described beautifully by Dr. Gautam Zaveri. You can do a minimal invasive approach in the form of Dr. PC Day, where he did the Standu, showing bilateral approach both from the canal and outside the canal. You can do it a contralateral approach as discussed by Dr. Arvind Kulkarni and highlighted by Dr. Amit Jhala, where they mentioned that contralateral approach, if the disc lies up to the foraminal under the facet. However, if a disc goes beyond the facet, then extraforaminal transforaminal approach is a better way to do. Full endoscopic view as described by Dr. Malcolm Pastanji is something that you can really try upon. And Bala Murli really wonderfully highlighted the challenges that one can come across while dealing with these far lateral discs. Fusion is far more predictable. However, it sacrifices the facet there, and it has a place, like it was highlighted, that if the disc space is narrow, there are osteophytes in there, there is a vacuum sign in the disc or instability documented. Fusion is the straightforward way to go and deal with these extraforaminal disc herniations which are symptomatic. With this, I would like to hand over the proceedings back to the chairman, Dr. Bharat Dave and Dr. Rajamani.
Thank you. Would like to add a few more things. It will just take a minute. I think considering to all the discussion, I have concluded a few things. I think clinical reporting of MRI is very important. We really need to have the clinical radiological correlation. I think we should also consider the varied anatomy has been highlighted in the chat box as well, and the mobility of the nerve root has been highlighted as well very well in the chat box. I think the spine radiologist really stands a new term. I think we should have somebody who is reporting day in and out like we have at our center as well. And I think uncomplicated disc should have the rule of 90-90-90. 90% resolves in 90 days in 90% of the cases. So that's what should be clearly discussed with the patient and shared decision to be taken as concluded by Dr. Gautam as well. So I think we are about to close this case. I think what we need to have is a 3D vision for handling the L5-S1 foraminal nerve root. And I think a lot of ways to tackle that disc. I'm sure one should really master one and carry on working on the same. Now over to the second case. I think I welcome moderator Dr. Bhavuk Garg, and panelists are Dr. Rohit Das, Dr. Ketan Deshpande, Dr. Rishi Khanna, and Dr. Umesh Rikanta. Dr. Rajamani, I think you may conclude what I did in the second case, sir.
Thank you, MISSAB, for giving us this opportunity. So I will be straight away starting with the case. He's a 48-year-old farmer with no comorbidities, presented to us with mid-low back pain, with right lower limb pain radiating from buttocks to back of the right calves in 6 months, which got aggravated since last 1 month. There was a history of lifting heavy weight. The examination findings were also commensurate. SLRT was positive. So this was the X-rays, and these were the MRI, which showed that there is an extruded disc at the L5-S1, and a right-sided L5-S1 microdiscectomy was done in 2018, and the patient got instant pain relief in the post-operative period, and the patient was discharged the following day. And now patient presented to us after 4 years with the recurrence of low back pain and numbness and paresthesias in the right lower limb since 4 months, with acute exacerbation for the last 15 days, with no, the significant neurological deficit. So what now? May I ask Rishi, how will you proceed in that case? Rishi, are you there?
Yeah, I am here. Thanks, Bhavuk. Since he's symptomatic for the past 4 months, I would like to get an MRI scan.
Okay. Is it okay?
If it is only 15 days, then maybe we could have tried a conservative trial and then we could have waited. But since he's having symptoms for 4 months, I think it's worthwhile to get an MRI scan.
These are the MRI pictures, Rishi.
Yeah. So same side, L5-S1 recurrent disc herniation, unilateral laminotomy has been done in the previous surgery. And if his neurology is normal, I would proceed with the selective nerve root block as the first trial of conservative care, and then review him again at the end of 3 weeks.
Dr. Umesh, are you agree with Dr. Rishi, or would you like to do some more investigations?
So yes, it's a case of a recurrent disc prolapse, and we would like to actually do a dynamic X-ray just to look for any instability, though there are no apparent signs, indirect signs on the MRI that there is some underlying instability. So in the absence of any instability, and if the disc prolapse is an acute fragment, if like say if we many times in recurrent disc prolapses, when we investigate, we find that some of the fragment that we see on the MRI is a chronic fragment, or some part of it may also be calcified. I think that is what we need to look for, and we need to identify whether a part of it is an acute fragment. And many times in these cases, the chronic fragment may be the larger component, where there is a small acute fragment that has exacerbated the symptoms and caused a radiculopathy. Because of the post-operative adhesions, even a small fragment can cause more symptoms in these particular cases. So I think that is what I would, in addition to what Dr. Rishi said, that is what I would look for in addition. But otherwise, yes, I would agree that this patient has to go through a period of conservative management. The symptoms, radicular symptoms, have been there only for 15 days, and patient doesn't have any neurological deficits, even though the disc prolapse seems significant in a recurrent case. So a period of conservative treatment can be tried, and epidural injections can be given for pain relief.
Rishi, you want to say something?
Yeah. So a question to Dr. Umesh. So even if you plan for a conservative treatment, would you like to do an X-ray immediately, or when you plan for a surgery, would you get stress radiographs?
No, I completely agree. So dynamic X-rays will be needed when we are actually planning for the surgery. But in case if the patient is having symptoms and the patient has been having this low back pain for 4 months, for example, in a particular scenario where the patient has been having back pain for a longer period, intermittent back pain, and it more suggests like a mechanical or an instability type of pain. So in those cases, I would be more aggressive, or more, I would get an X-ray upfront. As I already told, in this particular case, it's a short history. There are no indirect evidence, or there is nothing to suggest that there is an instability in this case. X-rays are done only for to complete the workup, but otherwise in this case we don't suspect that there is any underlying instability. So if in this particular case, yes, I wouldn't rush in to get an X-ray, but I think that is to be kept in our mind as a part of the complete workup in any case of recurrent disc prolapse.
Yeah, thank you.
Ketan, you want to add anything, or you want to get any other investigation?
Yes, if the patient is symptomatic, then I would not wait for like 4 months or something, because it is a case of the patient has been already operated before. So there's already sufficient space posteriorly because laminotomy and flavectomy has been done. So I would straight ahead jump into getting an MRI immediately. Also would like to get a CT scan, because majority of these recurrent disc herniations, they have an avulged fragment of the bony avulsion of the end plate that comes along with the chunk of the nucleus, and that determines a major role when you are planning to do an endoscopic approach, because there is a bony avulsion. It becomes again a difficult thing to remove. And also would like to see an AP view of the spine, so as to know, because although this looks like the last mobile segment, so the height of the iliac crest will also determine on what kind of an approach we are planning in this case.
So we have got 3 investigations: the MRI, the dynamic X-rays, and the CT scan. Dr. Anil, you want to add something? Or is it okay with you as well?
Yeah, that's okay. But earlier you decompress this, it is better, because there is no space remaining to narrow to go. So very high chances of developing deficits.
Okay, so just for the discussion and our experience, we always get a contrast enhanced MRI in these cases, because that is very important, because it is very important to differentiate between the scar and the disc herniation. And this is the contrast enhanced MRI. If in case of a scar, actually it enhances because of the vascularity, but in a disc you can see the disc fragment clearly. So there is a routine practice, and most of these cases they also have the epidural fibrosis component. So we always get the contrast enhanced MRI for a revision case.
Dr. Bhavuk, may I add a small point? Yes, so epidural fibrosis usually symptomatic only in the early phases. So it may not be a perfect strict rule, but it's usually said that only epidural fibrosis can become symptomatic only between 6 weeks to 6 months. And that is why when you have an early recurrences, like within 6 months, there it makes it very, very important to differentiate between an epidural fibrosis and an acute disc prolapse as the cause of patient symptoms. But when it is more than 4 years, so I want to clear it from you. So when it is more than 4 years, so how much would you attribute, like say for example, even if you see an enhancing scar in this particular case, how much would you attribute the symptomatology to the epidural scar?
Yes, so I agree, but the documentation of epidural scarring is important, because the prognosis changes. The chances of complication changes when you are doing the surgery, and that you have to inform the patient about the risk of the surgery, resurgery, and that's how they can take informed decisions. So for medical legal purposes, in a patient presenting 4 years after the surgery, I think the documentation is very, very important.
I completely agree. Thank you.
So these are.
Can I add a point here?
Yes, please.
Yeah, I completely agree. Can you go back to the previous slide, please? Yeah, I completely agree with Dr. Umesh about the duration of the symptoms. But I recently had a discussion with a radiologist, and they said that you can differentiate on this contrast MRI just by looking at the amount of the T2 weighted signal there. So if the signal is uniform, then it is more of a scar tissue. And if you look at the first picture, there is a central gray dot which is surrounded by that white tissue. So if you have that, that goes more in favor of a disc. So it is a clear-cut differentiation as far as the radiological axial sections of MRI is concerned. If the signal is uniform, it is a scar tissue. If the signal is central, the gray zone with a peripheral enhancement, it is definitely a disc prolapse.
Thank you. So these are the X-rays, and as you know, all the panelists agree that there is no instability from this case. So if the patient, my question is, does the type of primary surgery affect the rate of recurrent disc herniation? Rishi, what's your take on this? Suppose if you're going for open discectomy versus the primary surgery would have been a minimally invasive, any form of minimally invasive.
No, I think the literature has stated that the incidence of recurrent disc herniation doesn't differ between the type of surgery.
Yes, Dr. Dave?
Yeah, I think there are three questions which are asked in the box and which are relevant to the current discussion. One of them is the natural history of primary disc prolapse and recurrent disc prolapse. So can you address that as well before we go into the surgical discussion?
Dedicated vehicle means I am sending by Agarwal movers and packers.
So Dr. Umesh, can you take that question? What is the natural history of recurrent disc herniation?
So I feel that the natural history in recurrent disc prolapse is similar to that of an original disc prolapse, of a primary disc prolapse. But of course, what makes a difference is the amount of chronicity of the disc prolapse per se. So even a recurrent disc prolapse, if it is acute, and if there is an acute fragment in a recurrent case, so usually they also have a very good chance of regression. But what is the difference between primary and recurrent disc prolapses is that even though, yes, I agree that one of the panelists told that there is a space that we have already created a laminar space, there is a lateral recess decompression that has been done, subarticular decompression. So there is more space for the nerve root to move around. And that is why probably smaller recurrent disc prolapse are not so symptomatic. But once these starts causing symptoms, that means once it crosses that particular threshold in a recurrent disc prolapse and causes symptoms, because of the presence of epidural fibrosis, the amount of mobility of the nerve root in these cases is less. And that is why the patient's symptoms for a similar degree of a primary disc prolapse is slightly increased or slightly more aggravated in a case of recurrent disc prolapse. And that is why more patients of recurrent disc prolapse tend to go in for a surgery because of increased nature of symptoms rather than any difference. I feel rather than any difference in the natural history per se.
And another
Ethan,
thing,
you want to add something?
Yeah, patients also, when they have found extreme good benefits with the primary surgery, so they feel that if the recurrence comes after like 4 years, 5 years, they are very keen to have the surgery at the earliest. They don't want to have a conservative treatment for a longer time.
Yeah, I think I agree to both these, the answers, but at the same time, they are more symptomatic and probably, we should really address them. I think they are less likely to regress as well, like, because of the adhesion as well. Over to you, Bhavuk. Please carry on.
Yeah. People, as the Dr. Dave pointed out, the people have compared, people have done the systematic review and meta-analysis, and they've come up, that there is no difference. The type of primary surgery doesn't affect the rate of recurrent disc herniation. Also, people have looked whether even in minimally invasive techniques, people have compared looking at transforaminal versus interlaminar. Although the dural tear was significantly less in transforaminal approach as compared to the interlaminar one, however, the rate of recurrence remains the same in all sort of the minimally invasive surgeries. So now this patient has failed conservative treatment, and on examination, the right calf is wasted, right ankle jerk is absent, right plantar flexion is weak, and the back pain is equal to the leg pain. Rishi, what will be your choice of treatment?
I would still proceed with doing a microscopic revision discectomy, because there is no obvious reasons for him to have of back pain. So I would explain him that micro discectomy would be the way to go.
So, can you share us, a video of revision microdiscectomy? I think we have a
yeah, sure. So I shared my screen. So these are the factors I take into consideration before planning whether to do a revision discectomy or a fusion. So if the symptoms are more bilateral, sometimes if the disc is quite huge, and if we go for a bilateral root decompression, I think it's better to do a fusion instead of a decompression in a recurrent disc prolapse. Patients with the big disc prolapses with neurological deficit, so they are also better done with a fusion surgery. Presence of significant axial low back pain and a demonstrable radiographic instability. Number of prior herniations. Usually in our center, if the number of disc herniation, he has come after second or third time herniation, then we proceed with a fusion surgery. Of course, patient risk factors and surgeon preference also should be taken into consideration. So my typical indications for fusion will be multiple herniations, huge extrusions, calcified recurrent discs. So if there is a suspicion of calcification in the X-ray or a CT scan, then it's better to proceed with a fusion. Stenosis along with recurrent disc prolapse. And in the AP and lateral radiographs, if there is evidence of excessive bone removed, either in the lamina or in the facet joint, again I would consider a fusion surgery. So reading the radiographs as pointed out by Dr. Umesh is very important in planning whether to go for a revision discectomy. So in this patient we can see a wide laminectomy has been done by the previous surgeon. So in this situation, if the size of disc is quite big, then one would consider a fusion surgery. Similarly, a disc herniation in the presence of an instability again would warrant a fusion surgery. And presence of vacuum sign in the CT or the X-ray images, and presence of lateral listhesis. Often we focus most of the times in the lateral images, but sometimes in the AP we can see a translation in the coronal plane, so that also would be an indication for fusion. Right. So the challenges when we have decided to perform a revision microdiscectomies, the laminotomy borders are often embedded within the scar. So the first aim is to delineate the bone margins first and then proceed to do the discectomy, and use an instrument like a curator periosteal elevator to reduce the peridural tissue adhesions from the bone before starting to use the Kerrison upcutter. And I use a lot of burr within the bone so that I don't put a lot of force to remove the bone. And the principle is to identify the normal dura either proximally or distally, identify the nerve root, and then come towards the shoulder of the nerve root to remove the herniated disc. So this is a video of a patient. He was a 28-year-old male who presented with back pain and bilateral radiculopathy initially elsewhere, underwent an L5S1 midline decompression and a microdiscectomy 6 months before, and he was asymptomatic for 2 months, and then in the last 4 months he had significant right lower limb radiculopathy, exclusive right lower limb radiculopathy, and which has worsened in the last 2 months. And these are the MRI images at the level of L5S1. We can see there is a disc herniation. He failed a trial of conservative treatment, and in the axial we can see but L5S1 level, I find that usually the space is quite adequate for us to do a revision microdiscectomy. So this is the surgical video. So the right side of the screen will be the head end of the patient. Left side of the video will be the foot end. So I have reached up to the lamina of L5. So this is the lamina of L5 towards the right side of the surgical field, and towards the left side of the surgical field is the lamina of S1. So I am using Pennybacker probe to release the adhesions from the lamina. We can see the scarred dura. So once the scar is released from, so use a periosteal elevator, gently tap it with the mallet to release the adhesions. It helps me to control the release of the adhesions in a smoother way. So then I use an upcutter to create a small laminotomy. Aim is to reach towards the lateral part of the shoulder of the nerve root over the lateral discs, and we shouldn't transgress into the facet joint or the pars region. So these are the two areas where there is a risk of introducing an iatrogenic instability. So I am releasing the deeper layers of the ligamentum flavum. So that's the thecal sac, and that's the nerve root. Right. So now I use the Pennybacker probe to push the nerve root. So we can see it is quite tight. and as I release the adhesions, and we can see the disc coming into view now. Yeah, so that's the herniated disc contained within the posterior ligament. So the rest of the discectomy is the standard one. So we use a knife to increase the size of the annular defect. Some studies have shown that if the defect is more than 6 millimeters, the chance of a recurrence is much higher. So we try to keep the size of the annular defect as small as possible. So I just rushed through the video. So as much discuss remotes, now we can see that's the thecal sac and that's the nerve roots. It's quite free and easily retractable, so which indicates adequate decompression of the nerve root. Right. So thank you, Bhavuk and MISSAB team for the opportunity.
Thank you, Rishi. May I request Dr. Umesh to share his tricks and tips regarding the managed recurrent disc herniation with endoscopic technique?
Well, Dr. Bhavuk, I think Ketan is going to talk on endoscopic.
Yeah, Dr. Ketan.
Yeah.
Okay, you've got only another 4 minutes.
So this is a case of revision recurrent disc herniation. So it's a 57-year-old female patient who had undergone L4-5 microdiscectomy in 2018. She had a recurrent disc almost 4 years later on. At the same level, with the same side being symptomatic for last 8 weeks. She had taken a root block elsewhere with temporary relief, and she came to me with these MRI pictures. Although the axial cuts, they look fairly normal, but the cuts are not taken properly. You can see in the reference image there that it's a down migrated disc herniation, and the sagittal cuts, you can see that there is a left-sided L4-5 down migrated disc herniation. With the X-ray showing this picture, there's no instability on the dynamic view, and the iliac crest is fairly low for L4-5 disc level. So instead of approaching it directly through the scar tissue, if you use a transforaminal approach here, so you can spare the scar tissue and you can explore this virgin territory of directly landing into the Campbell's triangle and going in, landing onto the disc and taking out the disc fragment without interfering with the previous scar tissue. So we put in the needle on AP and lateral view. We confirm the position under local anesthesia. We extend the needle medially. We do a discography. We put in the cannula over the needle. We confirm the position in AP as well as the lateral views. And this is the endoscopic picture. So if your needle placement is correct, you can directly go and land onto the disc fragment itself. And the only thing remaining is just to take out the disc fragment slowly as you get a verbal feedback from the patient while you're doing so. And such large chunks of disc herniation can be very easily taken out without any interference of the previous scar tissue. So that's the endpoint of the surgery. And you can actually see this small piece of ligamentum flavum lateral recess that is added. And when I lift that, you can see that the traversing nerve root is there, which is absolutely free. So visualization of the traversing nerve root is also possible. That is the amount of disc which was removed. And this is the actual comparison. So the yellow arrow there is indicating the scar of the previous tissue. The transforaminal approach will be taken almost 10 or 11 centimeters laterally, symptomatically. So just forget about the scar tissue. Completely virgin territory, go in, dock, and remove the disc fragment. Thank you.
Thank you, Dr. Ketan. Can you quickly summarize the... Yes.
Most we have got time.
Babuk, you have 5 minutes.
Yes. So, Dr. Umesh, can you quickly summarize the steps related to MIS, TLIF related to recurrent disc herniation management?
Yeah, Bhavak. I think Dr. Rishi has already covered beautifully the indications for fusion in a case of a recurrent disc prolapse. So I'm not going to touch upon that again. I think he has covered all the indications that are there. So in a case of MIS TLIF, in a case where previously either a fenestration has been done when we are approaching from the same side, or when a wide laminectomy has been done. So usually in a TLIF, we know that we make an horizontal osteotomy and then a vertical osteotomy until the lower border of the lamina. So now we have to keep in mind that the medial border or medial to the facet, the lamina is missing because of the previous defect. And that is why we just need to make one small osteotomy from the pars to the area, to the edge of the defect, to the superolateral edge of the defect over there. And once that is done, then we can disengage the entire inferior radicular process. The idea here is that the medial and inferior part of the facet is usually adherent to the dura or to the underlying nerve root. So many cases, just by gradually lifting it and just by mild twisting movements, these adhesions can be left behind, or sometimes they can come out without any significant injury to the nerve root. And then the superior radicular process is removed per se. So in a case of recurrent disc prolapse, in a case when we are doing an MIS TLIF, so there we usually have to take care about dissection in the traversing nerve root area. So where we need to retract the traversing nerve root, we have to go under it and then remove that disc fragment that is there. So I tend to usually remove any kind of an epidural scar tissue in all cases of redo surgery. But of course, if it is very densely adherent to the dura, and if it is not able to, we are not able to easily dissect it off from the dura, it is always probably it is better to leave behind a small sliver of scar tissue on the nerve root or on the dura rather than trying to completely excise it. I think the rest of the steps for MIS TLIF will remain the same. So the main difference comes in the osteotomy that we do and the amount of dissection that we do around the traversing nerve root in order to access the disc and do our interbody work. But other than that, I think the entire principles of MIS TLIF would apply for a recurrent case as well.
Thank you, Umesh. Dr. Anil, you want to add something to this MIS TLIF?
Yeah. I'm not visible.
You are visible.
Am I audible?
You are visible, you are audible. Anilji, you are visible, you are audible.
So one thing, yes. One thing I want to mention here, we should go to the history of the previous surgery, if possible, because previous surgeon might have put a lot of fat over there. It is a protocol for the few of the surgeons to put the fat, and we may get afraid of seeing that fat when you go into the intraoperative field, number one. Number two, we have to also consider that the previous surgeon might have faced a dural tear at that time, and the scar can be just a healing part of that dural tear. So any moment while dissecting the dura, if you get a single drop of CSF, the only way to prevent it is to go away from that area and try to dissect some other corner, so that, considering that this may be a previous dural tear, sometimes while operating you may see a thread or a violet color tissue which is actually vicryl used to repair the dura. The moment you see that color, you should go away from that area, considering that there was a dural tear in the previous surgery. Those things has to be kept in mind while re-exploring which way. Of course, transforaminal, you are not going in that area, but when you are doing it by MIS or by conventional method, you should keep these things in mind.
Thank you, Dr. Anil. So just to summarize.
And one more thing I would like to that I prefer to go do CT for all these patients. This CT along with the MRI will give two things, added things. Number one, many times because of recurrence, the image quality recurrence, the image quality of the MRI is not satisfactory. Maybe previous burr iron may be lying over there, which is not giving the proper image quality in MRI. And CT will also give additional information about the calcification of the disc or the end plate thickness. That's it.
Thank you, Dr. Anil. Just to summarize, the fusion is not mandatory for recurrent disc herniation, and it should only be undertaken if there is associated spinal instability, deformity, or associated axial back pain. A commonly asked question is, at what numbers of recurrent disc herniation will you consider fusion? So normally, people they can go any type of revision discectomies depending upon this thing. So the indication still remains the same if there's associated instability, deformity, or associated axial back pain. And one should also look for the risk factors which are modifiable, because these have been shown to affect the rate of recurrent disc herniation after the surgery. Thank you.
So to to conclude this session, thank you for all the speakers. Just to summarize how long after the recurrence, don't take it lightly. Because you should not be once again a feedback surgeon and you deal with the feedback surgeon. So always how long, try to locate what is the due to the pain is due to. If it is a chronic, always you need to do contrast studies to differentiate between the scar and the root compression. It is acute and good. The role of X-ray has been very well important because to rule out any disability. And once again, I always take a CT which is going to be a recurrence because the bony points are very important when you going to do a surgical approach. Everything will be a scar tissue. So identify the bone will lead you where you are going to. So most of the cases, I always take a CT to guide me to go further. And then what is the almost done earlier is very important. If the surgery is very meticulous, very limited one is done, probably your job is easy. So try to get some more details of what has been done, what technique has been done earlier, so that you can almost see what has happened. Is there any complication, as I mentioned, neural tear and whatnot. So whatever it is, don't take it lightly for different disorders, make it as a big occasion. Inform the patient very well. You may have a nerve damage, patient may have a deficit, inform earlier as on this patient. And finally, if necessary, you may have to end up in the fusion also in reference surgery. So recurrence, plan very well. Try to isolate what is the pain generator, and unless you tackle that, once again, you will become a feedback surgeon and probably somebody else will be attending. Well, we have got almost exceeding the time. So now we will go to the third paper of this session with Lumbar Disconnection Central, and moderator is Abhijit Power, and the panelists are Ajay, Krishnan, Sudhir, Niraj Vaspada, and Hari Sharma. I request David Bharat.
Thank you, sir. Can you hear me?
Thank you, Dr. Rajamani. Thank you. Over to Dr. Abhijit Pawar.
Yes, sir. Can you hear me?
Yeah, we can hear you, Abhijit. Please carry
on. So thank you, MISSAB, for the opportunity to moderate this session. Now we have eminent panelists for this session, which is a tricky session, L2-3 disc, which is usually a hard disc or a difficult disc to operate because the quadra equina ends there at the L1, L2 level. We have eminent panelists here, Dr. Ajay Krishnan, Dr. Sudhir Dubey, Dr. Niraj Vasavda, and Dr. Amit Sharma. I hope they have all joined this session. Are you all there, sir?
Yes.
Ajay?
I'm here.
Yes. Yeah, please carry on. Please carry on.
All right. So I'll just, we will start this session with some cases directly. There'll be some interactive discussion with the panelists. What will the approach toward these cases? In case the panelists have some their own cases, they can share later on. We'll start with our first case. I'll share my screen now. So large central disc L2-3 and L3-4. If it's a sacralized L5, then it can be L3-4 as well. So we'll start with this case. A 35-year-old male patient, extremely obese, 135 kgs, presented with to us with limb weakness in the left lower extremity, left claudicant pain, and significant limitations in walking distance. He was barely able to walk more than 100 meters. So panelists here, Ajay, how would you investigate this case further? A 35-year-old male, obese, limb weakness, long-standing problems.
This is long-standing problem.
Yeah.
Months together.
Say it again, sir.
So it is many months.
It's about 1.5 to 2 years. He's been treating this with conservatively with all injections and physio, Canadian national with a huge obese patient.
Yeah, so this is quite obviously a calcified disc with a fragment there as well. Maybe it's a possibility that there is a fragment there. And for these category of patients, if they have enough of back pain and the leg pains, then further investigation is the first thing is to do a CT scan. That is more important.
Correct. Yeah. Yes. Yes, Dr. Niraj is there. Any insights, Niraj?
Well, I guess I agree with Ajay. Whenever there is a chronic back pain, chronic disc herniation, first check whether it is calcified or not, may change our planning. In addition to that, of course, just to see that any subtle instabilities are there or not. So,
right,
we need to check out.
So this was his L3-4 level, and this was his symptoms. SLR positive at 30 degrees, cross SLR positive, weakness in the knee extensors and flexors. There was grade 4. Ankle dorsiflexion was also weak. Partial foot drop like picture in spite of being at L3 level. No bowel bladder complaints. And this was his X-ray, EP and lateral X-rays of this gentleman, 135 kgs obese. As you are right, you can see a calcified disc here. You can see a thin layer of calcification at the level of L3-4. And these are his flexion extension views, as Neeraj had recommended that we should have flexion extension views. So Neeraj, after seeing this, we didn't have a CT scan picture.
Okay.
What would you plan? I mean, what would be your next plan with this patient, obese patient, long-standing problems, large calcified disc at?
How significant is the back pain?
There was back pain, but his main problem was weakness and the left leg pain. Back pain, back pain. Back pain was about 3/10. You can say 3/10, not like very bad back pain.
Okay, so there are few challenges we have to consider while dealing with this kind of a central large disc bulge. See, patient, it comes primarily with radiating pain on the left side. I think it is the root compression which is bothering the patient. So I think, at this point of time, calcified disc, we have to look for that, patient is, although it is having a calcified disc, primarily presenting with the left leg pain. So I guess, I would have to consider that, would I be doing only the discectomy, or I would have to consider a fusion in this patient, because disc looks quite degenerated. But the challenges for the fusion is there is a calcified disc, so it's a stable segment, one. Secondly, if you do fusion at this level, there is a degenerated disc below subjacent level. So should we consider it or not? So considering all this fact, I think, my plan would be to do a root decompressive surgery. Any technique, you may take a micro disc, tubular disc, if you go for UBL. But I think, at this point of time, although it is obese, I would want to go for a root decompressive surgery in this patient.
All right, Dr. Dubey, are you around?
Yeah, I am around.
Yes, sir.
Yeah,
what would be your approach to this patient, large disc with L4-5 also undergone degeneration?
If there is a neurological deficits, there are osteophytes on top and bottom, minimal listhesis. You have to undergo a TLIF at this level, because that will give a neurological improvement, and it will also lead to your adequate addressing of the osteophytes superiorly and inferiorly, because a lateral trajectory will be helpful. Otherwise, the struggle will be more, and amount of residual tissue which won't be in the flush with the bony bone in the posterior surface won't be adequate. So in my thing, I will do a TLIF at this level. Lower levels, I will just do a decompression if I feel that there is on the lateral, because lower down I don't see the MRI images, but if I see a significant foraminal stenosis, I will just do a endoportal foraminal decompression. But at this level, I will be doing a TLIF.
We have already difference of opinions. Two big bosses of minimal invasive surgery giving different opinions. Neeraj Asawda goes for micro discectomy or micro decompression. Dr. Dubey is saying, and TLIF, sir, is your approach minimal invasive TLIF or open TLIF, sir?
I've never done an open TLIF in my life, man. Sorry.
Okay. All right, sir. And Amit Sharma, you're around. Amit, what would be your approach?
Yes, Abhijit. So looking at the X-ray which you showed, there is definitely some element of calcification. Though I don't feel that calcification is actually, like cause of compression. It's I think the acute on the chronic disc. So there is I think the fresh fragment of the disc has come out, and that is the cause of the patient's current symptom. Even though it must be a soft disc, but I think it will be difficult to approach it from the posterior. So an expert of endoscopic spine surgery might be able to approach this particular disc also through a transforaminal route, and maybe get away with doing just excision of that soft component of the disc, and maybe with the help of burrs, they might be able to remove that calcified part of the disc as well. However, in my hand, I will agree with Dr. Sudhir Dubey that I'll be going for a T-leaf procedure straight away. And for somebody who is 135, I'll agree that an MIS T-leaf approach will be much better compared to an open surgery. In terms of the L4-5, I think on flexion extension X-ray also it looks quite stable. I don't see any significant element of stenosis in that area. So I think we can leave the L4-5 as of now as it is and just can focus on L3-4 segment.
Right. We have the expert and transforaminal endoscopic approach expert Ajay Krishnan. Ajay, would you address this with the transforaminal approach? Can you remove this hard disk with the transforaminal approach?
Yes, I can remove this, but that doesn't make the procedure universally acceptable for anybody because this is a central compression. For this case, particularly, I would say that rather than labeling this as a disc, this is a case of ventral stenosis. Yes, you have to understand that the soft fragment is very less. You can remove very well with the anterior, but you have to do a biportal, so bilateral transforaminal approach to remove the both sides. From the one side, I cannot remove the hardened end plate spurs, which is so much visible and looks like a cauliflower. You cannot remove directly, but it is possible. I have done many and I'm able to do it.
Can we have a look at the flexion extension X-ray, Abhijit?
I would like to add here, followed by Ajay's answer. I think what we have and what we are blessed with is immediately we do the post-operative MRI, and where we are adequately able to see the decompression. And Ajay does it beautifully by biportal, and we have quite a few with good follow-up as well. So that just adds into the armamentarium that post-op MRI, immediately post-op MRI, and then we can conclude that it's all done well. Carry on, please.
Ajay, I have one question for you.
My point in this case is one, whichever surgery is done, whatever you do, either it is if it is direct ventral approach, you are able to handle it properly. But for a posterior surgery, what you are doing, there should not be any direct attempt to retract the neural tissue. Actually speaking, the central tissue is compressing the central dura and laterally displacing the traversing nerve roots. And here, if we attempt the conventional training methods of retracting and pushing the neural tissue medially and going ahead, you are definitely precipitating more amount of neural damages only. Even the best hands would create problems. So it is better to do a more wider procedure here. And you can also appreciate that there is hardly any lordosis there. So a fallback is expected less in this case.
Right. Ajay, there's one question from my side is, if your biportal approach, by both side approach, what I have found is there is huge incidence of degenerative disc disease causing severe axial back pain. It's intractable back pain. What has been your experience with that?
Back pain, if there is significant amount of back, see, this is a settling disc also.
Post surgery. I'm talking about because of the excessive removal of the disc material from the bilateral approach.
No, I have done a good number of patients who are obese also. It's not a very big problem.
All right. Okay. All right. So,
Abhijit, I would want to pitch in here. Those probably who are advocating fusion here. That's a very valid treatment. But why I choose a decompression? Maybe with any technique. You may go for endoscopy, you may go for biportal or anything. The thing which I always consider is, do we need to remove this calcified fragment in every cases? The central fragment. Clinically, if you look at this particular patient, one thing is patient is only having left-sided radicular pain, and as Amit rightly said that this could be the new fresh ruptured disc which might be leading to an exacerbation in the pain. Secondly, I think our own secretary Dr. Arvind has published a paper with good follow-up that you don't need to remove every calcified fragment present in the canal. So I guess you can probably leave behind this fragment. Fusion has its own set of problem, and when patient is not having much back pain, as I said, it's a settling disc. I would not give too much importance to lordosis also. So I think, I would still stick out my neck and would say that probably for me, decompression is the right choice of treatment.
In my cases, whenever I've done with the foot weakness, if I just do a discectomy and if I compare my results with a T-lip versus discectomy, I have found that recovery is more complete and better in cases of foot weaknesses with the TLIF procedure. And that's what I think will be the right approach, because we are addressing a 3/5 foot weakness also. And if you don't take out a calcified spur, you won't be doing an adequate job at that level.
I agree with
And
sir.
the other thing is that you can see that how the cord is wrapped around that anterior compression. So on the axial cut of the MRI, so I think it will be really difficult to kind of get anterior to the thecal sac to ensure removal of that fragment. Whether it's soft or hard, that's another matter. I mean, if we had a CT, we would have been little more confident, but you can see that here in the upper axial cut, how the thecal sac is wrapped around that anterior compression. So I don't know, without doing a significant facetectomy, how will we go lateral to that thecal sac and get anterior to it to ensure removal of the disc?
So we went ahead and did a L3 for microendoscopic discectomy with a quadrant system. We could remove the disc fragment. It was calcified disc. We used a burr to remove that calcification. Post-operatively, his radiculopathy decreased. He's improved neurologically over 3 months, but he had some persistent axial back pain, and he was overall satisfied with the outcome at 4 months. Now, after 2 years of this surgery, he has come back to me again with this MRI, with recurrence of radicular pain. Weakness is not there. Is what he had partial foot drop and knee extensors are okay, is walking well. But now he says he has a persistent radicular pain, and he is still worried about this. So with this MRI, he has come to us.
Abhijit, before you go further, what was your experience in terms of like cord retraction and doing that first surgery in terms of the decompression? Like how easy was it, and how much?
It was tough. It was a large disc, calcified. Removing that calcified fragment with the burr was a tough task. I had to retract the traversing nerve root, and so it took time. I did use keratins. In fact, I did use keratins to remove that, the calcified portion of that annulus.
How much facetectomy did you have to do?
No, I didn't do. I mean, no, we did burr the facet, but I think probably I can't exactly quantify how much facetectomy we did, but we had to retract the root significantly. That was I can tell you.
Mm-hmm.
And now this is we have the post-operative MRI here, Amit. After 2 years with recurrence of radicular pain, 2 years down the line, and there's some small persistent fragment there. You can see at the L3-4, and this is his L4-5 level.
Recurrence on the same side, correct?
Same side recurrence, and he said I was okay for 2 years, but now this is upsetting him again. He says now do something for my pain. Again, this obese patient, previous scarring with a quadrant system. What should be the approach here now? With the eminent panelists here, Dr. Dubey, Dr. Vasavada, Dr. Ajay Krishnan.
My choice was always the same in the first surgery and the second surgery. It doesn't change. Because see, you have done a good job, you relieved the patient and the outcome was good. But still, you have not taken out if you see the scan, because you have not disrupted the facets a lot, you have not really gone medially to the median aspect of the disc space, because you can do as much with retraction also. You always have a limitation. More lateral approach or a ventral approach gives you that facility that you can address that thing well. So this is, at least he had 2 years of good outcome with the minimally invasive thing. So I think it was a good job. And now he requires a TLIF again. So in my opinion, it remains the same.
Both levels TLIF, sir, or one level only? No.
One level only. I think that will give him low doses, and that is the cause. But you would have tried all the other conservative measures and all that. You did give a facet block to him anytime?
Now we are not given. We are given the option again.
So give a facet block, you will know what exactly is, which level is the cause of the pain, and then you can address it. But you have to address the same level. See what happens once the degeneration set in, until you mechanically change the thing, why it is happening at L3-4 only level. Until that you address, this degeneration will be maximum at that level only. But if you have a problem, you are seeing a disc which is worsening at the lower level, maybe 2 levels, you can do, but that will be a far-fetched thing. So better to do a facet block before doing a 2-level thing, which is there. But normally the biomechanics of your body postures are there, that the degeneration will always happen more and more at that level until you have done some corrective measures for it. So it always happens like that.
Ajay, any change in your plan? What would you?
Would be an open TLIF, what I would do for the upper level only. Lower level is nearly settled, though it seems to be a little bit stenotic, but it is no more symptomatic, I think. So that can be just accepted there and then.
Ajay, why did you say open TLIF?
Abhijit, there are 2 questions in the chat box.
Yes,
one
sir.
is the intradural approach, and second one is by Dr. Ketan Deshpande about root redundancy sign in the pre-operative MRI. I think we need to address these 2 questions, which are very important, I think relevant. Root redundancy sign.
Let's put that question to the panelist. Neeraj, what would you like to answer this question? Neeraj, are you around?
Can you show the pre-operative MRI? So on the sagittal images there, you can clearly see that the conus looks straight, but just proximal to the pathology, there is root redundancy. So if we consider that, that is firstly an outcome of a poor, it will have a poor outcome post-operative. So I think one-shot surgery should be our approach if we see a root redundancy sign in the pre-operative MRI. So that was just my point.
So Abhijit, I have no experience with intradural. Maybe Dr. Sudhir can throw a light on that. I have already in this kind of
I have never done an
test, I have no
intradural.
experience. So I have
Anybody,
no
any from the panel can take this question, intradural approach.
The intradural, this is not an intradural thing. It had a calcified component. They did this thing. So intradural, there's a rare disc which go intradurally. Otherwise, this surgery is purely an extradural surgery. We should always remember and maintain that. There is no confusion about this fact. That if this surgery is extradural, it's very rare to have an intradural disc which goes inside. And that is very rare. It happens. Means I would have seen 2 cases in so many years. So it never happens normally.
Intradural approach for going ventral
Yeah,
is
so
an
that's why
approach to decompress. It has been reported by many neurosurgical institutes, and it holds well because it avoids complete retraction. And it is good in their hands, but we don't have any experience on it.
No, but if we are discussing at a scientific forum, all disc surgeries are extradural surgeries. The problem means I have also undergone training and I saw some people addressing it by intradural approach, but that was always because you didn't do enough lateral job. And if you do enough lateral job, you will reach a space where you will be extradural and you will be able to work your way and take out the extradural disc. You don't have to do an intradural approach for a disc at all. You have to just work more laterally and wait, have patience. You will do all the patients extradurally, sorry.
Abhijit, Ajay just said that he would like to do an open TLIF. And can we just ask him, like, why not an MIS TLIF? He's 135 kg, and doing an open TLIF in this particular case will be a lot of dissection.
Ajay, can you take that question, please?
For me, for anything which is handled for a recurrence, I usually do an open only. I'm not the best MIS guy who can manage any dural tears and things by a minimal invasive approach. That's why I would take the open approach.
Okay.
Right. So after all this discussion, Dr. Dave, what is your call? Would the MIS TLIF would have been the right option to begin with for this patient? Dr. Bharat Dave, sir?
Yeah, I think my answer would be open TLIF on day 1. As I am answerable to my patient who would like to travel back to Canada, and I will make sure that I have done the adequate and enough job. So MIS TLIF, yes, one can do that as well, but I think we really are obliged to remove the fragment which is there. The only thing which is not addressed here at the same time is probably conscious narrow canal. This is not a narrow canal, but it is a calcified disc with loss of lordosis. So I think probably, you know, I will be able to jack it out, remove the whole disc, and, you know, put the adequate, sort of give the adequate decompression. So that's my answer.
That's the expert opinion from Dr. Dubey. Dr. Dubey said that MIS TLIF would have been the right choice to begin with for this obese patient with a large calcified disc.
I have a question, Abhijit. Sir, when you will be going for a TLIF procedure, now Abhijit had removed the left side calcified component of the disc substantially. Now we see still there, like on the right side, that disc fragment is still there. Would you be kind of aiming for to remove that, or your entire working area will be staying to the left side only?
So Davi, can you take that question? I mean, would you go from the right side this time, or if you do a minimal invasive TLIF for Dr.
You want to remove that right side calcified disc, or you'll just leave it as it is?
No, I think we are obliged to do adequate decompression. I repeat the same answer. You know, I think we should be removing the, you know, full fragment as such. So we should do the, you know, proper job.
Dr. Dubey, would you approach from the right side this time if you do a minimal invasive TLIF, or?
Yeah, this time I will do a bilateral this thing facet. You cannot do a bilateral minimally invasive, you have to do, because this time the right side disc has really increased, and that is a virgin area for you. So it will help you if you go from the right side, but you have to do, because the facet was not removed last time, you have to do that decompression. So your primary site of going through will be the right side, and 15 minutes of facetal decompression you will do on the left side.
That's the take-home message here.
Yeah, I think that there are two hand raised. One is Neeraj and second is Anand Naik. So can we have one from Neeraj and then followed by Anand, please?
Sir, I have two questions. One, I want to ask to Dr. Arvind, you know, I mean, what is his experience about his assessment about calcified disc? And second, to Dr. Amit Jhala, you know, how would he think OLIF at this stage, you know, when the disc is paid? So one to Dr. Arvind and one to Dr. Amit Jhala. Probably they have extensive experience in this relevant questions.
Yeah, so this is, you know, the issue of calcified disc comes usually, you know, L4, L5, L3, L4, L5S1 levels, where there is a sharp shooting, you know, radiculopathy involving one particular dermatome. So if there is some degree of discogenic back pain as well as leg pain, probably in such a situation, especially at higher levels, you have to probably do a minimal invasive TLIF. These are those, what we published our data was about this, you know, sharp shooting L5, S1 pain where there is, you know, disc bulge, but, you know, patient has a negative SLR, patient has relief on sitting, patient gets pain mainly on, you know, the extension dominant pain, that kind of a situation. But here, I think the scenario is totally different.
Dr. Anand, your question, please.
Amit Bhai, one.
Amit sir.
Can
Dr.
you
Amit
take up
Jhala.
this? Okay, he doesn't appear to be there. Dr. Anand.
Yeah, I agree with all the approaches being discussed over here for this particular case. My question is, how much lordosis can you restore by any technique?
I think Dr.
Dr.
Pawar, Abhijit,
Yes.
you can take up this question, please.
Yeah, so Anand, I mean, I cannot quantify the lordosis, but you know, once you, my take home message here is, if you prepare the disc space well and you put an optimum size cage, I mean, whatever degree lordosis, whatever 5 or 10 degrees, I think that you have to accept that. I would not go and try to achieve certain level of lordosis in this case when it's already a revision case or even in a primary case for that matter. I would not target to achieve any specific degree of lordosis with whatever cage. My target is to put optimal size cage which fits in that space and achieve whatever, accept the lordosis which I get. Anybody has any?
With that calcified disc being there,
bilateral facet removal, you will be able to achieve around more than 8 degrees of lordosis.
Anand, would you
also
do
have
anterior
expandable cage? Yeah.
I will. Different opinion for the surgical approach. It's if you look at the first pre-surgery MRI scans and all, it's a mechanical instability because of failure of disc at multiple places. And I would definitely go in from the anterior approach because I can restore the sagittal and coronal balance both equally well, and I can achieve the highest amount of correction of the lumbar lordosis. The calcified disc can be removed from the anterior approach, be it an anterior lumbar interbody fusion, be it an Olive approach, be it an X-Lift approach, if you have those specifically designed Carrison rongers and pituitaries. So I believe that by using anterior approach, you can restore up to great amount. The discectomy is more complete. And specifically in a revision now, you have already gone in from the back, the nerve roots and everything has been irritated. There will be scar formation and all. So for this particular case, you need to quantify how much nerve is damaged. And you can get that with the electrophysiological studies to see how much a nerve is damaged, how much it will recover, what are the H reflexes, what are the F waves. And troubling the nerve root again by any posterior approach, probably I will not do that. I will definitely go in from the anterior for this patient.
Yeah, I
Right,
think
excellent discussion.
we need to conclude. Do you want to conclude, and then I can take up the Dr. Abhijit?
Yes, sir. So the excellent discussion. So the whole take-home message here is, I think the MIS tail lift would have been the right approach to begin with, or open tail lift. Anand had a slightly different opinion to restore lordosis. So excellent discussion over this session. We have another case in case we have time, sir, quickly. Similar case.
No, I think we need to conclude. I think we should have concluding remark from Dr. Rajkumar, and I think then followed by I will take just 1 minute to summarize. Can we have Dr. Rajkumar Deshpande, please?
Yes, it's a very interesting discussion, very difficult case, lots of different opinions. But I just want to highlight one thing. Most of us were considering either decompression or fusion, depending on how the patient was getting evaluated from the first time onwards. But I would like to highlight one point which Anand now put it up, and to consider correction of lordosis. We have begun to understand over last decade and a half, that lordosis plays a large role in preventing adjacent segment diseases as well as prevention of recurrences. In a very heavy patient, especially with a straightened spine, and if you just do a decompression, you're asking for trouble with a recurrence. So I was just wondering, please keep in mind the possibility of having a lordosis correction in patients who have very straight spine, multi-level disc degeneration, also having facial hypertrophy, and consider whether correction of lordosis plays a role in managing such patients. Thanks, Dr. Dave.
Thank you. Thank you. I think it was a great discussion, Dr. Abhijit. I think it was.
Sir, can I ask one last question, sir? One last question.
Yeah, please.
So these patients, whenever you give them an option of fusion with the screws or minimal invasive, they are suddenly, they on back foot. I don't want implants. Young guy, I don't want this fusion or implants, and preferably I would like to. So they're inclined towards more, minimal invasive decompression surgery. So, so how do you take a call here? If the patient is more inclined towards a minimal invasive decompression, and that option is available, that MIS tail lift is a better option, but the patient is more inclined, I don't want screws in my back.
Dr. Rajamani, would you like to answer this question? Sir, you
have to unmute, sir.
The patient, it all depends on what the patient, the work demand also. The patient demand is high, probably convince the patient, then you can implant. Otherwise, don't other go just do a decompression surgery and don't bother about this lordosis. It is an office worker. That's what I will be doing.
The way out would be for Dr. Abhijit.
Yes,
the
sir.
minute you take the consent of the patient that I'm ready to accept and ready to have the second surgery, he would surrender to your thoughts, because then you are practically giving him the correct, reply for his problem and for the future ailment which he is likely to have. So probably, the best way to convince would be to get his signature on that, and he will say, okay, let me go for second opinion, or even you can refer to, your colleague as well, and among your team as well, and then, that can be taken further. So that's what we do at our center.
Last one question.
Yeah, Arvind.
I just want to ask the endoscopists how confident they are removing this, transforaminal, and what is their experience?
Shall I answer this question?
Yeah.
I would say that we means not to praise anything, but I have been seeing this with Ajay back, from his right shoulder, and I can see he's adequately able to do the decompression. And I tell you that we confirmed that in the post-operative MRI on day 1. So by portal approach, he is doing it extremely well. So I'm not saying that, it is not impossible. It is possible to do it.
So can anyone share pre-op and post-op images if they're handy? Such case.
I think by the end of this, in half an hour, we can have the images shared by probably Ajay as well. Let's see. Let's move forward now.
So 1 minute endoscope is once again a good option for this type. We can tackle very well both by any endoscope, Stendu or full endoscope is possible.
Yeah. So let us conclude now in this case. I think the house was divided between endoscopy, open TLIP, missed TLIP, all the concepts. I think at the end of the day, it's a shared decision which we should take, and that answers Dr. Abhijit's last question as well. It's a shared decision which we take. So now we are in the last case. I invite Dr. Abhay Kumar, who is going to talk about the L1, L2 lumbar disc herniation. So over to Abhay Kumar. You may invite your panelists, sir. Dr. Abhay.
Yeah, I'm here, sir. Good morning. Good morning to all my seniors and colleagues and friends. You can hear me, sir?
Yeah, please. You're live.
Yeah,
you're live.
I'll share my screen. Yeah, can you see my screen, sir?
Yes.
Yeah. I've been told, except for Satish, sir, the rest of my panelists are available for the symposium here. So there will be some overlap between. I congratulate Abhijit as well for his complicated. He presented a very complicated case. I'll present a very simple cases here, so that there are a lot of juniors here who can get much more information than rather than a complicated. Let us keep us looking at a junior level at this time. So I'll just take 2 slides to just give some introduction here. Why are we discussing the lumbar disc collapses compared to the lower lumbar disc, the upper lumbar, which is an L1, 2 and L2, 3. There are narrow spinal canals, which is because of the lamina being shorter in length and width. The upper lumbar facet are oriented more parallel to the mid-sagittal plane compared to the lower spine level. And this facetal orientation makes the corridor to the intervertebral disc very narrow. And more importantly, compared to the lower lumbar level, we have multiple spinal roots and conus medullaris there. The characteristics and the way they present is also totally different. And again, the L1, L2 level is at the junction of the thoracic kyphosis and the lumbar lordosis. And in fact, we call that as a fulcrum disc as well. Next slide is about the characteristic. Am I moving the slide? Yes, I think. Yeah. So the frequency of the disc herniations are much less, around 5% if you combine both L1, L2 and L2, 3. In fact, L1, L2, it is just around 2% of the disc herniations. So the cases are much less. And more importantly, you can see you don't feel a classical radiculopathy, particularly in an L1, L2 case, you don't see as a radiculopathy. You can get multiple radiculopathies and they might find the different characteristics. Sometimes diagnosing these are correlating with the imaging, and the symptoms might be sometimes very difficult. Again, calcifications in this are more common because of this unique anatomy, and the selection of the surgical approach will be very difficult. So with this introduction, I'll go for my first case. It's a 40-year-old patient who presents with severe back pain and buttock pain, no radicular pain, no splinter disturbances. On examination, patient had a proximal low limb weakness bilaterally. We're not sure whether this weakness was because of the severe pain. She was unable to stand or walk. No sensory disturbances. So this is the scan. I would request one of the panelists, Dr. Mascarenas, are you there?
Yeah, I'm here.
Yeah. So you want to start off, sir?
Yeah. So there is the MRI scan sagittal views, and the axial views are. I can see these views. In the sagittal, I can see that there is a herniated disc. Looks like a soft disc which has come out and has gone slightly cranially, migrated a little cranially. On the it's more central. It's like there is a component which is a little more towards the left, but it looks like it is a diffuse disc, and the sac is completely flattened. There is significant compression of the cauda equina.
Yeah. Sorry. So I'll go back. So basically, there is a small disc bulge here, but there is looks like a soft extruded fragment here, which looks like to be more on a central and a lateral side. Agreed, sir? Yeah. Yeah. Dr. Tomar, Do you have any other finding? Can you see any other finding?
More or less, I agree with Dr. Mascarenhas' findings, and I mean it's a paracentral, central paracentral type AB kind of disc, which is compressing more on the left side. And can you just tell me the duration that patient is experiencing?
So patient has been having pain for last 6 weeks.
6 weeks.
6 weeks. Patient has been on absolute bed rest for last 6 weeks. Apart from the analgesics, there is no other treatment. Someone has started some steroids, oral steroids as well. No other treatment has been given. Patient has been really bedbound for last 6 weeks, unable to stand and walk. But she's moving. Only there was a mild proximal weakness. I still felt that it was because of the severe pain she had. Okay.
Okay. Thank you.
Okay. So I'll go for the X-ray. This is an X-ray which clearly doesn't show any calcified component here. There was no calcified component. I don't have the CT scan picture. Dr. Sharma, are you there?
Yeah, I'm there.
Do you want any other? I mean, ideally a CT scan should be done for the juniors to let every patient with a upper lumbar disc. We need to do a CT scan. I don't have a CT scan in this patient.
So I don't agree you need to do for every case, okay? If you look at the MRI, it looks like a soft disc, okay? And the history itself. So, you know, everything, like you cannot ask for CT for all the cases. But if I see few things, like if I see a black disc, if I see especially if you see those patients where you have a calcification, you see there's sort of a kyphosis happening, that junction where you have the disc. These are the cases where for sure I'll get a CT scan. But looking at this one, I think it's absolutely fine not to have a CT scan until unless anyone thinks other way around. But only if I believe the things I told earlier, I will definitely go for a CT scan because it really changes the approach for these cases.
Okay, point taken, sir. Dr. Datar?
Yes.
Just initial comment, sir. Initial comment, then we'll go for the management. Yes.
So I agree with Ayush that you don't need a CT scan in all these cases. But if you see a black disc there, then there probably there's an osteophyte or something.
Yeah.
But if you have a CT scan in the upper lumbar herniations, it's much better.
Right. Okay. So, so the patient definitely required. All of you agree? Is there a role of any conservative management here? Shall we start off with you, Dr. Datar? Is there a role? 6 weeks of already conservative treatment is given. Do you still want to go ahead with any conservative treatment like injection or anything like that?
6 weeks of agonizing pain and symptoms. I don't think there is role for any kind of conservative management.
Okay. My co-panelists can pitch in anytime because it will be, there are 5 panelists. It will be very difficult for me to give equal time to everyone. So go ahead.
I differ on this. I think that there is a good lateral recess present on the left side, and with the patient, I mean, whenever he has presented a transforaminal nerve root block, will be a good option for the patient. Initial first this thing.
So even though the thecal sac is significantly compressed here, patient has severe back pain, and there is a big soft disc, and thecal sac is done, and canal has become so narrow. So you still want to try conservative treatment.
A trial will be a good choice. I mean, I've seen patients.
Any of other panelists has a similar opinion?
Yeah, so I'll say it's always good to give an option to these patients. If there's only radiculopathy or only pain, even the back pain, it does improve. We have a good series with cases with transforaminal block and published in European Spine Journal. And this is what I tell them: 1/3 of you will improve completely and never come back to me. 1/3 of you might have a small improvement, and 1/3 of you will never improve. I don't know which 1/3 you'll fall into, and that is based on our work, our publication, and this is the way I communicate to them. So it is not a bad idea to give them an option. I'm not saying let them choose. That is, it could be an option, not a problem.
Okay. Assuming that this patient, we have given a block, we'll consider this block has not worked, or maybe the patient is not willing for any further block and we want to go ahead with a definitive procedure. So go ahead, Dr. Sharma. What is your, this is a CT, this is an X-ray. I don't have any further imaging. These are the 2 imagings I have. So now
So I have gone from doing these cases open to doing these cases tubular to doing these cases endoscopy. I'll give you all the 3 which I have done in different stages of my career. So if doing open, I used to do a sort of a partial facetectomy because it was very easy to reach. I find it difficult without that, so I will do a facetectomy, and it makes it very easy to go lateral without retracting the cord. You can take out this. This is my way. Same thing I used to do with tubes. Only thing when I used to do open, most of the time I'll put a screw because you need to remove quite a bit of facet. When I used to do it with tubes, most of the time I won't need to put the screws because you can get away with doing a partial. But endoscopy is a different ball game and it really changes. In this case, I think transfemoral endoscopy will do your job, but you have to plan your trajectory very, very nicely because you have to come a very, very acute angle to get not only the the lateral part, it will even go central. So trajectory planning could be a trick. So you have to come at a very, very sharp trajectory. But I think I will go today, if you ask me, I'll go transfemoral endoscopically. I think there's a pretty good chance that we'll get the whole fragment, and that is how I will do it.
So let me go back to the symptom here. Patient has severe back pain, buttock pain, no radicular pain. There's no pain radiating to the anterior aspect of the thigh here. So why is there just back pain? You think this back pain is because of the pressure on the dura?
Yeah. So once you have the annular, the tear in the pulposus, it keeps irritating them, especially when you have a central tear. Okay, and that is that's why they get the back pain. And this we have seen, especially I didn't see all this till I was doing from posterior, but when you go trans, you see those small tears, and they keep irritating. The moment you take them and shrink it, they do improve in the back pain. So even my concept of these things, where I used to think back pain only comes from bony pathology, sort of has changed when I migrated to other pathology. So I think the back pain is coming from the central part of it, which is irritating him. The disc, there may be a fissure in the annulus, and it is just irritating, and that is causing the back. That is my opinion.
Okay, so you want to go transfemonally and take the disc out and just do the decompression, right, sir? Yeah.
Can I add something here?
Yes, Dr. Datar, go ahead.
Yes, the majority of patients who perceive a lot of back pain is because of the resistance offered by the PLL in the central part of the disc. There is only a rent on the left side, that is the cause of the extrusion, but the central, which is a broad-based kind of a herniation, it is the PLL which causes this kind of back pain. Once the PLL is breached completely, there will be no more back pain, it will all be leg pain.
Right. Are you talking about this hypertension, this part or the?
Yeah, all the central part, because that's a broad-based annular fissure. It's a circumferential annular fissure.
Right. Okay. Dr. Mascarenhas?
Yeah.
You have any other opinion?
Yeah. So going back to the conservative treatment that you said that the steroid is an option. Yes, I would say that steroid, I would counsel the patient saying that my first choice is that of surgery. But if they are not for surgery, since there is since the neurology is intact, I would still agree, go along with the patient and say that, okay, fine, let's try a epidural steroid, transforaminal epidural. Now, coming to the surgery, my choice would be that of a partial facetectomy and removing the disc fragment from posterior by microdiscectomy procedure. Here, there is not much scope for going into the disc space from posterior. Most of the time, when I'm faced with these kind of cases, the posterior space, the interbody space, is very narrow. And going in, we end up having to drill a little bit and then make space and then go in and remove the rest of the disc. So usually it is just a fragmentectomy where I remove the fragment which is inside the canal, and then if possible, I explore the disc space and remove the disc the traditional way. Now, I would always keep screws standby. If I end up having to remove most of the facet joint, then I would go in and do an interbody fusion with.
So how much of the facet you're talking about, sir? Do you use this for tubular retractor or you?
I do it micro. This one I would do it micro.
And you think you'll be able to retract the theca?
Yes.
And the nerve there.
And finer instruments with 1 or 2 mm disc forceps. But yeah, if I end up removing more of the facet, then I won't hesitate to go to do an interbody fusion with 4 screws and come out.
Can I add something? Just a small comment.
Just 1 minute, Dr. Sharma. Let Dr. Tomar answer his question. Yeah, Dr. Tomar.
Dr. Abhay, just a point about the back pain that we were discussing.
Yeah.
This L1, L2, and D12, L1 are especially very, very different in the perspective of the other discs. These are the areas where the back pain and leg pain is very, very variable. Patient symptomatology is usually not in that kind of dermatomal pattern that we usually see with the disc. So these patients we usually see, I mean, they are, even I am having a patient whom I'm going to operate. I've been trying her on conservative treatment. So these patients usually, their symptomatology is quite different, and back pain is there, which is one of the most important feature in these patients, especially at L1, L2, and D12, L1. And once the disc is and the disc material is removed, these back pains usually improves.
Okay, so any one of you among the panelists would do a bilateral decompression here? I mean to say unilateral, from unilateral decompression, laminectomy, going on the other side as well, decompression, and then plus or minus fusion. All of you in only patient needs a decompression here.
Yeah, so if I am if I'm able to remove the fragment from the left side, I will still go to the right side and explore that route and explore that space and make sure that the canal is clear. So I would go on the opposite side, on the right side also, before I close, but not a formal laminectomy. The interspinous ligament, supraspinous ligament would be preserved.
Okay, Dr. Sharma.
Yeah, so only I just wanted to add one comment. I never try to retract the dura at these cases. I make sure I do everything without retracting it till I get the disc fragment. I put if I'm doing tubular or even open, I put a pin fill just at the lateral margin, and whatever facet I have to remove, I remove. Sometimes retracting this dura could have a significant problem, and we have seen in signal drop in neuromonitoring in these cases. So I'll advise, if you're doing tubular or even open, sort of try not to retract dura, especially if you see the central things. Sometimes it could lead to a complication. It's better you take out the facet, whatever you want, and you better fuse it rather than attempting to retract. Just a comment I wanted. That is my personal experience. Other can vary from.
Okay, thank you, Dr. Sharma. Dr. you wanted to come in. Yeah.
Dr. Abhay Kumar, sorry, before we go forward, I think there are two hands raised. One is Dr. Anand Nayak, and second one was Dr. Abhijit. So can you please unmute yourself one after another? And
so my question is the pain receptors at L1-2, the annular arrangement. And in the history, you have mentioned that the patient is having buttock pain. Do you think that buttock pain is because of L1-2 or L2-3? Or is it because of L4-5 and L5-S1 bottom down there, which is showing some signs of degeneration?
Yes, that's a very important point, because as you know, there are a lot of roots there at that level, particularly the L1-2 level. So the canal is so narrowed. So it's quite possible patient present with the L1-2 and L2-3 test can present with polyradiculopathies. They can have, and I feel you might probably right there, Dr. Nayak.
Can I come in? I think that this is because of this L1, L2 disc only. This is because of the compression. This is causing that buttock pain. It always presents like this. These discs doesn't present in the typical pattern that I was talking about. These will always present with severe back pain. Sometimes they will be having calf pain. Sometimes they will be having multiple dermatomal involvement. So these patients are a bit different than what we usually see in the L5-S1, L4, L5 discs.
So what is the way to find the reason for buttock pain? How can you be very sure that this is because of L1-2?
So one simple way would be, in this case, a transforaminal injection will be a good option, as I said, because I still feel that there is a good lateral recess is still there, and this tends to heal with time. If the patient is not having, I will counsel my patient that I will give a trial, and if you don't improve, I will go in the surgery also in the same setting. So that is something that I can do. And to differentiate, this L5-S1 looks perfectly fine to me. This is not going to cause pain. I mean, this MRI, the only problem here in this MRI is at the L1, L2 levels for me.
There is some internal disruption at L4-5 as well, and that might contribute to the buttock pain.
I think let us stop. I think you're right. Your point is well taken. We probably need to know, but sometimes you fail to differentiate. So I think let us continue with the Dr. Abhay Kumar's discussion. Sorry not to interrupt you, but in the matter of time, we'll keep on debating this. So over to Abhay Kumar. Please carry on with your.
Can I ask sir one question?
Yeah.
Yes, Abhijit, go ahead.
Yes, this is to Ayush Sharma and Dr. Girish Datar. Now, at the L1-2 levels, I feel that the trajectory of the endoscope is too angled to reach the annulotomy and to remove that fragment. So you might end up not removing the fragment or do an incomplete discectomy, and patient might land up in recurrence of pain. So do you approach through the ribs, or what is your approach at this level, L1-2 levels?
Ayush, can I answer this?
Yeah, please. I wanted you to answer. I wanted.
So the best part about the upper lumbar herniations, if you are trying to approach it transforaminally, is the interpedicular distance. Shorter is the interpedicular distance. You may get away with a very steep trajectory also, because the interpedicular distance at this level will be hardly around 20 millimeters. So you're talking about 10 millimeters from midline to the ipsilateral side. So even if you're getting in at a posterior lateral entry, which is going to be a shallow entry at around 30 degrees or 25 degrees, you'll still be able to do not only the ipsilateral, but also the contralateral decompression. This is very well known. In this case, you may have a choice to enter at medial pedicular border, which we normally don't do in L1-2 because of the large thecal sac. But the thecal sac is completely pushed dorsal because of the herniation. So you have abundant room in the lateral recess so that you can enter more medial. So absolutely, there is no chance that you can miss the herniation. And the best part about transforaminal at this point is, what is the end point of decompression is when you see the ventral thecal sac. That is the end of it. You don't have to do anything more. You don't have to remove central disc. As well, if you can get in the epidural space at the margin of the annulus and the end plate, you can also do a radiofrequency modulation of the annulus, which also takes care of substantial back pain that is coming from this area.
So you mean that if we go medially, you would not encounter the ribs there?
No.
No.
All right.
D12L1, D12L1, L1, L2, I have no problems because there is a lot of kyphosis in this area.
Okay, so basically there's unanimous. This is a consensus here. This patient could have been managed well with a transforaminal approach, or lumbar microdiscectomy from one side, and maybe you can do an opposite side decompression as well. Am I correct? Dr. Dave, you want to? What is your opinion about this case? You do something different?
No, I think as we have seen, the house is divided between the two. Yeah. And as Dr. Ayush Sharma mentioned his way of tackling in the 3 stages of his career. I think one learns to, which is best in your hand, that is something which one should follow rather than, going this way and that way. And over the period, I think we have been, seeing that how the minimal invasive surgery has evolved. So I think probably at the end of the day, we should concentrate on the optimal outcome, maximum outcome with optimum tissue damage.
So Dr. Dave, this is what we did. And this is
great.
The post of MRI scan and post of this thing. Have we done anything wrong here?
I would have done the same thing. I would have done the same thing.
Okay. So this is our learning. Maybe we might learn the endoscopy and maybe avoid putting these screws in future. But this is what we have done, and I think we wanted to be decompress adequately on both sides and stabilize so that you shouldn't come back again.
Sure.
Anyone have a comment? Shall I move to the next case?
Dr. Rajamani.
One question here.
I think we have just had adequate discussion of all this one. Better time we got discussed each and every one. Rightly said, each one has to decide as per his experience, his equipments available. What all we know we cannot do sometimes. So we have to choose the scenarios and then do the list as long as possible. So with that, I think for want of time, I think better we can and then go for the next session. And on behalf of Bharat and myself, I thank Aravind and all the RNC team for giving this opportunity to share the experience and learn from each other. Thank you so much.
Thank you. I think we have case ready for Ajay to show the calcified disc as Dr. Arvind Kulkarni asked. So can Ajay share your screen, please? I think we have got that calcified disc case ready. Can you the
the
organizers, can you allow Dr. Ajay to share his screen, please? Dr. Ajay? Yeah. You can describe, Ajay. It is all explainable, but you can still take it. Hello, Ajay. Ajay, unmute yourself.
Can I just add something to this case?
Yeah, please.
Yeah, so we 6 months back we did a extensive. There was extensive calcification and big, almost like osteophyte going inside, and she was 28-29-year female, and we went transfemoral and we navigated our endoscopic work, and we could exactly see and drill out that osteophyte, and that was the best thing. I thought that is amazing. You can really do things which you never thought you were able to do. Absolutely. And we avoided the patient a fusion surgery and in 26 or 28-year-old, and she is absolutely fine, 6 months follow-up.
Yeah, sure. So let us conclude now. I think, the way forward, probably certainly MISS in selected cases. I'm sure, everyone should dwell into their own experience, the way you have done the thing in the past, and probably, time to change as well on many occasions. I think one need to master, and I think probably, we should have a group of, surgeons working together and mastering each one of these technological advances with enabling technology added as well. So thank you, Dr. Arvind, and thank you, Dr. Deshpande, for giving us the opportunity from myself and Dr. Rajamani to handle this 2 hours. Thank you.
Thank you so much.
Now this is unilateral radiculopathy, a doctor by profession himself. This is 2-level disc done with unilateral decompression.
Your screen is not visible, Ajay.
Screen is not visible.
I think the most important thing is one need to have real patience and persistence in the MISS surgeries. Yeah, your full screen, please. Full screen.
Now this is a doctor by profession, unilateral radiculopathy, both alpha and S1. We could address by the transforaminal route. The decompression is quite evident there. It takes time. Definitely it takes time than any of the other surgeries, but it works. Like this is an L3-4, this is a 19-year-old boy. He is having this L3-4. This is completely calcified disc with a complete myeloblock. You can see here you have done a bilateral transforaminal approach to decompose complete ventral stenosis. That's what I'm saying. This is not disc per se. This is actually ventral stenosis. And you have an MR myeloblock also resolved in the immediate post-operative MRI. You can see it very, very well.
I think this boy had cauda equina, Ajay. Am I right?
Yeah. These are all.
This boy had cauda equina. Arvind, this boy had cauda equina, the one previous case.
Sure. Yeah. And this one is again a paraparesis patient, L12. It's a central calcified disc, big one, higher level, conus affected. And this is again their bilateral approaches. You can see the opposite side scope in the right-sided image, which is there. And this is the post-operative image. So you can do it. Definitely it is more tiring. It taxes your hands. It takes say 1.5 to 2 hours, but it is possible. It is possible.
It's doable.
It is doable. Yeah. If you want to see a video of it, you can see these videos. You can just, as Ayush was telling, this is the end plate on the side, on the right side. It is the end plate spur which you are actually burring to thin down. And once it is thinned down, you have small osteotomes that you use to break those. This is small osteotome which goes there. You break off that small spurs which is there, and then you deliver it out. This is transforaminal. This is the ventral part. This is it. And you remove it, you are able to see the neural tissue already. This is there. It is already, you are seeing the flutter of it. You can completely remove this.
That's it. I would.
Thank you. Over to Arvind. Thank you.
Excellent, Ajay. Excellent demonstration. So thank you very much, Dr. Bharat Dave and Dr. Rajamani, both senior and very busy surgeons. Though it is Sunday, you have taken enough time. I would request you to please hang around and give your pearls of wisdom for the next few sessions. Moving on to the free paper session. This was basically to invite the young Turks to make their presentations. I would like to invite Dr. Ravish Patel from Baroda and Dr. Damandeep Singh from Punjab. Dr. Damandeep was Dr. Amit's fellow for a long time. To chair this particular session, I would request them to invite the first speaker in this free paper session. Thank you.
Okay. Thank you. Thank you, MISSAB, for giving this opportunity. Thank you, Dr. Arvind, sir. I am Dr. Ravish Patel. I'll be co-chairing this session along with Dr. Damandeep Singh. Without wasting much time, let me invite the first paper, that is a 2-year outcome of various techniques of discectomy on complication, a multi-centric retrospective study by Dr. Goparaju Praveen. Can we have the paper, please?
Coming up. Good morning, seniors and colleagues. Today I'm going to speak on this topic, a 2-year outcome of various techniques of discectomy on complications, a multi-centric retrospective study. First of all, I'd like to thank all the senior doctors that have actively participated in this multi-centric study. And I'll also like to thank my mentor, Dr. Arvind Kulkarni, sir. There is no potential conflict of interest in this study. I would like to start this presentation with this quotation. This holds true particularly in the field of medicine. Ever since the introduction of lumbar discectomy by Mixter and Barr in 1934, there has been a constant evolution in terms of surgical techniques used for lumbar discectomy, like microscopic, endoscopic, and tubular. The main goal of each technique is to relieve the patients from their symptoms without causing any complications. However, there is always a claim that one technique is better than the other technique. Is it really true? Unfortunately, there is a limited data in the literature comparing multiple techniques, especially on complications, and there is no single study comparing complication rates of all the techniques. So the authors ventured to assess the total complication rate and individual complication rates of techniques that are prevalent across the globe. The aim of the current study is to look for the total complication rate and individual complication rate in terms of CSF leak, superficial and deep wound infections, recurrence and reoperation rate, and wrong level surgeries, and to compare the complication rate of various techniques. This was a retrospective study where consecutive patients that underwent discectomy using the following techniques like open discectomy, microscopic and tubular discectomy, interlaminar and transforaminal endoscopic discectomy, and descending techniques were included in the study. These were broadly categorized into 2 groups, where minimally invasive group includes both the types of endoscopic discectomy, tubular and descending techniques, and open group includes open and micro discectomy. Each surgeon included have a minimum experience of 5 years to have a level playing field and to counter the bias that is caused due to learning curve. There is the premise was set for minimum of 2 years follow-up, and data collection was initiated in July 2019. Thanks to all the 10 centers that participate across the length and breadth of the India in this study. This study the inclusion criteria includes single level lumbar segment and age more than 15 years and failed conservative treatment were included in the study, and patients with stenosis, instability, and calcified disc were excluded from the study. These are the statistical tests that were run in p-value less than 0.05 was considered as statistically significant. These were the demographic results where the sample, it includes a huge sample size of 946 patients and male to female ratio of 1.5:1 and the mean age of 44.3. This study throws light on the total complication rate of lumbar discectomy. The lumbar discectomy as such is a procedure is thought to be the simplest of the spine surgeries, has a total complication rate of 12.89%, that too on the hands of an experienced surgeons, with the most common being the recurrence, which accounts for 5.81%, and least being the deep infection that accounts for around 0.31%, and everything else falls in between the spectrum. It would be interesting to note the total complication rate in young surgeons who recently started their practice. Coming to individual complication rate, as soon as we see this chart, one thing that is glaring at our face is that there is no technique that is devoid of complications. And also there is a certain visible pattern that is noted, that irrespective of the procedure, recurrence is the most common, followed by reoperation. These two are comparatively higher in minimally invasive group compared to open groups, whereas deep infection and wrong level surgeries are almost zero in the minimally invasive group. Coming to individual complications per se, the most common being the recurrence, then there can be many factors that can be attributed to recurrence, which includes primary stability of the segment, the size of the annular defect, the volume of the disc, and the characteristics of the patients, and so on. Second common is being the reoperation. All the causes for recurrence can be attributed to reoperation. Along with that, some other causes like non-surgical factors like age of the patient, non-compliance of the post-operative protocol can be attributed for reoperation. CSF leak, if can be a deadly complication, is zero in interlaminar endoscopic discectomy and highest in open discectomy, but there is no statistically significant difference between them. So the evidence is not strong enough to suggest that magnification plays a pivotal role in preventing dural leaks. Superficial and deep infection both are relatively very low in these techniques. This can be due to the low morbidity of the approach, the shorter duration of the surgery, and also the non-implant nature of the surgery. In minimally invasive group, the reasons for infection can be because of the contamination from the drapes or image intensifiers and procedural equipment, while the reason for infection in open groups are completely different. It may be due to the larger dead space and a wider exposure. Wrong level surgery, it is a very unfortunate event that has a far-reaching medico-legal implications. The comparison again did not reach any statistically significant difference. It is mostly witnessed in open groups, which needs verification at multiple levels, like before starting the exposure and after completing the exposure, before doing the decompression or keeping the instrumentation and all. In the minimally invasive group, it is very low or nil, as it requires imaging till the endoscope or the tube is exactly positioned over the segment of interest. Coming to limitations, the main limitation is the retrospective nature of the study, and the longer study, like 5 years, would reveal events happening at a longer follow-ups. Anatomical location of the disc was not included in this study. This is because to have a large sample size. And in conclusion, this is the first study to compare all the prevalent techniques across the globe. This proves that all the techniques carry complications, and there are minor differences in the incidence of complications. There is no statistically significant difference. Because of the huge sample size and the multicentric nature of the study, the various rates of individual complication rates provides a reference value for future studies on complications following discectomy. Thank you.
Nice presentation, Abhijit. You know what, the biggest problem with India is we really don't have a registry kind of a system where you can actually go for a real multicentric study, but very well combined data. It's really nice. It must have taken a lot of effort to combine all these surgeons, but the biggest problem is that one technique doesn't work for everyone. Right? Like Dr. Kulkarni is a master of the MIS, somebody is a master of the open, somebody is a master of the transforaminal, but very well done. I think the good part is that it was a very unbiased presentation, that the results are actually the same. So I think the take home from you all would be do the technique which causes the least complications in your setup, right? Good.
Okay, thank you for a very good presentation. I would like you to answer two of the questions. First of all, this was a multicentric study and different surgeons were involved. So I just wanted to know whether a particular surgeon is doing only one kind of technique of discectomy, or there is an overlap. And second thing is, you mentioned that it is a retrospective study, so the case selection may not be random. So how does this influence the outcome of this study?
Good afternoon, sir. Thanks for the question. Regarding the first question, we have included the surgeons who have at least 5 years of experience on a single technique, and they have been doing the same technique all over. And they're not like doing 2 or 3 different techniques in this study. And regarding the second study, as we mentioned in the limitation part of our study, the anatomical location of the disc is not taken into consideration as it is a retrospective study. But to counter this, we are doing one more prospective study is going on right now to include the anatomical location of the disc and also many other factors.
Okay. There is a question that what were the recurrence or reoperation rate between the two groups, between the different groups in your study?
Sir, recurrence and hello.
Yes, go ahead.
Yes, sir. So the recurrence and reoperation rates are comparatively higher in the minimally invasive group. This might be because of the magnification that is there in the minimally invasive groups, and also the exactly defining the endpoint of discectomy is somewhat different for different surgeons. The comparatively the reoperation and recurrent rates are less in the open groups, like open and micro discectomy.
Okay. Thank you. Now we'll move on to the next paper, that is on concurrent use of lumbar disc arthroplasty and anterior lumbar interbody fusion for multi-level degenerative disc disease by Dr. V. Anand Naik.
Morning, everyone. Today we will be discussing about lumbar disc arthroplasty and combined with anterior lumbar interbody fusions used as a treatment modality for the multi-level degenerative disc disease. So we collected data between September 2014 and April 2016, and it's a prospective study of 121 patients undergoing lumbar disc replacements and anterior lumbar interbody fusions combined together, or known as hybrid procedure. The standard ALIF procedure, the anterior retroperitoneal approach being used, and fusion was achieved with by the use of independence ALIF spacers and RHPMP2 infuse kits, and the lumbar disc replacement devices being used for LPESP, which are second generation viscoelastic devices. So the objective of this paper was to evaluate the clinical and patient outcomes based post-combined lumbar replacements and anterior lumbar interbody fusions, which are also known as the hybrid surgery for the treatment of multi-level degenerative disc disease. There are multiple class 1 studies which are available for a single level degenerative disc disease by using either and total disc replacement or an anterior lumbar interbody fusions, and all these single level studies are very well documented. The data about the multi-level degenerative disc disease is still emerging, and now with the evolution of artificial disc replacements, the design and technology, a combined approach to multi-level disease have been developed, and this combined approach is also known as the hybrid procedure. We use the standard retroperitoneal approach. That means placing an incision in the midline, dividing the rectus sheath in midline, And then most of the patients we approached from the left retroperitoneal, and in few we approached on the right side, depending on the situation. Like some people, they had previous hernia repair or previous abdominal surgeries like cesarean or some GI surgeries. So in those situations, we use the right-sided approach. We did ALIF in all patients at L5S1 and with independence cage, and for fusion we used BMP infuse, and the lumbar disc replacements was performed in around approximately 69 patients at L4-5 and in 52 patients at L3-4 or L4-5. These are some of the X-rays of after the hybrid procedure. The statistics, if you look at the statistics of the analysis of data, the visual analog scale, it improved from the pre-surgery or the baseline of 74 to 9. And if you look at the leg pain over the period of time, over the period of 5 years, that also significantly improved from 51 baseline to either 1 or 2 at different time frames of the follow-up. The ODIs, they improved from initial 44 to 6. The RMDQ also improved from 16 to 1. And if you look at the statistics summary at the in terms of the patient self-rated satisfactions, either good or excellent, we got around 85% more people. They were either satisfied and they rated themselves as excellent or good over a period of time, and that was maintained for 5 years. So as you can see in the data, the clinically reduced back pain and statistically as well reduced back pain, and they were clinically significant. There was improved quality of life and function, and the patient satisfaction was rated as excellent or good. And these results, they sustained for 5 years of the midterm follow-up. There were limitations to this study and the data collection, and not all patients were experiencing leg pain before surgery, and they have marked themselves as 0 leg pain. And in this calculation of the data, we use the interquartile range, and we thought that it will provide more information. The interquartile range, for example, for the VAS leg pain, at baseline was around 14 to 80. And this indicates that 25% of the patients, they scored less than 14, and there were 25% of patients who scored more than 80. And this can happen only in 2 scenarios: who don't have any leg pain at the baseline, or maybe in those who have some pain, too severe pain. And this second subset are the ones who will show a great improvement in terms of pain. And analysis is being considered, and both the groups being considered as a homogeneous group. The difference in at the baseline is different, and that's why it shows that the leg pain recovery is slower than for the back pain. The conclusion of this study was there is a very strong evidence, and statistics are also in favor of suggesting us that there is significant reduction of the back and leg pain. And there was significant improvements in the self-rated physical disability and function of the patient. And these results, they suggest that lumbar total disc replacements combined with anterior lumbar interbody fusion, which are also known as the hybrid surgery, is a very suitable option for the patients who are suffering from the chronic back pain and also with leg pain, and for the multi-degenerated disc diseases. Thank you so much.
I have a few questions to ask you, sir. Can you hear me, sir?
Yes, I can hear you.
So the first question is, how did you work patient selection, anterior versus posterior? How did you go about it? Your inclusion and exclusion criteria?
So the only exclusion criteria is if there is any central stenosis or lumbar spinal stenosis, or if the or if the facet joints are at grade 3 or grade 4 arthritis. They are not the candidates for an artificial disc replacements. So those patients were excluded. The second exclusion criteria was any previous surgery being performed. So these were the exclusion criteria.
So did you use a GI team for exposures, or they were done by
No,
yourself?
I do approaches on my own.
Yes, sir. Any side effects of the using of BMP tool?
There are no side effects, but
bone formation that occurs in the later stage, if it leaks out, or
yeah, absolutely. So I don't consider them as a side effect. That is one of the effects of using BMP.
Yeah.
And if you use the collagen sponge in a judicious way, because in anterior approach, you get a very wide footprint and there is a big space for the sponge to go in. So you just have to do a properly and neat packing of the BMP sponge. Don't let the sponge slip out of the cage, and don't let it go all the way up to the back. Otherwise, it may create an osteophyte at that place. I have seen infusions, the anterior longitudinal ligament, they all get converted to bone.
And my last question, sir. In your study, your the improvement rates went down over time. Initially, you had a very good 114 good results, and by 60 months, they had gone down to 80. Can you explain that?
So if you look at the data, is the follow-up. The loss in follow-up is around 11%. And if you look at 5 years, I have 97 patients in the follow-up. And there are still more to come because it's a prospective study. So if you look at the baseline, the initial 99 at 5 years, and then I have data of 97 patients. So that's why the number, if you look at the chart, it may look down. But you need to see how much percentage change is there between the initial and the baseline patients.
So my last question.
Anand, can I ask one question, please? Can I ask one question, please?
Anand?
Yes,
so
yes,
Anand, can you hear me?
Yes, I can hear everyone.
Do you use BMP in all the cases, or do you use iliac crest? What is your?
I use BMP in all my cases.
And what quantity of BMP is enough for one level ALF? I mean, small size, small BMP, or?
I use extra large kit for anterior fusions per level.
Oh, is it? So that's only in the cage, or do you pack in the disc space as well?
I use it inside the cage because if I keep it somewhere else, it will create bone over there. I don't want a bone anterior to the anterior longitudinal ligament that may cause irritation to the IVC and the structures there, the lymphatic channels as well. And I don't want to, get some sort of leak of collagen at the posterior. So don't need any osteophyte formation at the neural foramen or at the PLL.
And you had any non-union with this?
I got 100% fusion within 6 months.
Okay, it's a question and a comment, Anand. I mean, I worked with Raymond Ross, one of the pioneers for disc replacements in Manchester, and one of the originators. And we had a study done from Manchester on a 2-year and a 5-year study. I'm sure you know it because you also were part of the team. The 2-year follow-up showed good mobility on the disc, the acro disc, as well as the Charité 3. But then the 5-year follow-ups on 51 patients showed only hardly a 4-degree movement at the lumbar spine levels. So what is your comment? And is that only from our take, it was only a expensive fusion after 5 years?
Sir, those devices in that study and during that time, they were first generation devices, which were not constrained or semi-constrained devices. And the movement of those devices were too high. And over a period of time, we have seen that if we are using the first generation like Prodicel or Charité, eventually over a period of time, the movements will decrease. Whereas the physiological range of the spine movement is around 8 degrees in every direction. So what I have used is the second generation. These are single piece viscoelastic devices. They are constrained devices and the range of movement is around 5.5 degrees in every directions. We are not able to get that 8-degree movement. So we don't need excessive movement at the level where an arthroplasty is being done. So we need the limited physiological range of movements and also at the same time to get the length of the erector spinae muscles after surgery, and that should be sufficient enough.
Okay. The other important thing which we found, revision of this was an almost impossible thing for us. We had 4 cases to be revised and 3 were abandoned.
So there are two aspects to revision. One is to approach. You can go in first time is easy. It's not difficult. But to do a revision, and if you're planning to do a left lateral approach, you will you will see scarring around the ureter, and it's very difficult. You need to identify ureter. So what I do in revisions, I stent my ureter if I'm planning to do the left-sided approach, or else I can do the right-sided. The real problem is that IVC, which gets stuck with the prevertebral fascia on the vertebral body. To prevent that, I always use anti-adhesion barrier. These are PTFE Teflon coated barriers. So in revisions, if I'm anticipating another level to be done, say at L23 or L34 in future, or maybe if I'm anticipating any revision, we initially started placing these barriers. I did 6 revisions, and trust me, they were very helpful, and it peels off like the banana peel. And yes, in revision, the risk for IVC injury is always there. So you need to have a very good vascular team. You need to get the control of the IVCs, superior, infrarenal, superior to the level being operated, and also at the common iliac levels. So you need to have a very good vascular support in revisions. It's doable, sir. It's difficult, but it's doable.
Hello, Doctor. Dr. Anand, I'm from Dr. Jayesh from LCPJ. Congratulations, very nice study. Just would like to ask, I am also big fan of anterolateral approach. How did you plan your segmental lordosis correction in the multi-level pathology as a long-term outcome? And so please comment about that segmental lordosis, because by 1 olive cage at 6 degree, you can correct 3 to 4 degree segmental lordosis. What about the alif? And on comparison, what was the experience of long-term bone effusion in your studies?
ALIF, you're sacrificing anterior longitudinal ligament completely, and that's why you can restore the maximum balance through this technique. And if you look at the OLIF or the XLIF, most of the times you're not sacrificing the entire length and breadth of anterior longitudinal ligament. And second point is that, like you have clearly mentioned, that in OLIF, whatever be the degree of the cage, you will not get that amount of lordosis. So in a preoperative planning, you need to calculate all the parameters for the lumbar spine. It can be done very easily on a standing full-length X-rays, including the hip and knee. You can calculate the pelvic incidence, sacral slope, global lumbar lordosis, the segmental lumbar lordosis, and you can plan that. The only significant issue is that we are doing this planning on a diseased spine. We don't know the normal lumbar spine, or how was the patient before. Unfortunately, in our country, we don't have EOS system. But still, it's pretty much accurate that you can achieve good sagittal and coronal balance.
Thank you.
Okay, thank you, Dr. Anand. Now we
move to the next speaker, and the speaker is Dr. Nishant, and he'll be presenting his paper on percutaneous pedicle screw fixation in Carey spine. Does early MIS fixation has advantage over conservative? Dr. Nishant?
Yes, sir. My presentation is pedicle screw fixation in Carey spine. Does early MIS fixation has advantage over conservative? My guides are Dr. Varun Agrawal and Professor Somashekhar. 1% of all TB cases and 50% of are osseous, and spondylodiscitis involves intervertebral disc and joining structures. Aggressive intervention further damage the healthy tissue around the lesion. Medical disease, excellent response to antituberculous drugs. Prolonged bed rest leads to hypostatic pneumonia, osteoporosis, loss of motor function, as pointed by Jan et al. Dr. Garg et al. Pointed out that early surgical intervention to prevent bone destruction and progressive pain and deformity. MIS provides adequate stability like percutaneous, working as an internal sprinter, brace to assist in early mobilization, rehabilitation by providing rigid stabilization with early return to work and to carry on our daily activities. The aim of our study was to evaluate the role of pedicle screw fixation as a temporary fixation in tuberculous spondylodiscitis. Our objectives were clinical outcome, VAS and Oswestry Disability Index, radiological outcome, effusion and stability, mean operative time and amount of blood loss, mean follow-up, average time of healing, average time of hospital stay. So it was a prospective cohort study from March 2017 to 19 with a 1-year follow-up for 32 patients. Treated with tuberculous spondylodiscitis at a hospital. Ethical committee approval and informed consent was taken. Our inclusion criteria is progressive bone destruction tending towards deformity, spinal instability, persistent pain. Our exclusion criteria were neurological deficit, large abscess. All cases were 32 cases were performed by a single spine surgeon, and remove was done at 1 year. I would just like to share with you the surgery per se. So pedicle target is seen both in APL lateral view and pedicular axis view is taken. We insert the guide wire, we insert the dilators to clear out the soft tissue, and finally we remove the inner dilators and insert the tap. We tap only till the pedicle. Remove the tap, insert the screw. Remove the guide wire finally. If guide wire is stuck, use pliers. Advance the screw. Repeat steps on the opposite side and always check in the fluoro. So this is a trajectory of the screw. And we take a short fluoro to confirm. It gives you like a 3D image. Rod contouring if required. We do the rod passage for rod insertion. And finally put the in. Keep the rod at desired angle to maintain a sagittal balance. Repeat the rod insertion on the other side. And also break off small taps. And finally insert the contour torque. And we remove the extenders. We use the compression distraction system, and then we compress and distract as we desire. And break off the screw extenders now. And finally, we're left with a small incision, about a 1 centimeter. And we close a small stab incision with the cables and restore a good height. So now coming back to my presentation. So this is a Medtronic dilator, sir. And this is the position of the patient that we usually use. So closure, the dilators. The first case was a case of spondylodiscitis L4-5. And as we can see, sagittal non-axial view also confirms that. This was fixed with L4-5, pedicular screw fixation. And then second case was an L1, L2, spondylodiscitis. In the 3D CT, you can see that, and NCCT as well, the axial view and sagittal view. And we had a 2-level above and below fusion. And this patient at the final follow-up, which is 1 year, as shown in the figure 1K, had a wonderful fusion. From D11, D12 to. So this was 21-year-old female with a temporary PBSF. And this 1 year follow-up, the 2H figure is the first. So this was the immediate post-op, and this was the final follow-up at 1 year. The case 3 was a similar case, a spondylodiscitis. We did a PBSF. Case 4 is a 25-year-old male, and he had a fusion from bilateral D9, D10, right D11, L1, and bilateral D12, L2 with fusion. And the final follow-up, the 3H image shows a wonderful fusion. So we compared with the historical cohort by Song and Intel, and we found our findings very similar to them. The male ratio was 19:13 in our case out of 32. Song had only 22. Our age was quite younger. For us, and even our series, we had more of lumbar. And operative time was comparable. Blood loss was comparable. We were very less compared to Song. Hospital stay was just 4 days on average. Mean follow-up was 14 months to plus minus 6 days, and average time of reading was from 6 months to 1 year. So we compared the graph between song and this. The only thing that was a little bit higher on our side was the operative time. So the average VAS score pre and post operatively was 7.2 for 412. It came down to 3.8. So ODI, the Hindi version of the ODI we used, which came from almost 74 at the post-op, and then 3 months was about 40%, and finally it was 14%. So back pain resolved in 2 weeks, radiculopathy improved as well. 2 cases, both lumbar had superficial infection, and we treated with culture sensitively guided approach antibiotics. However, none of our cases had immunocompromise, any comorbidity or skip lesion in the MRI, or any failure of instrumentation, or recurrence of tegument in the final follow-up. And no hypertension and neurological deficit. So this was the CRP, ESR, VAS, and ODI at baseline level at 3 months. As you can see, they all came down at the end of 3 months. So discussion, percutaneous stabilization works as an internal sprint of base, which gives rigid support. Magrill showed that in thoracic and lumbar sign that it works like external fixator. Weisner modified the Magrill technique in respect to the change in the entry point. Fori and Gupta used the PPS subcutaneous spinal tumor, spinal trauma, and spondylolisthesis. It's popular because manual soft tissue disruption provides pain relief, improving the disability, attaining good spinal alignment, and prevention of progressive kyphotic deformity. In conclusion, PPS is a safe, minimally invasive technique, provides internal rigid stabilization of spine in pathological spine conditions, and it provides pain relief, improves disability, attains bone fusion, and prevents progression of deformity in treatment of carefully selected patients with spinal TB. It also avoids the need for aggressive surgical retrievement and early rehabilitation with improved disability and early return to work. Thank you. And my references. Thank you.
Thank you, Dr. Nishant.
Thank you, sir.
I have a few questions for you.
Yes, sir.
First of all is, how do you mentioned that one of the criteria for selection of cases was spinal instability. So how do you determine spinal instability in a patient with TB spine or a patient with infection?
So basically, if there is any, translation or any retropulsion of the fragment, usually we avoid doing flexion extension views, although it's a relative contraindication as pointed out by literature. You know, a lot of people say you should not do a flexion extension view because you can do a neurological deficit. So, but that's a relative contraindication. That's not true per se, as you can see in literature. So basically, so these were the criteria we decided, looking at if the if there was more than 50% of the vertebral height involved, based on the McAfee's criteria, all the 3 criteria which talk about the height and kyphotic angle more than 30 degrees, then you can suspect all these signs of instability. And to reply to the question by my professor and teacher, Karthik sir, very good afternoon, sir. Your question was regarding what criteria I used for basically for fusion. So per se, we use this Steffi, Brantigan and Steffi criteria. It's a very famous old criteria, and believe me, new criteria have come and gone. So the Steffi's 3 criteria still hold quite decent method to predict fusion, sir. So this was my criteria.
Good to see you, Nishant.
Oh, thank you so much. No, I actually was, I did my spine fellowship with Dr. Chhabra for this short time. Then I worked with Mr. Rizzoli.
Right, Nishant, we'll get on with the things.
So, sorry, yeah, I'm a resident now, actually.
Thank you. And we'll
no,
did you use Bridwell's criteria or any other criteria?
Oh, no, sir, we did not.
You said you used Steffi's criteria.
Yeah.
But you haven't mentioned what were the criteria and what was the assessment done.
Yes,
in terms of your
paper. No, that's criteria. Your point is well taken, KK sir. We haven't mentioned it because of short thing. We have mentioned in the paper actually that we have submitted to the journal, but your point is well taken.
Sure. Thanks very much.
So there are different criteria. Even Bridwell's, I worked with Mr. Bridwell as well. He has his own criteria to fulfill. And but I had a little difference with Bidwell's criteria, because maybe I'm old school. I found Steffi's 3 criteria are very basic criteria, where he talks about the fusion and disc thing. So, but Professor Bidwell is a legend, undoubtedly. So your point is taken, KK sir. Absolutely.
Dr. Nishant, when do you say that this is the time to intervene? When do you say that this is you said the angular instability? What if a patient presents with that? Would you give him, because most of the patients in India present at a very late stage. So would you give the patient a conservative trial before you go for surgery, or you offer him surgery at the first go? Because in India, in India, cost-benefit ratio means a lot. And temporary screws, it counts for a lot of money. Medtronic screws are not...
Excellent question. Thank you very much. I'm glad you asked me this question, but let me give you a counter argument, sir, which is the future for spine surgery. I had a patient who was a laborer, and he asking him to put a brace for 6 months. He actually preferred to do a surgery. He was back to work in 2 weeks' time, and he came back. So your point is taken that, no, I understand that it's expensive thing. You give a conservative first, but the way the PPSF works, because we even with Kartik Kailash sir, we tried that, but it was open surgery and they had a lot of superficial infections. I was a resident then as a D-ortho. So let me tell you what is the best advantage of it. I won't argue about the expense part of it, but let me tell you what is the biggest advantage. I have patients who come back and tell me, sir, I'm going back to my work. So that's the most important. These are laborers from the lower class to middle class. We have to earn our bread, unlike the American system where you have insurance backup. So the first thing they want, sir, with all due respect, sir, mujhe apne kaam pe jana hai. So I take to your point in the best spirit. So wo balance hai, main manta hu.
Very controversial thing, but
no, it's definitely the most controversial. I agree with you, sir.
The labor can't earn 60,000 rupees in 2 months' time, and so, anyways,
we are very lucky. We have a government scheme that funds it, and thanks. Government should fund the lower class first. Not the rich. I'm glad that the government is funding the lower class first, and I'm very proud to tell you the government has funded all these 32 patients.
Oh, that's good.
Every one of them.
Ratio goes out, but yes.
Well, I'll go to the healthcare system. India's healthcare system is improving. We have a long way to go. I'm not saying that. I'm not any politically motivated person, but what I'm trying to say, when you put those screws in.
My last question to you. You were putting screws. Why didn't you decompress the cord also? Why didn't you take out the muscle? You could have decompressed it and given a better result out of it.
Thank you for
last question. And then we'll finish it after this. Yeah.
Yes. Sir, most of these patients, all the patients, this were neurologically intact. And we found one thing was not every radiculopathy needs a decompression. So the counter argument to you is, then why do we in every radiculopathy we give neurotropics? I had worked with Dr. Shabda. We had 1,500 patients who were treated with pregabalin for the radiculopathy. They never need a decompression. I can give you that counter argument. So but your point is right. There is a time when you have to intervene. आप जो कह रहे हैं कि decompression का, सर वो अलग carefully selected patients होने चाहिए. आपको ये पता होना चाहिए कि when you're going to intervene. So not every, with all due respect, sir, not every patient needs decompression. But you're right. When the time comes, when there's not improvement, even after, we had cases where we had to finally go in and decompress, do the laminotomy. So yes, there'll be cases like that. I won't argue with you on that. But sir, this was a very strict criteria based. I'm not saying that every patient who walks to me, I'm going to do a PPSF and send him back for that. So we're running out of time. We'll do a randomized study. We'll do a level 1 study and we'll see how it goes. But for your point, I'll be taking it very in my next my study. I'll take it very seriously because yes, you're absolutely right. We have to make sure. With all due respect to my great legend, Professor Tully, time has changed. We cannot expect medical disease hai, lekin usko 6 mahine leta ke rakhna bhi, or when to intervene, as you said, that criteria has to be established. As such, in PPSF, to my best of my knowledge, please educate me. There is no paper published as to say when you intervene.
Right. Okay.
So, but your point will be well taken, sir. Thank you very much.
We are already getting messages. We have to move to the next study.
Thanks very much.
Dr.
Thanks for your
Naseem. Dr. Atif
Thank you very much, sir.
Paper on perspective.
Sir, I just would answer the last question. Compare the result with conservative management. Unfortunately, we didn't do that. That's one of the lacking in our study. So thanks very much for your wonderful time, and you have a wonderful day, sir. A very nice day to you, and thanks for the opportunity. Thank you, KK sir. It was nice seeing you after a long time.
Okay, thank you. Prospective comparative study of functional outcome of open versus MIS surgery in degenerative lumbar pathology by Dr. Atif Naseem.
Hello everyone. So these two images here just to show the amount of window created in an open and minimally invasive lumbar spine surgery. Myself, Atif Naseem. I am here to present my talk on prospective comparative study of functional outcome of open versus minimally invasive spine surgery in degenerative lumbar spine pathology. So here is a graph that is taken from a published paper from a global spine journal, shows the benefit zone for minimally invasive spine surgery that includes procedures in mid-zone of complexity when compared to the traditional open surgeries. So we aimed our study to compare the functional outcome in open versus minimal invasive spine surgery in lumbar degenerative pathologies. So this was a prospective study for a duration of 24 months. Various demographic, clinical, and radiological criteria were assessed at pre-operatively, after post-operative day 1 month, 3 months, 6 months, and 1 year of follow-up. Complications of infection and dural tears were also noted. Function outcomes were assessed in terms of visual analog scale, OSWST disability index, and return to work was also noted. For the final analysis, out of 488 cases, 164 patients underwent minimal invasive surgeries and 242 patients underwent open surgery available for the final analysis. Mean age group for the open was 53 and for the MIS was 52. Number of level intervened between 1 to 4 in a range. Out of them, 59.3% underwent open laminectomy and 13.6% underwent in minimal invasive laminectomy decompression. 92.4% underwent open discectomy and 87.9% underwent minimal invasive discectomy. Intra-op complication of dural tear was more in open group as compared to minimal invasive group, which was also clinically significant. And complication of infection was lesser in MIS group when compared to the open surgery group. When we look to the functional outcomes, while pre-operatively mean VAS and ODI scores were comparable for both the group, follow-up VAS scores and ODI score were significantly better for MIS group at post-operatively day 1, after 1 month, 3 months, 6 months. Similarly, ODI scores were comparable between two groups at 3 months, 6 months, and 1 year. And if we consider return to work, then it was significantly better in the MIS group when we compare to the open group. So this was a systematic review of randomized controlled trial done to find out the best of evidence-based treatment between MIS and open surgery. They concluded, even though the highest level of evidence do not support minimal invasive surgery over open surgery, but definitely the minimal invasive surgery MIS TLIF demonstrate advantage over open. Comparing open, MIS TLIF has significantly less blood loss, lesser post-operative pain and narcotic dependence, reduced day of hospitalization, reduced time to return to work, and reduced indirect cost. This was another paper published in a Spine Journal, which is also a systematic review and meta-analysis that suggests spinal fusion by minimal invasive surgery is a safe and effective procedure to treat grade 1 and grade 2 spondylolisthesis which is also providing better functional outcome. This paper is selected from this study only, which suggests incidence of dural tears in open versus minimally invasive spine surgery, and concludes minimal invasive surgery was associated with significantly lower incidence of dural tear and earlier return to work compared with the open surgery among patients with degenerative lumbar pathology. So to conclude my presentation, I would likely to favor MIS surgery since it has significant improvement in the immediate and post-op VAS and ODI, early post-op VAS and ODI scores, despite similar long-term functional outcome when compared to the open group. Also, reduced blood loss, soft tissue damage, scarring, lower incidence of dural tear and complications of infection, and early hospital discharge, recovery, and early return to work. But every procedure has their own commitment. So MIS need a strong commitment that summarized as 6T. First is target, appropriate patient and procedure selection. Second one is technology, specialized technology that enables or facilitates a minimal invasive spine surgery. Third one is technique, surgical skills and peri-operative techniques and procedures. Fourth one is training, adequate training and teaching of the surgeons and collaborating team and trainees. The fifth one is testing, critical reviews and testing of the surgical outcome in research. And sixth and the last one is talent, development of surgical talent. To end up my talk, the take-home message is the MIS approach does have an advantage of faster recovery at the cost of more radiation and steeper learning curve. And these results from an analysis of current highest level of evidence should be made clear to the patients to give them the best chance to make an informed decision when choosing minimally invasive spine surgery versus open spine surgery, particularly given the current medical advertising climate, which greatly favors the choice of MIS. So in the last, choose what works best in your hand. Thank you.
Doctor, you've compared MIS versus open. It's a very broad subject. The MIS versus open, TLIFs, MIS is better. Discectomies and laminotomies at single level, there are a lot of studies which say they have almost the equal results. You've also shown that. Otherwise, yes, MIS is the latest trend, and but comparing different techniques, for example, if you want to do a cervical discectomy from the back, it does not have better results as compared to the open ACDFs. So there are different techniques which have to be different, surgeries have different results as far as the open and the MIS goes. So maybe you can expand this study in the Indian scenario of comparing different kind of procedures, MIS versus open, discectomy, tubular discectomies, laminectomies, MIS, TLIFs, and then you move on to the cervical part. Otherwise, all right, I take your point is well taken.
Thank you, sir. Thank you so much.
Can I add just a point? So basically he has presented a gist and we have compared one against other individually, and we just published only the complication part. So it's a very big study. You see there's 488 cases with more than 1 year follow. So now we'll go with individual comparison, discectomy versus discectomy, TLIF versus TLIF. And so this was the gist he presented. So we will definitely present individual as you suggested, because that is the way forward.
One more thing in this study, the same surgeon, the difference in surgeon and the learning
Single surgeon. I'm the primary surgeon for all the.
All right. So yeah, same surgeon has to be doing this, so that makes.
And this is very important because this was a time almost 3 years back where we were doing both open and MIS, and we have gone through the phase. I cannot include any more case in the series, but this was a time we thought this is the best time to capture the data, and it was a transition phase for us when going from open to MIS. So that was the idea of doing this.
That's the learning curve that all matters. Yes. Right.
Yeah. So I have one question. So Dr. Atif, you have compared open and minimal invasive surgeries, and as rightly shown in the study that the early outcomes are better, infection rates are less, blood loss is less, and it is more of an advantage in an obese patient, where we have to do surgery with a very big incision. My question to you will be, what is your take when you are operating on a higher lumbar levels? Say, for example, L1, 2, L2, 3, when the facets are closed, would you still believe that open MIS surgery will be better at those levels, or would you go for an open surgery at higher lumbar levels?
Sir, as according to this study, we have only included the lower segments only, like below L3 level, sir. But definitely your question is good, sir. We'd also like to improve, but as I say, we are dealing with the degenerative segments only. So most of the cases we have included in our studies basically L3, L4, L5, L5, S1 only, sir. So, but definitely if we get into these upper lumbar level cases, we will also include in our studies, sir.
Yeah, Dr. Ayush, would you like to answer that?
Yeah, I can tell you, we have not done open surgery for upper lumbar level, no matter which level it is now, at least for today. Last 3 years, I think it is better with MIS, and I was part of the panelists for another case, and the same thing I can tell you now. So you know the advantage with your tube, even with a partial fascectomy, you can get away with when you're doing an upper lumbar level, and there are times where you don't have to fuse it. And if you go a step further and include endoscopy, most of the time you will get away without doing the fusion. So I think it is a bigger advantage when it comes to upper lumbar level, and that is my personal experience going through the phase of open to tubular to endoscopy now. And I think you can save the fusions when it comes to doing L2, 3, 4, where if you're doing open, you need to sacrifice those facets just to get into that disc. So that is what I will say. I think this study has a component where we have upper lumbar level. Maybe we can analyze as a subset of it, and we could give you. I think that will make a difference. Once you ask the question, I can tell you it will definitely show the difference between the two. And we do have a subset, maybe 60, 80 odd cases where we can analyze, and I can get back to you. Maybe it's a good idea to analyze the subset with upper lumbar level. It will be very interesting to see.
Dr. Jayesh, you can go ahead with your question.
Yeah, first of all, congratulations, Dr. Ayush, for this wonderful study. In SGPGI, the Sanjay Gandhi Postgraduate Institute, we are doing a systemic analysis in which we are compiling all the Indian minimal invasive spine surgery series as a systemic review, and 15 studies have been included, and 1,300 patients. We are comparing all the single level things like operative time, blood loss, fusion rate, and VAS score, ODI score. I really must congratulate Dr. Ayush that this is one of the study. We are looking for that in the systemic review. We have compared our data with the world level data, and as a primary analysis, we can conclude that it is really, really comparable with the world data, especially in fusion rate, recovery rate, and as a all the segmental correction involved. And today, I'm very happy that this kind of studies, going more and more increasing from MIS literature series from India. Really, congratulations. And definitely, I would like to contact and would like to ask to include your result in this systemic analysis also, so that we can analyze more and more.
And we will be more than happy. It will be good to contribute, and that is what we should do. And these are why these platforms are. When we know, okay, well, not only we are doing, you also doing it, will be a much greater study and the strength of the study increases if you have multi-centric collaboration. So more than happy. Let me know anytime.
Yeah, thank you. So multi-centric study is the way forward, but we have to move forward. So let me invite the last paper, precise estimation of spinal osteoporosis for optimizing minimally invasive spine fusion surgery by Dr. Yashwant.
Dear chairpersons and colleagues, my presentation is on precise estimation of spinal osteoporosis for optimizing minimally invasive spine fusion surgeries. Spinal osteoporosis is a huge global burden. Worldwide prevalence being about 20 to 30% in females and 10 to 15% in males. So it is widely accepted that spinal osteoporosis is a new pandemic. No matter how far the technical advancements take forward in minimally invasive spine surgery, it relies very much on the vertebral bone stock, which is the soil on which the spine surgeon works. And the pedicle screw, which is the percutaneous pedicle screw, is quintessential for the success of the minimally invasive spine surgery. The consequences of spinal osteoporosis are very problematic, with the implant-related complications and proximal junctional kyphosis having high incidences and having a significant burden both morally, mentally, and financially on the society and the individuals. So, a high prevalence of untreated spinal osteoporosis is mainly due to underdiagnosis. If we see, the prevalence of low bone mineral density is very high with respect to the normal population, but on DEXA scan, majority are not osteoporotic. So the apparent burden of spinal osteoporosis is much less than the true burden. The DEXA scan, which is being the gold standard for the spine, has very many limitations which are often discussed but disregarded. So the DEXA scan, which often overestimates the vertebral bone mineral density, apart from causing confusion among patients and clinicians due to the site-related discordance. So it is a need of the hour that we should have a precise estimation of the vertebral bone mineral density to handle this pandemic. So coming to the trabecular bone, which is the main spotlight of this spinal osteoporosis, because it carries the majority of the physiological load, almost 80%, even more in elderly. And also it is the bone which is involved the most in the fragility fractures and implant-related complications. World Health Organization, when it formulated the guidelines citing DEXA for the gold standard for spinal osteoporosis, has clearly stated that for the time being, it has established DEXA because it was the dominant technology back then. And it also suggested for future considerations in terms of site and technological advancements for further diagnostic purposes. But nothing has been done globally for a better evaluation of spinal bone mineral density over the years. So we hypothesize that the QCT, which is the quantitative computed tomography or CT bone densitometry, is more precise for diagnosing the spinal osteoporosis than the DEXA scan. So ours is a prospective comparative study comprising 718 postmenopausal women who underwent the BMD estimation as a part of preoperative screening for osteoporosis. They were randomly assigned between QCT and DEXA, and almost 447 underwent QCT and 271 underwent DEXA. Between both the groups, the age distribution was similar, and the mean ages are being almost same. So the groups are age matched. And there is a significant difference between the QCT and DEXA group with respect to the means and modes of the T-scores. And there was very high statistically significant difference between the T-scores obtained by QCT and DEXA group, with the p-value being less than 0.0001. And the bell curves are plotted to illustrate the distribution of the T-scores, clearly depict that peak of the QCT curve is in osteoporotic zone, and the peak of the DEXA curve is in osteopenic zone. And the proportion of the normal individuals is much less in the DEXA, much high in DEXA group than the QCT group. So almost 60% of the those who are screened by QCT are osteoporotic, 37% are osteopenic, and less than 5% are normal. In DEXA scan, 30% are osteoporotic, half of them are osteopenic, and almost 20% are normal. So this apparent spinal osteoporosis is just the tip of an iceberg. So the optimum trabecular bone density estimation is very much essential, and it's critical for the success of the minimally invasive spine fusions, because this is the main spotlight in this context of spinal osteoporosis. And it is the zone of the compression fractures, pedicle screw loosening, progressive kyphosis, sagittal imbalance, and back pain. The DEXA, on the other hand, it gives both the cortical and trabecular bone mineral density, that is the integral bone mineral density, and it gives the aerial estimate of the bone mineral density. But density is the volumetric measure. Also in AP, the sclerotic bone of the posterolateral elements and the abdominal aortic calcification often overlap the vertebral body. In lateral, the rib and iliac crest overlap the vertebral body. Also, the fat overlap, apart from the patient positioning, affect the estimation of the vertebral body bone mineral density. Precisely, the trabecular bone mineral density is being compromised. The recent evidence from the literature suggests lumbar DEXA doesn't represent microarchitecture of the trabecular bone, and it is not a reliable tool for the evaluation of bone quality in spine. This is based on a micro-CT ex vivo study. Also, in osteoporotics, the implant failures and vertebral fracture rates are significantly higher after fusion surgeries. So the QCT enables us to focus the region of interest on the desired trabecular component of a specific vertebra. So it is more precise. It gives the volumetric measure of the density, and the trabecular bone is mainly focused. There is no discordance-related confusion. It's not affected by the bony overlap or fat. The radiation exposure, which is often the concern for many critics, is also comparable to the thoracic and lumbar spine radiographs, and the cause of DEXA and QCT being comparable. We conclude stressing for the need to cultivate a new protocol for the estimation of spinal osteoporosis to expand the utility and scale up the success rates of minimally invasive spine fusion surgeries. The DEXA had already played its part in making spinal osteoporosis a pandemic by underestimating it. The QCT, on the other hand, provides more precise estimation of the trabecular bone mineral density and is a reliable alternative to DEXA. Thank you.
Thank you. Thank you, Dr. Yashwant. It was an interesting paper. And
yes.
As rightly pointed out, there are many times when we see that DEXA scan, because it takes into consideration cortical bone also, sometimes it underestimates osteoporosis in many patients. And I think it will be interesting to see wide adoption of QCT in future. So we have a very, we don't have a time left. So we'll just take one question. Yes,
Ravish, can I just make one comment, a general comment, please? Now, we talked about the anterior surgery, the disc replacements and things. There are a lot of youngsters who are watching here, and we have done quite a bit of that. I just want to caution, medico-legally, I checked with my legal department at the university, we are not okay to do it alone, the exposure, however well-trained we are. So in our university, we are very clearly told that we have to add a general surgical name or a vascular surgeon's name or a urologist's name. And this is from our legal department. So they don't wash up with me, but they definitely, they are the next theater. We have the fortunate to be working in the university. So I get their name to be on. So I thought I'll bring this point in for a lot of our younger audience who are listening to it. So that I don't know whether it's correct or not, but I'm subject to correction from others.
Okay, we still have a few minutes to ask a few questions. And sir, Dr. Kailash, very good point. I did ask this question to the presenting author. Sir, do you get a general surgeon along? Yes, there are surgeons who do it alone, but we always get a general surgeon along so that, we never have this medical legal issue. I'll be very frank, I sometimes do intradural tumors and I have my neurosurgeon friend whose name comes in before me. So because medico-legally, it'll be a big issue for this intradural thing. So yes, you're right. Interior exposures, peritoneum opened, sir is online. I'm sure he'll add a point on this.
Precisely, very precisely what KK sir has told. You should have a vascular surgeon for the medico-legal purposes. His notes should be there. And it's a collaboration of the spine surgeon, the vascular surgeon, or the GI surgeon who should work together. Absolutely agree. All my patients, all my records, my GI surgeon and vascular surgeon is always on standby.
As far as the QCT, I'll ask you a question about the QCT, the availability, the cost, and your change in plan. If there is a difference between the DEXA and the QCT, what is the clinical significance of this difference between the DEXA and the QCT? The clinical,
regarding,
I understand the preciseness, I understand all that. How does it change your plan now? There is osteopenic in this, and there's suddenly slightly, osteoporotic in that, because I presume every lady above 55 to be osteoporotic, above 50 to be osteoporotic. we take them as osteoporotic.
Yes, yes. So I see 3 questions here. I'll answer them one by one. Regarding the availability, it is in the city of Mumbai, it is pretty much available in the bigger hospitals with a good imaging department. I consulted some of the radiologists, and they told me that getting QCT is not a different thing. So one thing is, when you are getting a CT machine, we can get the phantom, which is needed for that calibration of the bone mineral density and all. So we can get it with a few extra money. It's not too much. They said it will be like, it might cost some 5 lakhs extra, or maximum 10 to 15 in some places. And in long term, it will definitely help, because CT machine is not just used for the bone mineral density. It is used for vast conditions nowadays. So the availability is not an issue. And the second question is regarding the cost. It is around 1,500 to 2,200 rupees, which is the same cost of the DEXA scan in the Mumbai. So even in the periphery of Mumbai, we have seen centers where the DEXA scan costs like 2,300, 2,500. But in the center of Mumbai, we have QCT costing around 2,000 rupees. So it's like almost comparable. And regarding the third, how it changes our plan, because we are detecting more patients. Definitely, it's like almost 20% more patients we are uncovering them, and they are known osteoporotics. So one thing is, we can include them in the perioperative anti-osteoporotic medication, and we can take care regarding this any augmentation techniques in the intraoperative thing. And one more thing is, while doing the post-operative or any follow-up scans for the treatment assessment, so we found out that suppose in a post-operative case, when there is an implant, we cannot do DEXA scan. Obviously, it gives falsely elevated bone mineral density to the implant. But QCT we can do. We are actually doing the study now, and we are still the study is in progress. So in post-operative patients, we can do this QCT scan, and we can focus the region of interest on the trabecular bone of the vertebra where there is no implant. And we can even get the bone mineral density accurately in the post-operative case. So we think it is better than DEXA.
Because I doubt whether we have that in Ludhiana at this point of time. I'll ask all my radiologist friends. I've not used it so far, but I'll ask all my radiologist friends today itself whether you have the QCT thing.
Sure, sir, because we have to ask radiologists, because without we asking them, they don't advise all this. So obviously the patient is ours. So it is our headache to get QCT to the patient.
Yeah.
If it is very much.
Your point is well taken. Yeah, I'll ask my radiologist friend to get this phantom thing done.
Yeah, we have few questions from the faculties. Dr. Rajakumar Deshpande, sir, please, can we have your question, please?
Yes, it's a very interesting session. I really like the way the young guys are attacking this field, this particular basic science part of using QCT or using pedicle screw fixation in patients with tuberculosis. Anand Naik's very advanced disc replacement, etc., are food for thought. The reason I wanted to raise my hand was the following. Anand, you're very right, and I congratulate you on your paper, is the fact that a vascular surgeon or a GI surgeon presence is a must. Don't take it lightly, guys. A problem can yield you in a big situation, and if you don't have support, I have seen the case go south in one of my colleagues in other hospital in Bangalore. Please don't do that and get into trouble. Second thing is, Ranjit had asked about anterior cervical approach. No, there is no need for a vascular surgeon. Anterior cervical is different than anterior abdominal approach. And a congratulatory message to the doctor who presented this QCT. QCT is a very interesting method, and I hope many guys in India work on this and give more specific data regarding osteoporosis than just the DEXA scan, which most people use, and very difficult to have assumptions. Thanks for presenting your papers, guys. I appreciate it.
We have Dr. Zuberi to ask a question and followed by Dr. Ajay Krishnan.
Yeah.
Dr. Zuberi, sir.
Dr. Yashwant,
Yes, sir.
did you compare the DEXA and the QCT in the same patient, or they were different patients with these?
They were different sets of patients.
But then,
because we
did
could
you
not
ever do
both in the
that,
same
both the tests in the same patient? Because then only you can assess whether the two modalities are showing enhanced perfection versus the other. Because the patient may be a sedentary worker and may show high incidence of osteoporosis on QCT, whereas it may not be on a DEXA. So, and we all know that CT is far more precise for any bony pathology as compared. So, are we overdiagnosing osteoporosis? That was the thought that
yes, sir, because
so if you have the same patient where you do both, then you can actually compare the two modalities. Here you are not comparing the same patient. So that's my question. Have you done that? And if not,
yes, sir, we have. We did not do it in this study, which include the 700 odd patients. We have done this in quite a few patients. Like whenever there is bone pain in post-operative, like it's not reducing, and they are shown normal in DEXA preoperatively. And within a short span of 1 year gap, we have found that there are some like in all the patients which we have scanned, which we thought of scanning both DEXA and QCT, we found that definitely the QCT is the bone mineral density is much lower than the DEXA, and it is coming into the osteoporotic zone. The study is underway, but sample size is still, we are building it up. So we did it in just 5 to 6 patients for now, and we are still doing it.
Thank you.
Dr. Ajay Krishnan, sir.
Thank you.
For the matter of the study, probably this is not a prospective study which you got an approval and sequentially followed it through. Probably these were all cases which you evaluated for your lumbar spine itself, and in those cases you managed to get the quantifications. Is it so?
We did it for these for those cases which we have we are planning for fusion surgeries.
Yes.
So
otherwise what happens is that when you are involving this group of patients for prospective study, there is a good ethical question that comes, because the principle right
yes,
now
there is.
LARA principle, as low as possible radiation doses, that is must, LARA concept. And that doesn't follow. Even yes, you do a CT scan in the Western world, I'm talking in the Western world where they are so cautious about radiation. Even if you have to do a specific CT scan, you cannot just write lumbar spine CT scan. No, you have to write for 2 vertebrae, 1 disc. You have to mention that much. And just for the information and making it more elaborated, a CT scan for 2 vertebral body and 1 disc radiation is equivalent to 190 X-rays, chest PA X-rays. So that's one is the amount of the radiation which is there. So here it is, nobody is questioning us. So that happens. But when it comes through the ethical way, it will be questions once you put it in the ethical committee.
My point is that in QCT, the radiation is very low, because one thing is we are doing some the phantom calibration and selective imaging of the particular region of interest, and the radiation exposure in a 3D QCT scan comes down to a normal thoracic or lumbar spine X-rays. So some people say that it is even equivalent to a mammogram. So in a mammogram will have a radiation exposure of around 500 microsieverts. And that is almost same for the QCT, because it ranges from 500 to 700 microsieverts. So it is the data and everything is given by the radiologist itself.
I went through your sheet that shows that 700 millisieverts is what is required for a CT scan.
Microsieverts.
Microsieverts. So it is not that it's not like that. Once you evaluate for a CT scan of the lumbar spine, and when you are doing for QCT, these are both different.
Okay, but the radiologists, according to their literature, even they say that the radiation is not a thing for QCT, because even the time of scan is around 2 to 3 minutes. So that's what they are saying.
I may be missing out something.
Yeah, so can I make a point? This is out of the paper thing. So this was not experimental at all. It was a prospective study, and this QCT was not done as an experimental study. Wherever this was done, this particular in our hospital for 15 years, we've been doing QCT only for bone density, and it is not experimental. It's done as an investigation of choice. And these are 3 sections that they take at each vertebrae. So the 3-slice CT done with the low CT dose, and it is called automatic precision time. So the exact time that is needed to take these particular shots is as minimal as possible. So the dose is very minimal. And you see, if I'll show you some cross sections of CT scans where the aorta is totally a thick core of calcium, and
Yes.
you will be puzzled whether the patient has gone for DEXA of aorta or DEXA of the vertebra.
Yes, yes.
See, so many times it happens that you come out of surgery in a patient who has not been investigated earlier, and you tell the relatives, "Inka हड्डी बहुत कमजोर है, इनका scan करके we need to treat." Then you see in the clinic, so it is just -1 or it is plus sometimes, and you're surprised. So there's so much discordance, in what you discussed earlier and later on.
DEXA is the most fallacious report we all follow.
So
we all agree.
So we have seen scores like -6, -7 in patients with QCT. And for us, anterior column is the most important, whether it is fractures, whether it is pedicle screw, anchorage, sagittal imbalance. It is all the anterior column, and we miss it because of the sclerosis in the posterior column.
Dr. Amit Sharma has just raised his hand. Dr.
Arvind, as you are here, actually, I happened to read your article as well. The only thing I wanted to ask, so the QCTs were done in a particular subgroup of the patient, and DEXA was done in another group of the patient. There was no patient who had both the investigations done, correct?
Yeah.
So how did we come to the conclusion that QCT was better in terms of diagnosing the
So it was the same community of patients with the age matched and sex matched. It is a large volume, which you cannot miss. It is something like 450 and 250. And so in those patients where inquisitively you got DEXA and QCT done in the same patient, where there was a high suspicion that these patients had osteoporosis, we could see a remarkable difference. Like it used to be -1, 1.5 in DEXA, and something like -3 on QCT. So this was because the intraoperative field gave a totally different perspective, because of which they underwent a QCT later on. But these groups, we couldn't do it same patient because it was ethically not right to get them go through double radiation.
So basically, one population average to another population average.
Yeah.
Okay.
Age matched and sex matched, almost the same age and sex, and all probably South in Bombay population, elderly and all the postmenopausal women.
Yeah.
Do we have any other questions? Somebody just yes, sir.
One comment, Arvind. I think if you have done age and sex matched cohort, then you should have had the same number. So you have 440 in the QCT and you have lesser number in DEXA. So maybe that would have more weighted that you have the same number in both.
Yeah. So, but look at the remarkable difference in the mean, as well as the mode. The most recurring QCT number was -3.8. So here it was something like -1.7.
So it could be more stark then once you have lesser number compared with the lesser number on DEXA.
Possibly.
Okay, thank you all. Thank you all the speakers. Thank you, Damandeep. Thank you all the faculties for asking the questions. And now, I'll hand over to Dr. Arvind Kulkarni, sir.
So thank you, Damandeep and Ravish. So now we move on to the next session, which should be chaired by Dr. Jayesh and Dr. Ketan Deshpande. Dr. Ramchadda is stuck somewhere. So thanks both the young guns, Damandeep and Ravish, for moderating the last session. Lunch goes with the flow. So please carry your plates in front of the screens. And I would request Dr. Jayesh and Dr. Ketan to go ahead.
Yes.
Thank you for the opportunity, sir. Thank you.
Yeah. So very good afternoon to all. First of all, I would like to extend my sincere gratitude and thanks to Dr. Arvind and Dr. Deshpande and MISSAB, all the senior guys, to provide this opportunity to be a part of this wonderful session we are enjoying since morning. And so we have seen various kind of disc prolapse and management options discussed by all the stalwart. Then we have seen 4 and 5 interesting case session and interactive discussion. Now we are moving forward for very, very interesting case sessions, and it has a list of 4-5 cases, and stalwarts of panelists and faculties are there. Good afternoon, Dr. Ketan, my co-chair. Welcome you. You can start the session and move forward. Dr. Ketan.
I would like to request Dr. Nitin Gaur to start with the first case. That will be unilateral L4-5 stenosis. And as you go along, you can introduce the panelist as well.
Good afternoon, all of you. It's been a wonderful session. So, can I share my screen?
Yes, yes, please.
Yeah.
Yes, sir, yeah.
Okay. So, good afternoon to all my panelists. So, I'll be starting with I have 3 cases lined up. Let's see how many we can finish. So, unilateral lumbar canal stenosis, not very uncommon, but at the same time a bit challenging compared to bilateral stenosis. So this is a 70-year-old female patient, and she presented with left lower limb pain for the last 8 months. And the pain was predominantly when she was sitting, standing, walking. And it was relieved on taking rest. And she did have lower limb pain, which was much more than the low backache. The predominant symptom was actually left lower limb pain. On examination, she did not have any spine tenderness, but she did have moderate left sacroiliac joint tenderness, and there was slight restriction of SLR. And she had no deficits, and she had mild scoliosis. She was walking comfortably. The only complaint she gave was from the entry to the hospital to the OPD chamber, she started having pain and numbness in the left lower limb. So she came with the MRI scan, and I would put up the MRI scan, and I would request Dr. Subir to comment on this scan. I have put up only T2 sagittal and eggshell images. Dr. Sudhir, please.
Yeah, so here we have, I think, an L2-3 disc and L4-5 disc on the sagittal T2. A lot of multi-level degeneration. And there seems to be, I'll just remove this. Okay, so we have a significant lateral canal stenosis at the L5. So probably it's the L4-5 that I'm seeing here.
Yes, it is the L4-5.
Part of the pedicle, slightly oblique cut. So the left lateral canal stenosis seems to be stenosed with some facetal hypertrophy as well. So clinically, I think it would fall into a lateral canal stenosis on the left side at L4-5, causing L5 radicular pain, as far as I'm concerned.
Right, precisely. So I just want to ask, I mean, when such a scan comes in front of us, what exactly is the thought process going on when you see a patient, elderly patient with such a scan, but predominantly when there is a left-sided unilateral stenosis, so significant stenosis? What all things you start thinking?
Right. So the first thing is the duration of symptoms. She has been having this problem for 8 months. It is not something that has started last week or 2 weeks back. So that means she probably is significantly disabled.
Yes.
Sometimes the number of consultations that these patients have already done also tells you that this has been going on for quite some time. Patient is trying to search for, as commonly, that I want a non-surgical alternative. And she has probably visited orthopedic surgeons, pain physicians, 1 or 2 spine colleagues, and then probably has reached you. So that gives you a sense that this patient is having significant trouble. The problem is significant and I need to help her. So the next step would be to confirm whether I am at the right level or not. And in that scenario here, we are looking at a single pathology. Sometimes we have an L4-5 and L5S1. And in those cases, we may have to start confirming by doing maybe a root block, diagnostic block or something. So I would prefer to stop here, I think, because that is the thought process that goes. And another one thing I think you missed out was the duration of claudication. I always tend to ask a walking duration and a standing duration. So if the patients typically say, "Sir, मैं आधा घंटा चल सकता हूँ या चल सकती हूँ," then that patient is not so disabled. But if you ask that patient, चाय बना सकती हैं आप? तो कि नहीं सर, चाय बनाते बनाते भी मेरे को बैठना पड़ता है. And if it's a male, I typically ask them, "Can you stand while you are shaving your beard?" So these two questions tell me that how much disabled the person is for his day-to-day activity of living. And that gives me a sense that if these two basic activities are not possible without sitting, that person needs surgical intervention, and then it's a green light for me.
I think that's a very important clinical history, that each patient has their own work profile, and what works for a housewife may not be so significant for a laborer or for a very high active professional. Yes, Dr. Pai.
I think we also, before deciding anything, we should get X-rays, maybe a standing X-ray and a dynamic views. Because I think lateral stenosis may be one part of it. Yeah. Okay.
So I would request you to go through them. I'm sorry for the lateral. The lateral X-rays are the dynamic flexion extension. I'm sorry for the image quality. The first one.
I don't think there is any instability. Maybe before having any decision on this, one would like to obviously see the X-rays and that there is nothing else. Also, I think since you have mentioned that she has some sacroiliac tenderness, I would also think that she has a combination of both lateral recess stenosis as well as some sacroiliac pain also along with it. So might as well think of giving some differential SI block or transforaminal block to assume and have a prospective thing of how much relief she's going to get after surgery.
So I think that is another very valid point. And sacroiliac joint pain, I have felt that is quite often missed. It is underdiagnosed condition, and especially in elderly women. It is very important because sometimes even after the surgical procedure any intervention, we may find that the patient continues to have significant pain.
Yes,
it is a very important confounding factor, and therefore it is very important for all of us to pay very specific attention on this. Dr. Varun, would you like to comment regarding the X-ray? How much importance do you give to the scoliosis part? Because in elderly patients like these, we do tend to have significant lumbar degenerative scoliosis. So what importance do you give, and how do you take that into your decision making?
So in this case, like Dr. Pai said, that there is no instability, frank instability on the flexion extension, but I beg to differ. See, the big osteophyte which we can see on the AP view is a clue that there has been some sort of a micro instability, and this is the body's response to that micro instability. It is trying to autofuse itself. So that is one thing which we need to keep in mind. So there is some sort of micro instability present, and a little bit of scoliosis at that level also may be contributing to narrowing of the foramen and the lateral symptoms. So one should be aware of all these things while evaluating and making a decision for surgery perhaps.
Dr. Varun, you have raised a very important point. Yes, Dr. Subhi. Yes.
Yeah, there's one more thing. Perhaps if you look at the AP, I think there's a partial sacralization on the left side.
Yes, yes.
So that may be responsible for an exaggerated SI joint mobility on the left side, along with a slightly hypermobility at the L4-5 facet proximally. So a little bit of a shift in motion because of a partial sacralization might be responsible for why the patient is getting a unilateral lateral stenosis at L4-5 and why the patient also getting some sacroiliac pain on the left side.
Also, I think there is a chance of far out syndromes, looking at there is a, as you said, asymmetric narrowing of the L5S1 far out area. And I think about the upper area L3-4, it is on the right side. The symptoms are on the left side.
Yes, they are on the left side.
So the upper osteophyte, I think it's a stability thing over there. So I don't think that is the cause for any symptoms on the left side.
Yes, Dr. Jayesh.
Dr. Nitin, I would like to ask the question here because here the clinical presentation is, or you have described a left lower limb pain and SI joint. In radiology, if you see the MRI, axial MRI, can you do that axial MRI? We can see here here exactly at left side. Also, there is a foraminal disc. We can see that is second. That is also foraminal disc, and exactly at same left side L4-5 there is a osteophytes, means facetal arthropathy. And third thing is SI joint. So here I would say symptom is very important. Dermatable distribution of radicular pain. Where is exactly? Is it L3? Is it at L5 level or SI joint? What is predominant? Means on examination.
Yes, it is the L5 radiculopathy.
That is
yes. It was only on examination that she had some tenderness in the SI joint. She did not give any history of early morning stiffness, or she did not give any history of initial movement being very painful or difficult. It was only on examination.
Right. So means we can come to one level out of 3 that we have to focus on L4-5 because SI joint pathology is mild, so we can think on conservative even for L2-3 as there is a no growth instability. Carry on for further discussion.
Right. So, Dr. Amit, I'll just come to you. Before that, I would like to ask Dr. Varun, because he raised a point about this micro instability and osteophyte, because this is very important for all of us. That this is the X-ray. This is what is there in front of us. Now, if you mention that this is a factor of micro instability, it is very important for all of us, especially the youngsters, to decide whether this patient requires fusion or not at a later stage. So I think what you made the point that there is a micro instability. What is the clinical significance in your decision making for this patient? How do you decide?
Yeah, so like we have to correlate everything with the symptoms. We don't operate on radiology.
Absolutely.
And like you pointed out that she has symptoms around L5, and like Dr. Subir has pointed out that you can see some sort of sacralization happening there. I would say like a Bertolotti syndrome, where the transverse process is now fusing to the sacrum, and that is leading to her back pain and symptoms on that side. So even though there is a micro instability kind of a picture, and we need to rule out her symptoms are whether they are correlating with her radiology, and accordingly decide what level we should be offering the treatment. Because as you can't go on fusing the entire spine, especially in a degenerative condition.
Yes, Dr. Amit. Point well taken, Dr. Varun. Dr. Amit, you had to make some comment. Okay, I think he had raised his hand. Dr. Amit, are you there? He's raised.
Dr. Jayesh who was speaking.
Okay, no, he's raised his hand here. So fair enough. So
I'm sorry about that. It was for the previous auth.
Okay, fair enough. So apart from these imaging, the dynamic X-rays and the MRI, is there any additional evaluation which you would recommend for this patient? Radiological. I'm asking about radiological.
If you are thinking of doing a surgical procedure, a CT scan.
Okay, fine. Patient is in the OPD as of now. We have seen her for the first time. And yes, Dr. Subir.
Yeah, so typically in all my patients who are 65 and above, despite having a normal deep tendon jerks and everything being normal, we always tend to get a whole spine screen MR done.
Okay.
So many times these 78-year-old ladies have a cervical spondylosis, which is bad. And you don't want them to become quadriplegic after a lumbar spine surgery.
Right.
So always rule out a cervical concomitant early cervical myelopathy, even if it is not present on a clinical grounds. Rule it out by a whole spine screen and make sure that these patients are safe enough to be turned prone and do a routine lumbar surgery.
Yes, absolutely. I think that's a very good point. every elderly patient, what we have done in our department, radiology department, is that if a patient goes for lumbosacral MRI and he is more than 60, 65, they by default do a whole spine screening T2 sagittal. And I think sometimes we do come up with surprises, and then we relook the patient, go back, and we find that there are some subtle signs of myelopathy, some wrist reflexes or exaggerated. And then we take a neurophysician opinion also, to be sure that we are at the right level and we are addressing the right pathology and we don't have any undue surprises post-operative. Yes, Dr. Varun?
Yeah, so with that thought in mind, I would like to ask Dr. Subir, what if he finds a subtle myelopathic change in the cervical spine? Do you not offer surgery to this patient, and how does that change your approach to that patient? Because at the end of the day, you have to operate. At the end of the day, you have to put the patient prone.
Right.
And I don't think there is any escape from that.
Yeah, can I put my nose in? I think let's go out with the approaches. The whole idea is to discuss various approaches here. I think we are unnecessarily going to.
I and Varun will have a separate check sometime.
Sure.
Fine. So, so we have the following options as we have discussed. We've been discussing. First is, of course, the medical management, and this patient obviously is not responding to medical management. Now, we come to the next, pain management, and I think in elderly patients like these, pain management is an important aspect. And before she came to us, she had undergone 4 pain management procedures. So I would like to discuss or ask if any one of you would like to suggest what pain management option should we consider in this patient, or should we consider that at all and go directly for surgery?
May I?
Yes, please.
So I think at 78, if she has already undergone, if she comes primarily to me without anything, I would offer her some pain management. In this case, if I feel that it's more radicular than SI joint, I would first give her transforaminal epidural block. Whatever stenosis is there, she should get some relief, at least temporarily, and maybe the symptoms may again start. If she has got no relief absolutely with the transforaminal block, then I would revisit my diagnosis. In that case, I would definitely give a sacroiliac block also again to find out whether that is the responsible thing. So they should have some relief, but it may be temporary and the recurring symptoms before you label them that it is that level only.
Right. Yes, Dr. Subir.
So primarily, sometimes like this is more experience based thought process. That what happens that if you give a root block, it doesn't work. I don't know. Sometimes you may not be able to get into the L5 because it's a partially sacralized L5, mind you. You're not going to get into an L5 classically the way you otherwise get into, because the sacral foramen there for this partial may not let you get there exactly. So if you have a failed block, and you have also discussed with the patient that this may not last for a month, you are charging X amount for that, and then the patient is going to have a temporary benefit. So I actually discuss with the patient that, look, I can give you this if I had a doubt. I don't have a doubt. You have a clinically L5. You have been given 4 injections in the past. You've been having it for 8 months. I think you need surgery straightforward. If there is a doubt in my mind regarding the level, yes, an injection or a a root block was on the cards, but not in this patient.
So you mean to say that primarily you would do a root block for localization or as a diagnostic in case there is a doubt?
Yeah, if there was a doubt, I think we have an L5 pattern,
right.
We have an L4-5 stenosis causing
right.
compression, and
right.
there is nothing close by. L4-5 and L5-S1, if there are double stenosis, then yes, there is that doubt, because sometimes the radicular pattern of L5 and S1 is very similar. But here, I think we are not in doubt, and as partial sacralization, the access to that L5 root is also not very clear. It's
right.
going to be difficult, and you may fail. So if it is needed, then yes, otherwise not in this case. That is my
right. So the patient initially had a L5 block. She had relief for 2 months, and then she had some back pain along with leg pain. So she went for a SI joint block. She was not very happy with the SI joint block, though she had some relief. And then she had a facet block. I'm not sure why the facet block was given. And then last, she again underwent a transforaminal block and she was okay for another 2 to 3 months. And now she has come to us. So I think we have sort of exhausted the pain management options, but it is very important that these are options, especially in elderly patients who are not either very keen to get the surgery done, especially in our Indian psyche, or at the same time, they may be having some additional comorbidities. So now we come to the surgical part, and this is where I would like to now ask Dr. Varun that now that we have decided to go for the surgery, how do you proceed? How do you proceed with the preparing the patient, whether any additional investigations, and how do you plan out your surgery for these patients?
I think apart from the routine fitness for surgery, and I think all of the investigations have already been done. Now the question is how to, which kind of surgery to offer to this patient.
Right.
Yeah.
So we have nowadays, as we have been seeing since morning, we have so many options. We have a midline, we have a microscopic endoportal, a percutaneous lumbar approach, or a transforaminal approach, or a biportal, unilateral biportal, or a simple descend out technique. So how do you decide what is feasible in your hands?
So I guess like everybody has been saying since morning, whatever works best in your hand, how you can approach the pathology.
Right.
And I think in this case, I would be more inclined to use a tube.
Right.
And once we are talking about the unilateral stenosis, where to dock the tube is of utmost importance, not which modality you take, how you can reach that pathology.
Right.
And in this case, I would think I would put it from the opposite side, so I can do an over the top, and then you find the pathology is just in line with your, angle of the tube, and you don't end up resecting much more of the facets and the bony things there.
So you would prefer over the top?
Over the top.
Dr. Subir?
No, I am happy doing it from the same side because I think there's a far more facetal hypertrophy than foraminal disc component in this case. So if I am on the same side, I would ensure that the L5 root is thoroughly decompressed on my side. If we didn't have any parasagittal images of the L4 foramen on the left, but that is something that I would definitely look at. If there was, then that might prompt me to consider doing something different. But if there is only L5, there is no foraminal disc component and predominantly facet hypertrophy, then that works well from the same side. And I do not even need to consider any fusion in this patient.
So that's important. Most of the time we have been sort of taught and we have been practicing to approach from the symptomatic side. So I personally also would feel that going from the same side, but I think what Dr. Varun said is also fair enough. Dr. Pai, what is your take on endoscopic, Destendau, or transforaminal or microscopic?
So I think the main thing over here is decompression of the nerve root, complete nerve root as it emerges from the dural sac until the mid-pedicular line, mid-pedicular level. How you do it, it depends on your technique, your training, your expertise. So you can do it microsurgically, you can do it through the tube, you can do it endoscopic. But it is, in this case, it is to be done only interlaminar. I don't think transforaminal would work in the case what you have said. Transforaminal would be restricted to maybe a select case where the lateral recess stenosis is also caused because of a acute small disc herniation, which is pressing from below in a compromised lateral recess, and where you think that removing the disc would help. Or in a subset of cases where you have additional foraminal stenosis, which you have to tackle, where the exiting root above, so L4 and L5, both roots are involved. In that case, maybe a transforaminal approach would help you to tackle both at the same time. But in the case which you have mentioned, interlaminar approach, again, contralateral or ipsilateral, I would do a ipsilateral approach at L4-5. And in this case, if, as you said, any other investigation, I would like to do a CT scan to help me plan better. And if it is possible, that will help me in planning uniportal approach in a much better manner and precisely limiting bone resection to the minimum.
Yes, Dr. Jayesh.
Yeah, so here you have raised a very important question that is usually dilemma for every surgeon for unilateral stenosis, that is a lateral recess or a foraminal stenosis. One is fusion versus non-fusion, and second is if you are going only decompression, then transforaminal versus interlaminar. So if I do that, I address that thing. So fusion versus decompression, I would say 3-4 criteria that I wish everybody's I expect everybody's following. That is acute angle of the facet joint. Here I would see that angle is not acute; it is wide facet angle, less than 58. Second is interfacetal distance. It should not be narrow; it should be wide. Here we can see it's wide, almost facetal distance, interfacetal distance. Third thing is we can see there is a no facetal fluid hyperintensity. I cannot see that. So it means, and if it is there, it should be less than 1.5 mm. Disc face is narrow, so it is. I can see it's almost a stable kind of joint. So I would never suggest a fixation. That is number one. Second thing, interlaminar versus transforaminal. I go through all the literature, and I still never find any prospective randomized study between a transforaminal versus interlaminar for unilateral canal stenosis. I never find it. Level 3 or 4, it may be possible, but not in the literature. So it's just I would agree with all the panelists that it is only a surgeon's preference what he will be comfortable in with. So definitely for me, it's a interlaminar decompression.
Right. I think you have addressed the points which I was going to raise. Because this is very important, especially when we see some form of scoliosis and a unilateral facetal hypertrophy. And as Dr. Varun mentioned, that there could be some micro instability, but it is very important to not be over aggressive, and especially in elderly patients. There was one more doubt in my mind that sometimes, although not in this patient, we do have patients who have a moderate disc bulge also present at the same level. So what is the take of the panel on adding discectomy also along with the lateral recess decompression? Dr. Subir, you can start.
Yeah, so whenever we are doing a unilateral stenosis, decompression for stenosis, we are not causing significant disability. And if there is a bulge that is pushing the root proximally and more towards us, then in that case, doing a fragmentectomy, a small annular rent, and just removing the offending piece that is causing that bulge would be sufficient enough. If you're doing an open laminectomy and then also adding a discectomy to it, then you are worried because it might lead to potential instability. But with an MIS tube unilateral, I think it is okay to just add that little discectomy or a fragmentectomy and get away with it. That will help the patient definitely and reduce the heartburn that you may get, that sir leg pain reh gaya, abhi bhi ho raha hai, kind of thing.
Yeah. So yes, Dr. Pai.
I think the duration of symptoms also is sometimes this thing. If there is an acute exacerbation in a long-standing lateral recess stenosis, I would suspect that there is probably some disc, small disc fragment, which is again causing this acutely. So in that case, once I've decompressed the root, if I find that the annulus is bulging, I would rather do a discectomy, try to remove a fragment inside. But if there is a long-standing, just chronic claudicant type of pain, then in that case, just decompressing the nerve root without even doing a discectomy would be useful.
Right. So I raised this point mainly because sometimes we are concerned that if a patient has persistent symptom and a post-op MRI may show a disc bulge. So I think it's very important that maybe after decompression, just retract the root, see the annulus, how tense it is. And if it is supple and the root is okay, there's no point doing it. But if it is a bit moderate or tight, make a small incision and remove the fragment. So, Dr. Varun, would you like to add anything else?
Yeah, I think when I was training with Dr. Arvind, sir, he had published a good enough series of papers which said that addition of a discectomy doesn't add too much of a value in these kind of cases, where the compression is mostly, you can see, posterior and facetal hypertrophy and in the lateral recess. And even I found over a period of time that that additional discectomy hardly, gave me any advantage. Rather, it was predisposing that rent in the annulus for a later disc prolapse, perhaps. And then the patient returning with a, second prolapse of the disc, and then adding to that symptom. So if it is not a very, significant compression from the disc side, you might as well leave it alone.
Thank you. So we now have two videos. One is a tubular port with microscope, and another one is using interlaminar decompression using endoscope.
Dr. Nitin,
Yes. Yes.
It's a time already completed, but I think we can move fast forward to one video.
Okay. So which one would the all like to see, the microscopic or the endoscopic? I will leave it to the house. We have both.
Okay.
These are 2.5 minutes each. So around 5 minutes. Yes.
Yeah, I think we can quickly show both, So that's why I think we should be hampering more on, spend more time on this, diagnosis. It's already diagnosed.
Yeah, the reason, Dr. Arvind, is that I think sometimes what we see in our practice is that many times decision making is more difficult, and I think surgery more or less most of us nowadays are exposed adequately. So I'll just play. This is a left-sided L4-5. This is the cranial, and this is the midline. This is the lateral. I'm sorry. So this is a tube. I think it's a 18 mm tube, 18 or 16 mm tube. And as Dr. Varun was saying, placement of the tube is the most important in this tubular port procedures.
So this is the left side?
This is the left side. This is the cranial. This is the lateral. This is the medial. This is the caudal. And this is the superior lamina.
So you're going from the same side?
From the same side. It is from the same side. From the left side, this is the cranial, caudal, medial, and lateral. This is the L4 inferior lamina, and the L5 superior lamina will be here. This is the medial facet.
So I just want to discuss quickly one thing.
Yes.
We have been using a diamond burr for these cases. Does anybody use a fluted one, or everybody uses a diamond burr?
Well, I use a round burr. I don't use a diamond burr.
Match head.
And I don't use match head. I use a standard round spherical burr. But match head is also an option. I have not used it.
I use round fluted burr.
Cutting burr, 4 mm round burr.
Yes, cutting burr.
Initially cutting and maybe later on a diamond burr when you are very close to the
ligament of the.
Yes.
Okay.
So here the most important aspect is the angulation of the tube, or what we call toggling of the tube, because the tubes are of small diameters. So to visualize, we have to angulate the tube cranially, caudally, medially, or laterally. And so this is the L5 superior lamina, and now we have come to the medial facet. This is a slightly fast forward video. Again, as in this patient, you have significant facetal hypertrophy. So just a question to the panelist: how do you decide before you start drilling the facet, how much facet to drill? Because many times we, especially in the beginners, have a dilemma that they should not overcut it, and many times they do tend to undercut the facet. So just a quick remark from any of the panelists.
Typically, if you see the lateral aspect of the root, that is enough.
Right.
You should not have to dig the root out from underneath the facet. If you are able to see the lateral edge, then that is enough. You don't need to do more. That is one. And two, typically we usually are doing a little less with the microscope when we are looking in the microscope. So you can always have a feeler and feel the lateral edge of the pars, and keeping about 5 mm from there, and then making sure that you have sufficient length of bone of the pars to be retained. So I think I use these two parameters.
I think one more parameter is facetectomy should not extend lateral to a line which is tangential to the medial pedicular line. So actually you can't see that, but you have to imagine where the medial, because that is where your decompression has to be there. So, but it should not go lateral because then you may cause instability.
Let the video continue while we talk.
Yeah, so the diameter of your burr gives you a basic idea that how much bone you are resecting, because that is something of an objective measurement. You have a 3 mm burr, so you can visually measure for the juniors that that 3 mm of this much is 3 mm, the size of my tip of my burr. And like sir pointed out, that is where I differ from him, that if you go from the ipsilateral side, you have to pass a probe and guess that you have freed the lateral recess and the nerve root. But if you are from the opposite side, you can directly go see down the foramen and the nerve root, and it is free, and you don't end up resecting too much. For a unilateral pathology, although it may depend on a case-to-case basis where exactly and how much is the compression, but I do find that one should keep in mind that even from the opposite side, one can reach the pathology on the unilateral side. And then it's not mandatory that you only do it from your ipsilateral side.
Dr. Pai, are you ready with the video? Dr. Pai, you are muted. Please
unmute yourself.
Please unmute yourself. I will stop sharing my screen, and Dr. Pai would like to share his screen.
Can you see it?
Yes, we can see it. Please go ahead.
Yeah, so I think would be on a percutaneous uniportal. There is another axis which is biportal. So right now I am talking about uniportal ipsilateral. So we use this kind of a working channel endoscope, which is 25 degrees, which can have endoscopic burrs in it. This is the first article by Dr. Rutan, which when it started. So the endoscopic anatomy needs to be appreciated, because whatever you're seeing is too magnified and there are no relative points where you can find out. So you have to be very clear where you are in the field. Then once you are there, you can translate the cannula so as to reach other places. The other thing about endoscopy is this is done under continuous water irrigation. So water irrigation helps you to keep the field clear as well as to tackle bleeding. And it also helps you to dissect the area and maybe push the dura inside because of the pressure and help in decompression much better. So this is the cannula which is placed posteriorly in the laminofacet junction. You have to first identify the structures with and remove some part of muscles overlying the ligamentum flavum and the facet, and dissect the facet. So you place the cannula over here, and then you identify the tip of the inferior facet. This is the ligamentum flavum inside. This is the tip of the facet. This is superior, this is inferior, this is medial, this is lateral. Then you start drilling the inferior facet from the tip of the facet below. So this is drilling the inferior facet. So it has to be done layer by layer at maximum magnification. Once you do it, you gradually tend to go deeper and deeper, try to remove some part of ligamentum flavum, superficial ligamentum flavum, keeping the deep ligamentum flavum intact. You drill the facet till you are reaching the tip of the superior facet, so which you can see. So this is you use the cannula to retract the area, and there you reach the tip of the superior facet on lateral image intensifier, where you know that is the level you need to reach definitely for complete decompression. Mind well, you should keep the ligamentum flavum intact. Then once you have removed the inferior facet, the superior facet comes into view. The superior facet is now visualized, and where now you need to decompress the superior facet. So again, use the same burr. You can use a diamond burr. So this is the superior facet. which is going into the lamina over here. So you continuously keep rotating the scope and the cannula outside so as to have a very good feed, and because of the irrigation, and you use the cannula to retract whatever tissues are coming, and here you are trying to remove or thin out the inferior lamina also. Once you have done that up to the mid pedicular level, so you have now only the ligamentum flavum over here. And here I was talking that you need to be medial to the medial pedicular line and not crossing it so as to keep enough and minimize bone resection. Once you have the ligamentum flavum, then you cut the ligamentum flavum with a cutter in the midline first, and then gradually extend laterally. You can see the dura inside. So you, in lateral recess stenosis, you need to remove the ligamentum flavum completely. So you, piece by piece, you can remove the ligamentum flavum laterally until you reach the lateral edge of the root. You can use a punch to remove the ligamentum flavum and some part of lateral bone of the superior facet. So here you can see the lateral edge of the root over here. You can further. The advantage of this is because you can rotate the scope so easily, you can have a very good anatomical visualization. So here you can, and then you can retract the root. You can free the entire root. You can use the cannula again to further keep the root retracted and maybe try to remove any spurs anteriorly. So you can retract the root like this for some time and remove any spurs which are there anteriorly, or you can do a discectomy. So, and then you can free the nerve root completely. There are a lot of papers on the same.
Dr. Pai,
Yeah, thank you.
For oversetting that, I'm very sorry.
Yeah, no, that's fine.
Fantastic video you have shown. And here, Dr. Nitin Garg, fantastic moderation. I would like to thank all the panelists, Dr. Varun Agrawal, Dr. Subir Zaveri, Dr. Pai, and all the. Now, I guess because we are overshooting the time.
I just want to take this opportunity to welcome you to MISSAB Con in Pune this November. So please block your dates, 18th to 20th of November, and see you in Pune.
Thank you. We all will be there.
Thank you, Nitin Garg, and all my kind of fellow panelists. Thank you.
Thank you, all of you. Thank you so much.
Thank you, Dr. Dr. Ketan, would like to invite next.
Yeah, so the next case is L45 facetal cyst. The moderator for this session is Dr. Umesh Srikanta. We'd like Dr. Umesh to take this forward.
Welcome, Dr. Umesh.
Yeah, good afternoon. Good afternoon, everyone. So, just a minute. I'm just sharing my screen.
Yes.
So I think if it were to be an online conference, offline conference, we would have. We would have been breaking for lunch.
Here, I would like to welcome all the panelists, Dr. Devesh Dholakia, Dr. Pramod Lokhande, Dr. Mukul Kaushal, and Dr. Kartis Kailash. Very welcome you all. Very interesting case going to present L45 facetal cyst, untouched topic with majority of diloma there. Dr. Umesh. Are you there? Dr. Umesh?
Hello, can you hear me?
Yeah. Please.
Yes, sir.
I'm extremely sorry for that small interruption. So I would like to, welcome my esteemed panel, Dr. Devesh Dolakia from Mumbai, a senior consultant orthopedic surgeon, Dr. Karthik Kailash, doesn't need any introduction, from Chennai, Dr. Pramod, a well-known endoscopic spine surgeon from Pune, Dr. Mukul Kaushal, young and dynamic guy who does a lot of endoscopic spine surgery from Chandigarh. So, I'll not go into the too much details. We have to cover up for some time as well that has been lost. And, we know that facet cysts are also called as juxtafacet cysts, synovial cysts. We can sometimes differentiate them from ganglion as well as flaval cysts. I won't go into the details. So let me just bring up Dr. Mukul. Mukul, so can you just tell us briefly in a minute about the etiology of these facet cysts? So why do these facet cysts occur?
Yeah,
Dr.
thank
Mukul?
you. Yeah. Thank you, sir. Sir, facetal cysts, usually they have been associated with some form of instability in the spine. So usually if there is some sort of an instability in an effort to stabilize that segment, the facets, they do try to stabilize, and sometimes the facet capsule, it can get weakened, and the fluid, it kinds of leaks out and forms a cyst. And that cyst might lead to a neural compression and cause of symptoms to the patient in the form of leg pain or claudication.
Yeah, excellent. I think there are two theories that are involved. One is either a trauma or a degenerative tear in the facet cyst, and which leads to leak of the synovial fluid, and then it gets walled off by some inflammation and fibroblastic healing. And that is why we see a lot of epidural adhesions in the facet. Sometimes there can be adhesions between the facet cyst and the dura as well as the root. And because of the high range of mobility which predisposes to this, that is why it is more common in the L4-5 region as well. So let me bring in Dr. Pramod. Dr. Pramod, can you just briefly tell us again in a minute what about the symptomatology? What are all the ways in which these facet cysts can actually present to us?
I think a lot of
presentation, please. Sorry.
Hello.
Dr. Umesh,
Yeah.
can you do slides?
I'm sorry.
Please do slides slow. It's a.
We're seeing the slides.
Yeah.
Okay.
Now, fine.
Is it right now?
Right. Perfect.
Yeah. So, Dr. Pramod,
okay.
can I bring you in, and can you just share us in a minute about what are the symptomatology that we can expect in a synovial cyst?
I think if you look in the routine practice of spine surgery, a lot of times you see some cysts there, and majority of them, they are asymptomatic, But if they do become symptomatic, I think the most common symptoms that we have are radicular pain, and usually they occur in the lower lumbar spine, rarely in the cervical or the thoracic spine. So usually have symptoms pertaining to radicular compression. Very rarely, if the cyst is very big enough, it has been neglected for a long time, then maybe you could have symptoms of multiple root compressions or something like a quad equina syndrome. And obviously back pain is there associated with such symptoms.
Yeah, I think that systematic review that has been done on a very large number of patients also tells the same thing. And the incidence of motor deficits as well as sensory deficits can be there in around 20 to 30% of the patients. Most of these patients present with radiculopathy or low back pain. And as Dr. Pramod has mentioned, if the cysts are pretty large, in those cases, it can cause even a quad equina kind of syndrome or even claudication type of pain. So Dr. Karthik Kailash, so when you see a facet cyst in your OPD, when a patient walks in with a facet cyst, what all do you actually look for? How do you evaluate this patient? What do you look for clinically? What are the factors you will take? Do you do any further investigations?
Yeah, clinically, I look for lack of extension or pain on extension, number one. Number two, I would look at root compression signs or radicular signs, which Pramod already mentioned. That will be the two main clinical factors I look at. Radiologically, I would look at degenerate facet with, as you've pointed out on your MRI picture, a little bit of cystic change across over there. The cyst primarily occurs because the facet joint has got about 1 to 1.5 ml of fluid, and this fluid actually seems to be leaking out into the synovial area. And this is the cause of the facet cyst. So there will be a hyperintense thing on a T2 image, which is the most important thing to look for on a MRI scan. So once having decided that, then you can look at other pain sources to evaluate them before you confirm that this could be a facet cyst as a causality of the pain.
Yeah, so I'll just hold you on to one point. You told that hyperintense within the cyst. So there are some cases where we don't find this hyperintensity. So is there any clinical difference? Is there any prognostic difference between the cysts which are hyperintense on an MRI and those cysts which are slightly more heterogeneous or intermediate signal intensity or even sometimes hypointense on an MRI scan?
Well, sometimes they could have an auto leak or an auto thing on those facet cysts. And so a spontaneous rupture of the cyst can happen. And those are things which we don't need to do anything more aggressive on them. So those are situations where the treatment protocol goes in for a regular degenerative spine treatment protocol rather than a treatment protocol for a facet cyst management.
Yeah, thank you. Dr. Devesh, so you would have seen several facet cysts in your long career. So what are the things that you would look for? Is there anything else that you would like to add?
So I would say that facet is like a synovial joint, like a knee joint. Okay, this is type of a Moran-Baker cyst which is usually seen in the knee. But unfortunately, I would say that behind that cyst is your neurological structure which is giving a problem. So most of the time, as it's seen in 60 years of age, it's in the elderly age group, one. And you have to see what you can find the cause of the cyst. Most of the time, it is either arthritic or there is some form of instability causing the cyst. And whether it correlates with the clinical symptoms, it may be an incidental finding or it may be the cause of the symptom, or the patient has got an MRI for something else and you detect the cyst. So you have to correlate first whether it is the cause, and if you can find the cause, and you have to treat it accordingly. So you'll have to, along with the MRI, have to look for an X-ray, AP, lateral inflection and extension, because large number, about 50% of the patients do have instability causing the facet cyst.
Yes. So I think that is very important point. So this can be associated with some underlying instability, and that is why a dynamic standing flexion extension X-rays are very important to look for any instability. We have to look at the degree of degeneration within the facet joint. We have to look at the degree of compression, whether there are any associated degenerative changes within the disc, within the facet. So we usually have to grade all these things which are important in clinical decision making. So once we do that, so let's jump into the treatment aspects. Let me bring back Dr. Mukul. Dr. Mukul, so what are the treatment options in these kind of cases? So can you just enumerate them for us for a facet cyst?
Sir, yeah, absolutely. Sir, facet cyst, sir, we can start with the conservative treatment. It can be in the form of relative rest, allowing the patient to continue with all those activities which he's comfortable doing in. We can add some back extension, back flexion strengthening program also to strengthen his core, focus on the antilordotic exercises. We can put him on some gabapentin or pregabalin for if it helps with his leg pain discomfort. If the patient is managing his activities of daily living, probably that much is enough. But if he's not responding to the conservative treatment and that leg discomfort is affecting his activities of daily living, probably then we are looking at some kind of an intervention. It might be a image guided or a CT guided needle putting into the cyst to aspirate it, or we think of some kind of a surgical decompression of that cyst.
So, Dr. Karthik Kailash, I know that you have had quite an experience with percutaneous interventions in a facet cyst. So, can you tell us what are the type of cases you would actually select for a percutaneous interventions? We know that the literature states nearly a 50 to 60% recurrence rate for these cysts after a percutaneous intervention. We know that these cysts, even after percutaneous interventions, can come back with to the same degree with the same clinical symptoms. So, what are the cases? What is the success rate that you have experienced in your setup, as well as what are the cases which you would select for a percutaneous interventions? What do you look for?
In our thing, we do it as a combined protocol with the radiologist. I don't do a facet cyst individually. We use radiofrequency ablation as a methodology of treatment. What we do with these things is more than 1.5 centimeters in size. We go ahead and do a radiofrequency, first drain it, and then go ahead and do a radiofrequency ablation of these as a method of treatment. We find we have got about 6 or 7 cases with our radiologist, and we found 50% recurrence in them. So this is one methodology of treatment which we have apart from draining them. The other things which I talk about, which I have done in other cases, are going in for treating the instability as a fusion itself rather than anything else, by MIS techniques or by open techniques, which are comfortable at this point of time. Those are the various things we've done.
So would you look for any particular sign or any particular radiological feature where you would say the chance of success for a percutaneous intervention is higher? Or these are the cases I wouldn't try percutaneous interventions at all, and I would directly go in for either a surgery or some kind of surgical intervention?
But when there is the hyperintensity of the face of the cyst is not there, then I would not try at all. I would look in terms of going.
I think that's a very important point that has been even brought out in the literature as well. So hyperintensity within the cyst is a very good predictor of success for percutaneous interventions. Nearly around 70% of the cysts respond, as compared to 40% of the cysts which are of an intermediate or a low signal intensity on the MRI. So that's a very important factor that we need to consider, before we can recommend a particular case for a percutaneous interventions. So I think, so these were that. So coming to surgical options, Dr. Pramod, so can you just tell us, you are an endoscopic spine surgeon, and we know that you would like to treat this cyst as an endoscopic technique. So what are the points that you would look for to assess the suitability of a case to be treated by an endoscopic technique? Or how many times in your practice do you think that a facet cyst cannot be treated by endoscopy and I need to do an open or a decompression, a proper surgery for this kind of cases?
I think first of all, the reason for, hello?
Yes.
Yeah. Can you hear me?
Yes, I can hear you.
Okay. First of all, what I think is that the experience of the surgeon really matters. How experienced he is with that particular technique, that really matters. And usually these cysts, they are usually single level and on one side. So I don't think there is any contraindication for removal of the cyst by endoscopic technique. There are two different methods. Obviously, you either go from the ipsilateral approach, which I think is going to be slightly difficult, because one of the difficulties that we find is differentiating the cyst from the neural structure, the dural sac and the nerve root, and secondly to get the proximal and the distal extent also along the medial and the lateral extent. So the better technique would be to approach from the contralateral side, just like the ULBD approach, where we enter through the opposite interlaminar space, go under the spinous process, and because the plane of dissection from the opposite side is much more visible, and is going to be much more easy for us to remove the cyst from the opposite side.
Yeah, I'm sure we will discuss that more when you will show your video. But can I bring in Dr. Devesh? Dr. Devesh, sir, can you just tell us what are the factors you would consider? Now we know that these kind of cysts can be treated either by decompression alone, or in some cases we need to add a fusion. So in your practice, what are the factors that you would consider to decide whether this case is suitable for decompression or this case is suitable for fusion? And when would you advocate a fusion in cases of facet cyst?
I would look for instability. If there is any instability, then I would look for fusion, because that is more permanent, the chance of recurrence is less. If there's unilateral facet involvement, small cyst, occupying less than 25 to 50% of the area of, and it's a unilateral, then probably I'll just go for laminotomy and cyst excision and root decompression. But if there's any element of instability, I would always look for fusion in that area, because I would not like recurrences.
So, Dr. Karthik, is there anything else you would look at? Would you consider the patient symptomatology? If there is a back pain, would you tend to err more in terms of fusion? Whether there is a major motor neurological deficit, would you consider the degree of facet or a disc degeneration in deciding whether just a decompression or a fusion is required? Can you just throw some light on this topic?
Yeah, for me, the main criteria would be the significant back pain more than radicular pain. If the significant back pain more than radicular pain, as Devesh mentioned, there could be an instance of an instability added onto it. And the treatment protocol for that would change in terms of managing a degenerative instability spine, rather than looking at a radicular decompression alone. So there comes the issue of fusion for me at that point of time. Isolated radiculopathy with no significant extension block on clinical examination, and also a very small cyst, then I would think in terms of doing a foraminal decompression and a cyst excision at that point of time. Motor deficits are very, very rare. They can present exceedingly rare in less than 1% of times as Cauda-Equina syndromes, and the treatment protocol for that is completely different.
Yeah.
Yes. There's an excellent classification which has just come up because everybody doesn't know what to do. There's so many things going on. It's called as NSurg, Neurosurgery Society, something of that sort, where they divide into 5 parts. The first type 1 is where it occupies less than 25%. The cyst size, they consider 2 things, the cyst size and the instability. If the cyst is less than 25% of the canal causing radiculopathy with minimal instability, less than 15% instability, I said, then they said that you can try aspiration, facet joint, you can inject steroid in the facet, or some pain management system. If the cyst is between 25 to 50% and causing unilateral radiculopathy, then better to do an excision, laminotomy, or whatever you are comfortable with. If it is more than 50% and causing bilateral, then you may always need surgical intervention. But if there is any of this sort, along with more than 15% instability, better to go for fusion. That's what they have said, according to this criteria. Because they said even 15% more the instability you have, there are more chances of recurrence.
Yes.
Dr. Umesh, there is a question by Dr. Anand Naik that is there any role of isolated facet fusion in this case?
Sorry, what is the question?
Is there any role of isolated facet fusion?
See, if there is an underlying instability, as we were discussing in the topic, and if our idea is to limit or remove the segmental mobility, then the different modes of fusion can be considered. But the whole idea, what we were discussing here, and I will quote some literature as well in the coming slides, which probably decompression alone is sufficient for more of these cases. Of course, in cases where a fusion is required, you can always debate whether an isolated fusion without cyst excision, I don't know whether that makes any sense, but cyst excision and a type of fusion that you are going to do can probably always be debated, I think. So does the panelists would like to add anything else to that answer?
I would say one thing that suppose you don't want to do fusion, patient is young. Is there any role of non-fusion technology where you have dynamic, so it deloads the facets? So there's less chance of recurrence and the motion is maintained and you can always fuse later on. Or you can have interspinous spacer. I have not read any literature, but these are just a thoughts to it. So when you don't want fusion and there's minimal instability, patient is young. So these are the other things which you can consider, I think.
So let me bring in Dr. Mukul. Dr. Mukul, this is one of our cases where, this is a patient who had a low back pain for 6 months, with recent onset left lower radicular pain, 3 months neurogenic claudication, which is gradually progressive and is left EHL of grade 4. So what are the things that you would look for in this MRI and what would you advise for this particular patient?
Well, sir, I believe the conservative options have all been exhausted by now.
Yeah, it has been tried, but this is the first time the patient has come to us, or let us say if the patient has come to you and he's telling that he has tried some medicines, nothing, any specific treatment has not been given.
So as I can see, sir, there is on the L5S1, there is a left side recess compression from probably a L5S1 left-sided facet cyst. And on the L4-5 level, there is a disc degeneration with a mild disc bulge, but on the axial cuts, we can see that it is there is probably a left-sided L4-5 also, probably recess compression with mild facet fusion also, sir.
I completely agree. So what would you say for this patient? So what is your next step? What would you do?
Well, as the claudication is not improving much and it is gradually worsening, sir, and probably it must be affecting the quality of life of this patient also. Probably the next step would be a dynamic X-rays to see the amount of any.
Okay, so these are the dynamic X-rays.
Okay, sir. No, not much instability per se.
Yes, all right. So what are your options? What would you say?
Probably if he has been suffering for the past 3 to 6 months, probably the first option has already been tried quite a lot, sir.
Okay.
I
So
don't have much.
conservative is out then.
I don't have any experience
Which
with
of them,
percutaneous.
which of the other three are your favorites?
Well, sir, I usually offer decompression to such patients.
Excellent, excellent. So the patient has a 2-level disease. So what is the approach that you are going to use? What is the technique that you are going to use?
Well, sir, I am been trained and I'm comfortable with the stand technique, arthrospine technique, and UB technique. So either of the three I can work around. And probably I'd like to go from the symptomatic side here because the cyst is quite small and probably the facets are also quite wide. So I'll be able to do a good job and while also preserving the facets also.
All right. Okay, great. So I think Dr. Mukul, I can share your screen and show your video about how you do this kind of cyst with your endospine technique. So
Sure,
I think
sir.
if you can finish it in 3 minutes, I think it would be great.
Yeah, because it's last 5 to 7 minutes left for the session.
Correct. Yeah.
I hope my screen is visible, sir.
Not yet, Mukul.
Yeah.
Is the screen visible now, sir?
Yes, it's visible.
Yes.
Okay, sir. So I'll be presenting, sir, the arthrospine technique, which I do usually for lumbar facet cyst decompression. Well, obviously the surgical options have been discussed already. We can either excise the cyst and do a decompression or do a complete facetectomy and fusion if we are scared of the risk of recurrence. So this was a 66-year-old female. She complained of low backache with left-sided leg discomfort predominantly, and which was disturbing her walking since June 2021. She had multiple medical comorbidities also, which were controlled under medical treatment. Clinically, her nerve root tension signs were negative, but she was very much disturbed with pain along her L5 distribution on the left side. She had a claudication walking distance of around 300 meters before the pain started to affect her walking. Clinically, her vascularity distally was intact and neurology at rest was normal, and she had a self-voiding status. So this was her MRI, and there was a L4-5 small facet cyst with the left-sided L4-5 effusion, which was affecting probably her left L5 root in the lateral recess. Sorry, I don't have the dynamic X-rays, but she had a stable spine on dynamic X-rays and she had not much of back pain. So we planned for an arthrospine duo technique. I use this technique. It's an indigenous system. You can use it in dry mode or based on Stendo principles or saline mode as a PSLD-based technique. It is compatible with both 0 and 30 degree scope. And even if we can create another portal and convert it to a unilateral biportal endoscopy technique. So this is a small video. This was started in dry mode. 9 o'clock is the cranial side. 6 o'clock is the facet side. I'm operating from the left side. I'm exposing initial bites at the spinolaminar junction. Then I'm exposing the flavum by doing a laminotomy on my side. Now I'm using a blunt hook probe to detach the flavum cranially and release it. I can appreciate the epidural fat also being seen down. And once I remove this flavum, towards the 7 o'clock, I get a glimpse of that facet cyst also, that small facet cyst, and the thicker sac below that. So once I've excised, this is another better picture of the facet cyst. Probably I punctured it. And once I've removed it, I can see the epidural fat below and the epidural venous plexus in front of the disc space. Now I use a nerve root detector to see the amount of recess, nerve root mobility and the amount of recess decompression also on my side. Now I converted to a saline mode to the same system. That's how the thecal sac appears. And the contralateral decompression, I do it in the saline because it gives me more clarity and more magnification. And we can appreciate that once the instrument goes in saline, the hydrostatic pressure gently compresses the dura to allow me to do a better job on the opposite side. And I can use my little small pen field to see the opposite side traversing route going into the foramen on the opposite side, the disc which is stable on the opposite side also. And that is how my ipsilateral recess looks. The L5 root is completely decompressed, going from the shoulder up to the axilla and freely mobile as my probe is freely comfortably able to enter into the recess.
Thank you so much, Dr. Mukul. That was a very concise, very brief, and very excellent video that you have shown.
Thank you, sir.
Okay. Can you see my screen again now? So this is what we did. We did a tubular decompression at 2 levels for the same particular case. So let's move to the next case. I'll again skip this one. I'll not go into the details of percutaneous procedures, what the literature says. So Dr. Karthik, I would like to bring you in on this particular case. So this is a patient, one of our patients, 62-year-old, low back pain, bilateral lower limb radicular pain, severe neurogenic claudication. He can hardly walk for 20 meters. However, no motor neurological deficits. And he is relatively comfortable at when he's sitting down in a slouched position. So what is your plan of management for this particular case?
Yeah, the MRI looks like it's got a degenerative disc with a facet cyst, and it's got the degenerative listhesis also the same level, L4-5. So my treatment option would be looking at doing a decompression plus the cyst excision, A1. Number 2, again, it goes back to flexion extension X-rays. I presume the patient would be stable at this point of time with the X-rays.
Yeah, the X-rays did not show any kind of instability.
Yeah. So if that is stable, then I would look at, I have 2 options. I could do the standard bilateral decompression with facet cyst excision, undercut the thing. There are three areas commonly the facet cyst is seen: medial, anteromedial, as well as distally. So these 3 areas can be approached. Here it's more on the medial aspect, so I can address that. And then I can, all the other things, the current new things which all you've been demonstrating is the contralateral decompression from the unilateral side. So these things can be accomplished bilaterally. These are 2 options. I would hesitate in doing a fusion since the spine is clinically and radiologically stable.
So this patient has got a bilateral facet cyst. So would your management change when you see bilateral facet cyst, or would you still go for just a decompression alone?
Yeah, I would still look at, because you've proven again that there is no instability on the flexion extension X-rays. So yes, my view will not change. In fact, with the use of the younger guys like the Mukul and others who are doing the endoscopic procedures, doing it from one side is probably the easier option rather than the olden technique of what we guys do bilaterally.
Dr. Pramod, would your management be any different? Would you like to, tell us what your plan of management would be for this case?
I wouldn't go for fusion in this case. It is definitely going to be a bilateral decompression. And I would like to approach from the right side in this case, because the cyst on the right side appears to be slightly smaller. Yeah, so it's easy for me to access the bigger cyst from the contralateral side.
So wonderful. So wonderful again. So this is another 3rd case. So severe bilateral canal stenosis at L3-4 and L4-5 levels, and there is a small cyst. There is a cyst at L3-4 levels. Dr. Devesh, what would be your plan? So these are the dynamic X-rays. There is a small amount of listhesis at the L4-5 level, as we can see there, which is getting corrected on an extension view.
I think I'll go for fusion there.
Okay.
It's the 872.
So for just to point out, just to save time on that particular discussion. So the L4-5 is the level where there is an instability on the dynamic X-ray, but the facet cyst is at L3-4, and he's a 72-year-old male.
L3-4. But since it's just showing I think L4-5 is also looking stenotic. I would handle both the levels at the same time, because he's 72 years. You don't want to go operate again and again on him. I would always look for fusion to L4-5, and L3-4 probably do a bilateral decompression.
So means you would like to say that L3-4, even though that there is a cyst, there is a small amount of facet of fusion over there. The facet cyst is there from the other side. So you would say that you would fuse an adjacent segment and we can leave this segment behind. So would you feel that there is an increased chance of
L4-5, because X-ray is already showing early bridging osteophytes on that X-ray at L3-4.
Okay. All right.
It's already tending to fusion.
Yeah, I think it's a valid point. So there is also some amount of vacuum disc. You see the anteriorly that's opening up, and it is not actually fused. Means if we see the flexion extension X-rays at L3-4, it is not actually fused. So considering this point, would you like, would you alter, or would you like to change this one? Or I think you are very much convinced with just doing a decompression alone at L3-4 level in this case.
I think
Dr. Umesh, actually, we are sorry to interrupt, but we are running out of time. So if there is any video presentation left, can we just speed up to that?
Yes.
Umesh, am I This is probably the ideal case where you look at doing a percutaneous cyst excision drainage with radiofrequency ablation. I would definitely look at this as an ideal case because you have an area where you don't have to violate anything in this.
Okay, so but how would you treat the stenosis, sir?
See, so far we have not been doing anything. The patient's been conservatively managed. The claudication only gradually progressive. We'll wait till it gets to a critical point of time and then take it at that point of time.
So okay, so that's a different way of approaching this particular thing. So for want of time, I think we'll skip that discussion. So again, even there are several series that shows that fusion really does not change the outcome in many cases. In such cases, especially only when there is a grade 2 listhesis, that is what the literature says, grade 2 listhesis, or when there is a obvious instability, translational instability of more than 4 mm, and when there is a when iatrogenic instability is created during the surgery, that is, some people have done a total fascectomy for these cysts. In those cases only the fusion is required. I think Dr. Pramod has a very good video and on an endoscopic management of facet cysts, and we would like to, Dr. Pramod, would you like to share your screen?
Okay, so since most of the things have already been covered, I just rushed very fastly through this. We know the options that have been discussed in detail: percutaneous aspiration, surgical excision, and fusion. So this is one of the case, L4-5 left-sided cyst with a unilateral radicular, radiculopathy with some claudication pain. There's been failure of conservative treatment, and what we do is we take an interlaminar approach for this cyst. Transformal, I don't think it works very well. So just mark the center of the interlaminar space, insert the dilator inside till it reaches the facet joint, and over the dilator the cannula goes in. And this is the docking of the working channel, just 8 mm working channel. And once the cannula endoscope is inserted, you just remove a little bit of muscle fibers and the adipose tissue to expose the interlaminar space. This is the drilling of the superior lamina. Main key point that we have to remember is that we need to identify the margins on all the sides, the superior, the inferior. You have to get beyond the margins of the cyst on all the sides. There is no point in keeping the margin hidden by the bone or ligamentum flavum at some side. So this is one particular thing which I like to stress or put emphasis on. And second thing is, we always try to dissect out from the area of virgin areas, either the superior side, the inferior side, or the midline, wherever it is easier for us to dissect. Many of the times, the flavum is very firmly adherent to the cyst, and the cyst itself is very firmly adherent to the underlying dural sac. So the major problem which we feel, which we face, is that you can injure the dura. And since all the surgery is being done under irrigation fluid, it's identifying a small dural tear is very difficult because there is no CSF leak which you see on the image. Now here the cyst has been opened up a little bit, and just to confirm it, the forceps is put inside and visualize if there are any nerve roots which are herniating out. So it's basically a cyst. This is cutting of the inferior lamina to expose the dura and the nerve root, and you try to separate out the flavum as much as possible from the cyst. Sometimes it is not possible for us to remove the entire cyst because sometimes the adhesions are so firm. If you try to dissect out the cyst from the dural sac, you may just open up the dura. So in that case, we just keep some part of the facet cyst wall behind, like what we did in this case, that just part of the cyst wall has been kept behind, which is firmly adherent to the dural sac. And this is the lateral border of the nerve root, which is well mobilized. You see all those red dots, that is actually where the cyst was adhered to the dura. And this is part of the cyst wall, which is firmly stuck up, so which we have left behind. Another case, I think, right-sided L5 radicular pain, again, a big cyst. It looks hyper intense. And here it was easily possible for us to, put in the dura dissector between the cyst and the neural structures. So there was a good plane, and we just mobilized the entire cyst. And these are the end results. You see the cyst has been completely removed with a well decompressed ipsilateral nerve roots. So just to summarize, I think endoscopic excision of facet cyst is a very safe and reliable procedure. The chances of dural tear are there, but definitely I think they are much more less as compared to open surgery. And a contralateral over-the-top approach provides a better plane for dissection, especially in cysts which are very large in size.
Thank you so much, Dr. Pramod. Thank you very much, I think, for that excellent video presentation and how nicely these endoscopic cysts can be handled. So we are really out of time, and we have to conclude. So may I have just one words of wisdom from our senior faculty, Dr. Devesh and Dr. Karthik? Would you like to just give your closing remarks, just one sentences about facet cysts? What your main takeaway for the delegates is going to be from this session?
Nothing, Srikanth. Everything has been dealt with. Beautifully done. Well done. Thank you.
Thank you, sir. Dr. Devesh, would you like to add?
Umesh, you have taken the full range of facet problems. I think we have done an excellent job, right from conservative, endoscopic, and fusion. I think we have covered every aspect of the problem.
Absolutely. Well done, Pramod and Mukul. Lovely videos.
Yeah, I thank all my panelists. Thank you for spending your time, and thank you for giving your valuable inputs for facet cysts. I think I'll hand over back to the chairpersons, Dr. Jayesh and Dr. Ketan. And I apologize for overshooting time, if any. Thank you.
Thank you so much, Dr. Umesh. You have done a wonderful job, as you have covered all the dilemma points. Everything has been answered. Facet cysts that could be possible. So thank you all the panelists. I think we are moving to the next session from uncommon things to now very, very common thing we are facing day to day. That is L4-5 degenerative spondylolisthesis with moderate L3-4 stenosis. And I would like to invite Dr. Subir Javeri, the moderator. Dr. Subir, please.
Yeah. So thank you, Dr. Jayesh. Thank you, MISSAB, for having me here. So I'll start sharing my screen. So I would like to welcome my panelists for the session, Dr. Anand Nayak, Rajakumar Deshpande, Dr. Saishav Shah, and Dr. Sumoyu Datta. I presume all of you must be here with me. I can only see my screen at present. Is everybody able to see the screen?
Yes, yes.
Okay. So this is the first case. It's a 57-year-old female with backache on and off, gradually increasing since last 4 months with an acute exacerbation in the last 2 weeks. The back pain tended to, get aggravated with exertion. And she also had bilateral lower limb radiation of pain, which was a little worse on the right side. Bilateral lower limb heaviness, mild numbness over both the feet after walking. And a standing and walking duration was significantly limited, just about 10 minutes. She had a significant amount of claudication as well. So, do I have Anand here? I'm sorry, I'm only able to visualize a few of us. Anand, are you here with us?
Yeah, I'm there. I'm there.
Yeah. So, what do you get the sense? This is just the patient who has just walked in. What do you just get from the history? What are you staring at?
Oh, we are staring at degenerative disc disease and possible instability as well.
Okay. And does the acute exacerbation tell you something?
Yeah, probably an instability there, probably. And you need to get the investigations done. I think it's better to let's jump over to the investigations.
Okay. So I'll show the investigation. I'm not able to move here. So these are the X-rays, the plain films of the patient.
Yeah.
I'm sure all of us can appreciate what's happening at L4-5. And this is the MRI of the same patient. So Anna, let's move forward. You can see the L4-5.
It's a degenerative listhesis, L4-5. with possible neural foraminal, compression.
Right. So I have always had a little bit of a question about this MR myelogram. So how many of you put any weightage on the MR myelogram, on these images of the MR myelogram?
May I
Raja.
take that question, Subir?
Yes, Raja.
Subir, MR myelogram is very useful if you have got a very good MRI. If you take it in a very low Tesla MRI, 0.3, 0.5, images are blurred, you're not getting good images, you'll get this kind of sometimes not so great images. If you have 1.5 or a 3 Tesla image, an MR myelogram is a very useful indicator of how much the thecal sac is compressed at what levels. Many times in axial cuts, if there is no myelogram, you must understand that it gives you one dimension of axial cut at a certain cut that the radiologist has preferred to make the axial cut. But if you see like this, and we are all trained with myelograms when we were doing our neurosurgery training, we used to rely on this to see to what extent circumferentially the dural sac is compressed. Also, many of these are having a lot of flow artifacts. If you take away the flow artifact that is there in the CSF, and if it's a very good MR myelogram, it's an extremely useful tool. Don't neglect using it.
Okay, so this was showing a double level compression. So that actually, stimulated my thought process and whether I should, look forward to what is happening in this patient. I know Karthik always used to, rubbish that the MR myelograms are too, they're over exaggerated. But this is just, to bring a bit of a thought process to this discussion. So this is the axial images. Anand, so we're coming back to Anand. These are the axial images for the 3 relevant levels, the L34, L45, and L5S1.
So if you look at all these axial images, all 3 levels, the worst is probably L45, and L34 is also damaged. And in fact, L5S1 is also not looking good with the degeneration there.
Okay,
it's not looking good.
Let's leave L5S1 out of the discussion.
Yeah.
What do you think is your case now? What do you think should be the optimum management for this kind of a case?
So we'll discuss about surgical management, provided we have given the advocate conservative managements and blocks and everything. So we'll straightforward jump to the surgical management as it is required in this scenario. So you need to adequately decompress the exiting nerves at both the levels at L34 and L45. And I would probably think about something to stabilize the spine, and this can be done by many methods: posterior open TLIF, MIS TLIF, OLIF, XLIF, and or anterior lumbar interbody fusion.
Okay, so there's a lot to be discussed. So when I was going through these images, I actually just wanted to try and look up the literature if there is anything, and I came up with virtually zero. That is there a case where there is a degenerative listhesis and a lumbar stenosis above, and there's virtually nothing on the PubMed. So I was wondering why Arvind gave me this, but then I realized he probably has a case and he wants to learn from us that what to do for this case. No comments, Arvind? Anyways, so this is the case, and so now the treatment options. So obviously all of us are thinking surgical recommendations. And so what are the options? L4-5 decompress alone, TLIF, open or MIS, L3-4, any treatment or to be left alone, decompress only, or to do include in the TLIF as well. So Anand, what would be your surgical thought processes and what would you do for this patient?
Yeah, I will decompress both levels, L34 and L45, both levels.
Right. Any stabilization?
Yeah, definitely. Decompression means I need to stabilize this. Predominantly an anterior approach surgeon, so I will definitely look into ALIF for L4.
Bilateral ALIF, double level ALIF?
Yeah, double level ALIF.
So you want to fuse both the levels and decompress both the levels.
Yes, and L3-4 is, if you look at the axial images, the facets are good. So probably L3-4 lumbar disc replacement can be performed in this position.
Okay, so that's a different thought process altogether. Raja, your call on this patient.
So I would like to ask a question to the patient. How severe is her back pain? You said there is a background back pain.
Yes.
I want to know how severe is the back pain and how much it is coming in the way of life. If that is significant, I would consider fusion at these two levels. And I would do it generally posterior T-lifts, very comfortable doing it. But also tell the patient that their L5S1 is not so great. The facets are hypertrophied already. So just be worried about it.
So here there's a significant amount of listhesis already visible on the flexion images. So even if the patient did not have a lot of back pain, would you still, kind of not think about it? Would you just leave it?
So there was a study that was published a little while ago about grade 1 listhesis. So this is grade 1 listhesis. It's not grade 2 or above. Grade 1 listhesis in degenerative spine, there's a lot of controversy whether you should fuse or not fuse. If the back pain is not so much, and the patient has more stenosis, I would be tempted to just, talk to the patient, tell them that, you could get a fusion, but you could get away without a fusion too. So grade 1 is a little, clear, not so clear for fusion. Grade 2 and above, no confusion.
Okay.
So can I just step in here for a minute?
Yeah, it was actually to come to the young guns. So yeah, Shumo, yeah, you can answer the question. Yes.
Yeah. So it is the decision about whether to fuse or not. It's not. There are many factors to consider apart from just back pain. So here we're looking at a patient who has significant amount of translation, so translatory instability. This patient also has a kyphosis there. So there's segmental kyphosis when she's on a flexion extension. The facets are more sagittal. Another important point to look at is the disc height. So this is a tall disc. It's not a settled disc. There's no osteophyte formation. So it's not settling down. It's not into a stabilizing phase.
True.
She's 57, so she's going to go through her whole mechanical, continue to put mechanical load on the spine. So given all of these, and she's sort of obese also. So given all of these, the demand from the back, the amount of instability there is, how low it is on the stabilizing curve, I don't think there's any option in this apart from fusing it. Now, the real question is, once you fuse L4-5, how many would be comfortable with just decompressing L3-4 and leaving it alone? That becomes the next question. So
that is why I put all of these up, right? So what would you do?
I think the part about L4-5 fusion and L3-4 decompression, that remains constant. Whether to add the fusion to L3-4 or not is something I would discuss with the patient and decide based on what both.
But suppose the patient is illiterate and tells you, sir, you decide.
Oh, then I would fuse it.
The best judge.
Then I would fuse it.
And you would be doing it MIS or would you be doing it?
MIS, 2-level MIS.
Level?
MIS.
And Shaishav?
Yes, sir. I think I will use both the levels. Considering a young patient must be having more years, active years, 10 at least years, 5-10 years active years. I think considering an adjacent segment to be a long-term sequelae, I think I would fuse both the levels, decompressing both the things, and doing it posterior. I would prefer MIS, endoscopic T-lift. I would do it.
Okay. Subir?
Yeah.
Can I say something?
Yeah, please, Dr. Jay.
So there are two questions here. One is whether to fuse L3-4 along with L4-5. And second, if it is to be fused anterolateral versus posterior approach. So here L3-4 seems stable compared to L4-5. So of course L4-5 need to be fused and L3-4 need to be only decompressed. That is what my view. Second is my question is, I guess you did not mention about the neurological deficit. And what about the rest? Does patient have a rest pain or?
No, it's predominantly claudication.
Only claudication, I mean it subside. And no neurological deficit, right?
No.
So that is one of the very important criteria that we should consider. Anterolateral indirect decompression would be work well compared to the posterolateral approach. So of course, LE for OLIF can be tried in this patient compared to TILIF. That is my.
Okay. So that was a good discussion. I'll just show you what I did at that point. This was way back 8-10 years back, this case. So I had done a double level fusion, and I did not do a TILIF. I did a PLF at the upper level and just a TILIF at the lower level. The patient has had good 6-year follow-up. So I'll just move on to the next case. So I have the same theme that we have, the whole theme that Arvind has sort of given me. So this was an elderly 78-year-old dentist with back and leg pain since a year, gradually increasing difficulty, and an acute exacerbation of the left lower leg pain. Again, same type of scenario. And his claudican time was very less than 5 minutes. And he had multiple comorbidities. He has been given enough conservative management, no relief. These were his films, plain films. Again, the same level, L4-5. As Raja put it, mild grade 1 listhesis. So here we have a T2 SAG of the same patient. And Shumoyu, why don't you start this one? What do you see here?
So, so before the T2 SAG, can we go to the X-ray, the lateral flex X-ray?
Yeah, I can just take you back there.
Yeah, so here what we are seeing is on the dynamics that this is not a dynamic listhesis, it's a fixed in listhesis. So there is listhesis, but it's fixed, it's locked into that listhesis position. So there's no added translation or kyphosis happening on the dynamics. And when we come to the sagittal MRI cut, which would be the next slide. So now the patient is lying down supine on the MRI bed and still it's fixed in listhesis. So this is not an unstable situation at all.
Very good.
This is just a stable stenosis.
Okay.
Now he's 78, he has a stable stenosis, multiple comorbidities, acute exacerbation of the leg pains in 6 weeks. The two choices that there's no deficits. So the two choices are either to just subside the current symptoms with which he's come, which is the exacerbation for the last 6 weeks. So after seeing the axials, maybe a steroid block would also be worthwhile, or to do just a MIS decompression.
Okay. So I also want to draw your attention to something that probably has been missed out.
Yeah. So
this is the case. Now this is the case. Okay, you have a severe stenosis at L4-5 with some listhesis. Yes, I agree it's a stable listhesis, but with definitely the inferior articular process impinging here onto the inferior aspect. And then there's a central disc here, which is causing pressure. So what
can I also add something, Subir, in the axial MRI?
Yes,
please
Raja.
Look at the horn-like facets. You would think that these patients are fixed in the little limited mobility that they have posteriorly, much posteriorly in the arrow.
Here.
Yeah. So these kind of patients with huge horns, they are the ones with have severe back pains because the facet is completely out of sync with each other. There is hardly any movement. You think so, but they're extremely painful. Even a slight degree of movement on the facet will produce severe pain. So such patients, if you just do decompression thinking it's a fixed listhesis, their back pain won't go. Their leg pain may get better, but they continue to have a nuisance of a back pain. So facetal hypertrophy, significance, don't neglect it in your algorithm.
Okay. So Shumo, you were. So what would be your plan now? Does it change?
No, this is a small central disc.
You'd prefer to leave it?
Doesn't look very significant to me. Now, the facetal arthropathy is, I think the patient's, given this patient's history and his clinical scenario, 78 with comorbidities, I think he was more affected by the leg symptoms rather than the back pain. The back pain has been chronic, has been there.
Been there for a long time, but
has been there for
any reduction would definitely be on the cards. Anyway, so what about Shaisha? your suggestion or
Sir, can I again see the sagittal MRI cuts?
Sure.
I think so. The acute exacerbation which might be there would be because of this alpha S1 disc which we're talking about.
Yes.
Generally, these discs do desiccate away, but if at all we are going with the surgery, then I think I would like to remove this fragment as well. And I think I would sit down with this patient, talk about the fusion complications which we might face in the future, considering I mean absolutely body mass index and all those things has to have been considered prior to the fusion surgery. But I think if patient asks me what my choice would be, I think I would just decompress this and ask the patient that you might require a second surgery ahead. I think I would just decompress this, but I would definitely like to discuss it out with the patient. Pros and cons of both the surgeries. It's a difficult thing, but I think I would just decompress.
Anand?
Sir, can you please place the flexion
endoscopic decompression? Yes.
Okay, so both the levels, you do both the levels or just the one level? Just the 4-5. Shaisha, would you do only L4-5 or would you do both the levels?
I think sir, both the levels.
Both the levels. Okay.
Presently, if the patient is coming with acute exacerbation and we are going in, I think I would do both the levels endoscopic.
Yeah, sorry, Anand, you can speak now.
Sir, if you can place the flexion extension X-rays. So yeah, if we look at the flexion extension X-rays, the level at L5S1 is hypermobile. It's opening up in extension, and and when we go back to the MRI scans, there is an central disc herniation, and that can be the reason for the acute symptoms for the patient right now at this point of time. So L4-5, the listhesis is stable. Most of the degenerative listhesis, they will be up to grade 1 only, very rarely up to grade 2. And like Professor Rajkumar has pointed out, the horn sign of the facet, these are going to be extremely painful. Even a slight degree of movement there, they have acute back pain. And now at looking at L5S1, since this being the reason for the pain, most likely the acute reason for the pain. So would like to fix both the levels, L4-5 and L5S1. I agree with posterior approaches, be it open or MIS TLIF and everything. Slightly different thought process here. L4-5 is a good, for me, it will be a fusion, anterior lumbar interbody fusion. And L5, since the movement is present and the facet hypertrophy is at grade 3 or probably at grade 4. And if we talk about technology, the newer latest generation of lumbar disc replacements, probably a reverse hybrid will be good for him. L5S1. The reason is I can restore the lordosis because these two are the levels which will contribute to the maximum of the lumbar lordosis. Secondly, I don't want a strain at sacroiliac joint by doing 2-level fusion in Rosolis type 3 sacral slope, which we can see here. I think it's Rosolis type 3. So reverse hybrid is one of the options where I can tackle the back pain predominantly, along with the radicular pain by doing this central decompression, indirect decompression. And also I'll take care of the sacroiliac joints in long term.
Okay.
And secondly, this surgery will be done in a supine position. There will be no load on the cardiac parameters. The surgical time, the blood loss and everything, it will be very conducive for the patient at 78 years age. He is having cardiac issues with him as well. So it's probably going to be much better and safer option for him, the anterior approach. All if is not possible at L5S1 if you look at the vessel anatomy.
True.
Compared to posterior, anterior would be more safer for me.
Okay. Raja, do you want to make a comment?
Yeah, I would do a 2-level fusion straight away. No discussion. Here, quick fusions because this man is 78-year-old. I cannot ask him to come back for surgery again and again. Tell him, look, you have a discectomy that needs to be done at L5S1. and that's still at your age is opening up. So I don't want you to come back again. Get it done once for all, and tell him the pros and cons of each. Of course, L4-5 is a definite fusion for me, and also decompress nicely at these levels. Make sure the roots are good and mobilize him as quickly as possible.
Okay, so this is what I did. I did an MIS-TLIF at the 4-5, and I did an L5-S1 discectomy. Now, it's been a year as of now. He just visited me 3-4 days back, and I got his most recent X-rays. He's absolutely stable. He has no complaints, and he's able to walk 4 kilometers now.
So there is no fusion at 1 year.
He has. I have. There may be some, but I'm still not seeing. He's 1 year out. He was operated last March 21. It's been a year. We are still, despite all the graph that we put in, I sometimes tend to see more fusion at 2 years other than at the 1 year mark. I don't know why, but at 2 years, sometimes we see solid fusions. So I'll quickly go through the next case because this was the base for my next case, which is what I wanted to, discuss with the house. And I'll be quick. Again, the similar type of scenario, elderly gentleman, back and leg pain, 2 years, acute exacerbation, claudication, difficulty in walking, some weakness and numbness. These were his plain films. I'll quickly brush through so that we get to the gist of the matter. And then this was his MRI. The patient had a significant stenosis at L4-5 and a disc herniation at L5-S1. But interestingly, the MR Myelo, Raja, this is just a quick note for you, was only showing compression at the 1 level and not at the L5-S1.
Exactly, Subir. I need to interfere here. I'm not sure whether it's a 1.5 Tesla machine. If you leave the color, the picture.
In Ahmedabad, sir, most of these are 1.5. These are 1.5 because in Ahmedabad we get only 1.5. Nothing less is acceptable. So all are 1.5 and above.
But Subir, the L5 canal is huge. It's just a posterolateral disc and this is a mid-sagittal myelo.
Could be. That you are true. You are right. So
see, the lateral part of the roots can be seen to be depending on how the myelogram is done. Myelogram is in different planes. So if you put a little anterior part, you can see it's a level of cut. That's all, nothing else.
Okay, so we'll just move on quickly. I want to show something. And so this patient, obviously based on what we had discussed previously, most of you would probably, there was a diverse opinion. We didn't even, have an agreement on who would do what. But here, Shumoyu, would you do something different?
No,
just a double level discectomy as you did, as you would recommend in the previous case.
Yeah, so the L4-5 decompression definitely, but at L5-S1, is that disc herniation symptomatic? Is there a SLR positive? Is there something to indicate that the symptoms are coming from there also?
I am not sure.
I mean, apart from being just radiologically
numbness, he had new onset numbness with the pain. So there was some mild neurological involvement and acute exacerbations last 4 weeks. So SLR, I don't recollect, but I think that was what actually drove him to me and eventually to another surgeon. But
so then a 2-level decompression.
So do 2-level decompression. Shaishav, quickly from your side.
Yes, sir. I think 2-level. If the acute exacerbation is there, I think it might be mostly because of the test.
So 2-level what? Decompression, 2-level fusion.
Just the decompression. In elderly patients, I think I would like. I'm more sure.
Okay. And Anand?
A 2-level decompression and fusion.
You don't want to do any and fusion. Sorry. Okay. And fusion. And Raja? Same?
Maybe just fusion.
Okay. So we have a divided house here. We have the 2 young guns not opting for fusion, and we have the senior guys opting for fusion. Usually we would have seen the other way around, because the more you see, the more complications, the more you want to do less on the spine rather than to do more.
Can I?
So anyways, I'll just quickly move.
Hey,
Arvind, you are live. Arvind, you are live.
Your dog is coming.
But can I ask a question? If this patient warrants a fusion, then which patient gets a decompression only? What is the case that gets only decompressed?
I'll show you some other list of cases where we do only decompressions. Anyway, so this was not done by me. This was done by another colleague. Somebody else operated on him, despite him coming to me for the first time. But he underwent a fusion and an open discectomy by another senior colleague. And then once this was done, he was quite comfortable and he was moving around for 10 months. Till about then he began to have again leg pain and again new onset weakness. His weakness had already recovered. And then he again began to have the same weakness in the same leg. And then I got a fresh MRI done. And this is what we are looking at. So now, Shaishav, what do you see?
Yes, sir. Left-sided alpha S1 disc.
This is a huge recurrence. If you see the size of the fragment, it is much larger than what was initially taken out. Right. So, and you can see the decompression was also quite well done. You can see that a large area has been denuded, but perhaps the strain of a proximal level fusion and a rent in the annulus has led to the problem.
I think it's just unfortunate. I mean,
yeah.
So, Dr. Datta, may I ask you a question? What would you do now?
So that is why I put the case here.
No, but sir, this situation would not have arose in the first place because I would have done a 2-level decompression. This is because the whoever has done the surgery has done the worst of both, has fused one and decompressed both rather than decompressing both or fusing both. So this is the end result of that mistake.
Because I got away with the same scenario in the previous case.
True.
This patient did not get away with, doing a hybrid kind of a scenario. You decompress one and you fuse the other. So that's why I wanted to, share both the cases here, that this is the scenario that happened. And eventually, I think we all know what needs to be done in this case now. Right?
You know what it is, Subair?
Yeah.
Sometimes we end up with damned if you do and damned if you don't.
That's spine surgery. Well, the seniors in orthopedics, when I took spine surgery, told me, okay, that is basically a garbage dump. If you put your hands in it, they'll get black. Don't do it. That was the advice. But eventually I decided to go ahead. And yes, I agree. 15% cases are like that whatever you do, they're going to come back. But at least we end up helping 85 to 90% of our patients much better than what they were before. So this is what eventually I did. I did a revision and then did a TLIF at the lower end with obviously a rod exchange and a longer rod. This S1 is a little longer, but fortunately I got away with it. He didn't have any radicular pains from that long S1. So he is currently 3 years out. This is
9534.
Yeah, so that is what is up next.
Yes, I was going to tell you that.
Sir, if you go back to the X-rays again, post-op X-rays.
This one or the original ones?
Yeah.
Yeah, what did you want to say?
No, I think Anand was trying to see whether the rods were touching the facets, right, Anand?
No, sir. I was looking at the lordosis, trying to see the lordosis, because these are the two levels which contribute to the maximum percentage of lordosis here. And don't know, can't predict whether L3-4 is going to be a problem or not. But yeah, looks.
His pelvic incidence doesn't look great.
Yeah, doesn't look great.
For the degree of pelvic incidence, the degree of lordosis looks fine.
Yeah, so pelvic incidence is not looking great here, and even the sacral slope is also, it's too high. We can't calculate, but probably it's around 30, more than 30, maybe. And that is a recipe for an adjacent segment failure.
But it is not bad, yeah?
Yeah.
You see, if you look at the lumbar and the sacral slope, not looking too bad, Anand.
We can't say until unless you get the full length standing.
Fair enough. I'm assuming that these are erect spine X-rays.
No, no,
And
no.
looks reasonably okay.
These are not standing. These are probably horizontal.
Okay. So now what next? L34?
So we don't know. He's just been complaining some tingling numbness, but this was just the
It's gone.
last
It's gone. You can see the
MRI in
blade injury.
November, and I can see that he probably may come back.
So maybe Dr. Datta's suggestion that don't fuse, do decompression, wait, and then once for all do the whole lumbar spine fusion. What, Datta?
Remove all the screws.
Always something new.
All the screws.
And
with
L45 we have already fused long time back. So remove screws.
But then do what? What would that help?
Just do a decompression. No one is wiser in this. No one is wiser in this.
So my answer to such patients.
What benefit do you get by removing the screws if it's already fused?
He will be lighter.
In the pocket as well.
No. Jokes apart, Alok, I'll tell you, in such patients, whichever way you do, you're either right or you're wrong. They continue to come to you with more progression problems. So in such patient, in hindsight, I agree with Datta that we should do less and hope for the best.
So quickly, I would just like to summarize why I brought these last two cases to add to the discussion. Was that solution to degenerative listhesis as well? Grade 1 probably is definitely a case that needs discussions, and maybe yes, no. But other than that, it's more or less a fusion as far as we are concerned. Whenever there is an adjacent level pathology, be it a disc prolapse or an adjacent level stenosis, that is where the questions arise. In MIS, there are good chances that you may get away with just a discectomy or a decompression at an adjacent level using these MIS techniques. But if you're doing an open, then the lamina and the soft tissues that do not allow the surgeon to be exonerated, and you have to consider an additional level stabilization if you're doing a 2-level fixation. That's just my take and message from these 3 cases. And I thank Arvind and the rest of the MISSAB team for having all of us here. I hope we are well within time. If not, we have overshot a little bit.
Sure.
Ajay.
Yeah.
We hand over the mic to you guys.
Wonderful.
So the question still remains: if you have L4-5 listhesis and also have a L3-4 stenosis, what to do? Moderate stenosis. The question still remains. Should you consider fusing that level or decompressing that level, or wait?
No, if you're doing MIS, my answer is you can just do decompress and get away with it. If you're doing a fusion below, then you can. If you're doing by MIS, if you're doing open, I would just fuse both the levels.
When in doubt, don't fuse.
Anybody else wants to comment?
Yeah, when in doubt, I have learned one thing. When in doubt, don't fuse.
I agree with Alok.
Okay, now I have come back. When in doubt, I don't go towards fusion. I go towards.
Actually, when in doubt, fuse.
No, that's what I'm saying. That cycle you will also go across. Some more black hairs will come, and then you will say the same thing what I'm saying now.
No, Ajay, it's a fundamental difference between the neurosurgeon and the orthopedic surgeon.
No. It's not like that. It's basically, I agree with Alok in a way that as you get more and more experience, you understand the less you do with the spine, the better it is, and the happier are the outcomes, and the patients are happier, and you get less heartache and heartburn in the outpatient department. So,
one thing I can tell you guys, I have to interrupt for a minute, Subir.
Yeah.
The moment you put metal, the moment you put fusion, the responsibility on the surgeon is far more than just do decompression. This is the opinion I have got from my patients. The moment you put rods, screws, stuff, whatever you do, they'll think it is a far bigger surgery, cost more, and their anticipation of recovery and outcomes are all far better, higher. If you do a decompression, then the anticipation is there, is lesser, and even if something goes south, you still have a chance to do fusion. Once you have done fusion, the only thing you can do is decompression elsewhere or add fusion. Yeah. So there is a little psyche going on here between patients and you and how you talk. And I think this balance has to be learned.
I believe that ever since I am doing these anterior approaches, I do see very less amount of revisions. Probably I'm not damaging any structures at the back. I'm preserving all the joints, ligaments, and everything. Probably the adjacent rates are very less with anterior approaches, be it ILIF or be it OLIF. It's very less compared to the
No,
posterior.
no, I have a feeling it's different, Anand. It's nothing to do with the structures.
Yeah,
I think
exactly.
you're trying to do lordosis correction better. Many
Better.
times
Yeah.
when we are doing posterior fusions, we are in the process of finishing surgery. We are not thinking of lordosis as commonly. Many times you see post-op X-rays at the segment where it is fused, it is either straight or even mildly kyphotic. If we take time to assess lordosis on the table, and think about it in the whole spine, what happens to the patient standing up, your post-op complications and adjacent level problems will come down.
Will come down,
It's
sir.
something
Definitely.
to do with lordosis rather than tissue damage, because all of us do minimal access. We can't all be wrong.
Yeah, exactly, sir. It's all about balance. If it is restored properly, then secondly, degenerative disc disease, it's genetically linked. And if there is any sign of degeneration at the adjacent leg well and the bottom level, they will add on to the stress and they are going to either you are accelerating the degeneration process over there.
Exactly. Lordosis plays a key role. And many times, and I'm culprit to that too, and I'm very honest about it, that, you look at the post-op films and year down the line and say, Arre Baba, I should have given a little more lordosis. See, you don't discuss this with patients. You think about it, and perhaps if your mind is something else doing surgery, you don't look at the lordosis again. I think we are overshooting time. I agree. We'll go to the next one.
I will tell you about a very famous orthopedic surgeon who believes so much on lordosis. And every now and then I see his picture. He's from another city. Beautiful lordosis. Story is not that simple. A lot of patients come out with back pain. So lots more factors are there. It's not only lordotic, but which is important.
Thank you so much. Thank you so much, all the panelists, senior stalwarts of spine surgery, for the wisdom of the comments. And now we shall move to the next session, and that is very interesting. L5S1 grade 2 spondylolisthesis causing severe back pain, especially particularly with T-score 3.5. Would like to invite Dr. Sailesh Hadgaonkar. Dr. Sailesh.
Hello, everyone. Thank you, Dr. Kulkarni and Team MISSAB for giving us this opportunity for a grade 2 listhesis with osteoporosis talk and discussions mainly. And we will be having the panelists, Dr. Vishal Peshettiwar, Dr. Sumit Sinha, Dr. Shankarachar, and Dr. Gururaj. And I hope all of our panelists are there, and Chairperson, Dr. Ketan Deshpande and Dr. Jayesh. Let's start. I'm just going to share the screen. Yeah, can you see the screen?
Yeah,
Yes,
please.
sir.
But somehow I'll just
make it slideshow and then start sharing, Shailesh.
I'm just doing that.
So minimize your Zoom window.
It's sorted. Yeah. Okay. All right. Thank you. Let's start with the case. And a 67-year-old female, back pain since 4 years. And this is her X-ray. Been treated by many pathy doctors, allopathy and naturopathy, orthopedic surgeons, and her pain was persistent. And it started radiating to her lower limbs in, say, around 8-9 months, which worsened. And there was significant claudication, could not walk much, could not stand much, tolerance was reduced. And when we see these images, what is the next thing you will think in your mind, Guru Raj?
So she continues to have back pain, right? After the claudication, she still has a back pain.
Yeah.
Okay, and basically with back pain and claudication with kind of a listhesis, lytic listhesis we are seeing, it's a kind of straightforward. I would like to basically, this is flexion extension X-rays?
Yeah.
Which is flexion, which is extension, I don't know, but then it looks like lot stable.
The one on the left is flexion, the one is on the right is extension. Yeah.
It looks lot stable, but then I think there is a translational instability still there.
Yeah.
Because if you see the foramen and the pars, definitely there is a movement which is happening there.
Yes.
And even though there is disc space is reduced and it looks like a bone on bone, but still there is some movement happening there. That is why she is having back pain. And we know that with this, she has a foraminal stenosis. And if I see MRI, I would be happy to see whether there is a central canal stenosis is there or not. So if with that, actually with less than 5 minutes walking distance and all that, actually I would straight away basically advise surgery in this patient.
Yeah, Dr. Vishal. Is there a patient you are around?
Dr. Vishal, you are mute. Kindly.
I agree with what Dr. Guru has just said. We'll need to investigate her in form of an MRI, probably a DEXA scan to check her T-score, and then take a call of what to do. Looks like a surgical case.
Okay, Dr. Acharya.
Yeah, good afternoon, everyone. I think the setting has been set by Shailesh that this is an osteoporotic lytic listhesis. Though it looks like bone on bone and stable, actually when you position these patients, sometimes they open up and then you may have to do an interbody. And if they don't and they are stable, then I fix them in situ. But obviously you need to see all pictures, the MR and the bone density.
Okay. We'll go on the MR. And DEXA score was minus 3.5.
Foraminal stenosis essentially.
Yeah. But Shailesh, we have to be careful, like when we say DEXA is minus 3.5, it can be actually in this kind of lytic listhesis because of this chronic movement and degenerative changes happening there. Actually, the end plate of, if this is, I suppose this is L4-5 rather than L5-S1.
Yes.
If we count it from above, I think it's L4-5-1. The superior end plate of L5 will be sclerosed. And maybe you can surprise you, for your surprise, you might find the hold in L4 pedicle also is good. So to see a individual level DEXA scores at L4 and L5 is also important. Not an overall DEXA score like minus 3.5. It's
Correct.
better to see an individual level DEXA score before you plan your surgery in this patient.
Okay. That's a valid point. Any addition, Dr. Vishal?
So I agree with Guru on this one, that we'll actually get a good hold in L5 because if you see the X-ray, because of the chronic, how to say, rubbing between the L4 and L5 there, the superior part of the L5 there is going to be very hard. Here, this L5 is going to behave like an S1. So if at all I'm going to operate, I'm going to try and reach it anteriorly at the superior edge so as to get the best possible purchase, because except for the anterior half of L5, the posterior half and pedicles are barely going to have any purchase. So your aim is going to get to that anterior part and anchor your screw there.
Any views, Dr. Acharya?
And also another thing with DEXA scan. DEXA scan is not so good in confirming the reality of an osteoporosis. Sometimes you find there's a lot of caveats. Slight degeneration, scoliosis, some osteophytes, some overlap. You will find that the DEXA is good and you may have osteoporosis, or the other way around. Thing I think is what Guru said, is individual bones important. Second, you must also have a DEXA of the hip and the forearm if possible. Okay. Thirdly, normally if I really feel that it's osteoporotic and
and the balance is not good. The other thing that some of these ladies come forward with positive sagittal balance, some don't have so much positive sagittal balance. Some may be because of the pain and claudication, some may be actual. So you need to clinically define all this before you go in just for an X-ray and a MR picture and then decide for surgery. And obviously level facet above is also important to decide.
At how many times, Vishal, you feel that when you go and you actually purchase the pedicle, you find the surprise very poor purchase?
So if this is a chronic case, which in this case it is, from the X-ray, I can say with fair amount of certainty the pedicle will have no hole. Typically, 60% of purchase of a pedicle screw comes from the purchase in the cortical pedicle, because you have a cortical wall which gives the compactness to the screw. Unfortunately, here it is not going to be so because of the poor score. You will have to have your purchase anteriorly at the tip. That is the front half of the body is where the most dense bone is, and unless you have got a good grip there, that pedicle screw is going to have no purchase. That's my personal experience. I can be wrong in some of the cases, but majority of them, you got to have your purchase there.
Yes, Guru.
Yeah, actually, Dr. Jala just typed in the chat box that actually the good idea to have CT units of individual bones. To actually to plan, like Nikhil asked in the chat box, that whether the plan of surgery will change. I think plan of surgery will not change much, but then the kind of implant we are going to use, whether we are going to use a cement augmented pedicle screws or bicortical screws, or whether dual threaded screws, that actually matters. I think the plan of surgery really doesn't change whether it's osteoporotic or not.
Now you know it is a very poor quality bone stock, and it's in front of you. What will be your preferred screw?
So I think, see, in our center, we usually tend to do a cement augmented pedicle screws. But then if I'm doing a single level TLIF for a single level fusion, we have found that it really doesn't matter. But then if under, like Dr. Shankaracharya already said, when I position this patient under anesthesia in prone, and I see that this opens up and there is some movement, I would straight away go ahead and do a normal pedicle screw. And I'm sure that I will have a, if not a good purchase, I will have an optimal purchase to at least get back this listhesis to grade 1, and then achieve some disc height and relieve of her symptoms. But then if it doesn't open at all when I position, then I might think of doing a dual threaded screw or a cement augmented pedicle screw.
Is Arvind around?
You can do a delta fixation also here. No? You can fix this one too.
Okay. Yeah, Shailesh. Yeah, Shankar sir just said you can do a delta fixation. Your take, Arvind. Yeah, this is a good case. If you look at the trajectory, it's a good case to go through and through. But I would change my mind once the patient is positioned. If it opens up,
okay,
I'll do the regular TLIF in this case.
Shailesh, go back to the MRI, please.
Yeah.
Shailesh, can I talk about delta fixation in this patient particularly?
You can, please.
So because if it is a L4-5, I don't think if you see your CT or your pedicles, whether we'll be able to do a delta fixation in this patient, because there is no kyphosis here. So the end plates are parallel. To get a purchase from L5 to L4 is going to be difficult here unless there is a kyphosis. Correct. So I'm not sure whether I'll be able to do a delta fixation in this patient. I would like to study my CT properly, see my pedicle orientations, and then decide.
So Shailesh, another point I'd like to make, if you see the MRI, which has been done in supine position, there is a disc space. I believe your X-rays have been done in standing position. That's why it appears to be collapsed.
Yes.
So trying a delta fixation where you obviously have a disc space, I would rather restore the disc height and then get my screws to hold it than use my screws to get purchase on this. So that's one thing. Most of these guys will have some space on an MRI, which is an indicator that it's going to open up.
Yeah, the posterior inferior vertical body is on that ridge of L5 grade 2, and at that times, it's not easy to reduce. I can definitely say it's not difficult to reduce any case, but it's not the case. If you really want to have a minimal dissection, minimal bleeding, and very, very less invasion of surgery,
we can definitely consider delta in this particular scenario.
Shailesh, may I add a point?
Yes.
You see, I've been listening to this kind of discussion over time, and I believe that all these patients have a disc, sometimes dried up, but possible to get into. The trick we need to do here is you can drill a bit to the posterior border of either the L5 in this case, or the S1, whatever the case may be, or the L4 posterior border, and you enter the disc space, and then you'll have a nice way to expand the disc space. If you have done an adequate, I'm doing all this minimal access, and I've had no problems accessing the disc space. Disc space you can get as long as your direction of the posterior border drilling is done. And remember, when you're drilling the posterior border of the vertebra above or below, whichever is convenient for you, you're doing only a small part, maybe 3 or 4 mm, just enough for you to get the area to go into the disc. And all of this will have discs, and MRI shows it has discs. So I'm not sure whether you should even try a delta fixation without even trying a normal discectomy and putting a spacer there and see whether it moves.
Okay. If you see that contour of the end plate, the inferior end plate of L5, the way it is sitting on S1, whatever the level is marked in the MR, it's looking very, very close knit with the S1 vertebral body.
But you should look at the MRI, Shailesh.
So this is a sitting, this is a standing X-ray.
Standing X-ray.
It is going to be like that because there is no, the disc has collapsed.
Yeah, it's collapsed.
When you see the MRI, there is a fair amount of space. And like Dr. Deshpande said, you can get into the space and restore. Correct. The whole idea is to try and restore to the normal sagittal balance and normal anatomy.
Correct.
So if that is not possible, then yes, you go in for a delta fixation. But if it's possible, every attempt should be made.
Okay.
Shailesh,
yes.
That's a point. See, when you talk of delta fixation, so then you need to do a thorough decompression of your exiting root. Thorough,
correct.
Absolutely thorough. So here, if you're doing jacking up the disc space, putting your screws, you might even not see the roots, but you'll still get good symptom relief. So that is one difference between these two techniques.
Correct, Arvind. I agree with all of you. So let's proceed with what we have done.
Now, before that, can I ask the panelists, if you allow, all the wise people, that those, it's my impression is that when you do a decompression, you need to do a bilateral decompression in order to get a reduction. I know that Dr. Deshpande does an indirect reduction and distracts and then rocks and rolls and then it gets reduced. And if you keep the midline and you do that, maybe you get a reduction. But obviously, if you are looking at an osteoporotic patient, would be a worry for me. And if I want to restore the lordosis, I have to look at what my aim is here. My aim is actually to get bilateral decompression and fix it with minimum distraction. Even if I get a 7 or 8 millimeter cage, I'm good enough. I don't want to distract too much and fix it. So, but I don't know what others do and how things have changed. I would be interested to learn.
Shailesh, the one reason we introduced this score, minus 3.5 or 4, was to check what is the consensus of the panel on treating osteoporosis simultaneously, or should you prepare this patient first and then operate, and what should be the timeline, etc.
Correct. That's a very important, valid point, Arvind. And as you all know, most of our colleagues, they are very good in treating osteoporosis. This lady was already on teriparatide, 8-9 months, was already given all possible allodonates were already went in because she was having this for on and off for last 4 years.
No, but what are the rules of the game? Should we start, wait, and then operate? Should we simultaneously initiate both operate as well as initiate anti-osteoporotic?
I think the rule is very simple, Arvind. Pre-optimize your patient as much as possible unless it's an emergency. So that's always a gray area. So you will, surgeon, the patient, the factors decide what is an emergency and what is pre-optimization. And each has an individual practice to work on. So I normally optimize the patient as much as I can. Even in diabetes, high diabetes, I wouldn't operate unless I get a HbA1c up to 7.5.
Yes.
So they get these patients. So it's
Dr. Sina is there, Dr. Sumit Sina?
He's not well.
Okay. So let's proceed with what we did. We did the same delta. What we are doing is, I just spoke about all these different options, and we'll not go into the detail of this. The less invasive modified O-arm delta, and we do unilateral exposure, very small incision. And if you see the trajectory, and we use these small portals for the transpedicular, transdiscal, transcorporeal screws, TPDC. And because of O-arm navigation, we really can see the foramens very well, and that's the biggest advantage. You are seeing everything in 3 dimensions. You are seeing it in real time, and that's where you really can be very confident about putting your screw. You need a very longer length, appropriate screw and trajectory. Hardly 60-70 mils is the blood loss in this. And we are doing this open for last 15 years. And now we started doing the less invasive ones. And the biggest advantage which we have realized it, that minimal incision, second day patient can be mobilized, stable to stable, no need of thinking what screw I have used, because you have got a very good hold in the vertebral body, and operative time also is very, very less. Patient can be mobilized very, very fast. I'm just going screening through this one more case, as this is again a grade 2 to 3 high grade listhesis with T-score of -3, and the same technique, and we can get a very good sagittal contour, very good decompression, and very good outcome also. You don't need to go to L4, you don't need to go to L3, long segment fixation, nothing. You just need to do a good decompression at the, most of them are unilateral or bilateral symptoms. If it is bilateral, you can do over the top, release the nerve root, and that's it. It's now recently we are doing these cases in around 60-70 minutes, 80 minutes. We are completing the surgery, which used to take around 1.5 to 3 hours, you know. Yes, Shankar sir.
It's very good. I think you've got fantastic results. Though I would do delta, but I don't do as often as you have done. And I agree with Guru that when you do delta and L5, you have to be very careful because they behave as L5 and not as S1. And the trajectory is different. And there is less kyphosis. So you need to look at a slightly vertical sacrum with some kyphosis to get a good delta. But I think you've got very good cases because of O-arm, you've been able to accurately position them and got a full bicortical purchase. So it's good.
Yes, I think, see, this, especially this second case with your pelvic tilt being 25. So I would be a little wary of doing a delta fixation here. You have some disc space there. So I would try as much as possible to reduce them at least to grade 2 or grade 1.
Okay.
So that is my take on it.
I'm sorry. Are you packing the disc space with any?
We are packing the disc spaces. We are doing a posterolateral both.
How do you pack the disc space? Do you go through the hole that you have drilled, or do you?
Yes. No. We just go from the facet. We release the facet on one side and we go on the disc where we clear the interbody area and we put bone grafts.
How do you prepare the disc? Like a normal tailor?
With the curates mainly, because there is not much of a space at that space, that level. We don't try to distract much.
Why you don't want to distract much? If you are able to access the disc space, why not to distract?
No, we have done many 4, 5 spondyloptosis, many cases we have reduced, but this is one way in osteoporotic spine where you don't want to do too much. Where you want, yes, 68 year, -3, bone quality soft, just do a standard, simple in situ fusion and get a good outcome. Reduction is not a difficult situation. Reduction, you can do it in any case.
Shailesh, I
Yes.
want to ask you, reserve this for purely osteoporotic patient? Is that what you're trying to
Yes,
tell?
high grade only osteoporosis where bone quality is very soft. Otherwise, we are reducing, sir. We are reducing optosis 5, 4, 3, anything. That's not the question.
So you have done the in situ fixation, kind of in situ fixation.
Yes.
What about the exiting nerve roots?
Yeah, exiting nerve roots, you can definitely, because we are opening it from the side of pain, we are going from the side of pain, where we are completely decompressing the exiting as well as traversing route. We are going over the top for the opposite side also. So once you start, because as we used to do open, and we have done quite a reasonable amount of deltas. So we are quite used to this formula of decompression in this, because ultimately patients are in high grades, they are mainly worried about the leg symptoms. Back pain, they are okay to accept, it is ongoing for a long time. The root decompression is the key, but you can definitely do it.
And how much is the reduction in back pain?
I can say that around 70 to 80% patients are significantly happy. And maybe 20%, they keep talking about back pain and some symptoms.
What do you do for them?
No, basically medical management, and it's not that we fuse everyone and they are completely happy. The general happiness quotient on a scale of 10 is nearly same for these cases and interbody cases.
Anand, you are asking these questions. You have any train of thought that you would like to explore? I mean, tell us why you are asking this.
Yeah, I'm asking this because there will be some element of back pain in these kind of fixations, definitely. And predominantly, I'm an anterior surgeon now, and I can get rid of the back pain significantly based on ODI, RMDQs, and even SF36 by standalone anterior approaches. The key in anterior approach is you achieve a fusion before they fail. So that's why I use BMP.
No, but when you're doing anterior in osteoporotic patients, how sure are you that with your aggressive discectomy, you will not have subsidence as one, or the screw or cage having issues? And you cannot simply say, I have done 10,000 and say everybody is hunky-dory. I'm sure there will be a subset of patients who you run into problems and you may have to supplement posterior approaches afterwards.
Sir,
So
any distraction?
my only thinking, Anand, is your train of thought.
Sir,
because I want to pick your brain only for one reason. Does osteoporotic patients make any difference to anterior or posterior approach is what I'm asking you.
In anterior approaches, osteoporosis doesn't make any significant difference if you compare with the posterior. Number two, subsidence, it happens. It can happen in posterior as well. But in ALF, if you distract more than 15 millimeters, say if you get a distraction, say 16 or 17 mm, they are going to subside. So up to 15 millimeter, it's okay. In osteoporosis, yes, definitely there can be subsidence. I stage my procedures. If I see subsidence, it's a significant subsidence which is causing any later on compression on the nerves, then go in from the back and stabilize by MIS pedicle screws.
So Anand, sorry. So in these patients where there is almost like bone-on-bone situation, till what you distract these patients? Like, so I will be very skeptical, I would say, because when we try to distract these patients, you can end up having a breach into a bony cortical end plate, and then you can have serious problems with subsidence. Because in posterior we release both the facets, we take out the pars, we do kind of a 270-degree release. Still it happens. In anterior, you're not doing anything in the posterior. You're just going to do from anterior distraction. How confidently we can do that?
Guru, when you're doing distraction from the posterior, it's a very small instrument which is going in. It's like a bullet and you're distracting. So the forces are too much when you're applying that torque, and the end plate they will reach. With anterior distractor, you are placing your distractor. They are so big, you are placing them on the strong cortical ring of bone, and then you are distracting gently. So that's why probably in ALFs, when you distract, the chances of cortical breach is less because there is an even distribution of forces. And then I'm using the strong cortical ring of the entire vertebral body to distract. So the breach, the chances of breach is less. in posterior, you're using a bullet kind of a distractor that is directly placed on the weakest part of the bone, which is in the center. And there are chances that there will be cortical breach.
Yeah, and Dr. Anand, one question which you asked for back when we have some senior surgeons, some neurosurgeons, they used to say we have done so many lytics and we just decompress and patients are fine. You know, they come to us with leg pain mainly, and back pain is always there. And they have managed it for 20 years, 25 years, and they're very happy. That's what their experience is, which we normally don't want to accept it. You know, we want to stabilize it to get a better measure for instability. But that's the probable answer. You know, you need to decompress well and give a reasonable stability in this osteoporotics to get a better outcome. Whichever way you can
slightly disagree with this thought process, because patient is coming to you, he doesn't understand about the fixation. It's the idea which you are selling to the patient that you need a fixation. He's coming to you to get rid of his symptoms, and if you can get rid of his leg and as well as back pain by no matter whatever technique, be it posterior, lateral, anterior, whatever technique, that is most important. That is what the patient is there for you for. He doesn't understand any fusion or anything. That's the idea which you are selling.
Yeah, correct.
Celis, can we?
I think you should progress, guys.
Yeah, we'll go to one next case. And again, a 63-year-old patient, back pain, bias 8 on 10 and leg symptoms. And this is the high-grade listhesis, DEXA score -3.
Yes, since we are running out of time, I think you can just skip to the final part.
Okay.
Better to summarize.
Yeah.
Okay. And we will just go as per everyone was talking about, short, long, and this is the MIS. We could manage to do it very well, and the VAS score for back and leg reduced to 3. I think ideal candidates, there is no ideal candidate. It's a patient and you. That's the most important. We need to understand the needs of the patient and what exactly the patient is come to us for. Back pain and leg pain, both the things we need to tackle well. Wherever there is an opportunity for interbody, we always prefer to do an interbody fusion reduction and instrumented fixation. This is the most important thing, that osteoporosis sometimes can be a problem because there can be a poor hold, pseudoarthrosis, how much, and various papers have come, you know, they talk about treatment of osteoporosis per se in these kind of patients. Always it is going to be a challenge, because a lot of time even if you are treating, the scores will not improve, but patient will. Using the good screw and system is also important. Release for these high grades for leg symptoms is important, and you have to be very careful. And as the age progresses, safety and safe surgery is important, because patients are coming for not foot drop at this age. They want just a relief for their leg symptoms. Whatever system you use and whatever technique you are acquainted, that's the important thing. You can go front, back, any delta as per the experience which you have. Thank you very much for patient hearing, and all the panelists, chairpersons, and team MISSAB, and especially Dr. Arvind Kulkarni for giving us this opportunity. Thank you.
Thank you so much, Dr. Shailesh, for wonderful interaction and discussion. Would like to thank Dr. Vishal, Dr. Shankaracharya, and Dr. Gururaj for wisdom of advice for osteoporosis. Thank you so much. And I would like to thank Dr. Ketan Deshpande, my co-chair, and Dr. Arvind, and we are closing this session. Thank you all. Now I'd like to hand over to Dr. Arvind Kulkarni.
So we had a fantastic round of discussions on various interesting topics. So thank you, Dr. Jayesh and Dr. Ketan, for managing this particular symposium, part of the symposium. So next we go to the second free paper session. I'd like to invite Dr. Devesh Dholakia and Dr. Amit Sharma to chair this particular session, and invite the first speaker. Thank you.
Thank you, Arvind. So we have 4 papers coming up in this session. So the first paper is from your team only, I think. Timing of vertebroplasty in osteoporotic vertebral compression fracture, to be presented by Sharvari Gunjotikar. Can we have Dr. Sharvari's talk, please?
Good morning, everyone. My name is Dr. Sharvari, and my topic for today is timing of vertebroplasty in osteoporotic vertebral compression fractures. Vertebral compression fractures are common in elderly osteoporotic patients with an estimated annual incidence of 1.4 million fractures occurring worldwide. The incidence of osteoporotic vertebral compression fractures is estimated to be 5 to 10% in women in their 5th and 6th decade of life, and as high as 30% in women over 80 years of age. With increased life expectancy of the geriatric population, osteoporotic vertebral compression fractures have become a major source of pain and disability, often leading to significant morbidity and sometimes even mortality. While treating osteoporotic vertebral compression fractures, we are faced with a number of challenges. These patients often have a very poor osteogenic potential with World Health Organization T-scores less than -2.5. The dorsolumbar junction at which they occur is a high stress zone. There are high chances of non-union and kyphosis, which may require major surgery and instrumented fusion later. These patients often are elderly with a number of comorbidities which predispose them to infection, and they're predisposed to immobilization-related complications like DVT, pulmonary embolism, etc. While treating these fractures, there are a number of treatment modalities like rest, analgesics, bracing, physiotherapy, percutaneous vertebroplasty, and kyphoplasty. There are a number of proven benefits of vertebroplasty or kyphoplasty, which include quicker pain relief, earlier mobilization, fewer immobilization-related complications like UTI, DVT, thromboembolism, pressure sores, and pneumonia. However, the ideal timing at which vertebroplasty should be done is a matter of constant debate. So with this background in mind, we carried out a PubMed search for literature from January 2000 to January 2021 with the keywords acute vertebral compression fractures, vertebroplasty, and osteoporosis. We reviewed 107 abstracts and excluded any case reports, case series, animal studies, retrospective studies, and texts that were not English literature. And we included 16 articles. These 16 articles gave us a number of 1,836 patients, out of which 1,096 patients underwent percutaneous vertebroplasty or kyphoplasty, and 740 patients underwent either medical management or placebo. Majority of these females, that is close to almost 1,300, were females. The range of duration of symptoms in these patients was from 2 days to 12 months. Among all the studies, majority of the studies showed a beneficial effect of vertebroplasty, except for these 2 studies, which did not show any beneficial effect of vertebroplasty or other forms of treatment, possibly because of longer duration of symptoms in these patients. Coming to the pain scores, vertebroplasty patients had significantly lower pain scores at immediate post-operative period and at a later follow-up. It is interesting to see that this study where Diamond et al. Showed that vertebroplasty when done before 3 weeks, 33% of their patients had immediate pain scores less than 4. And 74% of patients versus only 48% of patients in the control group had pain scores less than 4. Vertebroplasty patients also have lesser analgesic requirement. They have a shorter length of hospital stay and quicker mobilization. 13 out of 55 patients in this study were able to stop all forms of analgesics within 24 hours, and 40% of the patients had a shorter length of hospital stay in the vertebroplasty group. Not only did they have these benefits, they also had a lower analgesic class requirement as compared to other patients. Coming to the functional outcome, vertebroplasty when done at an average of 2 to 21 days had better results functionally as compared to when it was done at a later date. In addition to all these benefits, vertebroplasty patients also had a better correction of fracture-related kyphosis when it was done before 6 weeks. A 4.3 degree correction was possible when it was done before 6 weeks versus only a 1.7 degree correction when it was done after 6 weeks. Vertebroplasty patients also had lesser loss of vertebral body height. That is only 27% for vertebroplasty patients as compared to 63% for placebo group. So this is a recent study that we have undertaken in our unit. So DEXA scan overestimates trabecular bone mineral density due to a number of factors. We found that there was a statistically significant difference between the QCT and DEXA T-scores with respect to the mean, that is the average, and the mode, that is the most recurring number. With DEXA T-scores being on an average minus 1.6 versus QCT T-scores being minus 2.7. Vertebroplasty patients also had fewer medical as well as neurological complications. In conclusion, I would like to say that vertebroplasty should be done within 6 weeks of the fracture on account of better reduction in pain scores, improved function, lesser analgesic requirement, better correction of fracture-related kyphosis, and thus sagittal balance. However, how early should vertebroplasty be done, whether at 3 weeks, 4 weeks, or 5 weeks, is a matter that needs further evaluation. Thank you for your time.
Thank you, Dr. Sarvari. Fantastic review of literature. Was there any, would you be able to throw some light on whether doing an early vertebroplasty can be harmful, or like you mentioned in some papers, the vertebroplasty was done at day 2 of injury as well. We tend to avoid doing vertebroplasty for at least initial 3 to 4 weeks for 2 reasons. Number one, to prevent cement leakage. We want those fracture fragments to kind of seal together, and if required later on do the vertebroplasty. And second reason is that many of the patients for whom we will feel on day 1 or like in the first week that they might require vertebroplasty might actually not require it only at all because they are healed sufficiently by the end of 4 to 6 weeks. So doing early vertebroplasty, did it have any harmful effect also in the literature which you reviewed?
So according to this review, sir, there was no difference between the complication. There was no additional list of complications that you would get with an early vertebroplasty based on this review. And in our practice, we also are doing at least a 2-week or 3-week conservative trial and then subjecting the patient to vertebroplasty.
So this particular factor was mentioned in those papers, or it was just not there? So that's why we don't know. The complication part.
Sorry, I did not understand your question, sir.
So the complication part, it was there in those papers, or it
no,
was...
so they're listed as the complication parts are listed, but they have not, in these papers, they have not specified as to which complication occurred at what age of the fracture.
Okay.
Do you add fixation to it, or you always just do vertebroplasty?
No, sir, this is a review. So they have only mentioned cases that have been subjected to vertebroplasty alone.
And any difference in terms of vertebroplasty versus kyphoplasty, or they were all pure vertebroplasty patients without kyphoplasty?
No, sir. These reviews are either focusing on vertebroplasty. These are different. So these are different people who have done different procedures. So majority of them have been, majority of these included vertebroplasty. So there's separate papers in which there is either vertebroplasty or kyphoplasty. So this review does not include comparison regarding vertebroplasty and kyphoplasty.
Okay. Do we have any other question for Dr. Sarvari, panelist?
Dr. Sarvari, I'm Dr. Rajkumar. I have a question for you, ma'am. I want to ask you, is there any difference that you will have in time per se for management in patients who get either vertebroplasty or kyphoplasty? For vertebroplasty, people are doing generally 2, 3, 4 weeks. Do you think kyphoplasty also you should wait for 3, 4 weeks, or do you think it's okay from your literature search?
Sir, so in this review, it does not address this concern.
Okay.
What are your thoughts, Dr. Deshpande, about this question which you asked? Can we do the kyphoplasty earlier because we are creating that space?
Yep.
Okay.
See, in vertebroplasty, one of the fears is that you have probably leakage of the cement, whereas in kyphoplasty, you're tending to create a space where the bones, fractured bones are compressed together and there's less chance of leakage. And of course, you have newer methodology where you put into a balloon so it doesn't cause leakage at all, stuff like that. I just wanted to ask this lady whether she has thought about that way cement augmentation is done, and vertebral augmentation using cement has its pluses minus. In which kind of procedure has she considered, which can be used earliest, when can be used late? Is there a balance that somebody can find? It is just to know how broad she has studied about it. That's all, nothing else. But she did good. She did good.
Yeah. So if we don't have any other question, I would like to thank Dr. Sharvari for her excellent presentation. Devesh sir.
Yeah, we can go to the next speaker, Dr. Harsh, going to talk of minimally invasive oblique lumbar interbody fusion. Dr. Harsh.
Good evening, everyone. Minimally invasive oblique lumbar interbody fusion for degenerative lumbar deformity correction. Is it worth it? There are different approaches for the fusion of the lumbar spine. The anterior lumbar, oblique lumbar, extreme lateral or the direct lateral, transforaminal, and posterior lumbar all are well known. The anterior lumbar interbody fusion is at least 90 years old, which was described in 1932 by Kapner for the treatment of spondylolisthesis. Later on, Hiromu Ito and Ibaraki have mentioned about their own approaches to the anterior lumbar spine. However, because of the morbidity associated with this approach, it is highly being abandoned now. The direct lateral approach to the lumbar spine was introduced in 2004. This approach goes through the psoas muscle. The psoas muscle contains the lumbosacral plexus, as a result of which there are chances of 30 to 40% of neurological injury. As a result, this approach is being seldomly used. So this diagram depicts the anterior problems with the approaches. The anterior lumbar interbody fusion requires the manipulation of the peritoneum along with manipulation of the great vessels. The lateral approach goes through the psoas and involves the risk of neurological injury, as a result of which the oblique lumbar interbody fusion came into view. So this is the window which is a natural corridor for the for approaching the lumbar disc through the oblique lumbar interbody fusion. For oblique OLIF, the patient is positioned in lateral decubitus position with left side facing up. 2 centimeter incision is taken over the line with the help of fluoroscopy. The muscles of the abdominal wall are not cut through, they are just retracted along the fibers, and then with the tactile sensation of the surgeon's finger, the peritoneal contents are pushed forward and the psoas muscle is retracted backwards, and the corridor to the interbody disc is established. This is how the intraoperatively looks, with the dilators in place and the tubular attachment and the surgical instrument in situ. So the aim of our study was to investigate the role of OLIF in degenerative lumbar deformity correction. Ours was a prospective observational study of 24 months duration. The patients were assessed preoperatively and then at regular intervals for a minimum of at least 1 year. Functional outcomes were measured in the form of visual analog score for back pain and leg pain. The Oswestry Disability Index was calculated. Radiological parameters in the form of scoliosis, lumbar lordosis, PILL mismatch, and sagittal vertical axis were recorded. There were 39 patients in our study with a mean follow-up of 15.8 months. Average age of the patient was 65.5 years. Average number of levels operated was 1.6 plus minus 0.69. Total blood loss was 68.2 ml, and hospital stays was an average of 7.2. 3 patients required ICU stay because of the comorbidities. Fusion at 12 months was assessed with the help of CT scan, and 38 fusions were found to be good out of 39. Complications that were encountered were Angry-Suez syndrome in 2 patients, superficial infection in 1 patient, venous injury in 1 patient, cage subsidence in 2 patients. However, there was no neurological deterioration in any of our patients. So on assessment, the radiological outcomes, the scoliosis, lumbar lordosis, PILL mismatch, and sagittal vertical axis all showed a statistically significant improvement as compared to the preoperative measures. The functional outcomes in form of visual analog score for back pain showed a gradual improvement, as well as for leg pain showed a gradual improvement over 1 year course period, and which was found to be statistically significant. The Oswestry Disability Index changed over a period of 1 year, and it was statistically significant and favorable for the patient outcome. So degenerative changes in the lumbar spine leads to a complex set of deformities. Consider this as a normal spine, the body, a well-hydrated disc in between, and the adjoining body. So when there is dehydration, there is buckling of the PLL into the spinal canal, as well as resultant instability at that level. This causes multiple deformity and causes a loss of sagittal and coronal alignment, leading to mechanical compromise. So here we can see the degenerative scoliosis and loss of sagittal vertical axis. So OLIF allows restoration of the disc height, correction of scoliosis, and restoration of lordosis and indirect decompression. For example, over here we have a 68-year-old male who was previously operated at L4-5 level, presented with L3, L4 disc prolapse and canal stenosis. Patient had degenerative scoliosis and kyphosis of the lumbar spine. The patient was approached through OLIF and posterior screw placement. Over here, the post-op X-ray shows restoration of the alignment of the spine and restoration of the disc height. This is the pre-op MRI of the patient with canal stenosis. The post-op MRI shows indirect decompression of the spinal column. The pre-op MRI, and this is the post-op MRI, which shows the placement of the cage, and the stenosis is gone. These are the scar marks of the patient on follow-up. This is a 2-year follow-up X-ray of the patient, which shows satisfactory results. So while doing OLIF, it is not necessary to change the position of the patient in order for the placement of the screws. It can be done in the lateral position itself. This is a case of where the patient was operated for multi-level OLIF. The patient presented with degenerative scoliosis with a Cobb's angle of 31.1 degrees. Patient was operated for 3 levels of scoliosis at 3 levels with OLIF cages. This is the post-op scanogram showing improvement in Cobb's angle to 5.8 degrees. And the sagittal vertical axis was also restored for this patient. This is the 1-year follow-up CT scan of the patient showing satisfactory fusion. So there is a previous publications literature available for these cases. The study by Patel et al. Was published in Indian Journal of Orthopaedics in 2019, wherein 15 patients were recruited, and the study concluded that there was a significant improvement in visual analog scale, ODI score, and spinopelvic parameters. Dr. Neeraj sir has published his case report on multi-level OLIF. And a meta-analysis was published in Global Spine Journal in 2021, wherein 16 studies were analyzed and 519 patients were recruited in those 16 studies. The study concluded that a significant improvement in the spinopelvic parameters can be achieved with the help of OLIF. So in conclusion, MIS OLIF is a very effective tool to counter the issue of degenerative lumbar spine deformity. It has decent correction in the spinopelvic parameters. It has a good functional outcome. However, the surgeon needs to beware of the complex anatomy and possible complications. Thank you.
Thank you, Harsh. I happen to notice that the average gain in lordosis was about 20 degree, from 17 to 37 degree. Is that correct?
Yes.
So how many of your cases were multiple level, so you must have achieved this correction in lordosis over the multiple levels rather than 1 or 2 levels?
So most of our patients were for single level OLIF. However, there was only one patient which had this multi-level degeneration and required 3 levels of OLIF.
So how do you ensure to achieve this much gain in lordosis by doing OLIF at single level? As you're saying, most of your cases were 1 or 2 levels. So how do you ensure that you achieve that much lordosis by doing 1 or 2 level OLIF?
So the degeneration leads to localized kyphosis. By gaining the disc height, we not only improve just the or lordosis at that level. However, the entire alignment of the spine changes just by gaining the disc height at that level. So maybe that is the reason which causes overall improvement of the spinal alignment.
Okay. Did you also measure the gain in lordosis after doing Olive and after putting the screws, or both the procedure was most of the time done in the same step?
No, sir. Most of the procedure was done in a single step, in a single position, in lateral position.
Thank
The
you.
main indication is degenerate. What is the main indication for surgery? Basically, stenosis or?
So the major indication was degenerative, as mentioned earlier, degenerative spine, where with the anatomy which was favorable for to do Olive.
No, why does the patient come with us? Backache or stenosis, or all cases which you see for scoliosis, you go ahead with surgery, or how is it? What is your indication for this surgery?
So the patient, mostly what we see is with stenosis, the complaint of claudication, and degenerative changes are associated with those patients. So most of the times it is because of this stenosis that the patients are opted for surgery.
Thank you.
Can I answer for some of them? I am Dr. Avi Sharma. I am the principal. Yeah. So first, going back to the part where most of the cases were multi-level, and so it's what he has missed on that. So that's why you see the good lordosis. The cases where we had single level, if you see now we have gone to doing single position. So what it helps is we do the releases if need to be on those positions from posterior. So doing anterior plus posterior at the same time. So it allows you to get better lordosis compared to doing only the cages. So the trick in getting good lordosis out of one level is to do releases, not that the cage helps. That is for sure. Okay. So that has been our experience. Just putting the cage doesn't give you much. You get something, but that is not enough. If you want to get good lordosis and good restoration with single position, the trick is to do posterior releases. And that's why now we have shifted all these cases to single position, which allows us to do both. And coming to the other part where you asked what were the indications, so most of the patient had both back plane and neurological claudication, and the idea is all these multi levels. Again, he didn't specify is we do stage surgery. We put the cages first, and as you can see with a few of the X-rays were only cages, not the screws, and then we make them walk and see how is the radiculopathy or the claudication. 90-95% they don't need a posterior work with them, but in selected few where we feel they complain of having a radiculopathy or some claudication, we get a post-operative MRI and see if the levels, if there is need of a very selective decompression, and we do add it. So that is how the philosophy works for us.
So you add that as a second surgery, or like when do
Yeah. All multi-levels, we operate, we let them walk on the same day. Without brace we give sometimes, but they walk on the same day of the surgery. So they will exactly tell you, okay, they are fine, there is no radiculopathy, nothing. If they say nothing, the second stage is mostly after 3 days, until unless patient has something, which because my next OTD is after 3 days, so that is the reason. So if they until unless they have no complaint,
next OT?
After 3 days we post it for the posterior work, MIS fixation.
So it's done 2 steps. Okay.
Ayush, if they have persistent pain, Ayush, do you ask for repeat MRI to see if
exactly. Exactly. So if we feel, if they walk for 3 days, they walk, they do whatever they want to. If they say there's a claudication or anything, we get MRI, we identify what we have to do, and most of the time it is small decompression or something, which you do when you are doing posterior. So that is the philosophy.
You also said that you do the posterior release in the same position of the patient.
Single level. Multi-level is when you do the second stage, you have a lot of time. You can decide. So multi-level is too much to decide. There are a lot of things, lot of variables. No matter how good you read the MRI, it is almost impossible to predict what will happen.
For these single levels, how do you how do you do the posterior release first to achieve more lordosis, and then you go at like you do posterior followed by anterior, then posterior, or how does that?
So most of them they don't need it. But if you need to do, you do posterior, release the facets, they put the cage, and then compress from posterior. But that's the way to go. So because you are in the single position, so you can do both. It is not that difficult.
Okay. Thank you, Dr. Harsh. Thank you, Ayush, for. Do you have any other question for Dr. Ayush and Dr. Harsh from the faculties? Thank you. Thank you very much.
Thank you.
May I invite Dr. Anil Patil for his paper on minimally invasive posterior cervical fragmentectomy and foraminectomy technique and our experience.
Hello everybody, I am Dr. Anil Patil, practicing as a consultant neurosurgeon in Satara. Today I am going to present minimally invasive posterior cervical fragmentectomy and foraminectomy technique and our experience. So in the historical aspects, Mixter first introduced this posterior cervical foraminectomy 65 years back, and at the same time, Smith and Robinson started anterior approach, which was popularized by Broward since 60s onwards. Anterior cervical discectomy and fusion has become the gold standard in 1995. Foley and Smith introduced a muscle-splitting tubular retractor system for the minimally invasive posterior foraminectomy or discectomy, and it has proven advantages over previous both of the procedures. Indications: lateral disc prolapse with nerve root compression after failure of 6 weeks conservative treatment or lateral foraminal stenosis. Contraindications are if there are cord compression with myelopathy signs, segmental kyphosis, instability, and relative contraindication is myelomalacia or C6-7. What are the advantages? 1.6 centimeter muscle splitting incision with minimal post-op pain and muscle spasm, avoiding fusion. Procedure prerequisites are every patient must undergo CT to see that whether there is bony stenosis or osteophytes, radiolucent table with good quality 9-inch high frequency CR, if available radiolucent table, and good drill along with remote operated OT table. Now in the position, prone on bolster with shoulder strapping, neck flexion to open up interlamellar space, head up 30° to reduce the venous pressure and congestion. Level confirmation, very few of the consultants prefer to do the level confirmation in AP, but I prefer to do it in lateral view because we don't have the radiolucent table and our horseshoe is not radiolucent, so AP cannot be taken. Now incision marking is arbitrarily 1.6 to 2 centimeter lateral to the midline. You palpate the spinous process and just go 2 to 3 millimeter lateral to it. Infiltration with xylocaine and adrenaline is mandatory. Incision should go up to the fascia and open the fascia, otherwise you will keep on pushing the neck, reducing the flexion while introducing the dilators. Confirmation of the tube position and level by lateral fluoroscopy, as you are seeing at C5-6, we have introduced all the dilators and we are ready to go through the microscope. Visualization of the interlamellar space with ligamentum flavum after removal. You are seeing the after removal of the muscle, ligamentum flavum is identified and we are started removing the now removal of the upper lamina. This is a right-sided lesion. You are seeing the right side is upper lamina. We are removing the upper lamina with the help of 2 mm Krishnan punch. You should reach up to the spinolamellar. You should reach up to the facetolamellar junction and try to remove the maximum facet if possible. Facetal work should be done with the help of Krishnan punch. Now for the removal of the lower lamina, you first drill the facetolamellar junction and then start removing the part of the lamina along with the facet with the 2 mm upbite. You can take out just medial, very minimal medial part of the facet with the help of the Krishnan. Now you have to drill some facet with the drill. Upper facet should be drilled less and lower facet should be drilled more, because nerve root is seen below the upper facet, but you want to work to the axilla. Now you have to remove the lateral part of the ligamentum flavum. First, it's separate with the hook from the dura. Take it out and identify the dural tube and nerve root junction so that you can go into the axilla. Removal of the removal of the fragment. You probe at the junction of the nerve root with the dural tube. In the lumbar spine, we go through preferably we go through the shoulder, whereas in the cervical spine, as the nerve root is more horizontal, you should try to go first through the axilla. You are seeing the fragment has been delivered. You take out the adequate fragments satisfactorily, slowly, without retracting the thecal sac. Once all the fragments have been removed, the nerve root becomes lax and you can confirm it by probing it with your hook. So this is how you just probe anterior to the nerve root. That will be confirmation of adequate decompression. Hemostasis can be achieved with just putting the Surgicel in the axilla and shoulder if the position is correct and anesthetist is doing their job perfect. Difficulties and challenges are venous hemorrhage can be troublesome, position, head high. Training yourself to operate in this position is also a big challenge. Most of the Europeans and Americans in the beginning used to do it in sitting position, but now they are also stopped using the sitting position. Adequacy of decompression and not injuring the bony part of the facet, making it unstable. Our experience is 37 cases in 7 years, 5, 6, 14, 6, 7, 20, and 4, 5, 3. Complications are uncontrolled venous hemorrhage leading to abandon to procedure. Dural tear, you don't need to worry, just pack it and close it properly and tightly. Cord injury, avoid cord injury, and temporary increase into the neurodeficits by retraction of the nerve root. Word of caution, don't touch the thecal sac. Must decide beforehand whether you are going to remove fragment or you are just going to do the foraminal decompression. Thank you.
Thank you, Dr. Patil. So, if the disc is migrated mainly upward, then how would you deal with that kind of situation? Because you feel comfortable going through the axilla of the root, but if the disc is gone upward, then what changes will you make in your procedure?
Am I audible?
Yes, you are.
So your question is, if the fragment is proximally migrated, then how will you manage?
How will you
So
modify your
commonly I said that preferably we should go to the axilla, but it's not like that we cannot superior or cranial to the nerve root. So we can go into shoulder, but the lower margin of the upper pedicle will be restricting your entry into that corridor. So obviously your entry is restricted means the disc fragments entry is also restricted. But once I have removed one small fragment from that area also, because that fragment will be pushing the nerve root bit lower down. If you don't get the fragment into the axilla, then you can go and look into shoulder. That is one point. Most important point is you have to read the MRI very thoroughly, because you are looking for the fragment which is very wide on the T2 sagittal sequences, and then fragment has to be located on the MRI very properly, and you should know that whether you are expecting the fragment into the axilla or into the shoulder.
What diameter of tube are you using?
Pardon?
Diameter of the tube you are using.
Yeah, I am right now using the 18 millimeter tube, but once for thin patient, I can use the 16 millimeter also.
What's the post-op protocol?
Yeah, the same day evening they are mobilized, but I discharge the patient very next day.
Any use of collar or anything of that sort?
No, I don't use the collar. Previously, I used to use collar, but it is not making much difference because the most of pain is only for days. That is the big thing.
Any recurrences which you have?
Yes, I have faced 2 recurrences. One was immediate, so I have to convert it into immediately into the. I on the 4th day, pain recovered severely. MRI was showing a big fragment. I was afraid to go once again severely, so I straightforward decided to go and did the anterior-cervical discectomy and fusion. Because the literature doesn't mention any attempt of the recurrence disc again tackling posteriorly, as far as I know.
What about that CSF leak? How did you handle that CSF leak?
Yeah, CSF leak means I had twice or thrice faced with the CSF leak, but twice it was only puncture and once it was a degrade. But the moment degrade has happened, fortunately that case was only for the foraminotomy. So I have just packed it with the gel foam and completed the foraminotomy and closed muscles. That is the beauty of the tubular system.
MIS.
You just put the surgical or gel foam and the muscle will prolapse and you take for one stitch only to the fascia and skin, the CSF leak will be taken care of.
Absolutely.
So this procedure will be primarily directed for paracentral disc prolapse.
I'm not getting, please.
This procedure will be primarily directed for the paracentral disc prolapse, correct?
Yes, absolutely. This fragment has to be laterally, and the most key point is, as Kulkarni sir is asking, that how the cord injuries happened. So I was in the early period, I was not happy of removal of the fragment in that case, or probably my MRI reading was wrong and I was looking a soft disc when there was a hard disc or osteophyte. So I tried to go behind the cord to take out the fragment or like that, whether I am missing the fragment, I am missing the fragment. So I tried, I retracted inadvertently I retracted the cord, which led to this injury. But there was no motor deficit. It was the neuropathic pain which continued for almost more than 3 weeks. And then slowly it came down. The numbness and the heaviness, there was heaviness also. That means there was some motor cortex, motor injury also. He was having some heaviness and bit spasticity, but in a month it settled.
Any more questions from any faculty members?
Yes, sir. One question. This is Dr. Ketan. There have been reports of surgical hardening post-operatively and causing impingement or pressure by themselves. So I saw in that video that there was a lot of surgical that was put in the axilla despite not that much of an epidural bleed. So is it a regular protocol or in some special cases only you do that?
I'm not able to listen properly, but the question, if I'm not making wrong, is how much to use the Surgicel. So nowadays I have stopped using Surgicel and I am using the gel foam. Just put it and put a patty over there. It swells and all hemostasis is done. Okay. Now I am not using the Surgicel.
Okay.
Thank you, Dr. Patil. Thank you very much. May we have Nikhil Arbatti for to put some light on technical analysis of MIS TLIV for alpha S1 lytic listhesis. Initial results. Nikhil, please.
I think my presentation is already given. Can I have?
Yes, sir.
Hello, everyone. My today's paper is going to be an MIS TLIV for alpha S1 lytic listhesis, a technical analysis of a case series. We all know that the MIS TLIV is slowly becoming the preferred method of doing a single or double level instrumented fusion for lumbar spine pathologies. The benefit of doing an MIS TLIV for open conventional TLIVs is in the shorter duration. It is because of a lesser intraoperative blood loss, no or minimal paraspinal muscle damage, thus leading to less post-operative pain and quicker mobilization post-operative. While single level MIS lifts are now commonly being done for almost all lumbar pathologies like a degenerative listhesis, degenerative disc, and even lytic listhesis. MIS lift for lumbar degenerative listhesis can be done very easily by all the newcomers and with a minimal training. But an MIS lift for lytic listhesis and especially at the alpha S1 can have its own challenges. The challenges that one can face while performing an MIS lift at alpha S1 can be because of the anatomical factors like a higher sectoral slope, smaller alpha apeticals causing the alpha to be pushed down too much, a deformed sectoral slope, an inverted pelvis, and a narrow disc space. Also, surgical factors like not sure whether the contralateral exiting nerve root and the ipsilateral nerve roots have got proper decompressions can be troublesome. These anatomical and surgical problems can cause technical difficulties while performing MIS lift at alpha S1 lytic listhesis in grade 2 and above cases. Thus, our paper tries to analyze that what were the technical difficulties faced by us to perform the MIS lift at alpha S1 level for lytic listhesis and how we overcame them over the longer period. While MIS lift has been the standard practice for the performing surgeon in his own private practice, we tried to check the feasibility of doing the MIS lift at alpha S1 at multiple centers and also the immediate short-term and long-term outcomes. The data that we analyzed retrospectively were the challenges that we faced while performing MIS lift for lytic listhesis and how we overcame these challenges and the technical difficulties to achieve a proper decompression and reduction. The parameters that were considered were the operative time, blood loss, sizes of cage that we inserted, post-operative improvement in VAS of leg pain, average hospital stay, and average duration of fusion. The inclusion criteria that we adopted were alpha S1 only lytic listhesis were considered, grade 1, 2, and 3 were considered, both males and females were considered. The patient should have presented with predominant leg pain in only one. Even if the patient had bilateral claudication, but a predominant one-sided leg pain should be present to decide the level of doing the T-lift. The patient could have either tried conservative management or may have come in the first presentation with severe back and leg pain. Exclusion criteria. No two-level listhesis or more were considered. Even if the adjacent level had lysis but no demonstrable listhesis on dynamic axis, it were excluded. Grade 4 and above lytic listhesis were not considered. Patients who had degenerative listhesis or any other causes of listhesis like iatrogenic listhesis or traumatic listhesis were not considered. Patients who had neurological symptoms because of brain-related like cerebral or Parkinsonism were not considered, but only frank neurological symptoms because of compression were included. Patients who had previous laminotomy or failed back surgeries were excluded. So after analyzing the data, we found that we had 13 patients who presented with the alpha S1 lytic listhesis in the grade 1 to 3 who were operated between the years 2017 to 2019. There were in total 9 females and 4 males, and the average age was 42, ranging between 20 to 60 years. The youngest patient that we had operated was 22 years, and the oldest male was 61 years. The surgical details. The patients were all operated by a single fellowship trained surgeon at multiple hospitals. The tubular system employed was a minimal invasive tubular Pitker fixed tube system was used, which not an expandable one. The tubes were of 19 or 22 mm diameters. The fixation systems that were used were different minimal invasive fixation systems, depending upon the patient's affordability and the insurance Medicare. These were the Medtronics, Jesco, Pitker, MJ, GS, and Solpo. This was the operative data of all the 13 patients, which were compiled according to the sex, age, the grade, the VAS for leg pain preoperatively, operative time, the blood loss, the average case size that we inserted, the hospital stay, any complications if we had, post-operative VAS for the leg pain, and the average duration of fusion in months. The analysis of the data. The average age, as we said, was around 42 years, thus showing that lytic listhesis presents with the symptoms very early, and especially in females. If the patient is not getting better with conservative line of treatment, and if the ADLs are affected, they'll look for a surgical remedy. The female to male ratio was again 2:1, showing that the standard affection was more likely in females than males. This can be due to a sectoral slope and high PI, thus causing the listhesis at an early age. The operative time initially for us was 240 minutes for a grade 2 listhesis to achieve the reduction in stabilization. We found that it was significantly higher than compared to an open T-lift, and this was because of the high sectoral slope and pelvic obliquity. This hindered us in putting adequate sizes cages and properly inserting the cage. Also, we were not sure on the decompression whether the opposite side contralateral nerve root, exiting nerve root was properly decompressed. So it took time to make sure that the decompression was adequate. The other difficulty that we had was that in some cases, upon positioning, the grade 2 was not reduced to grade 1, and the grade 3 was not reduced to grade 2. Thus, when we did the decompression, the reduction was still not there, We then decided to insert screws on the opposite side and distract and then achieve a significant more reduction and then insert the cage. This took an additional time. Also, some Indian systems had an extender where there was no reduction extender present. Thus, to engage the rod and to fix it took time. So in the subsequent cases, what we did was, after positioning the patient, if the listhesis was not reduced by grade 1, we immediately before doing the decompression, we inserted the screw, the wires and the screws on the opposite side, but didn't insert the rod. And then after doing the decompression from the ipsilateral affected side over the top, we then reduced it by putting the rod on the opposite side, got an adequate reduction, distracted the space, then size the cage and put an adequate size cage. This also helped us in putting in a more bigger size cage and also getting a proper reduction. Also for grade 3 or other listhesis, we try to use a system, even if Indian, where we could have reduced the rod properly. The blood loss initially was 220 ml, which reduced to 180 ml. This was achieved as we saw that with better positioning, there was less epidural blood loss and less operative time also reduced the blood loss. Initially, the cages that we put were around 9, and later on we could insert 11 sizes cages with proper positioning and proper distraction. The graph that we used was usually a patient's own autograph, which sufficed for almost all cases. In only one case, we used an allograph. In the later on cases, we distracted and a large position. This is one operative example, a grade 2 listhesis, which was adequately decompressed, and after putting the screws and the cage, we got a complete reduction and a distraction, stabilization. The hospital stay was on average 3 days, and only in 1 or 2 individuals who were young and who didn't require majority of investigations, we could get them admitted on the same day of surgery in the morning, and then they stayed for only 1 day more. The mobilization was started the same day. It was usually side turning and edge of bed sitting after 6 hours after the surgery and walking within the room by the end of the day. And next day, if the patient was comfortable, we remove the Foley's and make the patient walk by himself from the bed to the washroom and outside. IV antibiotics were given single dose preoperatively and only 1 dose postoperatively, and oral medications were started the next day. Only injectable analgesics were given as such basis the next day. Patients were usually discharged 48 hours after the operative time with oral medications and significant reduction in VAS of the leg pain. The patients were called for follow-up 15 days after the surgical for removal of staplers, 1.5 months after surgery, and 4 months after surgery to check for implant position fusion. Usually, a fusion was noticed 8 to 9 months post-surgery, and any doubtful fusion, we checked it at the end of 10 months with the CT scan. There were no dural tears and no infection at the operative site in the immediate post-operative period. 2 patients complained of minimal neuroplexia in the operated limb, which was reduced with gabapentin and pregabalin. No long-term effects were seen. Only 1 patient had a complication of a lower S1 screw breakout, which was seen on 9 months. This patient was a diabetic, which was not properly controlled, and thus was started on therapeutic therapy because his bone quality was not good. He had no complaint of pain even after the screw breakage at 9 months, and on the 10th month, CT scan showed proper fusion with no implant backup. Thus, MIS TLIF has now become a routine option for performing all single and double level interbody fusion at the lumbar level. Lytic listhesis at L5 can pose its own challenge because of the sacral slope, pelvic obliquity, and small pedicles. But with proper positioning, an opposite side screw insertion and distraction can help in reducing the technical difficulties. Also, an adequate size cage can help in proper reduction. Thus, the author feels that these cases can be handled properly by all surgeons with proper training. But at the same time, for the initial cases for the beginners, they can use an expandable retractor system to reduce the operative time and the ease of doing cases. Thank you.
Excellent talk, Nikhil.
Thank you, Nikhil. So, Nikhil, when you have this bilateral symptoms, do you do facetectomy on both sides, or you will go over the top and primary decompression on one side and just over the top for the other side?
Hi. So I never do bilateral facetectomy. From day one, I've been doing over the top only. It's only thing that for lytic listhesis, for initial cases, because of the rattler, it used to take time to have the contralateral side exiting root decompression done properly. It was not the traversing root which was a problem, but it's always over the top. And I feel, in fact, in a lytic listhesis, if you have done over the top, done an adequate decompression, and it opens up actually. You can, in fact, once you start putting the various sizes, you can easily go on up to 10, 11, 12 also. The only problem is because of the sacral slope, the sizers and all, the shavers they are usually almost parallel to the body if the patient is this thing. So to insert the scissors and then distracting and then putting the the shavers and then putting the scissors, that part is technically challenging. But I never do a bilateral facetectomy.
Nikhil, I have a question for you. Is it okay if I ask?
Yeah, sir, please. How are you?
I'm good. How are you? Thing is, have you ever noticed a conjoint route or a horizontal route which restricts your ability to go into the joint in your case series?
So not in the lytic but I have noticed that in my degenerative 1 or 2 cases, not in this lytic That was one thing which I always look for in the pre-op MRI, because I had one for the discectomy which I was doing, but not in the lytic.
Nikhil, other thing which I have seen, there are 2 kind of listhesis which happens when there is lysis at L5. Either L5 will go forward with the rest of the vertebral column along with it, and L4-5 disc will be spared. In some of the other cases, what I have noticed that the upper column will remain in its position and only the L5 will go front. So in these cases, L4-5 disc is also affected and L4 will have a retrolisthesis over L5. So do you look into this factor whenever you are doing especially the high grade listhesis? And if that is the case, then how do you plan to include the L4 also in your instrumentation?
So Amit, what you're saying is right, but my MI still is for lytic listhesis. I, unlike Vishal who does it, I do it for grade 3 and that only. I haven't attempted it for grade 4. And the cases which I do, I always check the adjacent level at L4-5 if there is any degenerative disc and what is the instability noticed on dynamic X-ray at the other level. If there is no significant instability seen and the disc height looks okay, I actually let it go. In grade 3 also, I have not gone this thing.
Okay. Do we have any other question for Dr. Nikhil? Yes, sir. Nikhil, thank you very much. I think
we can close the session.
Yeah, we can conclude this free paper session and we can move on to the third round of case discussion. Arvind, over to you, please.
I thank Amit and Devesh for doing a great job. We are running late. We jump to the next session. I would like to invite Dr. Jacob Eapen and Dr. Chandan Mohanty to chair this last session of the day, where we are going to have some interesting discussion on very uncommon topics.
Chandan is flying. He will be joining in half an hour also.
How about Jacob?
Jacob should.
Hi.
Jacob from Dubai.
Can you hear me?
Yeah.
Yes.
So there's some audio issues. Can I invite the moderator and panelists of this session? Neeraj?
Yes, I'm here.
And team. Dr. Amit, Dr. Ranjit, Nikhil, and Kshitij.
Amit, can I just start the session? Because what's happening looks like Jacob's audio is...
But that's okay. Rakesh can start it.
Okay.
Yeah.
Rakesh, can you chair this session, please?
Yeah, sure.
Okay,
yeah.
Thank you.
Okay, so Dr. Rakesh, can we start with your permission? Yes, Neeraj, go ahead. Yeah. Okay, so I would want to first welcome my co-panelists, Dr. Amit Jala, Dr. Ranjit Krishnan, Nikhil Arbatti, and Dr. Kshitij. All are doyens of deformity correction. So I'm going to present cases and probably are going to ask them to give tips so that I can further improvise and we all can learn from their experience. So without taking much time, this is a female of 72 years, significant back pain with front of thigh pain and also posterior radiation. Walking distance around 100 meters, walks with stoop gait with support, not able to stand at all without support. DEXA is minus 2.7 and diabetes, mellitus, hypertension on treatment. These are the X-rays. We could not get standing X-rays because patient was unable to stand without support. So we thought we did supine flexion extension, which is an acceptable norm. You can see that there is significant PI minus LL mismatch. These are the MRI scans, shows mainly 4-5, 3-4, 4-5 degenerated disc along with moderate and L4-5 severe lumbar canal stenosis. These are the sagittal views showing significant foraminal stenosis. May I ask panelists to start with Dr. Amit?
I think what happened to Neeraj?
Hello.
Hello.
Was I audible or I got?
No, not audible at all. Now you are.
I was not audible, right? So I'll go back. So this was a female, elderly female with neurogenic cloudy.
That you were able to. So we start with the question.
Stand without the support. So scanogram was not making much sense to me. So I did not do any scanogram. These are the MRI showing 4-5, which is lumbar canal stenosis, 3-4 showing moderate stenosis. And these are the sagittal scan showing 2-3 degenerated, 3-4 degenerated, 4-5 along with 5S1 degenerated disc. So I would want to start with you. Any other thing except apart from scanogram you would want to do this in this patient? 4-5 shows significant stenosis. 3-4, 2-3 showing moderate kind of a stenosis. How would you think about this patient henceforth?
First of all, I think the patient is old age with an osteoporosis, with a diabetes and hypertension. It's very important that these multi-level things are degenerations will be seen in such patients at 72. So we need to, before we go for any further investigation, it's very, very important to counsel the patient right from the start in OPD. That's what I would do. That how much the patient has got the pain and how much disabling it is. And this is very, very important because it's a multi-level lesion and in an old age patient. So we need to optimize all these patients before we go ahead, even for investigations. Because investigations are also going to cost the patient, and there is no point doing further investigation unless the patient is really keen on going further. So that's what my approach would be.
So this particular patient was disabled since more than 8 to 9 months, and patient was almost had tried all the other treatment possible. Patient was on anti-osteoporotic treatment with teriparatide since almost 4-5 months. And diabetes was also under control. So fairly optimized patient, you can say, cardiac wise, all other thing wise, patient was fairly optimized, came to us already optimized because she was
and motivated.
Yeah, motivated. So
that's also very important.
So Ranjit, any other investigations you would want?
So you have given all the relevant information. So now go ahead with surgery. That's what you want, right?
So he's leading us to surgery.
I don't, I think we did not do a standing X-ray. We did a seating X-ray for this patient just to see the collapse, whether the spine is flexible or not. So one thing I wanted to bring about is whenever you deal with this kind of deformities, always try to get a standing X-ray if possible, because supine and standing both would give you the flexibility of the spine and collapse of the deformity. So this is what I always would want to point out, that any deformity, try to get a supine as well as standing X-ray. Sometimes MRI would look very, very, very benign, and you make your patient stand in, a picture and understanding of the patient changes. So always get a standing X-ray. This is the CT scan.
Exactly. This is what I want.
Scan we do in almost all our
patients. Yes.
Yes. So I did CT scan. Shows 2 vacuum discs, 5S1, some vacuum bridging osteophytes, mainly the intradiscal instability at 4-5 and 2-3. So now, how to proceed, Nikhil? So surgery is the word now. Now, how would you proceed?
So now, actually, once we have decided to do for a surgery, the thing is that for a degen scoli, whether to do only the one symptoms, that is the claudication and leg pain, or to do the whole hog. Now, if you want to do the whole hog, you have to go and look at the upper level that you want to fuse and the lower level that you want to fuse. And if you're doing for the decompression only because the patient you feel is having morbidity and is obese and may not be able to withstand a full hog procedure, then do a minimal invasive decompression at multiple levels. But at the same time, the degen scoli, I have never found the perfect answer for doing for any case. But I assess the patient, what are her symptoms. If the patient has symptoms more of
leg pain and claudication, and if the patient is not someone who will be able to withstand the whole long level instrumentation, I would still give them the option of doing a minimal invasive decompression, and with the explanation, and hopefully they understand that what can be the post-op outcome. And if the patient is fairly fit and can answer, then I will definitely do a complete instrumented fusion from the upper level. In this case, I think maybe at D12 or this thing, and going down, because there is a vacuum disc at L5S1 also to till that one.
So Nikhil, would you offer a decompression in this patient having a collapsing spine and standing, walking with stoop gait, requiring support?
Yes. Yeah, Nikhil. Yeah, Nikhil. Neeraj, I tend to disagree with Nikhil on this. Yes. So these kind of patients, you do all this decompression partially, they are just not going to be happy. Because this is multifocal problem.
Neeraj, can you go back to the actual MRIs?
Sure.
Before
we discuss. MRI.
Actual MRI.
There is full facet, significant discal instability, back and leg pain, unable to stand. What are you going to achieve with the decompression?
You let me know where is the compression on actual MRI. So what are you going to decompress?
4.5 and 3.4. 4.5 is actually on axial. You see the significant stenosis at the, I think on the axial it's seen on the right.
4.5 is the one in stenosis. Yeah. Rest all are instability pain. The stenotic pain is only from 4.5. Rest all is pain of instability.
Yeah, but the pain of instability. But then, are you sure that the patient should be able to? I mean, definitely doing a complete instrumented fusion is one thing. But if the patient is not fit for that, and if the patient wants a symptom relief only for the leg pain and claudication, what would you still offer?
If a patient is not fit for decompression, the patient is not fit for
patient is significantly symptomatic for even back pain. And so I think, when you don't see
this patient, if it's back pain, then definitely doing an this thing complete instrumented is the norm for this.
Okay. So Kshitij, you are there?
Yeah, I mean.
So UIV, LIV. If you are going for fixation, UIV, LIV. You are a UIV and LIV.
Means my philosophy is to do less.
Okay.
I heard the chatter about back pain. I don't think you can treat anybody's back pain with a fusion surgery, especially if you have a multi-level fusion. So from the get-go, I'm not going to promise that, okay, we are doing this surgery for back pain. So your aim basically in the end is, you do less and then deal with adjacent segment problem, or you do more and deal with more problems acutely. So my philosophy is to do less, not do more.
So that's where what
everybody doesn't get an adjacent segment.
Most important.
So everybody doesn't get adjacent segments. So I don't think this is I wouldn't go very big UIV, LIV on this. I would just treat the L4-5 spondylolisthesis. And that vacuum disc and all is concerning, but you do more investigation, you start wondering what will happen. But even patients who don't have vacuum disc also get adjacent segment problems. So just because there's a vacuum disc doesn't mean I'm going to fuse L5S1. If there is no problem at L5S1, I'll just treat the spondylolisthesis and then decompress whichever levels. That's all. I'll not do more than that.
So you would just do 4-5 in this case?
Yeah.
So Ranjit, your approach, how much?
For me it is, for me, see, all taken, I know that whatever I do should give as much as pain relief for as long as possible. Nothing called 100% pain relief. So I would go L1 to S1. For me, it is OLIF L1 to. Can I go? Am I at the right level?
Can you go to the MRI?
Images. MRI, yeah. I will. MRI. That's right. Okay. Back. Yes. So the significant stenosis is at 4-5. But also there is black disc at that. So I'll do OLIF at 1, 2, 3, 4, 4, 5, right? And then I'll do it in 2 stages. This one, right? I'll make the patient walk and see what is the amount of claudican pain relief. If patient is not having significant claudican pain relief, I'll do a tube decompression 4-5 and instrument L1 to S1.
Amit, by your
take the body at 5S1.
Yeah. So my take is get me the CT
approach
scan.
and approach.
Get me CT scan. Okay. So my approach is I'm not going to fuse L5S1. I'm going 2, 3, 3, 4, and 4, 5 OLIF at 3 levels. I'm not going to go at L1, 2, and I'm going a single stage all the 3 levels. I'm not going to stage now. Initially, I was going to stage, but I feel that it's not a severe compression, and these patients, I do explain them that if they require a posterior approach later on, then I may do a decompression, but I will do a single stage all front and back.
So, Amit bhai, would your explanation include the future probability of alpha S1?
100%.
So,
yeah, because as you know that we are not going to give 100% to these patients. By sparing alpha S1, you are also sparing the upper levels. Because if I go to alpha S1, which is not that much at present involved, the load will definitely transfer to L1 too. So I will try, I'll do as little as possible, minimum as possible fusion.
So if at all you decide to go for alpha S1, not in this patient, maybe other patient, would you go for your standard alpha S1 OLIF, MIS TLIF, or
it will be MIS TLIF associated with OLIF at MIS TLIF.
Okay. So why not this alpha S1 OLIF? How we have implants and everything available, so why not? Amit bhai?
Yeah.
So if why alpha S1 MIS TLIF, why not interior approaches at alpha S1?
At alpha S1?
Yes.
Yeah, because I'm still not very well conversant with an alpha S1 anterior.
Okay.
But if it's possible, yeah, definitely alpha S1 anterior is much better because that's going to give much better lordosis.
Yes.
Yeah, that's the only reason. Otherwise, theoretically, yes.
Other factor is cost. Cost multiplies.
Yeah, definitely.
All right. So I think we have other cases. So we'll quickly go through what I did. This is what I did.
But Neeraj, what was the LLPI? I never knew that.
Sorry, I mean, I did not, we could not get a proper.
That's very, very important in this.
No, I could not get proper standing X-rays for this patient. So I think, PI, if I correctly remember, I don't have in this, but if I correctly remember, PI was somewhere around 43 or 44. So this is what we did. Now, Amit bhai, probably any panelists, I mean, do you require to put screws at every level when you are doing an OLIF, or you can skip levels? This particularly case, we had to put 2 screws because we had put 3 screws on the other side, but somehow it was not matching with the head because screw was going very lateral, and so we had to remove the screw and put only 2 screws. But would you want to go for every pedicle screw, or it's okay if you staggered the screw?
Neeraj, did you do a direct decompression for this patient 4-5?
Sorry, come again.
Did you do a direct decompression, or it was only percutaneous screws?
No, it's everything percutaneous. I have done single stage OLIF and percutaneous fixation. Did not do the second posterior or stage surgery in this patient.
So no decompression at 4-5 from behind.
No different.
Indirect decompression.
Indirect decompression.
And how long is the follow-up?
Now we have 3-month follow-up for this patient. Yesterday only patient came. Unfortunately, I could not patch the X-ray. This is immediate post-op.
But why didn't you do a 5S1?
5S1, I feel, I mean, again, it was a degenerated disc. This major disease was coming from, I feel, 2, 3, and 4, 5. 3, 4 was intervening. Probably, you could have gone without doing a fixation. But, when you are fixing 2, 3, 4, 5, it makes sense to, fix 3, 4 also. And, the deformity was mainly coming from 2, 3, 5, 4, 5. 5S1 was not clinically relevant to me at this point of time. And I would, keep my fingers crossed that in future patient doesn't require 5S1. Because if you go for 5S1, you are going up to 2, you will have to, start juggling around, putting your iliac screws and all those stuff. You are ultimately, as Ranjit said, if not subjacent, adjacent level disease you are facing for. So try to do as minimum as possible. That is probably what I did in this patient. Okay, I think, we have other cases.
Can I comment one thing?
Yeah, please.
Can you bend the rod a little bit more?
Yes, I thought so to do that, but I was a little worried about osteoporotic bone.
Okay, that's fine.
So
how about doing L2-3 and a 4-5
Neeraj, can I just make one simple comment?
Sure, sir.
See, your technique is good, and I second Amit's rod bending, because you know why? If you take away the S1 disc and you take away the L1-2, if you see the L2, 3, 3, 4, 4, 5, it's almost a straight column.
Exactly. That was I was worried about.
So having done all the good work, all you need to do was, in my opinion, bend the rod a bit compress the rods a bit if it allows, you would have got a far greater lordosis at these levels, and your work would have been phenomenal.
Well, I guess
take it in the right split.
Yeah, of
Please
course.
So with
misunderstand.
intact facets, would you get it?
Sorry?
With a cage in the front and almost arthritic facets in the back, will just bending the rod get that amount of lordosis?
Yes, Ranjit, it does. It does. It might.
Ranjit, I'll tell you one thing. That definitely, if you do a facetectomy, you are going to get better lordosis.
Yes.
But once you do a distraction, there is always a space which is created between the facet joints.
Facets to compress.
And then once the facet is slightly distracted, that you can use as a compression, which will give a little bit better lordosis.
Okay.
So, Neeraj, no hard feelings.
All in the spots.
Of 62, significant back pain, 7 on 10, both posterior thigh pain, walks with stoop posture, failed all conservative treatments. MRI does not show much compression. I have not included MRI because of the short of the time. DEXA was minus 3.7. HB1 AC, HbA1c was 7.6. FB compensatory mechanism at place. Now here, how would we optimize this patient? That would be very important. Patient is uncontrolled diabetes. Patient is having significant osteoporosis. Patient is having osteoarthritis of knee. So Kshitij, how would you optimize this patient?
I mean, optimize the patient thinking that I'm going to operate this patient? Optimize for what?
For knee surgery.
Optimize for what?
Sorry?
This patient is not a surgical patient.
Okay.
In my book, such a patient is not a surgical patient. If the patient doesn't have stenosis, has so much back pain, and has got a ton of problems that doesn't fit on a slide, then you have to start wondering how much can you help this patient. So obviously, from medical point of view, you can optimize every individual aspect of it. But
no, Kshitij, then how this patient is not able to walk? Patient is having significantly positive sagittal balance. Patient is falling forward.
But
because of OE.
But also
understand knees are fine. Patient is only having patellofemoral arthritis. That's all.
Can you go back to the Can you go back to the X-rays?
X-ray. I thought the X-ray knees are really bad.
Yeah.
Then Neeraj, the back pain and the stoop posture you're thinking is because of the lumbar spine only?
This is sagittal imbalance. Nikhil, this is sagittal imbalance I'm talking about. You see the SVA. SVA is more than 10 centimeter plus.
This is a standing X-ray or it's a what?
This is standing X-ray. This is standing.
Full spine. Looks to be the knee also to be severely arthritic.
I think, Neeraj, this is, if you see the sacrum and the hip and knee flexion, the hip and knee flexion should come after the total verticalization of the sacrum.
Yes, but if you see the pelvic,
here still there is, it's not fully retroverted.
Yeah.
So there is a flexion deformity which is occurring at the knee or hip.
Yeah. So we check knees fully functional. Knee is not FFD. Knee
and the hip,
and the
hip is also normal.
So you mean the primary driver is the hip. So you mean the primary driver of this is the lumbar spine?
Correct.
Because
I doubt out ONE, we have ruled out OA hip. Patient is only having patellofemoral arthritis.
Okay.
Neeraj, can I ask one more question, please?
Where are the MRIs?
No, MRI only shows foraminal stenosis to this patient.
Neeraj.
Yes, sir, please.
When this patient lies supine,
yes,
what happens to her?
Well, I don't have those X-rays here, but patient is in supine shows a straight spine. I mean, proper spine, not a sagittally imbalanced spine.
So it's basically a flexible.
Yeah.
This patient is having sagittal imbalance. Trust me on that.
Okay.
I agree. The patient has sagittal imbalance, but with that kind of DEXA, I think this is going to be a prolonged pre-optimization.
Agreed.
Pre-op optimization.
So that is
It's
what I
not
would
going
want
to
to
be a
talk here.
short-term thing at all.
And that is what I would want to talk here. You know, how much
It's going to be a
how
long-term
pre-optimize
issue.
this patient. So trust me on one thing. This is a sagittal imbalance patient. Patient has probably ruled out all conservative. Patient is wanting a final solution, and patient comes to us with this parameters. How would we optimize and how long we optimize this patient? So first, let's take diabetes. You know, I mean, what is a safe range for diabetes to operate when patient is having HbA1c of 7.5? How would you tackle that osteoporosis minus 3.7?
So HbA1c is actually not that much of a difference unless you're planning something very big.
Seven is the guideline.
One thing here, we are planning surgery. Now you go ahead. You know, how would you pre-optimize this patient?
So I would say that diabetes is something that unless the HbA1c is something like 10 and you're doing a long level open instrumented fusion, then you would want to optimize that. But if it's an HbA1c of 6.5, 7, 7.5, you can easily go ahead with it.
All right.
What is your
7 is the cutoff. Yeah. I don't think you should do more than 7.
Yeah. So 7 minutes into the session, so better we come to a point you put forward, basically.
And for osteoporosis, I would put this patient on teriparatide.
Wait. Let's finish one point first. You know, diabetes. You know, supposedly your patient comes with 7.5. How would you counsel the patient come back after your HbA1c is falling back below 7, right? That's what we want to send the message to the house.
Neeraj, if you
for
ask
an elective case,
elective cases, Neeraj, in our hospital, elective cases 8.5, 9, 9.5 we operate.
So what is your sugar level then? What is your safe sugar level?
What we do is we ask our diabetologist. He will say this particular patient has this comorbidity, this up to 8.5 is okay. And in this particular patient has hypertension, diabetes, kidney disease, you have to wait for 7.5. So,
one more thing, Neeraj, we have also the same protocol as Dr. Rajkumar said, that we can, if the patient has got 8.5 or 9, then we control the diabetes, but we never wait for it to come up to 7.
Agreed.
So that is one thing. That's our. But
so
coming to all these protocols, do you ever use the NSQIP protocols for surgical risk grading and counsel the patient?
Yes,
sir. Sir, I use it.
Even we take into account the fragility score. We take all those things into account, and I put it on paper for this patient.
Because if all this thing is there, the complication or this will come into a very high risk, more than 40% of medical problems.
So I'm coming to that part also.
Yeah, right.
So osteoporosis, how would we minus 3.7 is significant osteoporosis.
So it's not just the osteoporosis as a T-score. What is the gram per centimeter square on that?
BMC.
The score or a spine
score? Today, and I don't remember what was it exactly.
So for me, if you have like a gram per centimeter square less than 0.6, you are in terrible situation. Correct. Your screws are not going to hold at all. If you do a CT scan and calculate the Hounsfield units in the pedicles or the vertebral bodies around the path of the screw, and that comes to like 60, 70 or something, then your instrumentation not really going to hold. And remember, this patient is not walking right now. You do surgery on such kind of patients and get into a problem, they're definitely not going to walk. So and the blame will be on you. So basically, this patient should go on teriparatide. That would be the best one to start this patient pre-operatively. But the duration of teriparatide is kind of controversial. So I personally, with this kind of a problem, I might wait as long as easily possible to wait.
So a very, very recent meta-analysis on osteoporosis published in Lancet, they say that, any orthopedic or instrumentation surgery, 3 to 4 months of teriparatide before you take up any deformity cases as well. So 3 months to 3.5, 4 months, that's what the average we are putting, for preoperative optimization of osteoporosis. How long we should stop?
Why the patient is on blood thinner?
Low molecular.
Why
this is pre-optimization. I'm taking into all these things for
blood thinner because the patient
is not on blood thinners. This patient is not on blood thinners.
Okay, I'm thinking that the patient is having all this.
No. I'm just telling that this patient, if patient has was on blood thinner, how would you, optimize this patient when you would ask the patient to stop blood thinners?
Don't stop ecosprin. Other things 5 to 6 days before surgery.
So you switch over to molecular weight heparin, or you just randomly stop. It's okay. You can. And how soon you would start post-operative?
Sorry, I didn't get what you said.
No, what I'm trying to say is, when you stop your blood thinners, antiplatelets particularly, and would you switch over to low molecular weight heparin, or you just would continue with ecosprin only? And how soon post-operatively you would start your blood thinners?
No, so see, basically there are two things. If the patient is on only ecosprin, you don't need to stop anything. If the patient is on ecosprin plus clopidogrel because of recent history of PTC or a CABG, then you have to assess with the cardiologist when you are going to do it. Now, if it's post 1 year, usually they are they are going to 1 or they are stepped down on clopidogrel. Those you can easily stop it for 5 to 6 days before the surgery. Clopidogrel, ecosprin you can let it continue because usually it's 75 mg. And if it's an open one that you're doing, then when the drains are out, you can start again the other blood thinner which you have stopped. And if the patient is doing an MIS, then at least 4 to 5 days after the surgery, I would wait before starting the blood thinner.
Okay, Amit bhai, Ranjit, Kshitij.
Yes, so for my also 4 to 5 days, if there's a clopidogrel, I will stop the clopidogrel, but I will not start low molecular weight because of some issues that I had in 1 or 2 patients. It may be my personal choice, but I would wait for 48 hours before I start the low molecular after the surgery.
Okay.
So I was doing only when the patient had started after 24 hours with low molecular weight, and patient had a huge retroperitoneal hematoma with paralytic ileus and all that. So
low molecular weight heparin, you may only need to give the patient is still before that 1 year period post PTC or CABG.
Yeah.
Otherwise, usually you won't require. That is what the cardiologists say, or the cardiothoracic surgeon, because that is the crucial period after 1 year after that PTCA, within which you may require low molecular weight heparin. Otherwise,
Agreed. So I don't start low molecular weight. That's what I say. So I'm just
Ranjit, your DVD prophylaxis.
I mean, my hospital, there is a protocol that we have to give. Every patient has to have pre-op and post-op. So we start within 6 hours post-op. I had my share of issues like what Amit sir mentioned. But again, it's protocol. We use here this one, what do you call it? Enoxaparin.
What about pre-op?
Pre-op, see, for a walking, talking, running patient, I don't do anything. A patient, if he was lying down, we get a DVT scan done, Doppler and etc. to know that if there's any documented DVT. And then I use pumps, calf pump in every patient. In every patient, we use calf pump, irrespective of whatever any spine gets a calf pump, and everybody post-op gets within 6 hours. And they try to make the walk within 6 hours, 6 to 8 hours. Degenerative Scoliosis doesn't walk in 6 hours, at least by the evening they walk.
So our protocol is more or less same. We start, 8 hours before surgery, first dose of subcutaneous enoxaparin.
Even in an ambulant patient? Even in an ambulant patient?
Yes. Any surgery which is going to last more than 2.5 to 3 hours, I always start the DVD prophylaxis pre-operatively, and we continue till the patient is mobilized properly. So
heparin.
LMWH,
right?
LMWH. So this is what we do.
In sense of bleeding is more with LMWH than with heparin, right?
Yeah. So
in terms of bleeding, we are running short of time. Almost.
Yeah. I think I have half an hour. No,
half an hour is almost done.
Half an hour.
Just 5 minutes.
Half an hour is over.
So how much time you want me to finish into?
Finish.
It was already half an hour is over. 5 minutes more can take.
Was it a 1 hour? Half an hour?
Your session.
You are cutting short my time. Okay, then I'll quickly just we'll wrap up with this case. Okay, I was under impression that it is 1 hour. So maybe we'll wrap it up. So I think quickly, we are operating this patient. Believe me, this is a sagittal imbalance patient. I have operated this patient already. So what is your UIV, LIV? Amit bhai?
Yeah, go back. You get at least I want extension films. If it is a flexible, totally correctable, And MRI, where is the MRI?
I don't have this on this
So
presentation.
then it is difficult to tell anything about it.
Yeah, because the mobility of the thoracic kyphosis determines your
thoracic
because thoracic looks to be fused.
Yes, thoracic is not mobile. That is what I was.
So then I need to know how much I have to go.
Sorry, Ranjit?
Yeah, if thoracic is not mobile, then it is T2.
Amit bhai, your level?
No, I will not go to T2, but at least because there is no scolio, it's only sagittal imbalance. I'll just, and the maximum lordosis that SV correction that you want is at the lower lumbar levels. So I will just go L4, L5S1, L4, 5, and above I don't know because that I'll have to, but definitely L4, 5, and L5S1. That's what I can tell.
So this is
SPA correction will be right up to that.
So this is what I did. So I did not go all the way up to T2. You know, we stopped at T10 in this patient, and so far, you know, this is almost 8 months down the line, and patient is doing quite okay.
But Neeraj, isn't PJK more common when you stop at D10 than L1?
Yeah. Well, you know, in a fused spine,
I think incidence is same whether you get a PJF or PJK.
No, I think the literature is very clear. You know, whenever T10, 11 is least amongst 3, whether you stand.
No. Neeraj, what is a thoracic kyphosis?
No, I'm sorry, Amit bhai, let me finish. between three, if you stop at T10 or T11, you stop at D12 and L1 and L2. Maximum, least possible as T10, but it happens at all the level, maximum at L1 and L2.
But no, there's a paper which says that D10, if you stop, then PJK is more common.
No, PJF is common. That is
PJF again
more common.
But you need to find out the thoracic kyphosis, Neeraj.
Exactly. It's very relative. It depends upon the
because it is all fused, and if there is no thoracic kyphosis, definitely the inflection point will be at the upper level.
Yeah, true. Yes. But I don't have those images of, you know, thoracic kyphosis here. So this is what I did. I'll just quickly skip all these cases and we'll wrap up the point. So Amit bhai, just last point, you know, how before we conclude, what are the tips you would take to prevent PJKs and PJFs? Amit bhai, then Ranjit and Nikhil. Just quick one points.
I think first and foremost is PJK is your planning. If your sagittal planning is very, very important for any multi-level, whether it's a Degen scoli or a multi-level fusions for stenosis. For me, I think the main important point is a sagittal balance that you have to achieve. The rest of the things that you can do, I think the others will take over that point.
Right. Ranjit, so they say that, you know, when you correct maximum, you have higher chance of having PJKs and PJFs. So what is your strategy to stop PJKs and PJFs?
Yeah, so apart from what Dr. Amit mentioned, I also give a lot of importance to the bone quality. So, you know, build the bone and all that and try to release and try to get the sagittal balance. I see one single factor which really matters the amount of PJK and PJF is spinopelvic harmony. So I, even for a single level or 2 level, I try to recreate the spinopelvic harmony as much as possible. So that's exactly what the discussion about is it D10 or L1 or D12, right?
Right. Okay, Kshitij, your take? How would you do any other surgical techniques or anything to prevent your PJKs, PJF?
Conclude, Neeraj, conclude, please.
Okay.
Running short.
Fine. So, summary, we all discussed that there is no consensus about how to operate this patient or whether to operate or not. So, there are complex problems with complex solutions. Operation are as high as 40 to 50%, and some literature do quote that it is sometimes 70 to 80% combining major and minor complication. Clear understanding and discussion with the patient and their expectation is of utmost important. Pre-op optimization of the patient is utmost important. Never fail to plan pre-operative. Stick to what you planned and try to replicate intra-op and post-op rehabilitation of the patient is very important. First surgery is always optional, never the revision. So try to choose your patient very wisely. You may want to let go of some of the patient to either safeguard the patient or safeguard yourself. Thank you so much.
Thank you.
Thank you, everyone.
Thank you so much, Neeraj, for excellent presentation and discussion. So we move on to a next session, and the moderator is Dr. Arun Bhanut. Sorry. Yeah. Next, Dr. Ajay Shetty.
Okay.
And the panelists are Dr. Alok Ranjan, Dr. Arvind Bhave, Dr. Manish Kothari, Dr. Srinivasa, and Dr. Hitesh Modi.
Thank you, Dr. Rakesh. I hope I am audible.
Yes, sir.
Yeah, we would be discussing a case of a vertebral compression fracture in a patient who is diabetic, chronic renal failure. I would welcome my panelists, Alok Ranjan, Arvind Bhave, Rakshit, Dr. Hitesh, and Dr. Manish. I'll just go on with the history. We'll try to keep it as short as possible and hopefully finish within time. 78-year-old lady with a known chronic renal disease on dialysis, with history of cardiomyopathy, hypertension, asthma, recent history of cholecystectomy, no relief in back and flank pain after cholecystectomy, difficulty in sitting, standing, and walking. She is unable to go for dialysis, hence is on home dialysis, which has led to poor clearance in metabolic disorders, and referred for a back pain. And this is what the imaging looked like. This is the MRI scan. And this is the CT scan. First, I would ask Hitesh, what is the difference in patients with CKD? I mean, why the particular case scenario Arvind has given us? Why it is what is it different from a normal elderly patient with osteoporosis?
Thank you very much, Dr. Ajay. I think, am I audible?
Yes.
Yes. Yeah. So I think it's a great question that I think in elderly people, they have osteoporotic fracture, but the specific like CKD patients, they have very, very high incidences of fracture as well as mortality and morbidity compared to the general population or elderly population who generally get osteoporotic fracture. And I think as far as I remember, the incidence is probably it is around 10 to 20% higher rate of vertebral fractures, or 10 to 20% of vertebral fractures happening in patients of dialysis patients. And these patients are having like severely porotic bone. If you see the DEXA scan or bone density, it is like more than minus 3.5 or so. So they are really, really heavily osteoporotic with metabolic involvement.
Okay. Is there anything else, Manish? Do you think is there anything else important in the management in this patient which is different than a usual osteoporotic patient?
So these patients are very high turnover patients. So they are usually very high PTH. And the bone is, there are two types of bone disease in CKD. One is a adynamic disease and other is the high turnover disease. So we need to be aware of both of these conditions. Adynamic is where the bone turnover has completely stopped. Bone itself is in stasis, and the ability to form new bone is very difficult in these patients. Other is the high turnover, as Dr. Hitesh mentioned. These are the ones which are severely porotic, and the bones are there's almost no bone. If you can see in this CT, the bone has collapsed, and there's a huge vacuum which is creating in the center. And what is typically called as a rugged jersey spine is seen in the high turnover bones. Of course, and these are the ones which are, they don't have any active vitamin D in their body, so their kidneys have stopped converting the 25 hydroxy to 125 hydroxy vitamin D. So they, and very few patients actually receive continuous active vitamin D during their treatment. So they are deficient in calcium, deficient in vitamin D, as well as their proteins are restricted by the nephrologist. So the overall protein intake, which we usually recommend to our general osteoporosis patients, you cannot recommend to these patients. So overall, these are very challenging situations metabolically. The healing is not very predictable as in general osteoporotic patients.
Okay. Then basically, there is a higher incidence of fracture. There is about 7 to 20%. Number two, the usefulness of DEXA is very controversial. They say it's better to use radius rather than using a hip and spine. And QCT is probably much better than using a DEXA in this particular group of patients. The important thing, as you mentioned, because the 125 hydroxylation does not happen in the kidney, the active form of vitamin D, like calcitriol, has to be given to bring about the PTH levels to the normal. And in patients with significant renal dysfunction, bisphosphonates cannot be given. teriparatide also if there is a secondary hyperparathyroidism, and probably denosumab is probably the only drug of choice. Therefore, what it implies is the fact that whenever we are treating this particular group of patients, I don't think that we should make an attempt to treat it. Endocrinologist and the nephrologist should be the one who should be actually managing the osteoporosis part of it. Having said that, Arvind, do you think what is the role for conservative management in this particular, Arvind Bave, a particular group of patients? What will you do in this particular case?
No, most important thing is the bone healing is going to be very slow, and whatever bone healing occurs, it is mainly fibrosis occurs rather than having active bony tissue. So I would usually treat this type of patient little over treat. So additional bracings and also I am giving besides denosumab, and strict that is more important along with the kidney nephrologist and endocrinologist managing, because they don't have concepts of this, and we should be preventing the kyphosis, because if the kyphosis goes on increasing, then these patients are going to land up with paraparesis and further problems.
Therefore, you would manage them conservatively, more aggressively, and also you might think of intervening much earlier if they are not responding, if they're going into kyphosis.
Yes.
Right?
Yes.
Okay. Can we predict in osteoporotic fracture, not in a patient with a renal failure, is it possible to predict which one of them can go into pseudoarthrosis by looking at the CT scan or the MRI per se? Anybody?
Yeah, if you see the cavity progressively increasing, progressively collapse, and at the junctional zone particularly, when anterior height is less than the posterior height, and these are all points we should alert, which should alert you, and you should have regular follow-up. And if they are collapsing, then it is better to stabilize them, prevent further kyphosis, because kyphosis is the main thing which is going to change whole the final results.
Okay. What they say is the studies have shown that male sex has got a higher risk for pseudoarthrosis. When the initial vertebral loss itself and the time of presentation is about 30%, there is a higher chances of pseudoarthrosis. In the plain radiograph, the post-injury, that is the initial radiograph and the segmental cob angle is about 15 to 20 degrees. There is a higher chance of pseudoarthrosis. But most importantly, when you look at the CT scan, a burst type of fracture, there is a presence of a PLC injury. And if there is a diffuse hypointense in the affected vertebra or a confined hyperintense in the middle of the vertebra, these are the one who are supposedly has got a higher risk of development of pseudoarthrosis. It gives us an idea, and probably we can warn the patient that need to come for regular follow-up. And in the event it's going for early pseudoarthrosis, we may have to intervene. Manish, I think it's your case. I mean, tell me, what are the problems you face while you're doing this particular procedure, and what precautions you take, and why did you choose 2 levels? Manish?
Yeah. So these patients are extremely fragile, so you have to be very careful with them. Pre-op optimization is absolutely important. Even giving sedation, sometimes the anesthetists are not very happy. From the surgical point of view, the landmarks are absolutely very difficult to figure out. So I use a very lateral entry point to make sure, because the medial pedicle line may not always be seen. Try to use minimum cement in these patients. The flow of cement also may not be as expected that you see. Usually you can put in a die and see what will be the expected flow of cement. But in these where there is partly sclerotic and partly cleft, you may not always be seeing the flow of cement. Third, in this case, I think the lower one had some end plate marrow edema. Not quite sure. So I decided to add that level as well. On the CT, there was a cleft. It was more like a small nodule, but I should have probably added one above as well. But I decided to go with one below.
Is there a literature to support augmenting other levels in patients with the CKD?
I'm not quite sure, sir. I've not read that up. Sorry.
Okay.
It is called as prophylactic vertebroplasty, which we do in some cases Even at the end of the fixation to prevent PZK also sometimes it is done in severely osteoporotic patients. So this is well done. Only thing is the amount of cement, what we have done our mechanical studies in bioengineering labs is usually the 15 to 30% of the volume of the cement is sufficient. Otherwise, these will keep on collapsing and within few months they will have adjacent or same vertebra can collapse further. So
Arvind, can you just clarify on that? How do you decide the 15 to 30%?
Usually for Indian patients, what is our volume calculation is around 15 cc's is for D12, D10 to D12, and from L1, L2 it is around 20. So usually 15 to 30% means it comes to around 1.5 to 2 cc's of cement is usually sufficient, and that makes biomechanically stable vertebra as compared to adjacent vertebra. Because what we are interested is the problem is new bone is not going to form early. At the most, fibrosis can occur, and if we make sandwich-like hard cementing material between the two soft bones, then they are going to have adjacent collapse in next few months.
Okay.
So isoelastic. So it has to be isoelastic with the vertebra above and vertebra below, and particularly at the junctional levels, which is a high pressure demanding zone. Particularly in this patient, it is D12 L1. So which is already lower level is already collapsed. So I would prefer less cement in the upper vertebra. And second vertebra is just prophylactic vertebroplasty. So whatever has been done is okay. But even if you put less cement in the upper vertebra, it will give you long-lasting results.
Okay, thanks, Arvind.
We have got follow-up up to 2 to 8 years, and we have collapse in only one patient out of 300 patients.
Okay. Rakshit, what about kyphoplasty? I think you do kyphoplasty more often than just doing a vertebroplasty, right?
Yes, we do kyphoplasty more often, but for one of the contraindications for kyphoplasty is if there is vertebral body destruction beyond 60-65%, then vertebroplasty is preferred.
Okay, what are your critical steps of kyphoplasty? Can you just go through it briefly?
Yes, sir. So basically, the first step is under fluoroscopic guidance. The basic principles of minimal invasive spine is used, where you mark the lateral pedicular line and you cannulate into the pedicle across the posterior surface of the body using a cannula. Then you pass in a guide wire. You pass in what do we call as a handheld drill. With a handheld drill, we almost drill till the anterior portion of the vertebral body. Following which, the next step is we pass in the balloon which is inflated. Depending, it's very subjective depending on the case. You can go up to 100 to 150, or in some cases almost to 220 psi. And once the balloon is inflated, the balloon is removed, and the next step is bone cement is infiltrated on each pedicle. So it can either be done in a single pedicle or both pedicles. Usually, like what Dr. Bave said, we would prefer to inject around 2 cc's in each pedicle.
During the process, how do you aim to get the height of the vertebral body which is collapsed? What are the ways you attempt to get the height of the vertebral body back?
So we very gently increase the pressure of the balloon, and that helps us to compact the cancellous bone and helps us to increase the vertebral body height.
Alok, do you have any other technique of getting the height apart from using the balloon, the positioning of the patient?
No positioning. Most of these patients, you actually can't keep them on the table for very long. So balloon also I have found that if the bone is very fragile, it expands it, but it breaks it. And when you inject cement after that, then you find the cement is leaking in various corners. So that causes the problem. So I no longer attempt a very good correction. I just attempt some kind of stability there, because the aim is just to provide symptomatic treatment. Here you can't have a sagittal balance, out of question.
Okay. Rakshit, can you go through the cases of yours?
Yes, sir. This was a 70-year-old male patient who presented with axial low backache with no neurological deficits. And MRI T2 weighted shows he had a VAS score of 8 at presentation. MRI T2 weighted shows a wedge compression fracture at the L1 level. So we went ahead and did a kyphoplasty for him, percutaneous kyphoplasty. These are the method that we used. This is the, I'm sorry about the poor quality of the X-ray, but if you can observe, this is the balloon which has passed almost to the anterior part of the vertebral body. This is the next image below is the dilated balloon. And on the right side, we can see the post-operative X-rays where the vertebral body height has increased significantly. And on the coronal X-ray, on the AP X-ray, you can see the cement, and there is no extravasation of cement either to the disc space or along the nerve roots. Post-operatively, this patient had a good recovery, and when we followed up at around the 5th post-operative month, he had a VAS score of about 2. The next case was a 70-year-old female, again with a low backache since 6 months, axial low backache, no radicular pain. VAS score was of 8. MRI showed a D12 compression fracture. We did a percutaneous kyphoplasty. The problem that we faced in this, if you can carefully see the sagittal image, there was some extravasation of cement into the disc space and all along the pedicle as we removed the cannula after injecting the cement. But post-operative period was uneventful, and she recovered well with a VAS score of 2.
Okay. Thank you, Rakshit.
Thank you.
The current literature also favors the fact that, overall, both are effective in the sense the current literature says that even vertebroplasty and kyphoplasty are equally effective. But balloon kyphoplasty has significantly slightly better outcome with restorance of vertebral body height when compared to vertebroplasty alone. Therefore, we'll move on to the next one. I think, Arvind, your way to address these particular issues to prevent leakage and also, as you mentioned, to reduce the incidence of adjacent segment issues. Arvind Bave?
Yeah. So you will present or I should present?
I will present.
Yeah, please. Yes.
I have already put your slide.
No, can you go back to the history slide or you're coming?
History is not there. I just kept the.
Ajay, you removed the history. Yeah. Okay. So this is a lady I'm presenting. This is a about 74 years old lady who had household fall and was treated conservatively with bed rest, anti-osteoporotic treatment. She was on antihypertensive drugs, diabetes, asthma, and so many other medical problems. She developed acute cardiac infarct and she underwent angioplasty within 2 weeks of this fall. So now 2 weeks down the line, patient has 2 stents in her body with a compression fracture and she's on double anticoagulants. And then progressively, she is now brought to us at the time when she has become paraplegic, totally bedridden, unable to move. And she is on 2 blood thinners. And this is her situation. You can see CT scan showing collapse, MRI showing a small posterior vertebral component, which is going into the canal. And on the axial view, you can see a large void and you can't really identify the posterior vertebral body. So it is very near to the thecal sac. So as she was unfit to undergo any major surgical procedure or major anesthesia, we did vesselplasty under local anesthesia. You can see the intraoperative pictures. Here local anesthesia given at the pedicle site, way marked for the implant to get inserted inside. Then implant is inserted through transpedicular approach through this locally infiltrated stab incision site. And you can see the position of the implant, which is nicely central and holding the middle and anterior column. And this is another case showing in short what is vesselplasty. This is an implant And now in the implant we are injecting, and as the implant goes on holding the cement, it opens up, and that is how we gain height for the vertebral
I can
body.
play it again if you want.
Yeah, please play. So you can see implant inside. Now cement is getting injected and it is lifting the end plate. So sub-end plate approach is better whenever you want height correction also. The beauty of this is cement leakage can be prevented. So even if you don't have posterior wall, then also you can use. So this is another indigenously developed, I have developed this instrument where we can create a void wherever you want, like in kyphoplasty. This is a metallic instrument which inflates inside, creates a path for the implant to be seated nicely. And then here the implant is in the third view, you can see the implant, and now I'm injecting the cement, and you can see the implant opening up, lifting the end plate up, and at the end, last view is showing that it is disengaged and implant is in position. And next X-ray, she started walking on the same day. This is immediately post-operatively at the end of the, and this is almost 2 months follow-up. And now I have 2 years follow-up also, and there is no further collapse. So patient is fully recovered on her own from the evening of the surgery. Okay. That is the beauty of this procedure. There is no cement leak, even if she had posterior vertebral wall deficiency. And this was at D12 level.
Does it improve the kyphosis?
Yeah, you can see whatever is improved is this much. That is why we can have multiple heights of implants having different volumes. But currently I'm using 15 and 20 millimeters implants. So once they fully develop or fully opened up implant can increase the height up to 2 centimeters or 20 millimeters.
Okay, thank you, Arvind. I mean, the point you want to highlight is the fact that you should not inject
more safety, no cement leak, and can be done under local anesthesia. That is the beauty of all this.
Okay.
No GA, no ICU, no big wounds.
So far, we spoke about the first generation, that is vertebroplasty, the second generation, that is the kyphoplasty. Manish, do you have experience in UK when you were there of using spine jack or any stenting procedures?
Yeah, I've used the vertebral body stenting in about a couple of patients. And we use same as Dr. Bhave has mentioned, it just goes bipedicular and you can really lift up the end plates. But I was using it morely for the young patients or the middle-aged patients with burst fractures and so on. We very rarely used it for osteoporotic patients because the results overall didn't change versus vertebral body stent versus simple vertebroplasty. So cost-effective wise, vertebroplasty does the job.
Okay. Anybody else has got experience using stenting or any other other types of third generation implants? Okay. If not, but the current literature does suggest the fact that the kyphosis correction is significantly much more with third generation implant. And the most important thing they say, because of the correction of the wedge-shaped vertebral body, the chances of adjacent segment fractures also are relatively lesser when compared to the first and second generation implants.
Yeah.
And that's the current meta-analysis does say. Anybody? Any comment?
No, we have the same, our results are also showing the same thing. We don't have any adjacent fractures so far, but our follow-up is almost for 5 years now, 5 years plus, since I'm doing vesselplasty in India. Most of the patients are okay. Everything done under local anesthesia, so they are happy going home on the same day or next day.
So please correct me if I'm wrong. So most of the correction actually comes from the positioning of the
patient. Mostly it comes from position, and we don't aim at actually jacking up. But what we try to do is holding up the end plate, because that is the strongest part in the osteoporotic bone or osteoporotic vertebral body. So if we are under sub-end plate, like for neck femur, we try to remain subcapitate, so to have good purchase. So similarly, sub-end plate purchase, if you have, then you definitely have better results rather than post-operative collapse. And the philosophy of vessel is it has 0.1 micron pores through which the cement can percolate outside through these pores. So whenever there is no posterior wall collapse and you want to have a good bone and cement interface, you have to inject further more cement so that the cement will come out through the pores of the vessel and that will hold the marrow, vertebral marrow. And so that marrow holds the cement and implant holds the cement and the marrow. So
Thank you,
in a way, loosening doesn't happen. That problem is more seen when we are doing kyphoplasty, because that is a big central cement mass and porotic bone by the side. Many times after a few months or years, you can see a edge between cement and vertebral body bone or marrow, vertebral tissue. This type of differentiation you don't get in vesselplasty. If you inject little more, 1 or 2 cc more cement, which percolates and comes out of the wall of the vessel itself and holds the marrow tightly, so that this prevents lead collapse in our study, which is not done in kyphoplasty.
Okay. See, but Manish, the point you brought about is the fact that even when you position lordotic, this is from the literature on stent, maybe industry sponsored. They do say that the balloon, once it's deflated, it again can collapse. Whereas when you put a stent, it can withstand a load of 226 N, which is exceeding the normal 110, which is exerted by the vertebra. And that's what
in our experiment, what we found is, in our experiments in laboratories, what we found in Indian cadavers is 112 newtons per meter square is required to hold that position. So whatever these industries are claiming, anything above 112 newtons per meter square is going to be good technically so far as injuring or biomedical injuring is concerned. But for our Indian patients, usually 110 or 112 Newton meters per square centimeter is more than sufficient. And that holds the end plate nicely.
We'll just move on to the other case. This patient had a refracture which was managed conservatively by Manish, but this is one of our case. A patient who was treated elsewhere with a vertebroplasty at the level of L1, just done a vertebroplasty, comes back over a period of few months with the progressive weakness, in the sense weakness of the proximal musculature. And you can see there is a significant kyphosis. Alok, what will you do in this particular scenario? What do you think would have caused?
Do we have some MRI picture just on X-ray?
No. These are the MRI pictures and this is the CT picture.
I think the fragments have gone a little bit inside the canal. And if there is a neurological deficit, so obviously there's a compression.
So what will your approach be?
I think in this case, definitely we'll have to decompress it. The moment you have neurological deficit, then you have to decompress. I will do everything from posterior.
You will do a posterior instrumentation and anterior reconstruction.
Yeah, posterior.
Can we have index MRI or picture?
No, that is not there. Sorry. Unfortunately, they came to us with this picture.
Yeah, because primarily I feel that is a gross
instability. This is the index MRI. Sorry,
vertebroplasty should not have been carried. It should have been stabilized along with vertebroplasty.
What is the factor there which makes you think it needs stabilization?
Yeah, because it is a totally comminuted fracture. You can see some shadow anteriorly also. So there is anterior collapse, middle collapse, posterior column collapse. So all three columns are collapsed. So you have to stabilize. So in such patients, I would go percutaneous at least 1 or 2 levels above and below and do vertebroplasty. That helps.
Could you be worried about...
If patient is unfit for GA, I do everything under local anesthesia and sedation.
Okay.
This is possible with percutaneous fixation.
Okay. Rakshit, would you be worried in a L1 fracture whenever it is a burst L1 osteoporotic fracture?
Yeah, definitely, sir, because it's the junctional fracture. So we would prefer to go 2 levels above, 2 levels below to the posterior fusion and then do a laminectomy. And if possible, that should give sufficient decompression. And I don't think we would go ahead with the kyphoplasty for this.
Okay.
No, standalone kyphoplasty or any type of plasty won't help. You need to support posterior column also.
Hitesh, what would you do in this now when the patient has comes to it? It's not a true neurological deficit in the sense while lying down, the patient is able to move well. But when you make the patient stand, they're not able to stand. There is weakness of the proximal musculature. Therefore, how will you address that?
So this is a dynamic instability. So you need to stabilize this. You may not do posterior decompression if you feel so. Means no laminectomy may not be required if you get good correction on table. That option you can always consider while you are doing surgery.
You don't need to do laminectomy. You don't need to do laminectomy.
You just stabilize, correct the kyphosis, and everything will be taken care of.
You don't need to do laminectomy at all. Actually, you can do the anterior decompression from the posterior.
Yeah.
You shouldn't
Transpedicular also you can go because there are a lot of fragments in.
Yeah, you should not be touching the posterior element at all.
Okay, Hitesh, what will you do?
I think I will treat it as an instability and along with some burst fracture component.
Yeah.
So I will go at least 2 or 3 level up and 2 or 3 level below and try to correct and stabilize the kyphosis as well. And if I see larger void anteriorly, then sometimes, not always, you have to go extended laterally and you have to go inside and insert anterior cage as well. Otherwise, you can just fix it if you are satisfied. And if there is a large fragment going into the spinal canal, then yes, decompression is necessary.
Manish, what is your approach?
Sir, yeah, I think the treatment now is pretty standard that you'll have to kind of fix it, decompress, possibly depending on the MRI images. But indirect decompression alone will be sufficient mostly because on MRI there is no active compression as such. It is mostly dynamic. But I'm slightly worried about the anterior reconstruction because the cement is all haywire. There is absolutely nothing. So I would be tempted to put in a cage anteriorly, depending on the age of the patient. If she's 70, 60, around 70, 63. I would definitely add anterior cage from transpedicular approach and anterior support.
Okay. Rakshit, anything else you would like to add?
No, sir, that's it.
We can try pedicle subtraction osteotomy as well in some cases.
This because the whole body is disintegrated.
Not in this case.
Hello?
I had a very bad experience with pedicle subtraction in this setting. So I will not try. I will just do a transpedicular approach.
Just 5 minutes into the session.
Yeah, I had a similar case where the patient had infection, tuberculosis, and we have ruled it out and then did vertebral kyphoplasty. And finally, we had to remove the whole thing. So it comes out pretty easily. It is not very difficult to remove through the transpedicular. And the cage has to be put, anterior support has to be put apart from the pedicle screw.
So you've gone anterior for this or you put that large cage all from behind?
All from behind.
Transpedicular. Transpedicular. I will do I won't open anterior at all. These are not the right cases for interior, then you add further problem in these sick patients.
Manish, should you have used cement augmentation?
In the revision surgery, no, sir. I would definitely put a cage. Something similar to what.
No, what I mean to say is the screw
augmented screws. Yeah, you can use cement augmented
screws, sir. I'm not a big fan. I use these dual core screws and hooks at top and bottom. Yeah. I am not very big fan of augmented screws because if the bone is weak, whatever you do, it is better to have a screw pull out than to have a cemented screw pull out. So I'm not a big fan of augmented.
Hitesh?
Yeah, I will keep in mind that this patient might require revision again. And in those cases, if you had put cemented screws, then it would be very difficult. So I would remain away from cemented.
Okay, Rakshit, you would like to add something before we ask Alok to close?
No, sir. I think I would go with the augmented screws based on the DEXA bone scan. Augmented screws, transpedicular decompression, and cage. With that, I think the fusion should be good.
I would always prefer to use hooks in the top and bottom. It's transverse process hooks in the top and offset sublaminar hooks in the bottom. I mean, you have to be ready with it. I usually, like Manish said, I'm not a big fan of using cement augmented screws. The lowest, I try to put intradiscal, transdiscal whenever it's possible so that it gives you a better hold because inside the fusion construct. But only reason I did a laminectomy in this case is basically because when you put in a cage and you can compress it a bit so that you can get an adequate size cage. If you have not done a laminectomy, you have to put a cage in very perfectly, which sometimes becomes very difficult. I mean, at least in my experience. Otherwise, I can put a shorter cage and compress a bit so that I will be able to reconstruct it much better.
Anterior column, yeah.
Only thing probably I would add, sir, is I would add sublaminar wires on the rods as well.
Yeah.
With the
Actually,
same screws.
Okay.
Yes. So posterior stabilization, because even in cases of osteoporosis, lamina can still hold for a longer time. So you can go on adding sublaminar wires to just supplement your fixation.
So what is that extra rod in your case, Dr. Shetty?
Yeah, just put an extra rod connecting on one side. I didn't want to put on the other side just to stabilize it till the healing happens. I mean, it's now 1 year, the patient is doing well. We always supplement this patient with teriparatide, taking the endocrinologist opinion in along with it.
Yeah, Ajay, So the way we manage these is we have seen plenty of these. So I wouldn't go anterior at all. I wouldn't do laminectomy because this is a dynamic instability. So we use a posterior, the lamina we put a lot of bone graft there as much as possible to get a solid fusion at the back. And we compulsorily, we put four rods in these cases. And we apply the principles of kyphosis correction with regards to the levels.
Yeah.
So usually about 2-3 levels lower down, about 3 to 4 levels higher up. And this is, as of now, with whatever experience we have, we will not fail.
This is similar to the paper came out from Dr. Chabra, which was published last year. They use a dynamic MRI, and if there is a 50% or more, or there is a CSF flow in the front, they just do a posterior stabilization and fusion, which they have demonstrated a good results. Similar, I mean, there are a lot of papers. I think the initial publication came out of Korea, and after that, in the last few years, there are a lot of publication on just stabilization. Alok, can you summarize it?
I think this is a disease. If we are talking of two different things. We are talking of a traumatic part, and we are talking on osteoporotic part. So I'll concentrate on osteoporotic. In osteoporotic, obviously, most of these patients are not very good. And when we are talking of the topic of chronic renal failure, obviously you have a chronic renal failure because you have a lot of morbidity. That's why you get chronic renal failure. That's why you have a diabetes, hypertension, bedridden, wasted patient, poor healing, all kind of things. And there are two reasons why they come to us. They come to us for pain and they come to us for deficit. I think we must be more concerned about the treatment of their symptoms because their quality of life has to be improved. Unlike trauma, we have various kind of this screw, that screw, they have limitations. Anesthesia time is limited. We cannot keep them very long. So more and more instrumentation is something I am getting little jittery of. I think it is causing a more and more problem because with more instrumentations, problem also are much bigger. So I much rather add things than to subtract things because subtraction is becoming a big problem. And this is what my experience. So I feel that we must treat their symptoms and some of their future anticipated problem and don't go treating them like a normal person who require 5 level above, 5 level below. They won't last that surgery also.
Okay, I think we'll conclude. I thank all the panelists. Thank
Ajay, can I just have one question if you're allowed?
Yeah, sure.
The question is for any of the panelists. One question that nobody answered from the beginning in this topic is, when do you primarily do posterior fixation in osteoporotic fractures? From the time go, I'll say 3 level above, 3 level below, I'll not try kyphoplasty or even if it is just an addition. What are those specific markers and CT, X-ray or MRI that you will say, Baba, this is not for this, it has to be only posterior fixation, multi-level. You can start with Ajay itself to tell me.
No, but basically the factor you need to take into consider in a primary scenario, very rarely I do a instrumentation for this patient. I treat them conservatively. The indication for posterior instrumentation is whenever there is a posterior failure, either in the form of, that is what is called as an intervertebral instability, not intravertebral. Yeah. When you take a bending radiograph, there is a movement happening between the vertebra and the vertebra above, usually implies the posterior ligamentous complex is injured above. And at the level of L1, you have to be much more careful when you are doing a standalone procedure. These are the ones you tend to instrument. The current literature from Germany do suggest you go 1 above, 1 below. But in my practice, I have always been very hesitant. Whenever I instrument, I usually go 2 above, 2 below.
Anybody else?
If I may add, sir, there are certain, apart from the posterior tension band, as sir has mentioned, there are certain MRI features on the that you can also add fixation primarily. One is there's a coronal split, the A2 fractures in the trauma patients that you see, but you also see them in osteoporosis. So these are the ones I will always fix. I will never do a standalone because there is a coronal split. The cement is going to end up in between the two fragments of the bone and not hold the bone segments together. Other is a totally crushed vertebra, the patient that, as we've discussed previously, there is no end plate to hold the cement inside the bone. These are the ones you'll fix. And third one is an intervertebral, as sir mentioned. There is a dynamic, the disc has also gone. And I always do a sitting X-ray or a standing X-ray, the vertebral bones. Then these are the ones you will have to fix.
So neurological deficits are also something that we need to consider, I thought, importantly.
Okay, completed the 30 minutes of time.
Yeah.
Thank you, Rajesh, and thank you all for joining, and thank you all the faculty.
Yeah, thank you everyone.
Thank you.
For interesting cases and panelists for nice discussion. So we move on to the next case, that is C56 disc osteophyte complex causing radiculopathy by moderated by Arun Bharat. Please, Dr. Arun Bharat, take over.
Am I audible?
Yes, sir.
Okay, I'll share my screen.
And the panelists for this session are Dr. Ankur Nanda, Dr. Jean Kim, Dr. Arvind Malhotra, and Dr. Suku Barsula.
I'm finding a little difficulty in sharing the screen.
Doctor, you have the share screen option.
Yeah, I'm sharing it, but my Mac is not permitting me.
What is the message you're getting? Not permitting.
Preferences, open system preferences. Showing the Zoom is okay. Okay, is it obvious?
Yeah, can see, yeah.
Okay. So in this session, we'll be talking about the cervical radiculopathy and what are the possible treatment options we have. And we have a very eminent panel with us, which is a balanced panel from orthopedic spine surgeons, neurosurgeons, doing all types of open, micro, and endoscopic procedures. So we have Dr. Ankur Nanda from Delhi, Arvind Malhotra from Chandigarh, Dr. Sukumar Sura from Hyderabad, and Dr. Jinsun Kim from Seoul, Korea. I think Dr. Kim has yet to join. Is that right, Arvind?
He's still not seen, but he had confirmed his presence, that he would be present. Yeah, he's there. Hi, Dr. Kim. He's, yeah, I can see.
So welcome, Dr. Kim, as well now. So we have the full panel. Thank you. So we straight away go ahead to the case, which is case 1 for this, which is actually going to be the main case for our discussion. So this is a 45-year-old gentleman who presented with a right shoulder and arm pain, also neck pain for more than 6 months, probably a year or so, but which had worsened for the last 2 months. He also had right arm numbness and tingling occasionally. He lives very active lifestyle with the active sports participation on regular basis and wants to do that continuously. That doesn't want to restrict activities if that involves reduction of his pain. He didn't have any grip or hand weakness, and he had taken sufficient degree of conservative treatment from other spine specialists in the town before he presented to us, which was in the form of a reasonable course of medication, physical therapy, rehabilitation, exercise regime, etc. This is his clinical examination, finding the pain was in C6 and 7 dermatome on the right side. Motor tone and power were normal. He had hyposthesia to cotton light touch sensation in these 3 dermatomes. Sperling test positive and DTRs were normal and no upper motor neuron signs. Now, when we order investigations such people, I wanted to have the opinion of the panel Does X-ray of cervical spine play any role in your day-to-day management of such cases, Ankur?
Yeah, thanks for the question, Arun. I think X-ray does play a role. I usually like to start with X-rays and MRIs at one go if I have a radiculopathy. I won't send him for an X-ray first and come back and then go for an MRI, but I would order both. And I think the X-ray gives you an overall feel of, what is the degenerative status of the spine? Are there multiple osteophytes? What is the quality of the bone? Is there any metabolic component going on? Because these are things which are really difficult to detect on the MRI sometimes. So yes, X-ray does have a role. I usually like to get X-rays done initially and then take it from there. Yeah.
So does the panel agree on the use of X-rays as a primary investigation, or it is as a supplement to MRI and other things for this particular case when you're dealing with radiculopathy?
Yeah, I think X-ray is also important. For the X-ray, especially oblique view, we can find the osteophyte compromising foramen, and also sometimes, very often, especially in the old patient, not in patient have the low-grade degenerative spondylolisthesis as well. So it's going to be very important for decision making.
Great. So yes, X-ray, definitely you mentioned that these two things will be important, especially in terms of missing out on degenerative spondylolisthesis. And many a times, if you have an X-ray showing osteophyte, you may not actually need to do a CT scan as well in such cases. Now, MRI, everyone agrees. And how many would want to do a CT scan for such patients to rule out advanced degeneration leading to uncinate osteophytes as a contributing factor towards the symptoms?
Yeah,
would CT be an option, or it will be almost a mandatory thing?
Yeah, it should. Yeah. For me, I think CT scan is a mandatory armament. We should always get a CT scan. Missing out on calcified osteophyte or a disc might prove not good, while if you are having a replacement or a fusion thing, it might create a problem, and sudden surprises may be there. So CT for me is a must. Another thing, I would also do a dynamic X-ray. I don't know, sometimes you find you are missing something, and dynamic instability may be there. So for me, these two things are must.
Right. Dr. Sura, are you there? Dr. Sukumar? Okay. Anybody after seeing, okay, so I'll just go to the MRI. In this case, we didn't have the X-ray to put in this, but anyway, the dynamic X-rays did not show any instability. They were done. So I move on to the MRI in this case. So this is his MRI showing C5-6 and C6-7 disc osteophyte kind of a thing, which is looking like a disc osteophyte, but we'll check it on CT as well.
CT scanner.
So this is his MRI SAG running film. And this is the axials at C5-6 levels, which shows a pretty big foraminal stenosis on the right side at C5-6. So we agree that he has a significant foraminal stenosis at C5-6.
Definitely.
And this is his C6-7 level. Axials again showing reasonable level of foraminal stenosis at this level too. Now, this is probably a combination of a disc bulge in the foramen, and knowing by experience, knowing by the patient's long history, we know that there is a possibility of a calcification in such a case. So we would definitely want to do a CT scan, as Dr. Arvind mentioned. So this is his CT scan. I'll just run a small recording of his CT. So you can see the osteophytes on the right side. So you can see a small component of paracentral osteophytes as well at C6-7 level. Now I go back here, is this information sufficient for us to arrive at a clinical diagnosis, or anybody would want to have a further confirmation of this patient's presentation with the NCV nerve conduction studies? Or we are reasonably sure that he suffers from a radiculopathy arising from cervical foraminal stenosis? Ankur, yes.
Yeah, so I think at this point of time, probably not NCV, but I would definitely like to get some oblique MRIs done parallel to the foramen, because frankly, the axial sections in the MRI, you will see a lot of patients with these type of foraminal stenosis, but actually patients having no symptoms at all. Right. So axial sections, and there have been studies which have shown that the axial sections have a little low sensitivity towards really being able to pinpoint the foraminal stenosis, and that is where the oblique views come into play. So usually when we have MRIs where there are clear-cut disc herniations which are coming in the lateral area and then into the foramen, that is not when we would like to get the obliques done. But for a absolutely a disc osteophyte complex carrying the causing a foraminal stenosis, I would think of getting axials parallel to the foramen, so as to, I'm sure, because these are tricky patients. Once you go ahead and commit and do the surgery and the pain doesn't go, it's unhappy situation for both the patient and the surgeon. So I would further confirm with an oblique MRI.
So what is the gantry position for such oblique MRIs?
So I think I'm not sure about the exact angle, but something like a 15 degree, 20 degree. Basically, the technician has to get the sagittal parallel to the pedicle direction. And as you get the parallel to the pedicle direction, you'll be able to see the foramen absolutely in the plane, perpendicular to the foraminal plane. And then you will be able to see the osteophytes. I think a couple of Korean papers have come up with the description of this oblique view, and they've been talking about for almost a decade now.
Right. So we'll ask Dr. Kim on that, but I'll share my experience that to endorse this diagnosis, as you correctly said, sometimes it can be misleading. What we do is we look at the running sagittal sections and try to see the foramens even in sagittal sections. So the misleading foraminal stenosis that you see in axial, if it is not endorsed in the sagittal sections, which is far lateral foraminal sections, then you definitely have to think twice whether the foraminal stenosis is actual or not. The second thing that we can do, which you don't have to do anything extra, is beyond what you conventionally do in your MRCT, is if you have a 3D reconstruction CT, you can go to the console and tilt the angles of the orientation after the CT has been taken. So that will give you a true picture of the foraminal dimensions. So you may not need to do a special sections in that, but yes, that adds one more point. Dr. Kim, do you usually want to do a oblique MRI section?
Yeah, I believe the MRI, oblique MRI sagittal view is going to be very helpful for diagnosis properly. But it's not the routine examination in my hospital. So I obviously that kind of the oblique sagittal view, not only cervical spine, but also the lumbar spine, is going to be very helpful, especially for beginner. But if you have the enough sort of the experience on the spine and related diagnosis, I think that is the not mandatory tool. More importantly, I believe the patient clinical symptoms manifestation is more important than the sagittal oblique image itself, because the many foraminal stenosis are asymptomatic, so we need to focus the patient's symptoms. Is it definite C6 radiculopathy or definite C7 radiculopathy? It's going to be more helpful. But sometimes many patients has a little bit not obvious symptom there. So in this case, I have more belief in the diagnostic block than the image itself. If I am not sure, so I'm gonna do the treat both level.
Right.
If it is definite, we can avoid unnecessary surgery. That's my opinion there.
But no one would want to have any ratification of the nerve conduction velocity in studies in this patient.
So regarding the NCV, there is also the very helpful tool, but even though the patient has the normal, the positive finding on NCV, I have treated many patients that, so there is the additional tool, but it's not the mandatory, I believe.
Dr. Arvind?
Yeah. So I would like to add two things. So number one, we do not usually get the oblique MRIs. So what we do is we get hold of the CDs of these MRIs. Instead of looking at the films, if you look through the CDs yourself, I think you are much wiser. Sometimes you make better decisions as compared to the simple films. Number two, once this patient is there 6 months, he's ready for some interventional treatment. I wouldn't go ahead without a objective test like a NCV. NCV has to be there. Tomorrow, there can be so many things, and I think I would always like a NCV before a young patient. Yeah, for
your diagnosis.
Support the diagnosis.
As a medical legal tool.
Yeah, also that tool. That it would be helpful there also.
Do we have Dr. Sura with us now? Dr. Sukumar? Still not there? Okay. So now that we have arrived at a diagnosis of a C5-6 radiculopathy, and the patient has already tried conservative medical treatment, as I informed you. So do any one of us here believe that we still have some scope of a conservative trial further than what has been done? If yes, then what kind of conservative trial would you want to do for such a patient?
So I don't know what conservative, where it finishes and where the interventional treatment is starting, but I would, definitely consider a block for this patient and see if
as I'm moving to, because we are jumping the conservative right now. We are holding short of block because block comes under the domain of intervention.
Sure. So
I
would move on to block.
Now, I already told that it has been treated by experienced specialists in the town, and we trust each of us that okay, you have done enough for that patient to try and give a conservative trial, avoiding a surgical treatment for such a patient. So it has not helped. So at this juncture, you would not wish that you would want further conservative medical treatment, rehabilitation, etc. The patient is already fed up of all those things and says that I want the active treatment. So we start thinking that it is a case of intervention. Let's say if this is an intervention, this comes where you were wanting to, that would you want to do a nerve root block or a cervical epidural at this juncture as a diagnostic tool or as a intent to treat?
You want me to answer that?
Arvind, take it first and then sorry. Ankur. Sorry.
Okay. So here we have a situation where we have multiple dermatomal pain. It's C5, C6, and C7 as well. And we know that, in cervical spine, the dermatomes are really not very, very specific. Exactly. There's a lot of jump here and there. There's a lot of overlap. And these nerve root blocks, I would then start thinking more in terms of a cervical epidural here. And try to cover, because these dyes, they will travel very quickly up and down, and the medicine does travel. So I would be actually comfortable with a cervical epidural single shot rather than doing a multiple root blocks here. Yeah, that's what my thought would be at this point of time.
When you do cervical nerve root blocks, do you do it under CT scan guidance or do you do under fluoroscopy if you have to?
So to be honest, I've been doing epidurals, but not specific nerve root block. I asked my pain guy to do it, and they are able to do it in under C-arm. They're not doing it in CT. Yeah.
Arvind.
So cervical epidurals I would reserve for a more elderly kind of person. For this young patient, if we don't routinely go for blocks or epidural. So epidural I have reserved only for patients who are old, and I think then they do not need an intervention. So then I will tell my interventionist to do a epidural. But nerve block, really, I don't believe in it, and I haven't used it. Yeah.
Not even for having, when there is a diagnosis doubt that
diagnosis doubt, NCV is fairly correct.
Pretty happy with your NCV reportings.
So even in nerve block, I don't know if it is 100% thing.
Right.
So I don't believe
if I can just come in here, actually I have this same amount of distrust on NCV because all the reports which come to me, they come as
I second you on the
polyradiculopathy. It's
so
either
maybe
sensory
we talk.
motor polyradiculopathy. So I don't know what to make of it.
So we
I
have a
like
good
huge
neurologist, so we can talk to him. I don't know.
You are
It
lucky.
is
Dr.
just-
Kim,
You are lucky.
if you had to treat this with this block, what kind of block would you prefer, Dr. Kim?
Yeah, I don't have the enough experience about the epidural block and root block, selective nerve root block. So it's not the surgeon's job, but the pain doctor usually prefer the epidural block. This is going to be more safer than the selective nerve root block. I think the epidural nerve root block itself cannot doesn't have the evidence for the root where the pain generator here comes from. So I think from my side currently at the moment I prefer the safer epidural nerve block than the selective nerve root block.
Does the presence of neck pain associated with the radicular pain help you choose between a selective nerve root block, whether to send the patient to pain management for a nerve root block alone for radiculopathy, or because the patient has an element of neck pain, so cervical epidural is going to be more useful to that patient?
It's not the obvious, I think, because the foraminal stenosis itself, it makes the radiating pain, but also the report pain and neck pain as well. So neck pain, axial component pain itself cannot be a pure evidence for the instability.
Right. So that brings a very great point. We'll reveal it later once how the patient was managed. That the just point that you managed, that many times the foraminal stenosis causing radicular pain can also add to referred pain, which could be mimicking the axial neck pain. So one may not need to choose the decision making just for neck pain only on that point. Now, if we agree that this patient requires surgery, now I'll share because I have treated this. So I discussed all these options. So he asked that what are the chances of the cervical block or the epidural going to help me and for what duration? So I said it is unpredictable. It may not help, or it may help for a few months to a couple of years. He said that I'm not willing to go for that kind of a odds ratio where either it's not even for a couple of days that treatment is going to help me, or it goes to 2 years. So he said that, is there any surgical treatment? So now we come to that part that the patient is asking for a solution for which he has tried whatever else, and short of a surgical treatment, we had option of blocks, which he's kind of rejecting. So if surgery is to be done, what is the surgery? First, before we go ahead, are we agreeing that now this patient does require a surgery? All the three panelists? Are we convinced? Are we sure that, okay, we'll go ahead and take him up?
Yeah, I mean, if clinical signs and symptoms are matching what we are looking at and all the investigations.
They are there in front of you. The MRI is there, the CT is there, the patient symptoms are there in front of you. So they are kind of matching that the patient has this dermatomal pattern, which is resistant, which is confirmed by the imaging methodology as well.
Yeah, I think if there is a good clinical correlation, then I think yes.
Based on whatever information we have, it is a go ahead for surgery. Arvind.
Yeah, so I think we'll give the option. 6 months he has already had conservative treatment. So now it has to be the patient's call, rather than the doctor's call. Doctors have been treating him for 6 months. Now the patient wants to do actively something. It has to be from him. He wants the surgery, because you cannot 100% say that this surgery is going to help him. There are so many factors involved in that. So if he is interested and he wants that surgery, we are ready to offer him.
Dr. Kim?
So yeah, I think Of course, we need to start with the conservative treatment first prior to decision any kind of the surgery, because the foraminal stenosis, is truly we know the direction of the treatment effect. I have the immense experience of the medication itself on the severe the foraminal stenosis. So anti-conversion, NSAID, and kind of the medication itself, it works well many times. So because that is the radiculopathy in the little bit young age, so I usually recommend surgery. Patient wants surgery, right?
True. So if it is surgery, then what are the types of surgery? Are we going at 1 or 2 level?
I think
you've
this
already
patient.
Answered that. Yeah, you have already answered that. If it is you are doubtful, then you would rather go 2 than 1. Arvind, would you agree with that? 2
So,
level?
it is not very clear. I am not convinced about the second level. First stenosis was more marked compared to the second stenosis. So, and the neurology also is corresponding, shoulder pain and radiation. So I would go for a single level.
Single level. Arvind? Ankur?
Yeah, I think I would agree with Dr. Kim here. If I'm not sure, then prefer to go to 2 levels. But to be honest, it's very difficult to actually really look at these cases just on the PowerPoint and make these decisions. But yes, to err on the safer side, maybe 2 levels. Yeah,
I'll second that. So now coming to the hardcore surgical options, what is the one option that we would choose in our hands, and based on what rationale? Ankur, you have to unmute yourself. Yeah.
So my choice would be more anterior. The rationale may be more practical rather than theoretical. My training is more from the anterior to address these issues. I think I'll be able to effectively take care of the osteophytes more. Even though I am aware that this may be, treated by posterior foraminectomies here, but my experience with the anterior side is more. And I think the axial neck pain levels and everything, I'm more comfortable with them. So maybe an anterior approach would sort of be my approach.
So in anterior, would you be wanting to instrument, fuse, or replace?
So I think we'll need to see the levels more clearly, but the way I see, there are a lot of osteophytes. He has a tendency of arthritic joints already. I may think of a 2-level ACDF here.
So you would rather shy away from offering him a total disc replacement in this case?
So I would like to actually assess the other joints properly. How much is the degeneration in the above and the lower disc? What are we looking at overall degenerated status of the spine? And then take a call on this. But as of now, the way I thought it was an ACDF case. Yeah.
Would the requirement of the patient that he wants to continue pursuing his active sporting lifestyle have any bearing on your decision making?
So I did read what you had written, but I don't know what is active sporting lifestyle. See, if he's an athlete,
he actively plays tennis, he actively goes for runs, he can actively participates in some other sporting activities, group sporting activities, and he wants to continue. That is his lifestyle.
Yeah. So I think
whether these things matter or not, that is the only thing.
No, they matter. They matter definitely, and we want to preserve the motion for people. Our experience with arthroplasty, disc arthroplasties is not really huge. We have been operating very few cervical discs because we have seen they with conservative treatment, they go on to do very well. But having said that, we have been mostly restricting ourselves to single level TDRs. So I may consider a hybrid construct here, depending upon how the facet joints are.
Right.
Yeah.
That's very fair. Arvind?
So
you already said you'll choose only one level. So now when you're choosing one level, would it be fusion or a replacement?
So anterior, and I would talk at 45 years, I have to talk about replacement with the guy. So if he's understanding that 2 to 3 years he can have, before going again for fusion, which is the standard in all these replacement discs, and he understands it, I might go for a replacement. There's no big deal. Replacement or fusion, ultimately it has to fuse. So why not give him few years of good sporting life? That is what our data says. And if he is agreeing to it, I wouldn't hesitate from giving him that. You know,
So
who
you
am
choose
Shah Rukh Khan got it, so who am I to refuse him? You know.
Dr. Kim, what would be your choice of a procedure, anterior, posterior, and what, if yes, then what, why it is?
So, do we have the X-ray?
Unfortunately, I told you the X-ray we could not bring to the presentation today.
So, a little bit kyphotic?
No, it is not kyphotic.
Not
it is a
kyphotic?
normal lordotic
Okay.
X-ray.
Okay. I have seen the city patient already have a little bit the general disc height already collapsed at the 2 level, 5,
Right.
6, and 6, 7. So not only focal foraminal cells in right side, and generally the disc height discation already done. So first, the patient have the right side symptoms at both level. Probably, I think that both 2 level may have the contribute some sort of the radiating pain or referred pain, etc. So that is one of the good indication of the posterior decompression alone surgery, regardless endoscope or the tubular, the others, you know, the standard technique, it doesn't matter. So I think the one issue is that when I have thought between anterior and posterior, I have thought on patient age and patient activity and the patient or attitude about the future event. If patient have the serious concern of any reoperation at the same level, that is the good evidence for the anterior cervical discectomy fusion surgery. But this specific patient, a little bit patient less than 50 and young generation, the highly active patient, regardless of little bit reoperation rate following the posterior foraminotomy, I believe the junctional problem related the fusion or the other kind of the surgery in later than 5 years or 10 years, I think the index level reoperation might be better than the surgery for junctional problem. Just imagine the bad scenario after 2 level ACDF, because of highly active and there is a little bit the high risk of the wrist stenosis, junctional level stenosis, 4, 5, or 71. That is the CD junction. It's a little bit more difficult situation, and probably 10 years and 15 years later, right? So we need to.
Yes, yes. So I'll add one more piece of information which is interesting. Now, this is a very highly high-placed official in a software company, and he's very well read, very acknowledgeable. He's read all about ACDF. He understands that ACDF can cause adjacent level problem. Total disc replacement also can lead to issues, etc. So he comes with a specific requirement, as you correctly said, that I am not keen to go in for a fusion surgery just because fusion is being offered to me as the final solution, because that can add problems. So again, it brings you the same question that you already answered, that it is preferable to reoperate at the index level rather than doing a repeat surgery at a new level.
Excuse me, Dr. Bharat, just 5 minutes to the session.
Yeah, we're just about to finish. So, any role of anterior transcorporeal foraminotomy? Anybody who is
so
I can see Dr. Deshpande on the screen, and he has some experience. Would you choose such a case for this procedure, sir?
Thanks for inviting me. I was thinking of joining and telling. Now, recently, we have explored that option, and even earlier, of doing oncovertebral decompression for the foramina, anterior approach. and they do very well. You don't have to fuse, you don't have to do a posterior laminectomy. Their activity remains very good. You're just decompressing only the foramina at 1 or 2 levels on either side, and the patients do very well. Their activity levels after 3 or 4 weeks of recovery return to normal, and they do very well. I think this will be a measure for middle-aged or young patients who can wait till 50 or 60 years of age and see what happens to their cervical spine a little later, 5, 10, 15 years later. So for purely foraminal stenosis, especially bony, uncovertebral, something like a Joe procedure will be an excellent at 1 or 2 levels.
Yeah, I tend to agree because I've done a few of them myself, transcorporeal. So they are very targeted kind of decompressions. Dr. Kim, I think you also have some experience of transcorporeal decompressions.
But the indication of transcorporeal approach is a little bit the disc hernia, a little bit the unmigrated at the foraminal zone, not the bony spur.
Not the bony spur.
Yeah.
Okay.
So the same thing, yeah. So I wanted to say the anterior jaws procedure, you have to have a disc, material, because bony spur, it will be, or a calcified, it will be very difficult to handle with such a small opening.
But if you keep drilling along the hole, then you can actually reach right up to the uncinate process, as Dr. Deshpande said, and I have also done a few. That there is no need to.
There are so many spurs, I don't know, you might be able to achieve it if it is, very small and localized. Yeah.
Right. So in this case, being of similar philosophy as Dr. Kim said, that I personally treated him with a 2-level full endoscopic posterior foraminotomy. And the idea was, this was all discussed. Actually, he had come to me seeking this treatment. He had read all about it and said that I have been sent to you for specifically looking at whether this can help or not. So we did all that discussion and said that this is a 2-level disease, and if we have to treat, we'll do both the levels, because as Dr. Kim said, if there is any doubt, it is better to go safe and do 2 levels rather than 1. And he understood that it may help or it may not help, but this is a 1 step which is short of ACDF, and I want to take it. Thankfully, I'll just skip this video rather than come to the post-op. So we can see that we widened the foramina posteriorly at both the levels, and he's done reasonably well. It's been about 8 weeks now post-op, and his numbness, symptoms, neck pain also. That is why I mentioned that point that I'll tell you later, that what Dr. Kim said, that the foraminal stenosis, besides causing radicular pain, can lead to axial presentation of a axial neck pain, which is actually a referred pain, which has improved, which is beyond our own expectation. So that kind of sums up this case. Anybody else would want to add on to anything in this particular situation?
You can show the video, Arun.
Oh, that is only a representative video. If you want, this is only a representative video of a full endoscopic discectomy, just 1 minute. So this is how the full endoscopic posterior foraminotomy is done. Though this case is for a disc herniation, I couldn't get the time to edit the 2 videos for that particular patient. So we expose the lamina above and below and start drilling the undersurface of the lamina first, and then keep on moving towards the medial border of the facets, thus widening the foramen. So once you have drilled the facet, then you go to the inferior lamina. Superior edge of the inferior lamina is drilled, and one can see the attachment of the ligamentum flavum, which is gradually detached from the undersurface of the lamina using the endoscopic Carrison punch. So once you create this opening and start visualizing the epidural structures, you can see the lateral edge of the spinal cord, and one can start seeing the disc herniation, which is pushing the spinal cord. We have to expose the exiting nerve root first. So we can see the exposed exiting nerve root, which is tented by the hernia. For stenosis, we have to drill a little more laterally because we have to widen the foramen. So in this case, we stopped because the disc herniation was paracentral and a little bit into the foramen. So once you remove, you can see the fully decompressed nerve root and you search for any residual fragments. And then you remove and you can see the fully decompressed nerve root along its length. And this is the post-operative MRI. Now, when I'll just add a small point that when you have to treat the foraminal stenosis, we have to drill more laterally, and in cervical spine, more lateral also means a little more anterior where the vertebral arteries are lying. So one has to be a little careful in choosing this approach while drilling the facets. As you go more anteriorly, you have to safeguard the vertebral artery. Dr. Kim, your expert comments on this?
Oh, no, you have the great job. Yeah.
Okay. So then we agree that the posterior foraminotomy, by, as you already said, by Distandu or microscopy or tube or full endoscopy, whatever one is conversant with, can do reasonably well without needing to put any implant in this case, to allow him have his normal lifestyle, whatever he wants. The other option to have that thing is anterior transcorporeal or Joe's procedure. And then the third one is the total disc replacement. And of course, the ACDF remains our fallback procedure for all such patients. With that, I think we can conclude the session. Arvind?
Yeah.
Yeah, thank you.
Well said. Yeah, nicely done. Thank you.
So I'll stop sharing my screen.
Great case, Bhanot. Thanks.
Yeah, thank you so much, Dr. Arun Bhanot and the panelists. Excellent discussion, excellent video. So we move on to the last session, which is C56 central disc herniation causing myelopathy. And I invite moderator, Dr. Sanjay Rajan. Please, Dr. Rajan.
And the panelists
very good evening, everyone. Hello, am I audible?
Yes.
Yeah, very much. A very good evening, everyone. A very warm welcome to all the panelists as well. Dr. Chavda, Dr. Sunavane, Dr. Manoj Sharma, and Dr. Dheeraj, and Dr. Rakesh. We have a nice mix of faculty in terms of having 2 orthopedic surgeons and 2 neurosurgeons, and also Dr. Chavda is well versed and well popular for doing Sandu techniques in both cervical and lumbar. And Dr. Manoj Sharma is an endoscopic surgeon. And Dheeraj is obviously largely a conventional surgeon, but we have Rakesh, who does a lot of endotubular work. So we should have an interesting discussion. Even though the indications for doing all the MIS in myelopathy is still controversial, we do have some advances taking place in that direction. We'll cover them as well. So I'll start with the index case. And because the case that was given to me was for cervical C5, C6 PIVD with a myelopathy, compressive myelopathy. This is the patient who's a 40 years old male with neck pain of 3 months and arm pain and difficulty in walking off for 1 month. And he also had imbalance and tendency to fall over uneven surfaces with numbness and tingling on all 4 limbs, cotton wool sensation, typically all that you expect with a myelopathy, and constipation for 3 weeks. And on examination, he had grossly lowered power, 3/5 bilateral lower limbs. There was hypertonia, there was hyperreflexia. His X-ray did not reveal any major instability or any osteophytes, or a relatively young guy, so we didn't see any displacement and things like that. A relatively clean-looking X-ray and without dynamic instability and without any kyphosis as well. This is the MRI, which is showing a significant large disc prolapse. It seems like an acute disc prolapse. Not so sure that it's an osteophyte or it's calcification from the MRI. It doesn't look like. And there's a significant cord edema causing compressive damage to the spinal cord. And compressive myelopathic clinical features are already in front of us. Any first thoughts from anybody? Dr. Chavda, sir? I can't see. I'm not so sure whether he's joined us. Dr. Sharma? Dr. Manoj Sharma?
Yeah, hi.
What do you see what do you think of when you first see such a case?
And this is fine what you're speaking about. This axial cuts, can I see the place?
Yeah, sure. So these are the T1 images, and this is STIR, and these are the axial cuts.
Okay, so axial cut, I can see that it is a left-sided disc actually, and I mean it is starting from the center and going towards the left foramina. And now, you know, what just Banot speak about, that was about the foraminal disc. But if the disc is central, then tackling it with, I mean, any tube or anything is a little tough ask. So in this kind of cases, we have to go from the front. And obvious option would be ACDF or a disc arthroplasty.
Right. So if I can ask Dr. Rakesh, just a small twist. Now, this patient has a power of 3/5. Now, with such an MRI, if he is 5/5 is intact, is there any role of conservative treatment?
I would be wary of conservative treatment here. Such a significant herniation, such profound signal change, even though he has power of fully functional, I would offer surgery. In a case
we have cases where you can have a complete resorption of the disc, prolapsed disc, right? So on conservative treatment. So is that an absolute no-no, or you feel that there's a possibility that it may, because a young patient without any osteophytes, the disc prolapse may eventually get degenerated and absorbed?
Maybe
is that a possibility?
Disc, gradual symptoms, maybe yes, but in a MRI like this, you know, once patient develop myelopathy, the game completely changes. I would prefer to intervene early rather than wait.
Right. Fine. That's clear then. Has Dr. Chhabra joined us?
He's joining.
Okay, right, fine. And Dheeraj?
Yeah, I am here.
Yeah, hi Dheeraj. Any first thoughts? What are your opinion? Any contradictions?
No, right now I can see a severe cord compression, almost grade 4 cord compression with cord edema as well. With non-functional power in lower limbs, which is grade 3. I will like to intervene immediately.
Right, fine. So before intervention, what else would you want to get done? Any role of CT scan in this patient? And EMG NCD? I mean, just to cover the points for the juniors, for the students who probably attending as fresh pass outs.
Yeah.
Any role of all?
Is this question to me?
Yes, why not? Go ahead, please.
Yeah. So any role of conservative for me, it's no. We can we have a clinical assessment of the neurology, which is not having a functional power, and cord edema and compression suggestive of the same. So we don't have a role of conservative treatment in this patient. Role of EMG NCV only in cases where I have a doubt. Otherwise, most of the time I find it more confusing rather. So I won't go for EMG NCA studies. For CT scan, this looks like a soft disc, so I won't like to go for a CT.
Okay. Anybody else with a differing opinion?
Yeah, CT only if you are planning disc replacement, then maybe yes. Otherwise, just no other investigation needed.
Okay, fine. So the next question is, we have now decided to go for surgery, and it seems we're still not clear, or are we on a consensus regarding what approach?
Yeah, you're connected. Okay, thanks.
I'm not able to understand.
Dr. Chhabra has joined.
Okay, perfect.
Sorry, I was sitting here.
Dr. Chhabra, I'll run you through the case. It's a very straightforward case, something that you deal with on a regular basis. A young patient with neck pain of 3 months, difficulty in walking for a month, grossly diminished power in the lower limbs, 3/5, C5, C6, massive prolapsed disc causing cord compression and left-sided nerve root compression. So we are all clear that this patient requires some intervention because of the power. There's no role of conservative treatment. And in terms of investigations, we have decided that CT scan will be required only if we are considering cervical disc replacement. Otherwise, we are going ahead without the CT scan. So any role of NCV EMG, does it serve any purpose? Do you think it might help you to decide maybe whether the patient requires neuromonitoring, will work on intraoperatively, things like that?
I think in clinical practice, I think clinically the case is very clear. So personally, I don't think it is required.
Right.
Go ahead with the SDF. Yeah.
So any input from your side with regard to neuromonitoring? Is it mandatory? How many of the faculty is actually using it for such cases? And what is the experience? At what power level below that it is of no use, because sometimes your technician will come and tell you that even if the power is 3, the signals is 0. They're not able to appreciate any signals on the screen. So
Yes, I think this is a good case for neuro monitoring. Even if they don't pick up the signals, so many times they pick up one or the other muscle in a lesser frequency. Also, the SSCPs are intact mostly in such cases, which also guides us. So I will like to use a neuro monitoring in this case.
Right. So
Yeah,
how
same
many
here. I would use a neuro
in the
monitoring.
faculty, maybe Arvind, you can also join in, have found neuro monitoring misguiding them in such cases?
Yeah, this is a straightforward case of myelopathy. I beg to differ with Dheeraj. Many a times, the posterior column is affected indirectly by anterior compression. So you may not actually get signals. So it probably gives a false sense of either being very positive or being in despair.
Right. I agree with you that the feeling of despair is really depressing, because sometimes you tend to feel that the positioning of the patient has made things worse. You see, sometimes that's how things, how misleading it can be. With regard to positioning, any input, Dr. Sharma? Any things you need to take care of from junior students' perspective?
Regarding just now, as I just heard, clinically, you have to corroborate with the MR findings. And I've seen that NCB has never helped me. As an orthopedic surgeon, hardly ever ask for it. So at least in this kind of case, or even otherwise, I would like to correlate the case clinically with the MR finding, and that should be enough. Regarding the anterior, the patient has to lie supine with a little bit of extension, say about 15 degrees, so that you open up the spaces. The first thing I do is that I do the marking. Although anatomically we know where we are, but I just put in a needle and I do the marking with the CM, just to be where
Right.
exactly.
So we are all clear. Am I right that we are all clear on the approach? We are going to go anteriorly.
Yes. Yeah, of course, it's me in this case. Because central disc, you cannot go from back.
Yes.
Unless you have got about 3 or 4 of them, and then, of course,
you do a laminectomy or laminoplasty, right? Okay. Regarding right or left, it's I'm picking this question basically because of resident level people, students. So which one do you prefer and why?
Me,
Dr.
right.
Manoj, yes. Dr. Manoj, which one do you prefer and why?
The right-handed doctor, surgeon would prefer to go it from the right side. I have never done any case. I've done hundreds, but I have never done any from the left-hand side. So I would prefer, I am very happy, safe, and very easy in doing it on the right side. And the recurrent also, they say, is more safe from, I think they say it's more safe on the left.
For the side concerned, any side I think shall be do the job enough. If that was a more foraminal disc, I would go from the opposite side. So that is how I decide the side.
Fine.
In this case, since it's the central, any side is okay.
No, even from side, you can look on either side.
Right. Another thing which probably Dr. Chabra might want to point out is about the rectal engine, of course. So normally it is said that if it's a low disc at C6, C7 level, the rectal engine nerve is going to be coming more on the way. So there's more chance of injuring that. So in that case, we go for the left-sided approach. That is what I do in my practice as well. So for a C6, C7 or C7, D1, if it is accessible, I go from left side. And if it's 5, 6 and above, I go from right side. I'm more comfortable on the right side. Any thoughts? Has anybody else also changed their decision based on this?
You're right, Rajan.
A critical concern.
You're right, Rajan. I would also go from left side for the C7, D1 level. But up to C6, 7 level, I am more comfortable approaching from the right side, being a right-handed surgeon.
Right. Any other thoughts?
Yeah, initially I was doing it lower one on the left, but for last 8-9 years, I'm doing all from right, and I have not found any difference. So
wonderful. Yeah, that's very important. So
even for sorry to interrupt. Even for the C6, 7, D1 level from the right side.
Let me tell you don't have to dissect right down till the clavicle. You know, you just have to pull it down. So in that case, even if you're, how many cases? I mean, I have hardly any, nerve injury we have seen, hardly any. In hundreds, maybe one. And that too was transient. So, I mean, by my experience, I'm happy with right. But yes, theoretically, if you want to say that the nerve comes low on the left-hand side, so you would like to go from the left, then it's fine. But I have never seen.
Practically, it will not make much difference according to you, especially if you experience.
Can I come in?
Yes, please.
Yes, yeah, so this is a very interesting topic, always discuss, no end point, but I'll tell you something. I've always used right side. I've used only left when the right side cannot be done because of previous surgery. Somebody had cancer, thyroid, stuff like that, or some massive dissections. I will try to go on the left, but take it from me, it's always on the right at all levels. My colleague in my hospital, he's a neurosurgeon too, Satish. He has been doing it 20 plus years, 25 years, always on the left. So you can discuss this and say, I am a left-sided guy, I'm a right-sided guy. I don't know. I think ultimately, as long as you use certain protocol regarding careful dissection, being in the planes, checking the pressure in the endotracheal tube, cuff pressures, etc., your chances of having laryngeal nerve injury has lessened significantly.
Right. So going to the next point.
I think you're comfortable with the right. Going from the left will be a different, I mean, the whole scenario changes. Orientation becomes difficult and it is reversed. So you will find it a little difficult.
Okay, fine. So next point, are there people still who think of simple discectomy in the panel, or are everybody going to go for fusion or replacement?
For me,
of course,
I never do only discectomy, always fuse or replacement if you think.
Standard ACDF with a standalone cage and screw.
Right.
If you do not fuse, you will have the neck pain and you will have the flexion deformity of the cervical spine. So we have to fuse and give a sagittal balance.
Right. Okay, fine. So in terms of displacement, what about there's a controversy regarding displacement, cervical displacement in patients with CSM. So is it only indicated in patients with radiculopathy, or is it safe enough to be done in patients with myelopathy?
Oh, the myelopathy is the same.
Dr. Manoj.
Yes. The main thing in the myelopathy
Dr.
is
Chawla,
that
what do you say?
Once, what, I'm sorry?
Carry on. Yeah, please carry on, Dr. Sharma.
The decompression once has been done.
Yeah, carry on, please.
The choice, you want to put a cage or fuse, or you want to put in artificial disc. So if the patient is young, say younger than 40, and degen changes have not occurred, then you would like to give him some motion for some time. Although they say that even arthroplasty will fuse over 4 or 5 years. But yes, that period of time he will have. So I think if the patient is younger and there are no osteophytes and his spine looks quite young, so I would put in a disc. Otherwise, I will put in a standalone cage and fuse.
And Dr. Chawla, you wanted to say something with regard to CDR in myelopathy patients?
Well, I would prefer ACDF rather than CDR in all myelopathy cases.
Any specific reasons?
Yeah, especially because these patients are generally 45 years. This patient is 45-year-old, you said?
Yes, yes.
And well, I have limited experience with CDR. So I personally would like to go for ACDR.
Dr. Alok is also here. Can we have his opinion?
I think if the disc height compared to above and below is significantly less at the level of surgery, index level, and if the disc prolapse is also associated with osteophyte, then CDR is going to be a costly disc replacement is going to be a costly fusion. Other than that, you can give it.
Thank you very much. So basically the point
Rajan, sorry, I have to intervene again. I need to add one point here.
Please, please.
I had some experience with CDR in myelopathy. I did as a much younger surgeon, 10, 12, 15 years ago. And I found that, if I'm not mistaken, of the 5 myelopathy patients I did, 2 patients who had CDR actually worsened. I personally feel myelopathic patients do not tolerate excessive movement or whatever the movement that happens following the disc replacement at that level to be good. So I have stopped doing CDR for myelopathy because of my bad experience.
All right. Thank you. That's a very, very valid point.
One important point, Dr. Rajan.
Yes, please.
Myelopathy from a soft disc is very different from myelopathy from chronic.
Yes, that's what I
think you must differentiate. There are 2 different things. Okay.
You know, the quality of the disc in the, I think it is simple that in the myelopathy, the disc is central, and in the radiculopathy, it is the lateral disc, but the disc is same. So once you have removed the disc in the younger patient, why not, I mean, give him some motion. So myelopathy, it cannot be a different game. I mean, anyway, but if you might have thought, I mean, you might have experienced that way. But what I feel is that once you have nicely decompressed, then it's your choice.
Fine. So we have still no consensus on that. In fact, even in literature, there is no consensus regarding this. The initial studies for cervical disc replacement discouraged it to be used in patients with myelopathy, but ultimately it was open to all patients with myelopathy as well. And there have not been any major dramatic issues with using cervical disc replacement in myelopathy. But again, everybody has their own experience. So going to the next point, how much time do we have, Dr. Arvind? I don't have the watch in front of me, unfortunately. We have about 5-7 minutes?
10 minutes.
Yeah, almost 5 minutes.
Oh, perfect. Perfect. It's fine. So the end point of decompression, how many would like to open the PLL? How many will do the unstenotomy in this patient? Dr. Chabra?
Well, I would like to open the PLL in almost all my cases.
And suppose you're able to remove the disc completely without seeing a breach in the PLL, you still go and open it?
Well, if I see really there is no breach, I'm very sure, then of course I might not. But in most of the cases, I try to open and see the dura. I'm more comfortable with that.
Right. Dr. Rakesh?
Yeah, I always open PLL.
Dr.
Yeah, same for me, always open the PLL. And also I will like to check the foramen decompression, even though it might not be there, I will still like to decompress it. Yeah.
Very, very, very important points. So opening PLL is important because sometimes you may have fragments there. Passing a probe through the foramen to remove any fragments, especially in this patient, for example, this is a left-sided disc prolapse. Unstenotomy, your opinion, Dr. Sharma, for unstenotomy, the unstenotic excision?
If it is a lateral disc or if it's a foraminal disc, then it's fine. In the central, you do not need it. I mean, but yes, like you have said, you know, I would like to see the dura. The PLL, I mean, I'm not happy with the PLL. I would like to remove it and I would like to see a pulsating dura. That is a very important thing here. And uncinate process is pretty lateral. These are central discs. So why should I go so lateral?
No, the index case is a very lateral disc as well. But I understand.
No, in this case, fine, I don't have to remove that and destabilize the spine. And it's because then you might go a little more lateral and you can even pinch the vertebral artery. In this case, I mean, generally I have seen that a little bit of bite is okay, but not more.
Right. Fine. So how do we tackle the osteophytes and venous bleeding? This is an important point for those who are not frequently doing cervical spine. I would like a few points of consideration from each one of you.
Yeah, so for osteophytes, I usually use small curettes and at times fine drill. And venous bleeding is usually not a concern. You can use an Abgel, or if you're using a distractor, just relieve the distractor and it stops. So usually it stops on its own. Just put a gel foam and pack. Make sure that you are not pushing the cord.
Rakesh, that's a very controversial point. Using Abgel, but then you're not supposed to leave it behind.
No, just take it out later on. No, take it out once the bleeding stops. That's
right. And how many of you actually use things like Flow Seal and glues for whatever challenges you face in anterior cervical?
Yeah, I'd keep it on the table ready. If it's going out of control, not getting control with the gel foam and patty and compression with these things. If it's still not working, then I use that. Otherwise, I try to preserve this because that's expensive for us.
Fine. Thank you. And I think that's it. There is not anything else, Doctor.
Dr. Rajan, why
For the
not?
osteophytes, I would like to add one more thing. I try to bury it out the osteophyte till I get the soft spot, yeah. So this is my routine. So and for the bleeding part, I just move from the central to lateral and try to be closer to the bone. So that's another trick which usually help me in especially in foramen decompression. I try to be more anterior.
So the endoscopy guys would say, shame on you. You know, you use implants, you increase the cost.
I was going to come to the
drama
same
out
point.
of it. They would just do a discectomy. You ask the Descendo guys, endoscopy guys, how they would manage this.
So I was just thinking, come to the same thing. What is the role of MIS in such a case?
Endoscopic anterior endoscopy we had started long back, but that is only 4 mm in size, and it was very small in size, and it was very tough to remove the osteophytes along with that because the burr was very small and the vision was not so good. So and really we've stopped using that. That was
but Dr. Sharma, there's young blood now they're waiting to pounce on this case. Ajay.
But you see, this is a very large disc herniation. Here, simple discectomy won't help because you will have to fuse it.
Yes. So
agree, endoscopy guys.
Anybody wants to pitch in? Anybody from the faculty? You can unmute yourself.
No, we have done a couple of cases, but now anteriorly we don't have much at the moment because it's not very safe.
Yeah, for myelopathy, Arun here, Sanjay, for myelopathy,
yes, Arun, please.
Usually I do not choose endoscopy here. So Arvind can feel very happy about it that endoscopy guys also always don't want to use endoscope.
In the cervical.
Dr. PC Day.
So we'll briefly review that literature. Meanwhile, I'll just finish off with this case. This is what we did. We decided to go for fusion because there was myelopathy, and as a routine, we avoid using cervical displacement in myelopathy patients. This also there was a lot of you can say laxity in the disc space, so we had to use a large cage, even though it looks much larger than adjacent segments. But somehow all the other cages were much were coming loose because of laxity of ligaments. So we decided to use that. This is the post-op MRI, pre and post. So I'll just, Doctor, I don't have a video of this. Dr. Manoj Sharma has a video. He would like to describe this. Should I be playing, Dr. Manoj? You can take over.
Oh, yeah, of course I can do, but that's a little long, so you'll have to cut it short.
No, it's quite short. Go ahead. It's just a few seconds.
Okay. So, you see a disc over here at C56, as you can see, and it is central disc, or actually on the right-hand side, the patient has got pain in the right upper limb, and he had difficulty in walking as well. And he's, again, a young guy, about 40 years of age. And we decided to do a ACDFNM using a standard cage. So the first thing was that we used a needle for the marking. And now this is the latissimus we take off after injecting some xylocaine just to separate that from the skin. After that, as you know, we have to go in through the fascia, dissecting it right up to the up to the disc. And I mean, the best thing here is that your fingers are the best instrument. You can just give a nick in the fascia, and then you use your finger and you go straight medial down right up to the disc. And then you can retract the complete thing, and you are docked straight away on the disc. And longus coli will tell you that what is the central part of the disc. So, I mean, they just, they are very, very prominent, and you know where you are. So the first thing is that, the first thing what we do is, again, we bend in needle and we put inside the disc and we check again on the C-amp the level, because that's an important thing. And then we cut the disc and we remove it, go right back up to the osteophytes. And then first we drill it with a cutting burr. And then as we are close to the dura, we use a diamond burr. And now here you see that this standalone cage has been put. Now, let me tell you that you don't have to over distract, because generally the size of the disc is about 6 or 7 at the most. But if you distract, you can even put up to 8 or 9 size. So, that will put a lot of stress. So,
Dr. Manoj, the video has ended. So I think everybody's had a look. I'll just run through the literature. So regarding endoscopy and MIS. So far, most of the literature on endoscopy and MIS has been for cervical discs, for a disc prolapse causing radiculopathy, which is like lateral disc, either anterior or posterior approach. But a posterior approach by simple endoscopy is being discussed in the chatbot, has been described a long time ago. This also for myelopathy I'm talking about now, not just radiculopathy. So there's a partial laminectomy. Pardon me? Achha, sorry, I thought Arvind? I think he's on call.
I think it was accident.
That's all right. So I was talking about cervical endoscopy for compressive myelopathy. It has been described as far back as 2005. However, it's not picked up very strongly. It just involves cervical laminectomy, which is usually one-sided laminectomy, and then they do the over-the-top decompression of the opposite side. And for compressive myelopathy, they've also described a couple of interesting approaches. One of them is a transpedicular approach, where they burn the pedicle and then they're able to reach from behind. It starts from behind. It's a posterior approach and then it goes anteriorly. It's a very oblique approach to the anterior part of the spinal cord, anterior part of the spinal canal. There's also one which, okay, fine. This shows drilling of half to 2/3 of the middle water pedicle under endoscopy. There's also another study which also is it's also from China. It's talking about complete endoscopic approach to cervical myelopathy, but here it is anterior. So again, they've also shown good results. They compared it with the ACDF and said that it's better than ACDF. This is Dr. Yadav. We're talking about him right now. So he's described the approach of full endoscopic corpectomy, partial corpectomy, to decompress the spinal cord at the central level. So this is a post-op CT scan which shows how you can say corporeal, or you can say corpectomy approach to doing a decompression at the level of the vertebral bodies. But this, I think, is more for multi-level myelopathy, or for myelopathy which is anterior to the body, not just a simple PIVD. Regarding MIS, the first approach was described way back by Fessler in 2007, which he again said was okay for myelopathy. And this is a newer article which is showing pre and post posterior MIS approach using tubes, either a quadrant or a 22 millimeter or 18 millimeter tubes. They've also described a facetal fusion in patients with instability where they don't want to go anteriorly. It's all done by tubes under navigation. So laminoplasty has also been described for myelopathy. It's obviously more applicable in patients with multi-level problem rather than a single-level problem. We have one case, even though it's not a typical myelopathy at single level. This is a 3-level disc disease with cord compression, compressive myelopathy. This patient had a normal X-rays. So we decided to go for a endoportal laminoplasty. So 2 incisions were given, one on the right side, one on the left. The right side was used to make the small cuts into the bone to allow for hinging. And on the opposite side, the full depth cuts were made to allow for the raising of the lamina and allow for laminoplasty. So this is a post-op X-ray of the patient with the laminoplasty. And this is a small video which shows that through the tube, you can access 3 to 4 vertebral levels in the cervical spine. After doing a partial drilling on the opposite side, you can do a full drill on the ipsilateral side and then elevate them with help of these hinged plates. The one key difficulty that we faced in this patient was that the port that you use should be actually smaller than the one you need, so that the bone can come up and doesn't obstruct the, the port doesn't obstruct the lamina from elevating. This is pre and post. This is a intra-op OM image which shows that the canal was adequately decompressed. So this is a pre and comparison with open and normal incisions. Thank you so much. Any inputs? Any
excellent video?
Last minute points?
Very, very, very nicely done.
Very nice.
Thank you. Thank you.
Yeah.
Any stop share?
Yeah. Thank you, Dr. Rajan, and thank you for all the faculty. And it was a beautiful session. We had lumbar degenerative stenosis and lumbar degenerative scoliosis and vertebral compression fracture osteoporotic, followed by cervical radiculopathy and cervical myelopathy. And we have come to the end of the session, and I now invite Dr. Arvind to come and close the session. Thank you.
Thank you, everybody. Chandan, Jacob, Rakesh for handling this particular session. It was very interesting.
Thank you, Dr. Arvind.
It was a mix of challenging and exciting cases, complex cases. So with the curtains will come down now. We had a very long and tiring and educative day today. It was a marathon session right from morning 8 o'clock till now. I thank the executive committee for being there throughout the journey today. So I won't take much time. So I would like to invite Dr. Deshpande and our president and Dr. Amit Jhala, our vice president, to do the valedictory. So during the valedictory, I would request Dr. Pramod Lokhande to give us a sneak peek on the plans he's made to entertain us in November, when we'll be having our forthcoming MISSAB Con. Thank you, everybody. And especially I would like to thank the AV team, Avyaya Medicon from Bangalore, for being there I've been in touch with them for last 3 months, and we've been planning this particular program, and they've been very prompt and very helpful. I would say 3 cheers to them. Hip hip hooray. Thank you. So platform back to Dr. Deshpande and Dr. Amit. Thanks.
Thank you, Arvind. I must first congratulate you for organizing this excellent, fantastic meet today. Whole day full of discussion, very riveting discussion, great cases, wonderful participation. And I don't know how to thank you. I can just say, you have done a fantastic job. And we should say hip hip hooray to you too. And I'm sure the executive committee, the vice president, everybody will say wonderful and a super Sunday. Now, it's my duty to thank obviously all the sponsors, Akila from Intas, Jayon, Jesco, TechnoShine, Y, RevoSpine, Medtronic, Cure, and everybody else who has joined. And I also have the Avyaya team who always have supported us fantastically. Now, it's also my duty to announce the winners for the free papers today. So the free paper winners will get an award at the time of the Pune conference in November. And the winners are Dr. Tonangi Yeshwant, first prize for his paper on precise estimation of spinal osteoporosis. He's the winner. So 3 cheers to him. Dr. Praveen Goparaju will get the first runner-up. Is the multicentric retrospective study on the techniques of discectomy and complications. And of course, Anil Patil is a senior guy, but we decided to give him the second runner-up for his minimally invasive posterior cervical fragmentectomy and Foraminal. So congratulations to all of them. And they will get to be in the forefront and get good pictures of them receiving the award during the Pune conference. Now, for the sneak peek is Dr. Pramod there?
Hello.
Yes, Pramod is there.
Yeah, I'm here.
Hi, Pramod.
Hello, sir. Hello, how are you?
Yeah, all yours.
Yes. Thank you, sir. Thank you, President, Vice President, and all the MISSAB Executive Committee members for giving me this opportunity to hold this prestigious conference in Pune in November, this November 2022. We actually have a 3-day program from 18 to 20, and we have a 1 day of a cadaver workshop before the conference. So this particular conference we will be having under the aegis of Pune Association of Spine Surgeons, and it will be held in JW Marriott, which is a 5-star hotel in Pune, with I think a capacity of almost 2,000 delegates, which can be accommodated in the auditorium with lavish facilities. And these are the few highlights which I'd like to discuss. We have a pre-conference cadaver workshop hands-on 1 day before the conference, which will focus on endoscopy, which is full endoscopy, biportal, destandu, tubular, it will cover all the aspects of endoscopy. Secondly, we'll also have the option of having MIS fusion techniques, whether we'll do it on the same day or after the conference. If we manage to get more cadavers, we'll be able to do it on the same day. So that will focus on MIS T-lips and O-lips and A-lips. Then we have live surgeries planned on the day of first day of the conference from morning till afternoon. And they'll be focusing on decompressions, endoscopic decompressions and fusions. We'll probably have 3 theaters running at the same time. Full endoscopy will be, a few cases will be shown on full endoscopy, UV, destandu, and we are also trying to get a few cases of OLIF or ALIF, depending on the availability of the cases. Now, this is going to be a physical conference. This is not going to be entirely, but we do have a few online sessions, especially for those star faculty who are not able to attend, come down during that particular period. So we'll hold a few sessions, maybe 1 hour of each of online discussions involving prestigious faculties. And we are already approached COMIS, they have said yes. And we are approaching Asian MIS. The preliminary discussions are positive, and I think they'll be taking part on that. We are also trying to, considering Korea, Turkish Spine Society also to get attached to this conference. And these are a few interesting sessions, which I think apart from, although it's going to be an endoscopy, people know that most of the guys from Pune are endoscopic surgeons, but still, I think we'll be covering all the other aspects of MIS surgeries. We'll be having sessions on MIS in adult spinal deformity. Obviously, this is few guys are going to be online: Ronald Lehman, Vishal Saravai, Anand, and obviously our beloved president, Dr. Deshpande, Rajkumar Deshpande. He secretly, even though he's not promoting himself as a deformity surgeon, we do know that he does excellent MIS deformity correction surgeries. So he'll be a part of this session. Then we have got few sessions on management of metastatic spine diseases. So we are inviting few faculty from the Sloan Kettering Cancer Center, and I think Kshitij Chowdhury is taking care of this particular section. We'll be holding some sessions on MIS in spinal tumors. Spinal cord stimulator is something which is new and which can be implanted in a minimal invasive way also. And there are few people in India actually who are doing this particular, particular procedure, and I feel that it is our duty to get these people on stage and make the audience aware that what kind of work they are doing. And our beloved ASI president, Dr. Chabra sir, he does excellent work in robotics, and I'm still not personally talked with him, but I'll definitely ask him to be help us with this particular session on robotics and minimally invasive spine surgery. So this is something again we are planning to, and we are almost finalizing this thing that simulation-based workshops. There is a company called Real Spine based in Germany, and which manufactures simulation-based models for hands-on practice. So probably we could invite these people and we could have those lunch-on sessions or early morning sessions on this, and we could also incorporate them during the workshops. So this is again something which is new and still not been touched upon in India. And these are the star for faculties which we are getting physically. I think Professor Richard Hines, we are in early discussions with him. We want him to come physically in India. Then from Revo Spine, we have confirmed Professor Christopher Sife and Dr. Ali Guen. Then Dr. Pon Pavit, I think he does a lot of endoscopic surgeries for chronic low back pain. So he'll be coming also. Rubenzo is a deformity guy, and Vishal Saravai and Ronald Lehman, they are going to be probably online for sessions on minimal invasive adult deformity correction. So about Pune, I think everybody knows Pune. I think we have a few things not as glamorous, but there are definitely, everybody knows Dagdushet Ganpati, everybody knows Shaniwar Vada. And we have few interesting, entertaining sessions which we are planning, and I'm still going to keep it as a secret. So let us keep this, in mind. And I welcome all of you to, actively participate and, take as much, efforts to, or as much active involvement in this particular conference to make it as a successful and a memorable event. Thank you very much.
Oh, thank you, Pramod. We are looking forward to meeting you, not just online. I want to come and see how fantastic you are going to be as an organizer. And I hope you will beat us all in the whatever we have done earlier. I think you will do it better than us.
Thank you.
Dr. Amit Jala, your words, please.
Yes, actually, we are waiting for Pune for at least 2 to 3 years. That we were after Pramod, that he should take this meeting. And I think the D-Day has come and he has started working on it. And we are all excited to come at that place. Lastly, I would like to thank, definitely, I would echo what Dr. Deshpande has told about Arvind, the massive effort for this, and we should all clap, at least online, we should clap for whatever he has done. And he was after everyone to, and he has done a fantastic job to have this meeting in a very short duration. We wanted a physical, but at least it was his enthusiasm that we could have this meeting there. Nevertheless, I would also like to thank all the chairpersons, all the moderators, all the faculties for an excellent presentations and moderation of all the sessions that we had. And it was an exciting session all throughout the day. And we never, actually it was virtual, and we, not only the academics, it was good to see all good friends after so long time, though virtually, now excited to see in Pune physically. I think that's what I wanted to say all about. And we come to end of this session, and over to, I think, Arvind for anything else.
Yeah, last but not the least, I would like to thank Neeraj Bijlani from OrthoTV for not only relaying today's program, but relaying all our sessions in the last 2 years without any financial commitment. Thanks, Neeraj. So again, thanking Shweta Pradhan and her team from Avyava Medicon. Our best wishes to your team, and I think we'll call it a day.
Thank you, Arvind.
Thank you.
Thank you so much.
Bye-bye.
Thank you.
Bye. Have a great day.
Thank you, Arvind.
So thank you, guys. Have a nice time.
Thank you. Enjoy the remaining weekend.
Whatever remains of it. It's actually my anniversary today.
Oh,
You did a
happy
party.
anniversary, Rajan.
So I have to make up for the whole day away from my wife.
So our sympathies are with you.
Yeah, whatever is in store for me now. Thank you, sir. Thank you so much.
Thank you.
We are Medicon 1. Please, I'll leave the meeting. Bye. you.